Mayur Agrawal, Organizing Secretary for Hormone India Conference 2022, on behalf of Hormone India team, welcomes all the speaker, chairperson, delegates, medical students from India and abroad. Friday, we had a very excellent session on pediatric endo. All those topics were very relevant and very interesting. Yesterday, we had various talk on various aspects of diabetes, and we had special talks on the technology, rare form of diabetes, and we also had obesity workshop. Obviously, we discussed about the complication of diabetes and not to forget the GDM. Today, we'll be having sessions on adult endocrinology. So this adult endocrinology, various topics will be dealt by the eminent endocrinologist as well as endocrine surgeon. So we'll begin with the NGS and we'll cover other parts also. Calcium is obviously those patients are referred, that will be discussed, but other dyslipidemia, which are not considered to be dealt by an endocrinologist, but actually they are part of endocrinology. So that we'll discuss. Bone, obviously, that is will be discussed. That is less frequently seen by endocrinology, less referred. Then thyroid is the most important thing after diabetes, what we see in practice. So that we'll be discussing right from the nodule, goiter, and interesting cases. Not only those things, we will have discussion on topics which are post-DM level, like prolactinoma in pregnancy, resistant prolactinoma, all those. And we'll also discuss some of the very rarely discussed topics like the monogenic obesity, AMH, PCOS, HRT, all those controversial topics that also we are going to discuss. So I declare this session as open and we'll begin with the Saraswati Vandana. Tech team.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा.
Thank you, and may the goddess bless us with the knowledge. And to open the session, I welcome our first Hormone India repertoire for the session on basics endocrinology, orchestration of hormones. So we have with us Dr. Kanhaiya Agrawal. He has done his DM endocrinology from PGI Chandigarh. He is presently working as consultant Hormone India Gorakhpur. Over to you, Dr. Kanhaiya.
Thank you so much, Dr. Mayur. So for the today session, so we will just discussing about two topics, as Dr. Mayur said, about the NGS and endocrinology kaleidoscope. So for this session, we have two chairpersons. One is Dr. Akhil Krishna. He is an assistant consultant in endocrinology, KIMS Health, Trivandrum. And secondly, Dr. Alankar Tiwari. He is an endocrinologist in Varanasi. So I welcome you all, and I welcome all the chairpersons and the speakers for the today's session. So I hand over the session to Dr. Akhil Krishna to introduce Dr. Alakhani for the next lecture.
Good morning. Hope I'm audible. Yeah.
You're audible.
Yeah, thank you. First of all, I thank the organizers for this opportunity, and it's actually a great pleasure and privilege to share the dais with two prominent speakers, on Lakhani sir and Shubhankar Chaudhary sir. So first we'll proceed with the first session, that is the NGS in endocrinology. So for this, we have the eminent speaker, Dr. Om Lekhani, sir. He's a consultant endocrinologist at Sidus Hospital, Ahmedabad. And he has multiple honors to his credit. He's the gold medalist in endocrinology and winner of the National TISA Award and multiple gold medals during his MD and DM period. And he has come up with his notes in endocrinology app as well. So let us hear from him what he has to enlighten us regarding the role of next generation sequencing in the field of endocrinology, an emerging topic. So we have a lot to learn in this area. So let us hear from him. Over to you, sir.
Yeah, thank you so much, Dr. Akhil, for the kind introduction. I'll start by sharing my screen. Yeah. Is my screen visible?
Yes, sir. It's visible. You are well audible.
Okay, thank you so much. So thank you to the team of Hormone India for having me for this very interesting session and topic. And I think this is looking at the topics through the entire series of program, I think it's a very interesting, conference. And I think, I hope this is done every year because it's really, academically enriching. So I'm going to talk to you about something very important at present era, and that is next generation sequencing in endocrine. Now, the advent of next generation sequencing has completely changed the field of genetic medicine, and hence will also change the other fields as well. So this is something which brings genetics to the retail level, as we say, right? For example, there was a time when we used to make a diagnosis of valvular heart disease with a stethoscope. But now even a non-specialist who is not a specialist in cardiology uses an echocardiography to make a diagnosis. And this diagnosis is often very, very accurate. In the same way, the advent of various endocrine investigations at a retail level, at a cheaper level, helped us boom the field of endocrinology. And now even non-specialists can order endocrine investigations and then send it to endocrinologists for the interpretation and the diagnosis. In the same way, genetic medicine has changed completely with the presence of next generation sequencing. And now non-specialists in genetic medicine, like you and me, would be able to make diagnosis of complex genetic disorders with just one blood sample and with, of course, a few, it will require a little bit of investment from the patient and in terms of money. But this is something which is going to change, has already changed our clinical practice, but will play all a more important role in future. So what we're going to do is that we are going to discuss next generation sequencing from the context of an endocrinologist. And that is what we are going to really focus upon. And I'm going to show you a case as an illustration of how an endocrinologist can use the available next generation sequencing technology for the benefit of our patients. So when we talk about diagnosis of any disease, especially in endocrinology, we are talking about three major steps, which you do conventionally. One is the clinical diagnosis. A patient comes with puffiness of face, periorbital edema, pedal edema. You're thinking that patient is probably having an overt hypothyroidism. Then, of course, you do a thyroid function test, which is a biochemical support, right? Which is biochemistry is extremely important for endocrinologists, like we all know. We do a thyroid function test and so on. Then you might do a radiological investigation. So these three are the basis of any endocrine investigation, right? Starting from a clinical, biochemical to a radiological diagnosis. But then in 2022, we have one more step which is involved in the process of the diagnosis, and that is the genetic testing, right? And this, like I said, is the fourth arm of the clinical diagnosis, and this completes the diagnostic picture, right? And I'll show you with an illustration of a case how important the genetic testing is, and with several other cases in both adult and pediatric endocrinology where this was very, very useful in our own practice. So let's look at a case. So I think we have a lot of endocrinology students, residents, and also aspiring endocrinologists who are listening to this. So I think this is something which for an endocrinology resident, this is bread and butter. So hence I'll discuss it like a case with what you usually discuss in a ward. So this is a case of an 18-year-old male patient who came with absence of secondary sexual characteristics at age of 18. He also had a younger brother who is 15 years old. He also has delayed puberty, right? So now your bells are ringing. You're thinking of a particular diagnosis, right? From a clinical point of view. Obviously, do a clinical examination. There are no facial dysmorphism. There are no midline defects, no cleft palate or cleft lip. Please note these points because these are something which you ask in a patient with delayed puberty, a male with delayed puberty. There is no goiter, no gynecomastia, galactoria, of course, not relevant here. Hyperpigmentation, no, polydactyly, no inguinal hernia or scars. Now we go to the genital examination. The testicular volume is 2 ml bilaterally. And again, endocrinologists will know that less than 4 ml would suggest that the puberty there's no onset of puberty yet. There are no testicular mass and stretch penile length is suboptimal. So you are dealing with a patient who is having male hypogonadism, which is very clear. And I think, a lot of us would have already started making differential diagnosis in our minds. So very important history is history of anosmia. And the patient has no history of anosmia, no clinical examination, it was smell test and there is no anosmia. So again, we are narrowing a clinical diagnosis to a particular diagnosis, as you'd all say, right? Now, so that was the clinical diagnosis. And now let's talk about the biochemical assessment. So at a biochemical assessment, the important test here would be the gonadotropes, the LH and FSH, and LH is 0.03. Remember, an LH of less than 0.1 would suggest that, the pubertal onset is not started. You can clearly see the testosterone levels, which is again in a hypogonadal range. And the other investigations were done just to complete the picture. Right? Of course, we are not going to details of these. We're not going to discuss a hypogonadotrophic hypogonadism case here. We are mainly discussing the genetics of it. The patient's bone age was 15 to 16 years. We did an MRI, so this is where the radiology support comes, right? So you have the bone age and the an MRI, which may be useful in this patient. And the olfactory bulbs are preserved. So this is a patient who is having slight delay in the bone age, but absence with normal pituitary gland and olfactory bulbs preserved. And so you're dealing with a hypogonadotrophic hypogonadism with a preserved without anosmia, with normosmia. So, of course, with the clinical judgment, investigations, biochemical investigations, and the radiological investigations, we came up with the diagnosis of what is known as a IHH or CHH, which is idiopathic hypogonadotrophic hypogonadism with normosmia. Again, please let's not focus on the diagnosis here. The point is how we look at this early. So now we have the diagnosis in hand, right? And all endocrinologists would have reached to this diagnosis. But that is where we take the things one step further, right? And then we come to the patient also wants to know, and we are also interested in knowing what is the genetic diagnosis. What is the molecular defect? What is the genetic defect which has led to this disease? This is important. For one, it completes the diagnosis, but it also, we know that there is a very good, strong genotype-phenotype correlation in patients with idiopathic hypogonadotrophic hypogonadism. So when we talk about IHH, there are different levels at which genes are involved. So there could be developmental defects in the GnRH neurons, right? Which are, you have the CAL1 gene, which is very, very important here. And then you can have impaired GnRH secretion, where you have these genes which are involved. Again, you have GnRH resistance, and then you have ultimately gonadotrophic defects. So all of these patients would would have hypergonadotrophic hypogonadism. But we need to know where our patient stands, right? Where does our patient stand? And based on that, we might be able to, look at more phenotypes, probably, look at the future, genetic counseling also of this patient, depending on the gene which is involved. So now we want to do a genetic test. There are two conventional ways. There are two ways in which we can approach this. You can do something which is known as a conventional Sanger sequencing, or you can do what is now known as a next generation sequencing. So we'll discuss the difference between these two approaches in the next few slides. So conventionally, again, even when I did my own residency, and I did my residency from an area where genetic medicine was very strong. So I think we had in fact a posting in genetic medicine also for a month, which means that our teachers and our institute actually saw that genetic medicine was very important from an endocrinologist point of view. So even at that time, we used to generally do conventional Sanger sequencing. So what is Sanger sequencing? So this is a process of taking one gene at a time, right? So you're starting with one gene. Obviously, we start with the one with the highest probability. Then we go to the one which is low probability. And then you're looking at what is known as a genetic odyssey. So we are looking at one gene at a time, right? So start with one gene. If it's there, fine. No, then move to the next scene, then move to the next scene, and so on. Now, this is a time-consuming and often a frustrating process, but it's also very expensive because each of this Sanger sequence now, at current era, costs about 3,000 to 5,000 rupees. At that point of time, when I was doing my residency, it would cost around 8,000 to 10,000 rupees. So you are talking at, if you're looking at multiple genes, you're talking at about a investment cost about 50,000 to 60,000 rupees, which obviously all our patients would not be able to afford. Again, this process is also time consuming and often frustrating because you're then looking at one gene. If it works, fine. If it doesn't, you move to the next gene and so on. Right. So that is what conventionally Sanger sequencing used to do. But now we have moved to, what is known as a next generation sequencing. So if you, let's say this patient, we have made a clinical diagnosis of IHH with normosmia. And as an endocrinologist, you know that these are the genes which are involved in this process. So you have, the GnRH receptor and GnRH gene, which is involved. You have the KISS receptor and the KISS1 gene involved. And you have the TAC3 and TAC3 receptor, which are involved. So we'll have to check each of this. There are 6 genes involved here. And we have to check each of these genes for the clinical diagnosis. And hence, if you say, let's say, you take a charge cost of about 6,000 rupees for each of the gene, you're looking at a cost which is an upward of 36,000, 40,000 rupees. So that makes it not only time consuming but also very expensive. And it could so happen that all of these genes are negative. And sometimes we know that sometimes even a CAL1 or other genetic mutations may have normosmia or may have hyposmia, which is often thought to be normosmia. And in such cases, again, you will have to look at another set of investigations once again. So hence, it is perhaps a good idea to consider doing what is known as a next generation sequencing. So in next generation sequencing, we look at multiple genes in parallel instead of one gene at a time. So what we're doing with Sanger sequencing was a stepwise process where you are looking at looking at genes. But in a next generation sequencing, you are doing something in parallel, right? You're looking at multiple genes in the same time. So that is what makes the difference in terms of the diagnosis. It gives you a rapid checking of multiple genes. And then now you're looking at a panel of genes instead of a single gene at a time. So looking at a complete panel, and hence your diagnostic yield will also be much, much higher. So we need to understand there are certain terminologies which are related to next generation sequencing. We'll see what is NGS as well, but we'll also see there are certain terms which, again, all of the endocrinologists and definitely, of other special, doctors of other specialty also need to understand. So you have, first of all, what is known as a whole genome sequencing, where you sequence the entire human genome. Now, this is mainly experimental. This is very little clinical use. There is no point of checking the entire human genome. But just to tell you, after the completion of Human Genome Project, now you have a library of all the genes, of all the human genes. And the cost of sequencing the entire genome used to be very expensive in the past. It's come down to, a manageable range. But we are smarter. We are, of course, being doctors, we do not want to just blindly check the entire genome because it makes no sense for us. You are dealing with a disease-specific genetic problem, and you're not dealing with the entire human genome. You don't want to look at the entire human genome. So we look at, then we said, why don't we just check the exome, right? Exome, remember, exons are the coding regions, and exome is the entire coding sequence of the human DNA. So we are now then checking only the whole exome, right? So we just do a whole exome sequencing where you're looking at only at the coding regions. So that is what is known as the whole exome sequencing. So in the West, whole exome sequencing is popular. But in India, again, we are probably even smarter than people at the West. We know that. We do what is known as a clinical exome sequencing, or what is also known as targeted sequencing. So now I am dealing with a patient who is having idiopathic hypogonadotrophic hypogonadism. I'm not dealing with other disorders. So I'm not interested in what are the other genes involved, which are coincidental, which may not be related with this patient at all. So we are right now interested only in the disease-specific genetic testing, and hence we are looking at a clinical exome sequencing. So we are then only looking at disease-specific genes which are sequenced. So panel of disease-specific genes which are sequenced. Of course, you can broaden the range, but then you are not dealing with cancer genes, or you're not dealing with other genes which have little relevance to this patient. Maybe it is relevant to other patients, but for this patient it is not relevant. So we are looking at mainly at the targeted gene sequencing, which is also known as clinical exome sequencing, and this is what we practice in clinical medicine right now. So, like I said, what has been brought to the retail level is the clinical exome sequencing, and clinical exome sequencing, which is a form of next generation sequencing, has completely changed our clinical practice for good. So, broadly in terms of difference between a whole exome and clinical exome sequencing, whole exome sequencing would require coding at a larger region. We are looking at about 20,000 genes. Here we are looking only at 3 to 6,000 genes, even lesser if your clinical diagnosis is more accurate. It requires, a whole exome sequencing cost about 50 to 60,000, whereas a clinical exome sequencing can be done for 30 to 40,000. In fact, now a lot of labs also do it for 20 to 30,000, right? So that cost is much, much lower. Whole exome sequencing is done more in the West, but in India and developing countries, clinical exome sequencing is more popular, right? Remember, the amount of data which is generated from whole exome sequencing is also larger, and you require lot more time. So the turnaround time is also larger with the whole exome sequencing compared to a clinical exome sequencing. So let's be smarter and focus our tests on clinical exome sequencing. At least we are, we may not be experts in genetics, but we are experts in endocrinology. Hence, we are able to narrow down a list of genes which you can probably sequence in parallel and hence reduce the cost. So what exactly is next generation sequencing, NGS, and what are the steps involved in the process of NGS? So the first step obviously starts with the sample, right? So you take the DNA sample of the patient, you extract the genomic DNA. Then remember, you want to sequence things in parallel, right? Now, when you have such a large human genome, remember the human genome is a large set of genes. So what initially is done is that you break this gene into smaller segments, which are much more easier to really test or really look at, right? So to sequence an entire genome will take a lot of time. So you sequence parts of the genome. So you break the genes into particular segments, and then each of these segments is amplified using PCR. We all know what is PCR now, right? So in the era of COVID, I think everybody, even lay people, know what PCR is. So then you do a PCR. With the PCR, you multiply the relevant areas, and then you do what is known as a sequencing, right? So in sequencing, what you typically do is that, remember, you have the complementary base pairs, right? So you label the complementary, you have the labeled complementary pair, and then that is now matched with the area of interest, that is the amplified DNA segment. And then, once it completes, when there is joining of the complementary segments, it will give out the signal, and the signal with this will be able to sequence the segment which you are looking at, right? So that's how the sequencing is done. But the entire story does not end there, because then the major part really comes is the bioinformatics analysis. So now you have sequencing of the segment which is done. So you're looking at, remember, you're doing a clinical exome sequencing. So you're looking at the relevant areas of the DNA. And these areas now you have sequenced. But so it's like, doing the blood test. So you've done the TSH value. But now you need to interpret the TSH value. And that is where bioinformatics analysis comes into picture. So here what is done is that you look at the data, you look at the sequence data, you compare it with the existing library of the human genome, and then you look at the variations which are there in that segment. So that is where you look at, remember, there's a huge amount of data which is generated. The larger areas of the DNA you are sequencing, the more data it will be generated. So again, this is the major part of the entire process. This is where the genetic medicine expert really comes into picture. Just like an endocrinologist, TSH can be ordered by any doctor, but you'll require an expert to really make the fine tune and the important genetic analysis here. And that is where you have the clinician and the geneticist who come together to make the correct diagnosis. So the more information you give to a geneticist, the better they'll be able to give you a bioinformatics analysis and give you a better diagnosis. So these are the steps which are involved in NGS. Remember, this is where you have the involvement of big data and all these machine learning and the artificial intelligence and the big data. All these things are very, very important for bioinformatics analysis. They are just buzzwords in other specialties, but they are now day-to-day practice in bioinformatics. So these are the steps which are involved in a next generation sequencing. Then, of course, there are certain variations of next generation sequencing. You have short read and long read sequence. So depending on the platform you're using, you might have a short read or long read sequencing methods. In short reads, you're basically looking at reading limited base pairs. So at a single point of time, able to read limited base pairs. So for a genome which is very large, like the human genome, you need to break the genome into multiple segments, and then you need to read it by the platform. Whereas in a long read sequencing, you can sequence larger areas and more base pairs. So again, that makes the through output faster and the entire turnaround time faster. But the catch is that the errors are more in terms of long read sequencing, whereas errors are less with short read sequencing. So in India, and of course in most of the Asian countries where we generally do our clinical exome sequencing, we are generally looking at short read, platforms where you're looking at the relevant areas and you're not looking at the entire human genome. So if you're looking at a research process where you're looking at the entire human genome or the entire whole exome, perhaps a long read sequence analysis would be better. But in our practice, where you're mainly looking at clinical exome sequencing, you're mainly looking at short reads. And of course, there are other pitfalls with NGS. So NGS has trouble detecting short repeated sequence, like for example, CAG repeats, which you see in Fragile X syndrome. So like thinking of a diagnosis of Fragile X syndrome, or you're looking at, remember, in patients with POI, you're looking at whether they are carriers. These women are carrier for Fragile X. In such cases,
short of time. Sorry, sir.
Yeah. I'll quickly. I'm about to finish. Right.
Okay.
So in such cases, we are looking at Sanger sequencing may be better, and those mutations which are more than 25 base pairs away from the exon, this may be best. So again, you're looking at, these are often the pitfalls. So I'll just end with the last few slides. So we are coming back to the case, right? So we did a whole clinical exome sequencing for this patient, and we found that this patient had TAC-R3 mutation, which is again consistent with the diagnosis we are making. So it is hypogonadism with anosmia, and this was autosomal recessive, right? So a lot of these disorders are X-linked. This is autosomal recessive. So that makes it an important clinically relevant problem that we are solving. So the idea here is that with the next generation sequencing, we completed the clinical diagnosis from a clinical diagnosis to a biochemical to the radiological to the genetic diagnosis. Where to use NGS in endocrinology in other cases, for example, metabolic bone disease, where we are, I think, a lot of talk is going to be here today, IHH, CAH. You're looking at endocrine oncology, where it's very, very important, monogenic diabetes, monogenic and syndromic obesity. I think that makes the, guesswork out of it, with just the whole exome sequencing, you're able to make a diagnosis, pituitary disorders, short stature, and so on, right? So I just quickly show you some of our other cases, which I could just collect a few cases yesterday of where we did whole exome sequencing. This is a patient who had a family history of sudden cardiac death with dyslipidemia. We did a clinical exome sequencing looking at cardiovascular risk. This patient turned out to have IRIS1 gene defect, which is, makes us susceptible to type 2 diabetes. She also had arrhythmogenic right ventricular dysplasia gene, which is autosomal dominant. And perhaps this contributed to the sudden cardiac deaths in the family. We had this child who presented with short stature, where we found this had GH receptor defect, where we had, Layard syndrome was diagnosed. We had this patient, a young doctor, where we had, patient had pituitary involvement. She had a, pituitary prolactinoma, and she also had hyperparathyroidism. So we're looking at MEN1 syndrome. We did the genetic testing. Interestingly, we did the testing for the whole family, and she was the only one in the family with this genetic defect. We had this patient with CAH, where we sent the a clinical exome sequencing. So these are some of the illustrative cases. So these are cases where you can use this in clinical practice. So I thank you for a patient listening. And as introduced, we have this Notes in Endocrinology app, which is very useful for endocrinologists. When it's free of cost, you can probably download this and look at this. We also have this Centurion Insulin app, which is mainly targeted at physicians and doctors who are interested in diabetes practice, where we are telling you when to start insulin, what dose to start, what type of insulin to start, and so on. And of course, this is Hypothyroid. This is recently launched. This is currently available right now in the just a few weeks back. We are able to put this on the iOS and the both the platforms. And this is hypothyroidism in pregnancy for doctors. This is useful both for physicians, endocrinologists, and OBGYN for when to treat and when not to treat hypothyroidism in pregnancy. So this is what I have to deliberate today. So thank you for a patient listening, and apologize if I short the time. Sorry.
Thank you so much, sir.
Thank you, sir.
Yeah. So for the next lecture, I invite Dr. Ankar. Yeah. Okay. Fine.
Thank you very much, sir, and 100% for the presentation, and obviously 200% for the way you presented it. We had close to 3,000 registration for this conference, and there are various questions, but I have taken just 2 questions for you because short of time. First question was asked by a delegate: what is variant of unknown significance, pathogenic, likely pathogenic? The other question was, what is the role of getting non-coding gene? Like whole genome sequence, you get the non-coding gene. What is the role of getting that?
Yeah. So I'll take the first question. So, American Society of Genetic Medicine classifies the variants into broadly three major categories. So one is very likely to be pathogenic, where you have the genetic variation which is found, and which, in terms of, if you see the genetic library, the epigenetic library, you are able to have prior history of that same gene defect leading to the particular disease of where you are looking at in terms of significance. Again, you have likely pathogenic, where you have the genetic defect found, but either it does not completely match with the phenotype which you're observing, or B, it is completely different from the phenotype which you are interested in. Right? So we're looking at IHH, and you found some other genetic defect which like we did in one of the other patients. The third is CNV, copy number variation, or likely again an incidental finding, where again you are completely looking at something as a final genetic variation which is reported. But then you have up to a phenotype correlation to really look at whether this disease really exists. So you have a variation, but whether this variation leads to the disease or not, and whether that's the thing which are relevant to what you're testing, that is what you are often comes up. So when we do a whole or a clinical exome, even a whole exome sequencing, you will often find certain genetic defects, certain SNPs which may not be completely relevant to your case, and that is where again you'll have to use your clinical judgment in terms of the diagnosis. Now, the second part is, what's the importance of non-coding region? Sometimes the non-coding region has remember, there is epigenetics, right? So there is a non-coding region may also sometimes come into picture, may be activated in relevant periods of time, and they can act as switches which can switch a gene on or off. So when you are looking at a monogenic disorder, when you're looking at something which is very specific, like IHH or something like that, or MEN, you are mainly interested in doing clinical exome sequencing. You're not, or maybe Sanger sequencing. You're not interested in looking at the non-coding region because you're looking at a particular specific diagnosis. When does a non-coding region come into picture? That comes into picture when you're looking at a broad picture in terms of polygenic diagnosis, a polygenic disorder like type 2 diabetes or obesity and so on. It's more useful looking at that when you are doing a research purpose. So let's say you're doing you want to do a GWAS study for type 2 diabetes in Indian patients, or you want to do something for obesity. When you're looking at a bigger picture, that is where the non-coding region really comes into picture. It's actually, now you have a library which is called GTEx, which is for the epigenomics and epigenetics also. So there are certain genes there which may be activated in relevant situation, leading to a particular diagnosis or a particular risk parameter, like in terms of diabetes and so on. Could also be potential targets for treatment in future in terms of precision medicine and so on. So those things are more useful for research purpose. From a day-to-day practical retail clinical purpose, where you're looking at monogenic disorders and you're sending a genetic test mainly for monogenic disorders, you're mainly looking at coding regions. You're not looking at non-coding regions, right? So that is where it really comes into picture.
Thank you, sir, for that great explanation. Yes. So just because short of time, we'll move on to next session. Thank you. Sure. Thank you.
So I just like the next lecture will be recorded for by Dr. Shivanka Chaudhary, sir. So I just like to call Dr. Alankar to introduce Shivanka Chaudhary, sir, for his lecture.
I thanks team Hormone India to invite me for this very informative session and conference. So introducing Dr. Shivanka Chaudhary, sir, who needs no introduction. Sir is currently serving as professor and head and Department of Endocrinology in IP Tumor and SSKM Hospital, Kolkata. And he's member of Subject Expert Committee CDCSO in Government of India. He is founder patron of South Asian Federation of Endocrine Society. He has been chairman RSSDI in West Bengal chapter of Endocrinology. Sir has been the past editor-in-chief in Indian Journal of Endocrinology and Metabolism. Sir has been the past president of Endocrine Society of India and immediate past president in Endocrine Society of Bengal. Sir has a very keen interest in research and theories like in gut microbiome, gestational diabetes mellitus, also in field of pathogenesis of Graves' orbitopathy and biology of fat in different body compartments. Sir has around 218 publications in various national and international peer-reviewed journals. So we welcome Sir for this enlightening talk on kaleidoscope of endocrinology.
So tech team, please.
Very good morning. It's a wonderful opportunity to speak before you in this Hormone India conference. I thank Dr. Mayur Agarwal for providing me this opportunity. So what I plan to do in the next 20 minutes or so is to look at endocrinology as a whole, but quickly trying to provide the interest and the challenge in the management of endocrine disorders. So the first part of the talk is essentially didactic. The later half is only through photographs that I've taken of various patients and their issues over the last 40 years. So if you think of endocrinology as a discipline, it's relatively new. But if you think of endocrine disorders, I think they are amongst the oldest recognized diseases that one knows. For example, if we talk of diabetes, the earliest references are in the Ebers Papyrus in Egypt, which is probably 700 or 800 BC. And then we have in our own country reference to Madhumeha, which is what diabetes is, way back by Charak and Shushruth. And then if we go down different important points in the landmark events in the development of endocrinology, I don't think we need to go into all the details, but we remember that the science actually had a boost in the 20th century with the discovery of different hormones. First on the list is adrenaline in the year 1901, then secretin 1902. But the word hormone itself was used only in 1905 by Sir Starling, Ernst Starling, during his Croonian lectures in London. And then we have a list of so many different hormones, and the discovery of hormones continued even into the 21st century with new hormones like resistin and visfatin and adiponectin being identified. While this journey continues, this is again remembering Starling, who first used the word hormone in 1905. Now, if we think of the definition of hormone, the classic definition of hormone as a chemical substance produced in a specialized gland, which is released into the bloodstream and transported to distant tissues to elicit physiological responses. But we already know that this understanding of hormone and actions has undergone a lot of change over time. For example, we now know that hormones need not come only from specialized glands. We always talk of the pituitary, the thyroid, the adrenal, the gonads. But hormones are known to be produced practically all across the body. So either they could be some specialized cells dispersed in other tissues. For example, in the intestinal lining, you have endocrine cells which secrete maybe the GLP-1 or GIP that we all know. And then even otherwise normal cells, fat cells, are known to secrete so many hormones like leptin or adiponectin. And then our classic understanding is that hormones have to be produced in one part and have to be carried over long distance to have an effect in a different part of the body. But now we know that hormones can act locally, which we refer to as paracrine, which is just outside the cell from which this hormone arises, or it could even be autocrine, that is, the cell that produces the hormone can influence itself. So these are new understanding. And we also now understand that hormone receptors can be present much more widely than in classic organs or tissues that are known to be final effector organs for different hormones. For example, let's take the example of prolactin. Prolactin, the primary organ for its action, is known to be the breast for causing milk secretion, milk production. But now we understand that prolactin receptors are present widely on different cell types, including on lymphocytes. So what are prolactin receptors doing on lymphocytes? So it must be having some immune-related action as well, which is not a classic action of prolactin. And this slide lists, once again, the classic sites of hormones and the non-classic sites and different hormones that are produced. And these days we talk a lot about pro-BNP as a marker of heart failure, and which is secreted from the heart. So heart, once again, is also an endocrine organ. So which organ is not an endocrine organ? Now we are in a difficulty to find out. And as we were saying, the understanding has undergone a lot of change. So we thought one gene could produce one hormone. We thought one cell could produce one hormone only, and one hormone acts on only one receptor. But we now know that there could be multiple receptors for the same hormone. For example, estrogen receptor alpha and beta both attract estrogen. Similarly, one hormone has one coherent action. Now we know that one hormone could have so many different actions. And very importantly, in the past, we thought that hormone concentration, if we could measure in blood, then that will give us an idea of the hormone action at the tissue level. But now we understand from the concept of receptor upregulation, downregulation, that the same level of hormone may give rise to practically no effect of the hormone because of hormone resistance. And that's because of receptor downregulation. That's, of course, one mechanism. So these are all the recent advances, the understanding in the discipline of endocrinology. So now we have established that endocrine disorders are there for time immemorial, and there has been a lot of advances in the understanding of endocrinology. And we also wish to put on record that endocrine disorders are quite common in our country. If we put together thyroid disorders and diabetes, which are by far the most common endocrine disorders that we see, but there are a whole host of others. And I think metabolic bone disease is something which is newly being, over the last, new doesn't mean absolutely new, but over the last 15 years or so, is being recognized that metabolic bone disease is an endocrine disorder. And so if we add all of these together, then possibly more than 170 million people in our country are suffering from one or the other endocrine disorder. Now that brings us to the topic, endocrine kaleidoscope. Why is this name? Well, I'm sure as a child, you, just as I have, been fascinated by this small toy, the kaleidoscope, where if you turn the kaleidoscope a little bit, you come to see a whole new set of colors and patterns. So similarly in endocrinology, I think each patient is different from the next one, and we see so many different hues and patterns of the same disease. So let me now try and take you through the excitement of an endocrinologist in its clinical, the clinical charm related to endocrinology, while show you different actual real life cases. Now, this is a lady who is elderly, more than 65, who has got a large toxic multinodular goiter. I do remember because she was mother of one of the nurses in our institute. Now, we had suggested that surgery is the best form of treatment, but she just refused. She said, no, I'll continue with medical treatment, whatever you have to offer. So we could control her hyperthyroid features with antithyroid drugs, but those large thyroid nodules we clearly cannot dissolve just by giving medicines. But remember that this lady looks otherwise healthy and is fully conscious. This is a younger lady who is just about 50, who also has got multinodular goiter, but who looks clearly sick, is already having difficulty breathing. And she, on top of that, was euthyroid, whether the previous elderly lady was hyperthyroid. So euthyroid should make things simpler. But clearly these thyroid nodules are pressing on the trachea and sort of suffocating her. So what determines these symptoms would be which way these thyroid nodules are growing. If they're growing outwards, then they are not causing compression of the trachea. However, if they are growing inwards, and this seems to be the case in this particular lady, this can lead to catastrophic results. So the same condition, multinodular goiter, could present in different ways. And this is just in passing. I wish to mention that this patient, just by the appearance of the patient, one could almost make a diagnosis of ankylosing spondylitis. And there was a time, unfortunately, several decades back, where radiation was used as a form of treatment and was supposed to reduce the pain related to this inflammatory condition. And this gentleman was moving around with a huge goiter. This is a side view, and I think we have a front view. And the gauze piece was there because the lesion was ulcerating. And this was a case of likely radiation-induced thyroid malignancy. And it's very uncommon these days to see such large goiters. Remember, this was a photograph taken, I think, in the late 80s or early 90s. So we have progressed significantly, and rarely do we see such huge goiters these days. Now, when we are on the issue of thyroid, so hypothyroidism is one of the more common endocrine conditions that we see, and a condition that is very satisfying to treat most of the time. Now, hypothyroidism is associated, some of the classic clinical signs is loss of scalp hair, loss of eyebrows. These are almost classic symptoms or signs in a patient of hypothyroidism. Now, see on the left, we have a girl of 6 years who has got increased hair over her back. This is downy sort of hair, not terminal hair. And on the right, the same, and she was diagnosed to have primary hypothyroidism with quite high TSH value. She was treated with thyroxine, and the same girl, this is a different, more close-up view. So it's the same girl, which shows significant reduction in that excess hair growth over the back. So the point that I'm trying to make is hypothyroidism classically causes hair loss, but it can also cause increased hair growth, especially downy hair growth, and maybe uncovered areas of the body, which can improve, which can decrease after successful treatment of hypothyroidism. Now, once again, we know hypothyroidism as a condition that is associated with slowness of metabolism, with everything slows down, your mental process slows down, you grow less, and so on and so forth. Puberty is delayed. But the girl on the left actually was referred to us from gynecology department. Now, she is a girl of 4.5 years. Now, she had breast development, and on this slide, we can demonstrate, we can see the breast development, breast being, right, the breast being enlarged, which was there for the last 6 to 8 months. mother, of course, had ignored it. But then when she had the first menstrual bleed, was she brought to the hospital, and she had been taken to the gynecology department. And there they found on ultrasonography large cystic ovaries, and they were ready to do surgery for those cysts. Somehow they sought an endocrine consultation. Now, looking at this girl, we could clearly suspect hypothyroidism. It was almost written on her face, hypothyroidism. When we did the blood test, it was indeed cross primary hypothyroidism with TSH value more than 100. And so we somehow requested our gynae colleagues, please do not operate on this girl. Let us give her medical treatment. Let us see how she progresses. And so rather reluctantly, they agreed to it. And this is the same girl after about 4 months, where the breast has no further enlarged, possibly has regressed somewhat. She not having any further bleeds. So now the point that I wanted to make is, so the same disease, hypothyroidism, while classically, typically causes delayed puberty, it can also cause precocious puberty, particularly in girls. So we should remember about hypothyroidism being a cause of precocious puberty as well. Now, this is another lady. This is a lady of, she is about 55 years. Now, she has a puffy face, some pallor, and the general physician had done a thyroid function test and found a TSH being about 7, which is a little bit high, but not high enough. And so he thought that he's got the cause for her symptoms and signs and referred to us. But on clinical examination, and here again is the importance of clinical examination, what we find are these veins on the neck, prominent veins on the neck, which made us suspect there may be something amiss. So we just did a chest X-ray and we found a large shadow there, and as well as mediastinal lymph nodes. So this was a case of malignancy, a lung carcinoma with mediastinal lymphadenopathy causing superior vena cava syndrome, which by interfering with the venous drainage from the upper half of the body, it causes these veins to be dilated and cause this puffy face. So we need to be very careful about our clinical examination. Just we cannot do by treating the blood reports. Now we come to hyperthyroidism. And Graves' disease is an autoimmune condition where associated with hyperthyroidism and an enlarged thyroid, you have prominence of the eyes, bulging of the eyes, redness of the eyes. So this is a condition that is treatable typically in the past with intravenous oral steroids. Then we had intravenous steroids. Now we have other immunosuppressives that can be added, like mycophenolate acetate and mycophenolate mofetil and so on. And this is the same person after about 3 months, significant reduction of the eye signs, the redness is less, the proptosis is less. So this is Graves' hyperthyroidism. Now this was another lady who also had a somewhat prominent stare on the left eye, and she also has a mark of vitiligo on her neck and also possibly on her face around the eyes. So we thought this must be a case of Graves' disease once more. So we sent off the blood for tests. And lo and behold, what came out was hypothyroidism. We thought the laboratory must have goofed up. So we asked them to do the test again, but again, the test was similar. So once again, the point that I wanted to make is while ophthalmopathy or eye signs are typical of Graves' disease, of hyperthyroidism, we can see somewhat similar, usually less prominent, and much, much less commonly similar eye symptoms and signs even in hypothyroidism, because the underlying mechanism is autoimmune. So it can cause also in hypothyroidism. Now we turn to the adrenal glands, and primary adrenocortical insufficiency is a condition that is associated with diffuse body pigmentation, skin pigmentation, mucosal pigmentation, associated with significant systemic symptoms, patient feels weak, tired, has nausea, loss of appetite, has low blood pressure, and so on and so forth. So this is a gentleman who had adrenocortical insufficiency, and this on the left was his initial presentation, on the right after about a year when the pigmentation had become much less. However, in management of this patient, we made a mistake. Now, primary adrenocortical insufficiency in our country many a time is because of infective etiology, because of tuberculosis of the adrenal glands or histoplasmosis, whereas in the West, it is mostly of autoimmune origin. In this gentleman, we found enlarged adrenal glands. We did an FNSC, and the report was consistent with tuberculosis, so we started him off on antitubercular drugs. And after a month or so, he came back. And of course, this picture that I'm showing on the right is much later, but in between, in about a month's back a time, he came back very ill, collapsed, almost dying to our emergency. So what had we done wrong? We had given him a steroid replacement, hydrocortisone, but we had also given him antitubercular drug, of which included also rifampicin, which is a potent hepatic enzyme inducer. So what it does is whatever hydrocortisone we are giving, it metabolizes it rapidly, breaks it down rapidly. So if a patient with hypoadrenocorticism because of adrenocortical tuberculosis needs antitubercular drugs, let us be clear that if we are using rifampicin, we should be doubling or tripling the dose of hydrocortisone so that this patient does not develop this worsening of the adrenal crisis because of antitubercular drug. Now, because of the awareness that primary adrenal insufficiency can cause pigmentation, this girl was referred from skin department. However, see, despite the intense pigmentation of her palms, the tongue or the mucosa is not pigmented. So this patient was also, we undertook the test, but hormonally she was found to be normal. So this is some form of primary pigmentary dermatosis. Now, while on the subject of adrenal, we come to adrenal tumors. Now, this is a gentleman who has got a lump, as it's marked out on the abdomen, which was thought to be an enlarged spleen, and he was admitted in gastroenterology department for assessment, and we were referred because he also had gynecomastia, middle-aged man, why he should have gynecomastia. It turned out eventually that this was an adrenal mass, a large adrenal mass, which was because of an adrenocortical carcinoma, and this carcinoma was producing some feminizing hormones giving rise to gynecomastia. So this adrenocortical carcinoma with feminizing features. Now, this is another boy who is younger, about 17 years, who also has got adrenocortical carcinoma. Unfortunately, at this point of time, he also had liver metastasis. And he also has got gynecomastia. But on top of that, he is Cushingoid, clearly Cushingoid. So not only does he have feminizing features, he also has features of excess glucocorticoids. So it's the same adrenocortical carcinoma, remember. The previous gentleman did not have any features of Cushing syndrome. And now we come to a 4-year-old girl who has got again an adrenocortical carcinoma, but what she has got is excess virilization at age 4. She's already developed mustache, her pubic hair has appeared, and she has got significant clitoral enlargement. So the point, once again, that I'm trying to bring home is the same adrenocortical carcinoma under the histopathologist's knife or under the microscope, it's the same adrenocortical carcinoma. But in one, the feature is only feminizing. In the other, it's feminizing plus glucocorticoid excess. And yet in another, it could just present with androgen excess. So the same adrenocortical carcinoma with different features. And this is a SIB pair, both of whom were grossly short. Now, grossly short, we commonly ascribe to growth hormone deficiency. So we did the growth hormone test, which was normal. Then we thought it's because of growth hormone resistance. So we did the IGF-1 test, which is a measure of growth hormone action at the level of liver. Now that was also normal to high. So this is one of the very, very rare instances of IGF-1 resistance causing short stature. Now this is a 16 or 15-year-old girl who was being treated in neuromedicine outdoor because of her epilepsy. Now she also has, as you can clearly find out, a mature cataract in the right eye. So she was referred to the eye department, and the eye department thought that it's not quite all right that a 16-year-old girl should be having cataract. So somehow they referred to us. And then we evaluated and found that she was grossly hypocalcemic. And this hypocalcemia was because of hypoparathyroidism. And so we remember that hypoparathyroidism can give rise to seizure-like manifestations. So this child, this girl was being treated just as an epilepsy, but what she had underlying was hypocalcemia. And so under our follow-up, under our treatment, the calcium levels improved. And over a couple of years, we were gradually able to wean her off the anti-epileptic medications. This is a case of Leydig cells of the testis. They produce excess testosterone even without getting stimulus from LH, which normally happens at puberty because of a constitutional activation of the G protein coupled receptors on these Leydig cells of testis. So this is a rare condition, and this, but triglycerides were high, and she had this typical appearance which suggests lipoatrophy. See, loss of buccal pad of fat, loss of fat over her forearms or over her arms, which makes her muscles look so much prominent. So this is also a case of insulin resistance. Again, if we measure the insulin, it will be high. It will be much higher than in the previous case, but the blood glucose is also high. So we had high insulin with normal glucose in the previous girl with polycystic ovarian disease. This is high insulin with high glucose because the insulin level is high, but the resistance is so severe that even elevating the level of insulin, the body is not able to compensate for the level of insulin resistance. And then we come to this. This is not the patient's photograph, but this is CT scan of abdomen. This was a middle-aged man who was behaving abnormally at times, so he had been taken to a psychiatrist, and nothing came of it. He was put on antipsychotic. He continued to gain weight, but he continued to have abnormal spells of behavior. And so eventually he was referred to us. And when we admitted and did a thorough sort of clinical examination and following up during his hospital stay, we found that he was developing low blood glucose, and those low blood glucose levels were coinciding with these periods of abnormal behavior because of the neuroglycopenia. And so we further evaluated, found that he's got high insulin levels. And then we did a CT scan, a triphasic CT scan, and we found that there was a tumor in the pancreas. It's marked out here, which is an insulinoma. So this is a case where, again, the insulin level is high, but the glucose level is low. So remember, the insulin level could be high with a normal glucose, with a high glucose, and even a low glucose, as in this individual. But of course, after removal of the tumor, he was completely cured of his symptoms. So, ladies and gentlemen, this is a short sort of overview of the exciting and enigmatic world of endocrinology. Hope it helps us understand and appreciate endocrine disorders better, and also the difficulties that we endocrinologists feel time to time. Thank you very much for your patient hearing.
So, thank you so much, sir, for the wonderful lecture. So, with lots of visuals. So, without wasting much time, I will just hand over the session to Dr. Shekhar for the next session.
Thank you, Dr. Kamaya. Next, we will move on to the next session, bone, remodeling and strengthening endocrinology. Can I have the chairperson slide, please? Tech team. Now I introduce Dr. Pankaj Jain sir, who is a consultant endocrinologist at Pratham Endocrine Clinic, Gwalior, and Dr. Suresh Damodaran sir, consultant endocrinologist, Sri Ramakrishna Hospital, Coimbatore. Now I request Dr. Suresh Damodaran sir to introduce our first speaker, Dr. Rishi Shukla sir, who will be speaking about primary hyperparathyroidism, a clinician's perspective. Over to you, sir. Dr. Suresh.
Good morning, everyone. Thank you for the opportunity. I think it is a pleasure to introduce Dr. Rishi. We know him for most of us will know. He's head of department in Regency Hospital in Kanpur, and he's almost got 50 publications, and he's very active in EASD as a speaker and also various organizations. And he's done a lot of talks in RSSDA, and also is very active as a person in the state chair of RSSDA UP. And he's done loads and loads of publication. We all know him in endocrine circle very well. Dr. Shukla, over to you, please, sir. Thank you.
My screen is visible?
Yes, sir. Kindly
My
making
Yes, sir. Yes, sir.
visible? Slides are visible?
Yes, sir. Full mode, sir.
Right, full mode is visible.
No, not yet.
No, sir. Kindly make in full mode, sir.
Not full mode. I have made it full mode. All right. I'll do it once again. Now it is visible?
Yes, sir.
Now
Perfect, sir.
Good evening, friends. Thank you, Dr. Ajay, Dr. Mayur. I was looking at connect. Thank you, Dr. Damodaran, Dr. Pankaj, and I'll take just 10 seconds to compliment you. This is, I think, one meeting that has connected the roots of endocrinology. I was looking who everywhere, because over the decades, the endocrinology is divided into three parts. The general endocrinology, pediatricians call us adult endocrinologist, and then the pediatric endocrinology, they are bifurcated. MD pediatrics is not allowed into general endocrinology, and MD medicine is not allowed into pediatrics endocrinology. And then I was talking to our RSSDI president. He was saying we don't need endocrinologists to treat diabetes, but you are the guys who and collected everyone. So huge compliments. Connecting India together, connecting people together, connecting medical help together. I think this is what we need. We don't need bifurcation, trifurcation, quadrification. We need a union. So that's why I was saying everybody. And if you look the all endocrinologists, pediatricians, they emerge from where? They are all trained somewhere in endocrinology, and then they did. So I'll finish my talk faster. Don't worry. So this is a clinician's perspective about hyperparathyroidism.
Thank you, sir. That is what exactly defines Hormones India, and you rightly encouraged us in this direction, and we are very, very thankful for your words.
Really, thank you, sir, because we had a slight backlash also from some, but it's really encouraging to hear this from you.
I was asking Saurabh Mishra, and he was saying, what is this Hormone India? Then he was giving a very positive young brigade of clinician endocrinologists in the country. So that's nice. So coming to the hyperparathyroidism, it is simply increased level of hyperparathyroid, and geographical differences are present in developed country. It is mostly asymptomatic. See, the basic difference is asymptomatic versus symptomatic in our country. And if you look at India, as usual, the all endocrine is more common in females. And look at this line, 71% of cases were less than 40 years of age, whereas in patients from and here we see patient in a later part. But now I think we have started seeing good number of patients. Last 10 years, a lot has happened. And the mean duration of symptom is almost 5-6 years, the mortality used to be very high earlier, maybe 10-15 years from now. This is the 2011 publication. Look at the number of publications. So we have relatively small contribution of hyperparathyroid publications. A very important component. And Dr. Shubhankar very nicely, I think, mentioned a case of hypoparathyroidism. Eventually, the girl did not need. So calcium is responsible for bone metabolism, muscle contraction, nerve conduction, and various hormone release. And it functions through calcium sensing receptors. Look how much calcium we have. We have almost a kg of calcium, 1 kg, and out of which 1% is stored. 1% is into the circulation. It is available to us. 99% is stored in the bone, and that maintains the calcium. A very short description of a calcium mobilizing hormone. This is the calcium in blood circulation, you can understand. Through calcium receptors, thyroid gland, these are small, tiny parathyroid glands, almost a gram, 0.5 to 1.5 gram, all 4 gram, and it leads to release of parathyroid hormone. I will not be going into detail. And what this parathyroid hormone does, it acts on the bone to release more calcium, and it also acts at the kidney, which helps in reabsorbing calcium. And parathyroid hormone also helps in kidney to convert from 25 to 125. And this 125 from intestine helps, and active vitamin D helps to absorb calcium. And this calcium gives a feedback to bone and to parathyroid. So this is a feedback in a very small nutshell. Hypercalcemia is a common clinical problem. Why this can happen? Because of accelerated bone resorption, excessive GI absorption, and something is happening at the renal level. So decreased renal excretion. Among all, the most important causes are 2, primary hyperthyroidism and malignancy. I think third important cause that I should mention right at the moment is a lot of orthopedic friends give injection vitamin D voraciously. And this is also responsible for bringing about hypercalcemia. So always look at how much vitamin D, whether it is given, because oral vitamin D as such does not give hypercalcemia, but parenteral it gives. The clinical manifestations are, it may be renal, gastrointestinal, musculoskeletal, neurologic, cardiovascular. Look, polyuria, polydipsia are not only part of diabetes mellitus and diabetes insipidus, it can also happen in renal part. The GI disturbances, even pancreatitis, anorexia, nausea, musculoskeletal, proximal muscle weakness is seen in both hyperparathyroidism and hypoparathyroidism. Cardiovascular part. What happens when there is excessive parathyroid? Renal problems, hypophosphatemia, hypomagnesemia, even anorexia leads to anemia. The classifications of disturbances in calcium parathyroids. This is a very simple but very useful slide. Look at parathyroid, look at calcium, and then what is happening. If there is both low parathyroid and low calcium, we are probably dealing with hypoparathyroidism. If PTH is low and calcium is high, so hypercalcemia because of non-parathyroid reasons. It may be vitamin D, as I shared with you, malignancies, thyrotoxicosis. I think 3 to 4% of patients thyrotoxicosis. Immobilization. If parathyroid is high and the calcium is high, most likely we are dealing with hyperparathyroidism. It may be primary or tertiary. If PTH is high and calcium is low, so number of drugs coming into the picture. Lithium again is a very common thing. It may be secondary hyperparathyroidism also. If elevated PTH levels cannot be explained by any condition known to increase secretion, the conditions often termed normocalcemia. So this is a different thing. PTH levels may be elevated as a normal. PTH levels, I mean, whenever there is a small fall in calcium, there is a spike of calcium. So there might be at times a physiological rise, but if PTH is consistently raised, it has a catabolic effect. And that word we give hyperparathyroidism. And coming to hyperparathyroid hypercalcemia, it may be primary, maybe because of, and most commonly tertiary. Secondary hyperthyroidism are renal tubular acidosis, CKD most commonly seen. The another part is the familiar hypocalciuric hypercalcium. This is actually interesting genetic mode, and what happens in hyperparathyroidism, there is an increase, just for the concept understanding, there is an increased excretion of calcium. Here the calcium excretion goes down, and that is the differential point, because otherwise most of the features in biochemistry is more or less same. It affects, it causes stones, bones, thrones, and bones. This is the usual word that we use. So stones at kidney, throwing of urine, bones are affected, painful bones, osteoporosis, fractures, and the psychiatric disorders. This is a very nice look. I mean, if you look at these simple hand X-ray, which are not very frequently seen, very carefully see there is irregular margin. This is called bone resorption. Look at this. There are black and white patches of bone resorption. We classically call it salt and pepper. Salt. And look here. Look here. This is a black part. This is called brown tumor. Again, this is a black part. Brown. I remember a brown tumor was located in the hip of femur, and orthopedic surgeon was ready to operate. The patient was admitted. Then I did a full work, and finally turned out to be secondary hyperparathyroidism. The person was severely vitamin D deficient, and with vitamin D deficiency, the tumor, vitamin D supplementation, the tumor reduced and vanished. What else it can do? It reduces bone mineral density. The glucose intolerance, amount of insulin resistance is seen. Cardiovascular, the hypertension is associated. Arrhythmia, calcium plays a role. Ventricular hypertrophy, rheumatologic manifestations like hyperuricemia, gout, fractures. So it is important. The incidence of hyperparathyroidism in India, insights from Indian. So if you look at two graphs, the upper graph and the lower, the upper graph basically is a symptomatic and lower is asymptomatic. So asymptomatic number has not increased. Symptomatic we are capturing. Only 5% patients were asymptomatic. So that is the tragedy in our country. So whenever you find a more calcium, look at vitamin D, look at injectable vitamin D, and go for parathyroid hormone testing. And if PTH is high, then you need to find out a reason why it is so, and you have to reach at the end point. This is all different institutions presentation, and the most common clinical symptoms are weakness, fatigability, bone pains, and renal stones. India versus developed countries. We have the most common presentation in terms of bone, the fractures, renal disease, pancreatitis is also, but as against West, where they have more than 80% asymptomatic. So friends, a lot of investigations, there are a lot of labs are doing lots of investigation, free labs, 300 rupees, 80 tests. I think grab the calcium, grab vitamin D, and go for PTS. PTS is not regularly being done. It is not required also. Brown tumors, as I shared with you, large bone cysts due to high osteoclast activity. Another brown tumor. Diagnosis I shared with you. The primary, secondary, and tertiary. Primary, high calcium, low phosphate, and hyperthyroid. Secondary, calcium is usually normal or low because it is associated with a vitamin D deficiency. Phosphate is high, so that is again, but we need a NAV patient. Most of the patients are already given a lot of calcitriol, vitamin D, and whatnot. And tertiary, calcium may be normal or high, PTH is high, and it is without it is autonomous high and associated with renal disease most of the time. What are the causes? Most common cause is adenoma. Sometimes we see glandular hyperplasia, and small, very small percentage is associated with a carcinoma. Conditions associated, thiazides, which is very commonly prescribed. Thiazide diuretics reduce urinary calcium and therefore can cause possible transient mild hypercalcemia. So that is again a very important thing. Whenever hypercalcemia is there, look for lithium, look for excess vitamin D, look for thiazide. Lithium, again, so this is another part that I've already mentioned. How to manage symptomatic versus asymptomatic. Symptomatic means there are bone pains, there are fractures, there are nephrolithiasis, there is a osteoporosis, remove abnormal parathyroid gland or adrenal. And asymptomatic is a little controversial. So asymptomatic, if the calcium is high, then person should be operated. Skeletal, if there is osteoporosis, then should be operated. Renal, if there are renal stones and recurrent renal stones, number one. And number two, if there is a renal deterioration, this is the time it should be operated. Suppose patient is not willing, what to do? For patient whose primary indications for surgery is symptomatic or severe hypercalcemia, then cinacalcet should be given. For individuals who are unable to have surgery and primary indication is osteoporosis, then bisphosphonate, and most commonly tried bisphosphonate is alendronate. If there is no need to improve bone density or lower the serial condition, don't do anything. Just keep observing yearly or 2 yearly basis. What to do? Should you give vitamin D or not? It should be given with smaller doses. Vitamin D and calcium also should be given a small amount, and keep a watch. Like this is a trial in a randomized trial of calciferol versus placebo in 46 patients with primary hyperparathyroidism and hypovitaminosis. Vitamin D supplementation raised PTH and reduced parathyroid. So look at vitamin D deficiency, is there or not associated? Give maybe half doses of vitamin D as a maintenance. So it should not be stopped. Preventive measures, avoid factors that aggravate hypercalcemia. I think this is very important. You can always stop thiazide diuretics, you can always stop lithium, excess vitamin D. So these are all, and then encourage physical activity to strengthen the bone, and adequate water, adequate hydration to avoid the hypercalcemia. Pregnancy, most likely it is better to operate in second trimester. If it is mild, you can wait and watch. But most important thing is neonatal complication like hypocalcemia and tetany secondary to fetal. So baby or the neonate can have a very severe hypocalcemia, and that should be taken care of. And that should be informed to pediatrician or a neonatalologist. Parathyroid crisis. If the calcium is very high, it can give rise to change in mentation, abdominal pain, nausea, vomiting, pancreatitis. And it may be due to intercurrent illness, volume depletion, infarction of the gland. So multiple reasons are there. Familial hypocalcemic hyperparathyroidism, I have already spoken. Biochemically, it is same, but if you go for 24 hours urinary calcium and creatinine ratio, there is also single sample of calcium and urinary creatinine ratio. But if 24-hour urinary calcium in respect to creatinine is less than 100 milligram, most likely we're dealing with hypocalciuric hypercalcemia. Then you need to go for genetic analysis and go ahead with that. Normocalcemia with hyperparathyroidism. There are many causes of secondary hyperparathyroidism. It may be physiological, it may be because of renal, intestinal. I think I'll not be going into detail because this is very useful but a little lengthy, and I'm aware that you guys are running a bit of time lacking. So normocalcemic primary hyperparathyroidism, I think Dr. Ajay wanted me to speak only on this, but I thought let me cover the entire thing. And look here at findings from small cohort studies that normocalcemic may progress to hypercalcemia in certain portion, 6 to 9%. So we have to have a very close watch. Progression from mild to severe form may occur in all patients with primary hyperparathyroidism, and if the disease progress, it is slow process. Progression of complications, including nephrolithiasis, osteoporosis. So everything can happen. Only thing is immediate surgery is not required. You have to keep a very close watch. And normocalcemic means simply parathyroid is more, calcium is normal, bones are normal, there is no nephrolithiasis, there is no renal insufficiency. Hungry bone syndrome, a subset of patient severe hypocalcemia is seen. We need to supplement calcium immediately after surgery. So that is very important. And studies on long-term follow-up, and this is, I think Ajay will be happy, GPGI's data. And what was reported that long-term follow-up after parathyroidectomy, 2 to 13 years was reported. Alkaline phosphatase is normalized. Healing of cortical bones occurred in 2 to 7 months. At a median follow-up 3 years, the gain in bone mineral density was 48%. So there was a huge gain. So osteoporosis inclusive parathyroid. If we treat the cause, we don't need to treat osteoporosis as a separate entity other than. So this is a very nice data of bone improvement. If there is a recurrent hyperthyroidism, then I think if there is hypercalcemia, you give sinacalcet, hypophosphatemia, better to take care of parathyroid, maybe re-exploration. Now the question is transplant versus hyperparathyroidism. Suppose there is a primary hyperparathyroidism and patient requires transplant creatinine 7 or 8. What is first? The ideally parathyroidectomy should be done first, so that at least one thing you have removed. So parathyroidism is not so uncommon problem. We should keep an eye, and whenever calcium is more, we have to look at the reasons I shared with you. Excess vitamin D supplementation, inclusive of injectable vitamin D. Chlorothiazide or thiazide is the number 2 cause. Lithium, you look at it, and then look for any other reason. And if PTH is more, you tend to reach at the end point. Thank you so much for your kind attention. I think over to you. I believe I finished on time.
Yes, sir, you're well on time, and thank you very much. I would like also to share that we had close to 3,000 registration for this conference, and we are also running live on YouTube with close to 600 viewership. There are many questions, but due to lack of time, we'll just take one question, which is very pertinent. One of the doctor has asked, in CKD, how do you differentiate primary versus tertiary hyperparathyroidism? A quick answer, sir.
I think in this, calcium is most of the time is not raised. If calcium is not raised, most likely, and the background of CKD, most likely we are dealing with tertiary.
Okay.
With a raised calcium, I believe the question would be with a raised calcium, primary and tertiary, how to differentiate?
With the raised, I think it goes because in renal insufficiency, most of the time hypercalcemia is not seen. And if it is raised, then what we need to do, we can go for ultrasound or we can go for a maybe scan if there is a tumor, one tumor. Otherwise, tertiary hyperparathyroidism, what happens? There is a generalized hyperplasia. If there is a tumor, possibly we are dealing with primary. If there is no hyperplasia, most likely, if there is no adenoma, most likely we are dealing with tertiary. Because there is background, of renal background is there, and that background is very important. Yes.
So I think any hypercalcemia in CKD should be first diagnosed as tertiary unless there is very specific indication for primary hyperthyroidism, there adenoma or some clear-cut thing. Because
we have to screening plays because most of the time it is clinically, if you look the background of renal failure, and most of the time hypercalcemia is not there. Most of the time,
there will be history also, like very uncontrolled secondary hyperpara followed by tertiary, that is leading to tertiary. That is what scenario will be in tertiary.
Yeah, then I think the localization plays a very, very important role. If you can localize adenoma, then it's important.
Thank you, sir.
And I think one last point I can simply add, sometimes we are not able to localize parathyroid tumors. I mean, even with now, we do ultrasound is the first line of action, then maybe scan number 2, and then we do 4D CT. Even then we are not applied. And I think very recently, one of my patients, the most sensitive marker is surgeon's finger. We requested her to get opened and they found adenoma and PTH went down. So that is another clue. I mean, still even now, and most of the well-to-do, understandable patients will not be ready to get themselves operated.
Yeah, that is what our surgeon friends tells us, like regarding parathyroid.
Surgeons, if the surgeon is good, they can do
it. Dr. Ramya is already joined, so like to that. Okay.
Thank you so much for the opportunity, and thank you. All the best for your meeting.
Thank you, sir.
Thank you, sir. Now moving on to the next session, I would like to request Chairperson Dr. Pankaj Jain sir to introduce our next speaker, Dr. Rajesh Verma sir. He will be speaking about management advances in hypoparathyroid. Over to Pankaj Jain sir.
Sir, kindly unmute, sir. Pankaj Jain sir.
Introducing Dr. Rajesh. He is MD Medicine from the same place, GR Medical College, Cavalier, and doing DM endocrinology from the PHU. My alumni, having more than 15 years of experience of teaching a undergraduate and postgraduate, received Endocrine Society of India AB Gandhi Award, a prestigious award, having a lots of publication, and discussing the recent advances in management of hypopara. As such, we knew electrolyte always add electric current in endocrinology. And the conventional treatment is always the vitamin D, active vitamin D and calcium. But there is much more in the recent advances. So over to Dr. Rajesh Verma.
Thank you, Dr. Pankaj Jain sir, for introducing me. Let me share my screen.
Yes, sir. Perfect.
So am I audible and visible?
Yes, sir.
Okay. So at the outset, I would like to thank Dr. Mayur for making me a part of this conference, and congratulations to all your team for organizing this conference. So the topic I am talking about today is recent advances in the management of hypoparathyroidism. So first, I will be talking about gloss overview and few slides about the clinical features and management, and followed by comparison of conventional therapies, their limitations, and recent advances, as well as some molecules in the pipeline of management of hypoparathyroidism. So to start with, so what is hypoparathyroidism? So it is a disease characterized by the absence or inappropriately low concentration of circulating PTH hormones, which leads to the hypocalcemia, hyperphosphatemia, and elevated fractional excretion of calcium in the urine. So the role of PTH is in promotion of the renal reabsorption of calcium, stimulating renal phosphate excretion, and promote conversion of 25-OSD to active form of vitamin D, and it is a powerful regulator of the bone turnovers. So how PTH controls the mineral metabolism? See, this is low serum calcium level. It is sensed to the CSR receptors on the parathyroid cells, and CSR receptors, their stimulation increases the PTH in the circulation. Now this PTH goes and acts at the 3 levels. It goes to the bones, causing the bone resorption and thereby increasing the serum calcium levels. Secondly, it goes to the kidneys, thereby has an important role in conversion of 25 OSD to active form of vitamin D calcitriol, 125 OSD, which promotes intestinal absorption of calcium and thereby increasing the serum calcium levels. And thirdly, it increases calcium reabsorption from the kidneys. So all the effects of the PTH are to increase the serum calcium and decrease phosphate into the serum. And all this metabolism is tightly regulated. So when the actions of PTH are reduced or lost, all subsequent steps of maintaining the homeostasis are impaired and resulting in hypocalcemia, hyperphosphatemia, and hypercalciuria. Now, this is a gross overview of regulation of PTH synthesis, secretion and action, and associated genetic disorders. So they are broadly categorized, and at the cellular level, at the cell membrane level of PTH, whether PTH or target cells, it is autosomal dominant hypocalcemia as well as autosomal dominant hypocalcemia and Bartter syndrome. And syndromic hypopara, where transcription factor defects are present, and they are categorized as transcription factor defects like Kane's hair, Melas, MTP deficiency, Kenny-Caffey, Sanja-Sakari, Di-George, Charge, part of APS type 1, SDR, Kenny-Caffey. Isolated hypopara occurs when the defect is at the PTH synthesis level or at the PTH secretions level. So the most common cause of hypopara is surgical, post-surgical hypopara. It is followed by the idiopathic as well as autoimmune. The genetic basis of hypopara forms a very less but very important topics. So they are broadly categorized into five categories. There is the isolated, forming the autosomal dominant, recessive, or X-linked. Congenital multisystem disorders like Di-George and Bartter, metabolic disorders, autoimmune disorders as a part of PPS1, and parathyroid resistance syndrome, pseudohypopara. These are simple pictures showing the clinical manifestations of hypopara. So most of the clinical manifestations of hypopara, they are associated with the peripheral nervous system. So paresthesia, muscle cramps, and tetany. They are very much common and most common clinical features. Whereas less commonly encountered, but more important, they are calcifications, especially in the basal ganglia, cerebellar calcifications, cardiovascular clinical features like cardiac arrhythmias and cardiomyopathies, respiratory system causing laryngospasm, renal system associated with nephrocalcinosis and lithiasis, thereby increasing the chances of chronic kidney disease when the patient is on therapy. Neuropsychiatric symptoms like anxiety and depression, cataract, very common clinical feature of hypopara, altered tooth morphology, skin manifestations in the form of dry skin and onycholysis, musculoskeletal system in the form of myopathy and spondyloarthritis. So these are very common clinical manifestations, but the most commonly encountered are muscle cramps, tetany, paresthesia, basal ganglia calcifications, as well as nephrolithiasis and calcinosis when patient is on treatment. Now, this is a picture of showing extraskeletal calcifications. So this is a coronal picture and sagittal picture, CT head of the individual in hypopara. This is showing extensive symmetrical calcifications involving the subcortical white matter, basal ganglia, as well as the cerebellar areas. And this is the abdominal CT of an individual with long-standing idiopathic hypoparia, and which is on treatment, showing the bilateral large stones. And the largest one is the staghorn calculus. Now, the discussion of today is management of hypoparathyroidism. So the conventional therapy is what we have been using and still commonly used is oral calcium in the form of calcium carbonate or citrate, and the active form of vitamin D in the form of calcitriol. And thiazide diuretics when the patient is not adequately controlled, maintaining eucalcemia after these oral calcium and active vitamin D, or there is increased incidence of nephrolithiasis or calcinosis. So thiazide diuretics may be added, and they increase the reabsorption of the calcium at the distal tubules, and magnesium supplementation in those refractory cases. But the majority of treatment is with oral calcium and active vitamin Ds. So this is the tabular form of the dosage forms. So the typical doses of calcium carbonate and citrate are 1 to 9 grams, and 1 to 9 grams in 2 to 4 divided doses of calcium. Vitamin D preparation, they are used as ergocalciferol or polycalciferol, to maintain the serum vitamin D level of more than 30 nanogram per ml. Now, various studies have suggested that if we are using vitamin D as a treatment of hypopara, then a very large amount of vitamin D may be required, approximately 40,000 to 1.2 lakh units per day to maintain the eucalcemia. So calcitile forms the molecule of choice, vitamin D molecule of choice in management of hypopara, and it can be given up to the dose of 2 microgram, but usually 1 to 1.5 microgram are more than sufficient. Alpha calcidol, it can be given up to 4 microgram per day. Thiazide diuretics, when the patient has high risk of nephrolithasis and calcinosis, so hydrochlorothiazide, chlorothalidone, indapamide, and amiloride, they may also be used. Now, there are a few limitations of these conventional therapies. First, it does not replace the other functions of PTS. They can maintain the eucalcemia as well as phosphatemia, but they do not have the effect of decreasing the renal excretion of calcium. And they have unpredictable occurrence of hypo as well as hypercalcemias. There is increased calcium phosphate products of more than 55, thereby increasing the ectopic calcifications like nephrocalcinosis, nephrolithasis, and renal dysfunction possibilities are more. So the emerging treatments, teriparatide. First to discuss is teriparatide. So PTH 134, it has been evaluated in a number of studies in adults as well as pediatric patients with post-surgical hypopara and permanent hypopara from other causes. And it appears to be safe and efficacious. Urinary calcium in PTH 134 treated patients, they were decreased when injections were given once a day compared to calcitile treated controls. Second, in a study of 14 children treated with twice daily PTH for 28 weeks, once daily injection, serum calcium, magnesium, and urine calcium parameters, they were better controlled in twice daily injection compared to once daily treatment, especially in the second half of the day. And when PTH 134 was given by an insulin pump as compared to the continuous infusion, urine calcium reduction by 50% and serum calcium was near normal with minimal fluctuations of compared to twice daily injections. And there is improvement in mental as well as physical health has been reported. So we have 3 types of studies. First study, once daily PTH injection versus calcitile oral. Second study is comparing once daily PTH injection versus twice daily PTH injections. And third study, comparing twice daily PTH injection versus infusion pumps. So let's discuss one by one. So this is the first case report of a once daily PTH subcutaneous injection given over 4 days in a 14-year-old boy with post-surgical hypopara. So these blue dots are for serum calcium and these red dots are for serum phosphate. Now you see that serum calcium level, they are gradually increasing, and phosphorus levels, it is gradually decreasing. Similarly for calcium and phosphorus in the urine, so calcium in the urine, it is gradually decreased, and phosphorus in the urine is gradually increased. Now, this second study, the serial urinary calcium levels in response to PTH 134 versus calcitile and calcium in the adults with hypopara. The repeated measures of urine calcium excretion after subcutaneous 134 injection given at time 0, biphasic response, and overall decrease in the calcium excretion, calcitile and calcium retaining effects on the kidney, and led to a rising urine calcium excretion. So urine calcium levels, this is the PTH and this is the calcitile. So you can see the urinary calcium level, it is gradually decreased, and this calcitile levels, urine calcium. Now this again graph, this is showing the serial every 2-hourly serum calcium levels comparing PTH 134 delivered by the twice daily subcutaneous injection versus insulin pump in children with hypopara. So these dotted lines, these are for injections, and this continuous line is for the pump. Now you can see when injections were given twice daily, the serum calcium level is toward the low normal level, but there is wide fluctuations. But when it is given with the pump therapies, then serum calcium level is towards the normal level, but there is less fluctuations. Similarly, the serum urine calcium excretions levels compared with PTH 34 by twice daily injection versus pump. So this is urine calcium levels, and you can see that when patient is given injection with subcutaneous injection, there is wide variations of the urine calcium level, where there is sustained urinary calcium reabsorption in pump therapies. Now another graph, the difference between once daily PTH and versus twice daily PTH. So for serum magnesium levels, these are serum magnesium levels, and their magnesium levels is improved during the latter half of the day with twice daily PTH injection. So this is once daily PTH, these red dots, and these white dots are twice daily PTH. So you can see serum magnesium levels, they are gradually increased to upper normal, low normal limit, but as compared to the once daily PTH. So twice daily PTH injection has a favorable effect on serum magnesium levels. Now, this graph, this is serum magnesium levels in pump therapies versus twice daily. This is subcutaneous once daily versus twice daily, and this is subcutaneous twice daily versus pump therapy. So you can see subcutaneous twice daily, although it has a favorable outcome, but the pump therapies has a very sustained effect, and there is very less, almost negligible fluctuations of serum magnesium levels. So pump therapies is considered is superior to twice daily injections. So continuous PTH administrations, it mimics the endogenous PTH secretion. It normalizes serum calcium level, phosphorus levels, urinary calcium levels are, urinary calcium excretions decrease, bone remodeling, and magnesium levels are improved significantly. So continuous exposure of PTH, it provides a highly physiological effect to reverse the biochemical derangements that are hallmark of hypopara. The recombinant human PTH, it is first approved form of PTH, and it was approved by FDA in January 2015. So it is indicated for adjunctive treatment in management of hypopara in individuals not adequately controlled with calcium, active vitamin D, thiazide diuretics, or maximum therapies. And the RHPTH in an open label trial of 27 patients treated with RHPTH 184 every other day at the 100 microgram dose for 4 years, it showed that all patients have stable serum calcium and were able to reduce their calcium and active vitamin D supplementation significantly. Now this landmark replace trial, it is done with RHPTH 184 and showed that 50%, 53% of treated subjects, they were able to reduce their supplemental calcium and active vitamin dose by 50%, and nearly 43% they were able to completely stop all active vitamin D and calcium supplementation by PTH injections alone, or calcium dose reduced to less than 500 and maintaining all serum calcium and phosphorus levels. And the various side effects like muscle spasm, hypocalcemia, paresthesia, headaches, and nausea, they were observed, most commonly observed, and they are those receiving PTH compared to placebo. But these occurred during the dose titration or at the beginning of the study. So what are the indications of use of PTH 184? So expert opinion on the first international conference on management of hypopara to guide the use of full-length recombinant human PTH. It was published in JCM in 2016. So RHPTH therapy is indicated in those patients who have inadequate control of serum calcium, hypocalcemia, or erratic swings to hypocalcemia or hypercalcemia on conventional therapies. Second indication is dose of supplemental calcium more than 2.5 or active vitamin D doses more than 1.5 or more than 3 microgram of alpha calcium. Third indication is when there is renal involvement with hypercalciuria, nephrocalcinosis, lithiasis, or reduced creatinine clearance or progression to the CKD on conventional therapies. And another indication is hyperphosphatemia or a calcium phosphate product more than 55 leading to nephrolithiasis and calcinosis on conventional therapies. Patients suffering from GI disorders or post-bariatric surgery, those are associated with the malabsorption of calcium. So they are also an indication. And when there is reduced quality of life from conventional therapy. So these are few indications for consideration of RHPTH therapies. Now the few future therapies, RHPTH 184, it is already approved. PTH 134, it is individualizing dosing, should be administered twice daily or even thrice daily injections. Another molecule in pipeline is transcon PTH. It is inactive product of PTH designed to achieve an infusion-like profile by liberating sustained PTH in a sustained fashion. Another molecule, PCO 371, it is less potent than PTH and effects were more long-lasting than those of PTH 134 or 184. And this molecule, long-acting PTH, this is prolonged and enhanced effect on blood calcium levels in hypoparathyroidism. So what are the gaps in management of hypopara patient right now? There is a lack of technology to continuously monitor endogenous calcium levels because calcium level fluctuation, they vary widely with exercise or general illness. So a device for monitoring of calcium to allow for the dose adjustment in response to fluctuations in blood calcium would facilitate such titration. So such a continuous calcium sensor in combination with PTH delivery by pump device, it could constitute a transformative closed-loop artificial parathyroid system for hypothyroid patient, just like similar for CGMS as well as CGMS plus insulin delivery systems for diabetes. So continuous monitoring device for calcium and PTH therapy should be short of. So to conclude my talk, the prevention of long-term complication of hypopara is still unknown, and PTH therapy is likely to be most effective when administered in physiological manner that minimizes serum and urinary calcium fluctuation, particularly most useful in decreasing the urinary calciums. And yet, large and long-term studies testing the continuous PTH exposure are lacking. Thank you.
Thank you, sir, for that lucid presentation. I think most of the questions that I have asked have been covered in this. So we'll move on to our next session, sir. Thank you.
Thank you.
Thank you, sir.
Now, moving on to the next session, I would request Dr. Suresh Damodaran, sir, to introduce our next speaker, Dr. Ramya Valiveru, ma'am, who will be speaking about focused parathyroid activity.
Good morning to all. We got Dr. Ramya Valiveru. She's a consultant endocrine and breast onco surgeon. It's nice to have a surgeon in a conference of our.
I think we lost him. Pankaj Jain, sir, are you there?
Yeah.
Sir, please go on.
So already discussed Dr. Ramya.
Ask Dr. Ramya to take over, please.
Yeah, I'm very happy to be here. And thanks
You're
for
muted,
the
madam, I think.
Yeah, you are audible.
Yeah. So good morning, everyone. I'm so happy to be presenting at this forum, especially because I had a great time at SGPJ with my colleagues, Dr. Ajay, Dr. Mayur, and Dr. Harsha. I'm so happy to present on focused parathyroidectomy. So I hope my screen is visible.
Yes, it's visible.
Please, you can start. You can.
Is
yes,
it full mode? Yeah. So autonomous parathyroid hypersecretion is mainly caused by adenoma and in some other cases caused by hyperplasia. And surgery for these cases is the curative option, and especially in symptomatic patients, it becomes the only curative options. So there are a few types of parathyroid surgery for primary hyperparathyroidism. Predominantly, we can classify them into bilateral approach, unilateral approach, and focused approach. In bilateral approach, the surgeon explores all 4 parathyroid glands and visually compares them to identify the abnormal glands and decide on how much extent of parathyroid surgery to be performed. And in unilateral approach, surgeon identifies 2 glands on the same side of the neck and removes the abnormal one. This is especially used if there is a confusion regarding whether it is a superior or inferior gland. In focused approach, however, only the one abnormal gland, the presumed single adenoma, is identified and excised. So the difference between the classical, that is bilateral exploration, and the current approach, that is focused, is that in bilateral, the surgeon is depending on his experience on whether that gland is abnormal or not, based on certain aspects that he might recognize to be abnormal, like the size, like the number, and depending on the history and examination and all those. Whereas in focused approach, the surgeon has to rely on non-visual confirmation for determining cure, like the intraoperative adjuncts, that is frozen section and intraoperative PTH assays, that I'll be talking in detail. So why surgeons have moved on from a generalized approach to focused approach is that there are a few advantages. Number one is the starting short operating time, and definitely there is a lower risk of injury to recurrent laryngeal nerve, as we are not interfering with dissecting in larger areas, and especially if it is on both sides. As we all know, parathyroids are in close association with recurrent laryngeal nerve. And obviously, when we are exploring, the blood supply to parathyroids is by very small twigs of arteries, which can even go into spasm. And even though the gland is visually not damaged, the unnecessary insult to the arteries can cause hypoparathyroidism. And obviously, because the incisions are going to be small and the exploration retraction is going to be less, there will be less post-operative pain. And because of the smaller incision, there will be more cosmetic appealing, and the scar tissue is going to be less. So what is the definition of focused parathyroidectomy? So excision of a single abnormal parathyroid gland via a small incision with just minimal surgical flap elevation without exploring other parathyroid glands. So the prerequisites then form, the surgeon has to be sure of whether it is actually a PHPT and not a familial hypocalciuric hypercalcemia or other diagnosis. And there should be only one abnormal gland, and there should be concordant preoperative imaging. Mostly we use high resolution ultrasonography and functional imaging in the form of sestamibi SPECT CT. And all efforts should be made to rule out the possibilities of hyperplasia, because that becomes the absolute contraindication for this focused exploration. And there should be availability of intraoperative PTH assay and frozen section to have good success rates. So a focused exploration in concordant imaging is successful even if the facilities of intraoperative PTH imaging is not available in about 96% of the patients. So for a successful approach, that is via focused approach, the surgeon needs to know where to look for, that is the localization studies can guide, and surgeon should know when the surgery can be concluded based on the adjuncts. So how do we approach in focused parathyroidectomy? So it's a team management. It's very important to work in conjunction with the endocrinologist. And that is what we used to do day in and day out at SGPGI, that we were in fact, our wards were across and we were in close coordination for almost every case that we operated was in conjunction with the team of endocrinologists. So I need not again emphasize that inappropriate elevation of serum levels of parathormone for the level of serum calcium is the definition of PHPT. And the most common cause for such PHPT is a single adenoma. So that is where that we can manage most patients with focused approaches. So a thorough clinical history to look at the severity of the disease and to assess the end organ damage and to assess for associated other organ disease in this patient and to detect and rule out familial disease by 6-question panel for MEN1 assessment is very important, because if we have any clue that this could be a multi-gland disease, then we should not choose focused approach. So biochemical tests to establish the diagnosis and the imaging to assess the severity of the disease, and pre-operative localization in terms of resolution of high resolution ultrasound with color Doppler, sestamibi, and 4D CT we used to use in very selective cases. Though it gives excellent visualization, the availability and the radiation exposure is significant. So we use it in selective cases, and alternative imaging, functional imaging like choline PET are also useful. So I would like to emphasize a few points on preoperative localization, because this is very important. Surgery focused approach is not just about the surgery per se. It's also about proper planning and then proceeding in a very systematic manner. It's actually a multiple steps put together that is going to determine the success of the outcomes. So on ultrasonography, we generally perform, surgeon performed ultrasonography ourselves. And what we look at is the classical description of an adenoma is a well-defined homogeneous hypoechoic lesion with hyperechoic rim separately visualized from the thyroid margin with a polar vessel entering into the gland. However, we have seen in many cases in our own experience that the glands can be hyperechoic, They can have cystic areas if it is especially a large one or a long-standing one. And it is important to identify any coexistent thyroid disease, which if present needs evaluation, and it can be addressed in the same sitting if needed. So generally, how we determine if it is a superior or inferior is based on the position and in relation to the nerve. A superior parathyroid adenoma is in close relation to the capsule of the thyroid, generally more posteriorly located in relation to the superior pole. Inferior gland is found at or near the posterior aspect, and in fact, most of the times it is anterior to the nerve and just distal or lateral to the inferior pole of the thyroid. So this picture I've taken from the web because it depicts all the features that I was just talking about. This is the parathyroid adenoma. This is a vessel, carotid artery, and we can see a polar vessel entering into the parathyroid adenoma. As we can see, it is homogeneous, and of course there are some more hypoechoic areas, and it is separate from the thyroid, and there's a clear demarcation on this. So system EB becomes very important, especially it gives us confidence that in fact this is the abnormal gland, and though less commonly we may visualize more than one gland, but however in case of multi-gland disease, a negative SPECT actually discourages us to take a focused approach. So in system EB we acquire planar and oblique images. Especially oblique images become important in guiding us in which plane to look for, and it can help us locate ectopic locations, or sometimes the inferior gland is more down into the cervical limb of the thymus. And especially in the mediastinum, especially in the descended superior or inferior, how we differentiate is a descended inferior gland is going to descend into anterior mediastinum because it's more anteriorly located, whereas a descended superior gland is going to be in the posterior mediastinum. So it is going to completely change our approach for focused. And sometimes, rarely, aortopulmonary window parathyroid adenomas have been reported, and the only way to know their location is via system EB SPECT CT. So this is an example of a classical SPECT CT where on the planar images we can see abnormal retention in delayed scans, and that is how they're going to light up in the SPECT CT. Actually, this gives us an excellent plan. It's like a Google Map road path for exploration. So what is the best localization for parathyroid? Yeah, this is not said by me. Locate a parathyroid surgeon. This is said by Irwin et al. And Udelsman et al. That the experience of the parathyroid surgeon, the training is what is going to determine the success. So if available, genetic assessment is going to preclude the possibility of focused approach. So what are the principles, or what are the checklists as a surgeon that I will look at before proceeding on to surgery? Is that there should be an undoubted proof of biochemical proof of the disease, and there should be pre-operative concordant imaging. And the patient, I'm very careful while shifting because in fact, I don't shift the patient into the theater without my presence, because these patients have fragile bones, especially in India. And we had instances where during shifting, patients sustained significant fractures, and we have to inform the labs prior. Careful planning is very important because the success is going to depend upon the IOPTH and frozen section. It can be performed either under GA or local anesthesia. And in fact, during intubation, the anesthetists are also to be very careful not to hyperextend the neck for intubation. And even for our position, the classic rose position is not possible in many cases because the bones are fragile. And in some cases, we have used central venous access for two reasons. Number one, even in case of severe disease, we are anticipating a need for IV calcium postoperatively. And as we know, calcium is an irritant, and the patients cannot tolerate calcium through peripheral lines, and it's going to thrombose. And the other thing is the ease of sampling, because we are going to take multiple samples for intraoperative parathormone estimation. And it is very important to carefully sample to make sure that the sampling is correct. So before giving an incision, we do surgeon performed ultrasound and just place our incision in the crease of the neck, in the closest area possible on the adenoma that we have localized. And we decide whether we want to go via a lateral approach or a midline approach, depending on the location of the adenoma. And the most important is to use a no-touch technique. We do not touch the parathyroid capsule at all. We're always outside the capsule. We hold on to the fat or the soft tissue around the adenoma. It's very important to identify recurrent laryngeal nerve because these are in close relation, these are glands are in close relation with them, and any injury with the energy devices can cause post-operative voice changes. So there should be very gentle dissection, and it's one of the gentlest surgeries, and the field should be absolutely bloodless. And one has to understand that parathyroid adenomas can be of bizarre shapes, and it is important that sometimes the glands are bilobed, and we can just it is sometimes possible that we are incompletely excising because we have failed to identify that small extension that is going here and there, and complete removal is very important. Remove as much as even if you feel that additional tissue has to be removed, that also has to be removed. If adherent to the thyroid because of large gland having some inflammatory reaction, it's okay to remove a part of thyroid, but never retain any abnormal parathyroid tissue inside the body. So this is one of the cases that we had, that this is, as we can see, the adenoma is in close relation. It's beyond the inferior part of the thyroid, and it's clearly separate from the thyroid. And this is in fact the adenoma after the excision. So why is parathyroid surgery called a parathyroid exploration? It's actually an expedition that the surgeon goes on, because even if we have a concurrent imaging, it's not always possible to identify the gland. And even if we identify the abnormal gland, sometimes with associated thyroid disease, like for example, in this case that I'm showing on the right, there was Hashimoto's thyroiditis, and there were multiple inflammatory small lymph nodes. In fact, the one here is actually a lymph node, which can be confused easily with a parathyroid gland, especially if the size of the abdominal gland is small. So one has to be very careful in deciding. So we actually follow a surgical algorithm. We explore on the preoperative localized side, and then if even in focused approach, if we can't localize, then we go to check other normal locations. And we should not take a back step if even if started with focus, if we can't find the abnormal gland, then we have to convert it into bilateral exploration. And this is how we actually go about. We are aware of the normal locations, expanded normal locations, and ectopic locations, depending on whether it can be a superior parathyroid or an inferior parathyroid. And so for this, a clear embryological knowledge is important. In fact, the endocrine surgeon called the parathyroid surgery is not an anatomical surgery, it's an embryological surgery. So the heavy parathyroid tumors can track because of gravity into abnormal locations, especially, as I said, superior glands can go in retroesophageal locations, right, or into the superior mediastinum, and the inferior can go down into the thymus because of embryological, or anterior path into superior mediastinum because of gravity. So the surgical management of PHPT is successful in more than 95%, and in hands of specialists, the morbidity rate is very less, that is less than 1%. And in most common causes of recurrent persistent disease, the number one cause is an unlocated parathyroid adenoma, despite having a good concordant imaging preoperatively, because untrained surgeon can easily miss or confuse or abnormal adenoma with other structures. And the other reasons being, yes, of course, hypoplasia and undiagnosed second adenoma, a parathyroid carcinoma, or incomplete removal of parathyroid swelling. And coming to the adjuncts, the main adjunct is intraoperative parathormone protocol, which leverages on the short half-life of PTH hormone, that is 3 to 5 minutes. And it is possible only in centers where there is a turbo intact PTH assay, where the incubation time becomes only 14 minutes versus 60 to 90 minutes for the classical assays. And the turnaround time is about 20 minutes, and the sample has to be collected meticulously, about 3 to 5 ml, avoid hemodilution or hemolysis while collecting the sample. And at each facility, the surgeon should use consistently a particular practical protocol and use the same over and over again, because the goal to cure about 97 to 99% of PHPT patients via focused approach. So this is how we note down the timings and the values for each patient at our center. And what we used to use is a modified Miami criteria, where we take pre-incision, pre-excision, 5, 10, 15 minutes post-excision samples, and then we define cure as more than 50% drop of PTH at 10 minutes compared to the pre-incision or pre-excision, whichever is the highest. This has given us a cure rates of about 95 to 99%. And if the surgery, there is no drop, we look at the post-excision trend. If there is a decreasing trend at 15 minutes, especially if there is renal disease, we expect a little later fall. So then if there is a trend of decrease, we may still can wait and repeat samples at some more samples. But if there is no fall at 10 minutes, no significant fall, and surgery is not convinced, then we should not take a step back to explore further. And frozen section is important to confirm parathyroid tissue, not to diagnose. It cannot tell us whether it is hyperplasia or adenoma. And it can tell us if we have removed a lymph node, or sometimes even thyroid nodules, adenomatous nodules can look like, detached ones can look like parathyroid. So post-operative course, it's very important to involve endocrinologists, and if depending on the need, to give IV or oral calcium and vitamin D supplements. And hungry bone syndrome patients may need aggressive treatment with even magnesium supplementation, and these can be gradually tapered. So the studies have shown that the outcomes for focused exploration are comparable to bilateral exploration, with similar success rates, with much less complication rates, and a 7-fold reduction in length of hospital stay, and much significant less hospital cost. And even if, in fact, it is even confirmed in randomized controlled trials, multiple of them are there, and even meta-analysis have shown us to have comparable outcomes with much less complications and significantly less operating time. So there are other types of focused parathyroidectomy other than what I have just shown, like the radio guided, where we use a gamma probe to locate the abnormal gland, and video assisted minimally invasive techniques are also currently done. There are remote access surgeries, which necessarily are not minimally invasive. They in fact need a wide raising of flaps, and surgeon has to be very, very meticulous. Otherwise, seedling of parathyroid tissue can happen and can result in recurrence. So the only advantage of these remote techniques is just avoiding a small scar in the neck, unlike thyroid, where we may require a big incision. For focused approaches, even a 2.5 centimeter is sufficient, as I will demonstrate in the video. And whether we use video assisted or open, there is no impact on the post-operative recovery. So I would like to show a small video. I hope we have time for this.
Yeah, Ramya, we can quickly finish as time is running short.
Yeah. So I'll just fast forward it for the sake of. Am my screen visible?
Not you're not visible.
Is it visible now? So this is how. Am I audible?
You are audible.
Yeah, this is how we are going to mark the incision.
Your audio, like video, is not coming. I think you can reshare or something.
Okay.
I think you can share it on the chat box.
Sure. I'll do that.
Yes.
We can play.
Can I play?
Chat. You can just paste and then click that.
Okay.
Don't think.
I think it must be visible now.
Yeah.
Yes.
So this is how we had marked the incision, and then we raise minimal flaps. That is how small the incision is going to be. And then we use energy devices to have absolutely bloodless field, and meticulous technique. So just for the sake of time, I'm going to quickly fast forward this. See how the surgeon is careful in not holding the adenoma. We are outside the adenoma. This is the adenoma that we are seeing. So we are mostly excising it outside the adenoma. So we have identified and saved the recurrent laryngeal nerve. That is how the post-op specimen is going to look. So that's about my presentation, and I'm happy to take any questions if we have time.
Thank you for the kind this presentation. But Dr. Ganpati is actually leaving his flight, so we need to hurry.
Yeah, hi. Over to Dr. Basavaraj. Thank you, ma'am. Thank you.
Yeah, hi.
Yes,
Am I audible?
Our next session, Hormone India repertoire, Dr. Basavaraj. He is at Hormone India, Bangalore. And we can have the next session. Please introduce the chairperson.
Yeah, hi. Good afternoon, everyone. I think continuing the bone endocrinology, we'll go ahead. We have two chairpersons for the session. We have got Dr. Navya Kurian, who is Assistant Professor, Department of Endocrinology, Lucknow, and Dr. Yashasvi, Consultant Endocrinology, Jaipur. So I would request Dr. Yashasvi to introduce Dr. Ganapati and Dr. Navya to further introduce the latest speakers. Over to you, Dr. Yashasvi.
Thank you so much. So I'm very humbled and especially privileged to be inviting the next speaker. He does not need any introduction, and especially humbling for me because very recently he was my examiner in my DM examination. So I welcome Dr. Ganpati Bhatwal, sir. He's a professor and head of endocrinology at St. John's Medical College, Bangalore. And of course, he has held many positions in many endocrine society over the past few years and received many awards and has multiple publications in both international and international journals. So without much ado, because we are running short of time, I would hand over the session to Ganpati. Over to you, sir.
Thank you. Thank you, Hormone India, for giving me this opportunity.
Dr. Ramya, you can answer one query in chat box.
Sorry. I think, hello.
Yes, sir.
I'm just reaching the airport. I'll do one thing. I'll do after Hari's. Okay?
No issue, sir. No issue.
Fine. Just read the. Okay.
Yes.
Yeah, I think we'll take up Dr. KVS Harikumar's talk then. So, Dr. Navya, if you can introduce Dr. KVS Harikumar.
Pleasant morning to all. I'm introducing Dr. KVS Harikumar. He is a consultant endocrinologist in Magna Clinics, Hyderabad. And he has got several awards from ICMR, NAMS, and Endocrine Society. And he was a Thyroid Rising Star Oration from Indian Thyroid Society. And he has so many international and national awards to his name. So I invite you, sir, for the state of the art talk.
Good morning, everybody. And thanks to Dr. Mayur for giving me an opportunity to speak in the Hormone India program about endocrine approach to pathological fractures. Most of the times these are unaddressed or these are like neglected in the clinical practice as because you just treat the fracture and don't look at beyond what is the reason behind it and why it is happening. So in the next 15 to 20 minutes, I shall be telling about some of the issues which we should be looking at in these patients so that the fracture morbidity and mortality is prevented. I shall cover the topic under the following headings. Introduction, what are the basic etiologies behind the pathological fractures, relevant endocrine workup, couple of slides about the hypophosphatemia, how to approach, and interspersed with some of our reports and some of our studies also I'll touch upon. So if you exactly look at what is the definition of a pathological fracture, it's a fracture in bone tissue that is actually weak or remodeled. Basically, it's not a properly formed fracture. So that is most important to understand. It has obviously altered mechanical and viscoelastic properties, which makes it more prone for fractures. And the bone disease may be a local or a diffuse. You have a cyst in the bone, you have some other tumor in the bone, that's a local problem, or you have a diffuse metabolic bone disease, which can actually increase the susceptibility across all bones, and some of them get fractured. So this is the spectrum of pathological fractures. And obviously you have different terms for this, that is a traumatic fracture, fracture with normal or preserved BMD, all those things. But as we know, the BMD in the conventional terms, what we actually assess is the aerial BMD, and anybody who is outside the 2.5 standard deviations is considered as the abnormal one. So what exactly is normal BMD or normal bone strength? Lot of issues behind that. So that is, we will keep it aside. But identification of underlying etiology is the key in the management of looking at this problem. When you look at the etiology of the pathological fractures, the commonest malignancy, be it leukemias or solid tumors, you have a lot of inflammatory disorders which affect the bone, the rheumatoid, celiac, all those things. If somebody is immobile, somebody has got strokes or some other things, then that also increases the risk of fractures of that particular part. And use of drugs which can affect the bone. And endocrinopathies live right in the center, which may have all these, some of these direct or indirect actions. Before we look at how to work up, just a slide about what exactly is the hormonal control of bone remodeling. The left side slide is a bit busy, but what I would say is there are many number of hormones which affect the bone functioning, be it resorption as well as the formation. To make it simple, the estrogen is the one which inhibits the resorption, and IGF-1 which promotes the formation, and cortisol and PTH both leads to increased resorption, and cortisol as well inhibits the formation. So basically the 3-4 key hormones which have a role to play in the formation of the bone. As we all know, the formation is preceded by resorption. So you have all these actions which may, any alteration in these hormonal parameters will affect the bone formation and resorption. Coming to endocrine disorders per se leading to bone loss, if you are looking from the perspective of endocrine disorders, obviously the common being osteomalacia, be it the calcium or phosphorus deficient, or a glucocorticoid excess condition, be it endogenous or exogenous, and hyperthyroidism obviously affects the bone also. Reasonably uncommon or possibly not looked at is the hypogonadism, diabetes, and hyperparathyroidism. Some of them are neglected or undetected, but they are also in a reasonable number of patients. Rarely some of these conditions like growth hormone deficiency, acromegaly, hyperprolactinemia, anorexia nervosa, all these also can affect to bone loss. So this is a spectrum of endocrine disorders which can affect the bone and lead to bone loss. We will go some of the common ones now. That is the osteomalacia. Basically what it means is the newly formed mineral osteoid is not mineralized adequately. It can be PTH mediated, FGF23 mediated, or renal mediated, but the clinical features remain the same. The aches and pains, antalgic gait, frequent fractures, loser zones, all those things remain the same irrespective of the underlying etiology. And commonest available feature or clue in the clinical diagnosis is actually elevated alkaline phosphatase. Whenever you are looking at normal, I mean, you get a number of tests nowadays, but the alkaline phosphatase should give a clue if it is elevated. Is there something to do with the bone? So that should be the key factor. Other things depending on the availability. The X-rays will show thin cortex and loser zones.
and the definitive diagnosis may be after tetracycline labeling depending on the osteoid thickness and the lag time, which mineralization lag time. The spectrum of osteomalacia of these three conditions, if you look at one, as I said, PTH dependent, commonly vitamin D deficiency, which can lead to either primary or secondary hyperpara, affects the calcium and phosphorus absorption, and this hyperpara will lead to internalization of NP2 receptors and then lead to phosphate loss. So both deficiency of calcium as well as phosphate loss will lead to a osteomalacia. The FGF23 is the basic phosphaturic molecule, so it produces from osteoblast and osteoclast. Again, after affecting the phosphate loss, it also inhibits the 1-alpha hydroxylation and reduced formation of the active form of vitamin D. And there are multiple reasons why FGF23 mediated occurs, the commonest being tumor-induced osteomalacia, and you have inherited forms also. We'll dwell upon this slightly when I move to hypophosphatemic area. The renal dependent, it is FGF23s are normal, other things are normal, these are mutations, or due to a Fanconi syndrome of the proximal tubular dysfunction, FGF23s are low, and they can be both acquired or inherited. So this is the spectrum of osteomalacia which can happen in these different patients. As I have said, this is the disease, the PTH mediated disorders, decrease in the vitamin D by pore intake or decreased 1-alpha or 25 hydroxylation. FGF23 being tumor-induced osteomalacia, autonomously secreting FGF23 or X-linked or autosomal dominant and recessive varieties, and renal ones being renal proximal tubular dysfunction or hereditary hypophosphatemic rickets with hypercalciuria. One of our patient who was labeled as a spinal muscular atrophy and then said that nothing can be done was actually a osteomalacic myopathy due to a simple primary hyperpara. So before you label somebody with an irreversible disease or possibly there is no remedy, we should all look at and screen for the metabolic bone disease, and then because most of them are 100% amenable to therapies and the improvement is remarkable. Glucocorticoid excess leads to bone loss by multiple mechanisms on the bone, on the intestine. So it is commonest cause of possibly abuse, and they're mostly visible in that say we don't miss these patients because they have all florid features of the Cushing's. So, but this is to be considered whenever there is a bone loss per se, which is not commensurating to the clinical picture. Very early stage of Cushing's may be where you just have maybe osteopenia and then you look at other features, simple obesity, maybe there may be a lacking glucocorticoid excess inside. The genetic disorders are predominantly in the children and childhood, commonest being osteogenesis imperfecta. I will not go into other details, but nevertheless, there are plenty of other syndromes which affect the bone formation and causes recurrent fractures. You have different types of osteogenesis imperfecta, the commonest being type 1 and autosomal dominant inheritance, and you have other clinical features like blue sclera or other things which can give you some clue in the clinical diagnosis. This was one of our report which had unilateral blue sclera, then when compared, usually you get a bilateral ones. The third group which commonly is looked at in the bone loss is the drug-induced bone loss, especially relevant to endocrine drugs, as I said, glucocorticoids, or possibly the thyroid hormone abuse, where a lot of people take it for weight loss or some other benefits, but that should be discouraged. And any excess, either iatrogenic or intentional drug-induced hyperthyroidism, all these things can cause bone loss. The thiazolidinediones as a group also leads to bone loss, but the usage of it has come a bit less nowadays. Other drugs which also can lead to bone loss. So you should look at all these drugs whenever you are evaluating a patient with recurrent fractures. And this is the spectrum of what fracture risk can happen in different endocrine disorders. Most of the times the vertebral fracture risk is more. Some of the data is not available, particular drugs, and the important thing is the DEXA may be normal or high, but still your fracture risk is more. So that is most important to understand. So your DEXA may be not affected, especially in diabetes, whereas others, they may be reduction in the T-score. So it is important to know that DEXA normality does not preclude or prevent the patient from having a fracture because of a underlying endocrine disorders. One of our study which looked at the effects on the bone and body composition with two different modalities in antithyroid drugs, but both the bone density, we didn't have the fracture data because of less duration of follow-up. So the bone density improved in both, but same irrespective of whether the patients were treated with the radioiodine therapy or with the antithyroid drugs. So coming to clinical approach, whenever you have a recurrent fractures or some other disease which suggests that there is an endocrine disorder, look at either you can go by the fracture based, how many types, how many numbers, how many frequency, and obviously other symptoms to suggest a metabolic bone disease, the classic acronym of stones, moans, groans, and for hyperpara. And gland based, because if you have other clinical features which are looking at, which are staring at you, maybe a Cushing's, maybe hyperthyroidism, maybe hypogonadism. So some of these features also in a background of fracture will give you a etiological clue, or possibly the history of other members of the family affected, or children getting affected, or the consumption of drugs. All those things are important to look at. So your approach may be, the start point may be fracture based, or maybe a gland based, or maybe depending other history, which will give you some clue about how to go about in investigating these patients. Why I have said this is the importance of identifying the endocrine condition. This was our paper published about the spectrum of parathyroid disorders, which looked at the delay in the diagnosis. So if somebody had a fracture, there was almost about 2 years delay before actually the patients were diagnosed with the underlying endocrine disease. So somebody who presented with spondyloarthropathy, the almost 5 years it took before you actually labeled the patient has got hyperpara. So it is important to know, not that everybody should be investigated, but if you have 2-3 other supportive symptoms, suggestive features, the threshold should be high to investigate these patients for the endocrine disorders. What is the initial laboratory approach? The simple mineral metabolism, work up the calcium, phosphorus, creatinine, vitamin D, and alkaline phosphatase. Bone turnover markers, you would be hearing from Professor Ganpati now. The not very relevant, but useful in more of follow-ups. And basic screening of all CBCs, thyroid workup, sugar, testosterone, hypogonadism, all those things are important. And depending on the alterations, depending on the clinical profile, you may have to follow up testing, obviously to confirm the diagnosis, what you have actually thought about in the initial phase. The specific for the endocrine, if you are looking at obviously for the thyroid disorders, thyroid profile, diabetes simple. For the glucocorticoid excess, you do 8 AM cortisol, and if you are suspecting endogenous, you can look at ONDST or low dose DEXA suppression. For hypophosphatemia, you look at using TRP and TMP-GFR. I'll spend a couple of minutes here. Basically, when you are looking at approach to any hypophosphatemia, now what is the renal wasting, number one? And is that renal wasting appropriate for the GFR for the given patient? So these are the two key factors which will determine whether there is a renal phosphate leak or not. So if you have to calculate the TRP, you require a sample of urine and plasma phosphorus and creatinine in the morning, and the formula is given. And if it is anything which is beyond 85 to 95%, the reabsorption, that means it is okay. But if you have the more loss in the urine, and which is when you plot it in the algorithm for calculating the TMP-GFR, then you would get actually whether the phosphate wasting or not is happening. at the face value, the TRP may not give you the value. So always I would suggest you should get the TMP-GFR also along with it. And once you have the TMP-GFR and confirm that there is renal phosphate wasting, then possibly there will be a role of FGF23. If it is low, it will suggest a proximal renal tubule dysfunction, and hereditary forms will have most of the normal or elevated values. So to look at hypophosphatemic disorders, hypophosphatemic osteomalacia commonly, if you look at, most of them have secondary, if they have secondary hyperpara, that is calcipenic rickets, be it vitamin D deficiency or nutritional calcium deficiency. Phosphopenic rickets, and if you don't have a renal phosphate leak by TRP, then it is just a decreased intake of phosphate. And if you have phosphate leak, and if you look at vitamin D, if vitamin, that is a 125 vitamin D, if it is not appropriate, that means it is suppressed. That means because FGF23 is high, which is suppressing it. So it is FGF23 dependent, which is high in all these conditions. If it is normal 125, then it is not FGF23 independent. It can be a Fanconi's or a proximal tubular dysfunction, or isolated phosphate leak due to the mutations in the NP2, that is hereditary hyperphosphatemic rickets with hypercalciuria or idiopathic hypercalciuria. If you have hypercalciuria, nephrolithiasis, then it is clinically, mostly it is primary hyperpara, or very rarely, if you have hypercalciuria without other things, you may look at other uricosuriia or cystinuria or other conditions. So this is a spectrum of hypophosphatemic disorders which you should be looking at whenever there is a patient who has got multiple fractures. Another important thing is RTA, which generally comes in the pediatric to adult age group. Spectrum of distal RTA versus proximal RTA, fasting urine pH is the one which determines, and you should look at bicarb, and stone disease is usually seen in the distal one. Our study of about 90 patients who had the clinical profile of distal RTA, who were having suspected metabolic bone disease, recurrent unexplained hypokalemias, renal stones, all those things. So it is important whenever such patients come up, you should be investigating them for RTA also. Genetic approach, mostly relevant in osteogenesis imperfecta patients. Other mutations are quite rare and not relevant in the clinical practice. DEXA is definitely useful just for documenting what is the Z-score at that point of time, and possibly helps in follow-up depending on whatever interventions we do. And because these are like younger age group, you don't actually have the classical guidelines about how to go about. So most of the times the indications being more than 2 fragility fractures or fractures at unusual site which you don't expect in a patient. So these are the times where you should be doing DEXA, and which will help in actually documenting the bone density at that point of time. The other modalities of bone fragility evaluation are there, but most of them are in the research settings and not useful in the clinical settings. The TBS, HSA, and QS, maybe QCT also is going to be useful in the future. But as of now, mostly the reliance is based on the DEXA. So to conclude, pathological fractures is a problem of hereditology, and many hormones control the process of bone remodeling, as I have said, and high index of suspicion is required for unsuspected endocrine etiology. The focus will always remain on the fractures, but we should look at what led to this. Look for 3 P's in the workup: the phosphate, potassium, and parathyroid, which will give the clue about hypophosphatemia, RTAs, and hyperpara. And you should always look at 3 O's in the diagnosis: osteomalacia, imperfecta, and osteoporosis. And most important thing is if you are able to identify an endocrine etiology, it is always satisfying and rewarding, because the patient can get cured and have permanent treatment for the same, and do not have to suffer with the fractures again. You require a multidisciplinary team for this in the diagnosis and management, because close support with the lab, close support with orthopedician who is going to refer to you, all those things are important in managing these patients. Finished here. Thank you for the opportunity given to me.
I have joined. Okay.
Yeah, thank you, sir. Thank you very much for such a nice deliberation. And obviously, this is a very important topic, recurrent fracture. All those patients actually go to just the orthopedics and miss on the actual cause. So endocrinologists have equal part to play. So without wasting time, we'll just start with Dr. Ganpati Bantwal, sir. He has a flight. Sure, sir, you can start.
Yeah, thank you, Mayur, and the team. Yeah, I think my screen is visible and I'm audible.
Yes, sir. Yes, sir.
I'll be speaking in the next 15 minutes on value of bone turnover markers in osteoporosis. As you know, the burden of osteoporosis is significant, and the main reason is the population is aging. Around 200 million women are affected worldwide, and the amount spent is around 37 billion euros. Actually, that's what has been spent in 2010 in European Union. And in India, more than 46 million Indian women over the age of 50 are affected. And these are all, the most of the cost of osteoporosis are accounted by fractures. So what is the future? It is said that by 2025, you will have around more than 1,200 million people, more than 60, having osteoporosis. And the estimated expenditure is around 76.1 billion by 2050. However, there's a major challenge, that is non-response to treatment. So these are the various studies, but they found that 50% patients stop therapy after 12 months. Why? Because complex dosing regimens, undesirable side effects, lack of visible benefit of the osteoporosis therapy. And non-response to treatment can also be caused by a suboptimal response to the prescribed therapy, bioavailability, low dietary calcium intake, vitamin D insufficiency. So there are some unmet needs, that is non-compliance and non-response to therapy, uncertainties with respect to duration of treatment and provision of a drug holiday, lack of appropriate monitoring tool, and you don't have a single test to accurately identify the risk of fracture. Currently, DEXA is a gold standard, but then what it does, it provides quantitative data. There's no assessment of microarchitecture. It's a static measure. 50% of women who sustain osteoporotic fracture do not have a BMD in the osteoporotic range. Now, you want to see the response, you'll have to be picked up within the next 6 months. So that's the reason you have to wait for more than at least a year to find out. Poor quality of DEXA may result in expensive, unnecessary, and potentially harmful clinical decisions. It's expensive, limited availability. A little bit about bone turnover markers. This is the classical description of bone remodeling by Frost. So it begins with resorption by the osteoclast, then you have a reversal, and then you have formation by the osteoblast, and then you have the resting phase. So once you attain the peak bone mass, then what happens is there is a gradual decline. So the peak bone mass happens by around the end of puberty, by which time the maximal accrual of bone mineral density happens. A defect here can lead to osteoporosis, osteopetrosis, or Page's disease of bone. There are multiple bone turnover markers involved in formation and resorption. Like your formation markers include the P1NP, that is pro-collagen type 1 amino-terminal propeptide. You have the alkaline phosphatase, osteocalcin, bone resorption marker like CTX, that is carboxy-terminal telopeptide of type 1 collagen, pyridinolin, deoxypyridinolin, TRAP, that is tartrate-resistant acid phosphatase isoform 5B, and the NTX, that is the amino-terminal cross-linking telopeptide of type 1 collagen. But what is the reference one? Reference bone turnover marker. So the International Osteoporosis Federation and the IFCC says for bone formation, it is a P1NP, and for bone resorption, it is beta cross labs or the CTX. Why? Because they are adequately characterized, clearly defined, bone specific. They perform well in predicting fracture risk and monitoring treatment, acceptable biological and analytical variability, then ideally obtained from blood samples to help limit individual variation that may otherwise arise from measurement in urine. Measures in routine clinical laboratory are ideally using automated, so in them also you can actually measure. Now coming to the utility of these markers. So in osteoporosis, so you can look into treatment monitoring of patients under therapy. You will know whether the drug is acting or not as early as 3 months. You can look for these beta cross labs P1NP. Whereas you want to do a BMD, you have to wait for 1 to 2 years. You can enhance the patient adherence. I told you 50% stop treatment after 12 months. So find that the bone mineral markers are increased, bone turnover markers. You can tell them, yes, you are at high risk for fractures. So you can tell you must take this, otherwise you will get a fracture. So how do you identify? So two things you must remember. There was a study known as a trio study. So this included a formal assessment of two treatment strategies. One is the least significant change. The least significant change can be considered to be significant based on two measurements in an individual. Number one, the level should be around 10 microgram per liter for P1NP and 120 nanogram per liter for CTX. So you must see that there should be a variable. I'll give some examples in the later part. Then you must know the median value of the bone turnover in a healthy young women, that is a preterm person. This is useful if only one bone turnover measurement documented while on treatment. If the BTM is below the premenopausal median mean, then the patient is considered to have responded. For example, these numbers are 35 micrograms per liter for P1NP and 280 nanogram per liter for CTX. Suppose you had a person who had 400 was the CTX. You started on treatment, it came to around 200. Patient has responded because it has come below that thing. And is it more than 120? Yes, it is more than 120 because from 400 it came to say 250. It's more than that 120 change. Similarly, suppose you had a P1NP which was say around 100, and then you started on treatment, it came down to now 20. Is it below the? It's below the detectable range. 35, yes, and the decrease was more than 10. Yes, so that's how you decide. So these are the expected values in osteoporotic patients versus healthier subjects. So you can see in the premenopausal, the mean is around 40-31. And in the osteoporotic, it's 54. Men, once again, it's around 38. So you can see these expected values in healthy women. There is no significant change in serum CTX concentration with age in premenopausal women. They continue to be roughly around this range only, from as low as 0.21 to 0.38 micrograms or around 271 nanogram per liter. We have studied it in the Indian population also from CMC Vellore. Yeah, not so much difference here, but then they are matching premenopausal women having a better response compared to that of postmenopause. Coming to monitoring for anti-resorptive and anabolic treatments, say utility. You can indicate therapy success and monitor treatment compliance. So you started with a placebo, you gave them ibandronate. Within 12 weeks, you see that the levels have come down, the beta cross level, that is the CTX. You stop it, it rises. Similarly, for osteocalcemia, you treat, came down, stop it, it improved. So the patient achieving the greatest reduction in the bone turnover markers demonstrate the largest improvement in BMD. So here you can see 833 postmenopausal women treated with once weekly bisphosphonates. The women who achieved the greatest reduction in BTMs, the highest tertile at 3 months, had the largest mean increase in BMD measured at 24 months. And those who had the least had the worst response at 24 months. Coming to how do you enhance the patient adherence? I told you before itself, see, as early as 3 months, you find that the least significant change is overcome. That's because you get a 30 to 200% change within 3 months of therapy. BMD, this 2 to 5% change because at least more than 1.5 to 2 years. And that's the reason we measure. Exceptions include post hyperpara therapy or post Cushing's. So I'll just give an example of BMD versus bone turnover markers. Suppose you are driving from A to B. This trip takes 2 years, and there are no signs or signals whether you're on the right way unless you have an accident. Bone markers are like signals, example, a GPS or a signpost on a road to show you after a few months already that you're on track with your therapy. So that is how it is. Early monitoring, anti-resorptive, it came down, you can see by 3 months. For anabolic, we should see the increase in the bone turnover markers because you are increasing, the bone formation marker starts increasing. So the P1NP, you should look for this, including the CTX. Bone formation will start increasing first and then the CTX. So this is the anabolic window. So once it starts becoming nearer, that means to say now we should, that's a time that to tell you that, yeah, probably, yes, you have to start the action of anabolic therapy is coming to an end. So I told you the positive P1NP response were defined by more than 10 micrograms per micrograms per liter. If it is the P1NP are identified non-responders, that is, an increase less than 10 minutes, they are non-responders. Okay, so what are the differences bone turnover markers versus BMD? So here you use an instrument, of course, not much of radiation. Bone turnover markers, blood or urine sample collection, non-invasive. You can repeat it frequently, here probably only after a year or so, exceptions. More expensive is BMD, cheaper. Expected change, time and size of signal in response to therapy, 6 to 8% within a year, 20 to 300% within 3 to 6 months. Methodology is actually more robust with BMDs, whereas BTMs, it's so this is what the same thing, the noise change. Coming to algorithms and guidelines, what do? How do you monitor osteoporosis therapy? So get a baseline BTM, P1NP and CTX, start them on treatment, monitor once again. BTM decrease less than the least significant change. Find out what is the reason, reassess treatment, poor compliance, other issues. BTM decrease is more than the least significant change. The patient is responding, continue the treatment. This is the absolute change, 10 in different studies, 10 micrograms and 100, it crossed that. Median should be below that mean I told you, less than 35 and less than 280. You found that means the patient is responding. So response, I told you, changes greater than the least significant change, results that exceed an absolute target, and reduction to a level below the median found in the healthy young women. This is the Sheffield algorithm. 1 month you do a compliance check, 6 months once again P1NP check response, 5 years reassess fracture risk using DEXA, consider pause in treatment. What do you mean by positive response? Decrease by more than 10, decrease to less than 35 micrograms. So anabolic, you look for the increase. It should be at least more than 10 or increase to more than 16. And that is the upper limit of normal, the cutoffs of P1NP. So I'll just end by 2 cases. 70-year-old women, osteopenia noted in spinal radiographs. She was treated with alendronate 70 milligram once weekly, calcium, vitamin D. At that time, the BMD was -3 at the hip and spine. They were measured at baseline, and after 6 months, she took alendronate for 5 years. Then we stopped it. They were measured once again after 1 year. So baseline 500, 60. 6 months, 120 and 20. 60 months, same, 120 and 20. You stopped it now, it increased, 440. Did the patient respond to treatment? Has the treatment effect worn off? She responded initially because from 400, it came down to 280. Below this 280 range, it came down to 120, I told no. So the decrease was more than 120, yes. And it fell below the median of the young healthy adults. Yes, it happened. So it was below that. For P1NP, did she respond? Did the decrease by more than 10? Yes. Did it fall below the premenopausal range of 35 micrograms per liter? Yes. And then after stopping, there was an offset. Now, did it increase by more than 280? Yes. It has gone up to 400 now. And what about PNP? Did we increase from 20? It became 40. Increase was more than 10. It went above the premenopausal range, 35. So telling that she did respond, but then now after stopping, it has increased. Case 2, 87-year-old women, previous fracture, multiple fractures, L3, L4, treated with alendronate 70 milligram once weekly for 10 years, stopped 2 years ago. She is using calcium and vitamin D alone. A vertebral fracture assessment reveals a fracture at L2. Now, after this is after 10 years. There's another fracture at L. Workup for secondary cause of osteoporosis negative. Of course, at 87, we'll not think about that. Her P1NP is 140. What is the interpretation? Line of action. So now, because it is 140, it should have been less than 35. That means patient is no longer having suppression of bone turnover from prior alendronate therapy. She has a high bone turnover. Probably we should give instead of alendronate, probably a zolendronate or a derazumab. Can you use anabolic? Yeah, maybe. But the only thing is, if you use first alendronate followed by an anabolic, they don't respond well. So that is one. Is she a non-responder? No, it's not. When you say non-responder, when you have more than 2 fractures during the treatment period. To summarize, BTMs are a useful tool in the monitoring therapy of osteoporosis and improving patient adherence to therapy. P1NP, CTX bone resorption, reference bone turnover markers recommended by the IFCC and IOF. The BTMs are affected by sources of biological and analytical variability, feeding, circadian rhythm, CKD, steroid therapy being important ones. Many can be controlled or worked around. The response to treatment and adherence can be assessed with BTMs earlier than with BMD as early as 3 months after start of therapy. Appropriate treatment targets for BTMs using least significant and reference intervals have been developed to help identify patients with poor compliance and non-responding. A number of guidelines have been developed for BTMs in the management of osteoporosis in clinical practice. Thank you for patient hearing.
Thank you, sir.
I think I was audible, no?
Yeah, yes, sir. Sorry.
Audible. Yeah, Dr. Tony, go on.
Sir, we do know that people with type 1 and type 2 diabetes have poor bone quality, and sometimes it's not reflected on the BMD. So is there any role for bone turnover markers in these?
Yeah, I think there also they'll play. But then for the diabetes, we have corrections also for the BMDs. Number one is instead of minus 2.5, you take 0.5 lesser. So instead of, you don't wait for minus 2 point, you take 2 as the cutoff. The other thing is you can actually look at a bacular bone score. The third one is maybe you can actually, a 15% change also. That is another thing which you can actually do. So you can, or you use rheumatoid arthritis as a correction instead of diabetes. So these are the 3 or 4 things which you can do for predicting the risk scores using a BMD or a FRAX.
Thank you.
You can use this marker. This is also useful.
Hello, Ganpati. Hi, lovely.
Hi, ma'am.
Thank you, ma'am.
Yeah. Enjoyed your talk.
Okay, Premada, we can go ahead with the next session.
Okay. Good afternoon, everybody.
So let me introduce Dr. Premada. She is from Hormone India, Noida. She is DM Endocrinology from Sanjay Gandhi PGI. And she'll be guiding us through the next session here.
Okay. So good afternoon, everybody. So for this session, we have excellent speakers. But before we go ahead, I would like to invite the chairpersons for this session. We have Dr. Anand Kumar, who is Assistant Professor in Endocrinology Department of IGIMS Patna. He has done his DM from SDPGI. We also have Dr. Pankaj Kumar Agarwal, who is Director and Consulting Physician at Paral Hospital in Bhopal. The first session for today will be by Dr. Sarita Bajaj, ma'am. I would like to request Dr. Anand Kumar, sir, to introduce ma'am.
Okay, am I audible?
Yes.
Thank you. So at the outset, I would like to congratulate the team of Hormone India for having organized this event beautifully and bright. And the next speaker is Dr. Sarita Bajaj, ma'am. And she is very well recognized and known throughout the endocrine fraternity. Ma'am is DM endocrinology from AIIMS New Delhi. She has been consultant in, she is consultant endocrinologist and former director professor and head of medicine in MLNR Prayagraj. And she has been president of Indian Thyroid Society, RSSDI in the past. And she is the founder president of South Asian Federation of Endocrine Society, CEFES. And ma'am has so many publications and so many of awards in her accolades. So over to you, ma'am.
A very good afternoon. And of course, thank you for this invitation. Thank you for the introduction, Anand, to my chairs. And so it's a pleasure to see Ajay also after such a long time, though he has reached endocrinology after quite a circuitous route, I believe. Of course, congratulations for forming this, I think, excellent platform. We're calling it Hormones in Hormone India, Hormones India. Is it plural? Hormone India. And of course, I can see Mayur here, Tony, Priyambada was the one who's, I think, looking after this session in particular. Right, so the task allotted to me is the role of the endocrinologist in the management of thyroid disorders. So I believe I am audible and I am visible as well. This is now PowerPoint. There we are. Okay, all set? Can I go ahead?
Yes, ma'am.
Perfect. So basically, I'll be focusing on hypothyroidism. And majorly, we talk about primary and secondary hypothyroidism. Extremely common. In India, the prevalence is higher as compared to the United Kingdom or the USA. You can see the difference between the coastal cities and Indian inland cities, the prevalence rates. And this was an article which was published in the Lancet Diabetes Endocrinology, that hypothyroidism in India, there's a lot to be done. So remember that before 1880, we had nothing. So all patients with hypothyroidism diagnosed before 1880, the mortality was 100%. From 1880 to 1970, we had desiccated thyroid extract, which was a crude mixture of T4 and T3. So I'll be coming back to this a little later. So since 1970 only that we have the first branded levothyroxine, and we all know that is T4. This is my favorite slide, just to show you. So the father has hypothyroidism. This is a type 1 diabetic, and here she also has hypothyroidism. So we have two members in the family with hypothyroidism and one with type 1 diabetes. So type 1 diabetes, it does not run in families. Type 2 does. The concordance rate is much higher, but concordance rate I've explained already. Now, when we talk of familial hypothyroidism, you can see two members of the family having primary hypothyroidism. So what happened was that the mother went into the kitchen. She was cooking. She caught fire. She died. The father stopped his thyroid medication. He went into myxedema coma. He died, and the three children were subsequently orphans, and they're now being looked after their grandparents. I'm talking of about almost a quarter of a century back. So now they're lost to follow-up. Just to highlight the importance of lifelong medication for hypothyroidism, I know all of you will have had this experience that despite counseling, patients still discontinue their medications quite often. And then the end result can be very tragic, like in this case study, which I have shown you. I'll start off with adult hypothyroidism. I'm not going into the symptoms and signs. Everybody is familiar with them. But it is important to know that many patients with hypothyroidism report no symptoms. The diagnostic accuracy of symptoms and signs, which are non-specific, occasionally quite insensitive. So the symptoms will be related to the duration, severity, and the rapidity with which hypothyroidism develops. And if the patient has new or persistent symptoms which are occurring in combination, it is more likely to be relevant. Again, a host of laboratory radiological findings as well. Now coming to the case. She's 46 years old. She has gained 20 kilograms of weight. She has features which are typical of hypothyroidism on exam as well as in the history. She also has bilateral carpal tunnel syndrome, delayed relaxation, all features which are typical of hypothyroidism, which is corroborated by this very high TSH. So undoubtedly, she's a case of primary autoimmune hypothyroidism. She was started on levothyroxine 100 micrograms, and her biochemically, she was normal and she was now euthyroid. The question that I want to address is the complaint or the weight record. She had gained 20 kilograms of weight gain. So what about that? What will happen to that? So taking the other case and then I will tell you what I want, what the message I want to convey. So another lady who has swelling, weight gain, 10 kilograms in the last 1 year with aches and pains, and she is absolutely euthyroid, as you can see from her thyroid profile. So the message that I want to convey here, the 20 kilograms there and the 10 kilograms are not because of hypothyroidism. Please remember, obesity exists without hypothyroidism. Obesity can mimic most symptoms of hypothyroidism, and obese people lifelong, they attribute their symptoms to hypothyroidism if ever by chance that TSH is marginally elevated. So hypothyroidism does not cause morbid obesity, and weight gain, even in severe hypothyroidism, is less than 5 kilograms. So that weight loss they have to achieve on their own, however they may do so. So this algorithm is very familiar to all of us. Again, I'm not going to go into details, let alone to show you that at one point in time, when the diagnosis is not clear, then an endocrinology consultation is warranted. In the elderly, the symptoms and lab data are utterly confusing. And you can see that the different symptoms at the above 70 or less than 55, the totally different manifestations in the elderly. They have decreased T4 clearance, which is likely related to the decreased lean body mass and leads to decreased T4 production rate. So older or the elderly persons may require a lower T4 dose to treat hypothyroidism. And you can see changes in the mean ALT4 dose with advancing age from 40 up to over 60 plus. And if you look at the percentiles, you can see that as age advances, so does the TSH. And we know where we are with the up to 60, even maybe 85. But beyond 85, we really do not know what the TSH levels should be maintained. But just to give you the take-home message here, in the elderly, we will not treat subclinical hypothyroidism until the antibodies are strongly positive, or if the patient has dyslipidemia. So there's markers which we will look into before deciding to treat. So subclinical hypothyroidism in the elderly, no, because I said TSH advances with age, and some of that is also protective. It says that a longer life may be associated with a higher TSH. Okay, so your patient has normal TSH. I gave you one example, but persistent symptoms of hypothyroidism, genuinely. So these are the causes that I have listed here. Rare adrenal insufficiency is relatively rare. B12 iron deficiency, CKD, depression, CLD, obstructive sleep apnea, certain viral infections, and vitamin D deficiency can also be responsible. But reasons for abnormal TSH levels on a previously stable dose. So your patient is euthyroid, all of a sudden everything goes haywire. Or if your patient requires a higher levothyroxine. I was wanting to put 10 slides on non-compliance because this is the biggest issue of all. Ensure compliance 10 times, many times over, if you have to ensure this. Then patient medication handling, storage, brand substitution, yes, very important. Pregnancy, oral contraceptives, hormone replacement therapy, celiac disease is extremely important, malabsorption, or if the patient is taking these medications along with T4. So rather than say you wait so many hours, you tell them you take your thyroxine in the morning and you have the rest in the afternoon or evening. So that makes it a little convenient rather than, sitting by the clock and trying to make out as to how many hours I need to wait before I have my next, even the simple iron calcium. Then if there are other medications that affect absorption, spurious medicine, and I told you morbidly obese might have a marginally elevated that was circulating in the market. So even that does happen. What about secondary hypothyroidism? A low normal or low TSH with low T4 and a history of pituitary disease. So I've just listed the causes and the clinical manifestations here. Just remember, all patients of secondary hypothyroidism need a referral. What about pregnancy? Yes, we have had a revision in the upper limit of the TSH with which we need to treat. So 2.5 in the first trimester, 3.0 in the second and third trimesters. And there are more recent studies in Asia, India, and the Netherlands as well. But ideally, you should have your own population-specific values, which unfortunately we do not have. So we are following the same criteria. And from 2011 ATA to 2017, we have had a revision in the numbers which I have just given you. A very, very common question. Severe hypothyroidism in pregnancy, does it affect the child in utero? So you can see two examples, a 22-year-old primey with a TSH of 61, and a second patient, she's the 34-year lady, treated for secondary infertility. It's an IVF pregnancy, TSH is 42. So would you terminate? Absolutely no. You would not terminate the pregnancy. You'd continue it. This is extremely important. Okay, so please, this is very important take-home message here. Another woman, she's planning pregnancy, several miscarriages, thyroid gland, excuse me, is palpable, TSH is normal, but the test for thyroid antibodies is strongly positive. Here also, from the values I gave you, we wanted to be less than 2.5, so TSH 3.2 may warrant treatment here, but the thyroid antibodies are strongly positive. So what would you do? Yes, you would recommend levothyroxine, starting with 25 microgram. And these are the recommendations of the ATA guidelines. TPO antibody positive, more than 2.5 recommended. TPO antibody negative, more than 10 recommended. So these two are absolutely clear. Negative between 4 and 10 you would consider. Negative between 2.5 and 4, no. But in that particular case, I said, yes, there is a weak recommendation to treat. If there are recurrent abortions, TPO antibody is positive. You are not going to be wrong in treating that particular patient. So that will now depend from patient to patient. Is that, I hope that is clear. So as far as pregnancy is concerned, all pregnant women with pre-existing or newly diagnosed thyroid dysfunction or a thyroid nodules should be referred to an endocrinologist. So which child needs referral? All, and I will now tell you why. Firstly, juvenile hypothyroidism. So the developmental retardation is not as severe as in cretinism, nor the features of adult myxedema, but there is severe retardation of the linear growth. Eruption of permanent teeth is delayed. Puberty, usually delayed, rarely precocious, with galactorrhea also. Poor intellectual performance. So an intelligent or a good and normal intelligence child all of a sudden starts performing poorly in school. That may be the only history with which the parents may bring the child. Bone age is significantly retarded. So these are just typical cases of juvenile hypothyroidism, and you can see the faces in all three, which is classical. So it can be so much delayed. This is a 19-year-old boy standing next to his 17-year-old cousin. You can see there is significant retardation of growth here. Again, this is a case of juvenile hypothyroidism. You can see that his chronological age is 12. But you can barely see 3 carpal bones. The bone age is just 3 years. And believe you me, that once we start levothyroxine, within a year, all these bones, all the carpal bones will have come. So the bone age advances rapidly, and the sooner you diagnose, the better the catch-up growth. This is typical cretinism, and just look at the whopping high TSH over 1000, and of course a very, very low free T4. So this is another example of cretinism. This is a 4-year-old child who still has not ever sat up on his own. He's been in the lab, and these are typical. You can see the macroglossia, you can see the tongue almost protruding out, and the typical facies as well. So unfortunately, they have very few or no specific signs or symptoms. The only sure way to catch it is by screening of newborns. We are already very late in that. We are way, way behind because it was initiated way back in 1963. And you can see even almost a decade back when India launched programs for child health screening, this was not included. So it is really a very bad case scenario. It has a very strong public health relevance. However, it does not seem to be cost effective because every state has its own policy. Even if it is dictated from the center, it is up to the state to decide. So as president of the Indian Thyroid Society, I have been trying ever since I took over in March. You can see it's already 6 months down the line, but on that front, it has been a total disaster. We have not been able to make any progress in that direction. And like I said, very, very well known that we need to screen children. And these are sad faces of children who were not diagnosed in time, even though there are a host of clinical features. So it has to be diagnosed at birth. Right. Remember the almost second or third slide in which I showed you that before 1970, we did not have even levothyroxine. It was a crude preparation of T4, T3. So now this is a 29-year-old woman. She again gaining weight, exercise, she's tired, poor memory, work performance. She is absolutely euthyroid. What would you like to do? Continue the current dose, increase the dose, add LT3 or replace LT4 with T3. So just to answer this particular question, despite achieving euthyroidism, some patients may continue to have hypothyroid symptoms, including a picture consistent with that of depression. So for this reason, a clinician following patients with TSH values, which was considered euthyroid, would likely increase the replacement dose with such complaints to return the TSH to the expected range. I've already said LT4 is what we are using. However, there is a small group of patients who do not feel well, in whom a combination of T4 with T3. So this is the answer. You can add LT3 in these individuals, and that would benefit the patient, or that may benefit the patient, or rather should benefit the patient. However, please note here, who should administer? If you are going to give T3 in combination with T4, the therapy must be supervised by a specialist. Okay, this is extremely important. This cannot be used by anybody and everybody. So I hope everybody out there is not going to start prescribing T3 left, right, and center whenever it is available. So I'll end up with maybe possibly the second last slide. So who should be referred to an endocrinologist? All children and infants, elderly, individuals who have unusual constellation of thyroid function tests, patients in whom it is difficult to render and maintain a euthyroid state. I've given you examples of individuals who are unresponsive to therapy. If you're suspecting myxedema coma or secondary hypothyroidism. goiter, nodule, or other structural changes in the thyroid gland. I have not even touched upon thyroid hormone resistance. Presence of other endocrine diseases such as adrenal or pituitary disorders, unusual causes of hypothyroidism, such as those induced by agents, pregnancy or planning pregnancy, especially in this era when a lot of women are going in for IVF because we are having pregnancies at a later and later age, anyone with cardiac disease, and if you need to add T3 to the prescription of LT4. Thank you. Thank you very much.
Thank you, ma'am. Let me first compliment you. Listening to you, or I would say rather legend like you, is like listening to the music. This session was really interesting. The question and answer box actually got some hinge. So I got a message. One of our doctor is asking what is the treatment target for elderly, not to start like when, what to target, and it should be whether it should be a normal range or it should be normal for that age.
Yeah, so I've given you the cutoff values. We would again, if we're deciding to treat the TSH, we will keep it below 4. Okay, but if the TSH has not crossed 10, we would not even look at it. Above 10 with anti-TPO positivity is what we would consider. So if it's more than 10, even then if TPO antibodies are positive, only then we would treat. I've already said if there is dyslipidemia.
Ma'am, the question is not to start the treatment, what target TSH to be taken? What is the aim?
Yeah, once we decide to treat, then we'll keep it less than 4. That is, so we'll keep it
like normal, not normal for age.
Yes, absolutely, absolutely.
Yes.
Thank you, ma'am, for the session.
Thank you. Thank you for the invitation.
It was a very comprehensive and very timely finished session, and we all learned, especially the pregnancy statement. We all get very confused and sometimes pressed by the family also. So that is very clear slide, and that gives us confidence to go ahead with pregnancy and monitor it.
Yes, the only problem we face is that these women come from the OBGYNs who have already scared them like crazy. So it's very, like we have to balance. We can't be saying, no, nothing will happen. So, you have to explain.
One myth which is very common in especially gynecology about TPO positivity, especially if the titers are really high and if the woman is fighting for fertility issue. So they keep on, guiding them. So is there any thing like if that is euthyroid? I don't think there's specific thing as I know.
Absolutely. But then I did not show that recommendation slide. The ATA, like I said, there is weak evidence, recurrent. But then the point is, how much recurrence are you going to give time to? Because if she's already 30 plus, fair enough. You don't conceive like maybe next month or the month after, maybe a year or 2 later, despite whatever you're doing, IVF is going on. So if there's recurrent abortions, or if she's young, she's had recurrent, fine. If they have to come to you in that setting, and that's what they're likely to come with. The OBGYN is not going to send them for the one after one abortion or something like that. So if there's recurrent abortions, the woman is TPO positive, even if she's euthyroid, it is worth treating. You're not wrong in prescribing a 25 mcg dose. Even 12.5 you can try.
In that case, we treat to like target of 2.5 and below.
Yes.
But even then, they keep on monitoring TPO, and it's like it's
no.
not.
Oh God, I must this message absolutely loud. TPO antibody is once a lifetime test, please. Yes. No repeats required. The labs are very happy with that when they're doing TPO, because it's costly, isn't? No way, it's not required once a lifetime. I tell my patients it's like a high school certificate exam. You put it in your locker. If you're ever asked, yes, it was done. Was it high? Yes, it was high. And fold your hands and please don't get it done. Because I've had, like crazy referrals for dermatologists blaming everything on the skin going on with a very high TPO. And I don't know how they brainwash them. I think I'm quite ineffective. I'm not able to convey it. I try very hard, honest to God I do, but somehow I think when a man says it,
thyroid as
I think
a
man versus woman bhi hota. Aadmi ne keh diya to zarur maan lenge. I'm not sure. I think I just thought about that.
Okay, so sometimes like thyroid is caught as a poor guy who's caught by the police and responsible for all infertility issue.
Absolutely. Like diabetes is a waste paper diet. Like in the basket, jo sugar hai to sab ho raha hai, thyroid hai to sab ho raha hai. Well, it's just depends on your luck and how good you are at convincing.
Okay, thank you, ma'am.
Thank you, ma'am.
You can go ahead with.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much. All the best to all of you.
Thank you, ma'am.
Hormone India team. Thank you so much. Lovely seeing you, Dr. Bharadwaj. So here's next time. Thank you to the chairpersons as well. Thank you, Dr. Anand.
Thank you, ma'am.
So for the next session, I would like to introduce the chairperson, Dr. Pankaj Agrawal. He's consultant endocrinologist at Hormone Care and Research Center, Ghaziabad. He's founder of Medical Concepts in Hindi, and he has multiple research papers to his name. He's university examiner for DM endocrinology and has been conducting online certificate training courses. So, Dr. Pankaj Agrawal, I would like to request you to introduce our next speaker, Dr. V.K. Bharadwaj.
धन्यवाद डॉक्टर प्रियमदा, धन्यवाद डॉक्टर अजय शुक्ला और हार्मोन इंडिया की टीम। अपने इस मिशन के तहत मैं कम से कम थोड़ा समय जो मेरे पास है उसको मैं हिंदी में ही बिताना चाहूँगा अपने मित्र डॉक्टर वी के भारद्वाज को इंट्रोड्यूस करने के लिए। डॉक्टर वी के भारद्वाज MD पीडियाट्रिक्स 1990 में जबलपुर मेडिकल कॉलेज से, उन्होंने DM किया IMS PHU से 1992 में, वॉलंटरली रिटायर्ड इन 2014 जो कि HOD पीडियाट्रिक्स जबलपुर मेडिकल कॉलेज में रहने के बाद BC रॉय मेमोरियल ओरेशन अवार्ड मिला है इनको 2012 में, चरक अवार्ड मिला इनको 2016 में IMA मध्य प्रदेश ब्रांच के साथ। रीजनल फैकल्टी बहुत सारे प्रोग्राम्स में PHFI कोर्सेज में रहे हैं और MP RSSBI के प्रेसिडेंट रहे हैं। 40 से अधिक आर्टिकल्स, 8 चैप्टर्स, क्या क्या कहा जाए आपके बारे में डॉक्टर भारद्वाज, आपको सुनना बहुत आनंददायक होगा। मैं आपको आमंत्रित करता हूं अगले कुछ मिनटों में अपने डेलिब्रेशन के लिए। डॉक्टर भारद्वाज प्लीज।
धन्यवाद डॉक्टर पंकज। Thank you, Dr. Mayur, for organizing such an excellent meeting. I shall be making a presentation which is not in sync with the current recommendations. I agree that I am walking into a minefield. I may be blamed of qualified quackery, but let me put my viewpoints before this august audience. Presentation deals with candid discussion on evaluation and management of goiter. A 48-year-old serving officer in CISF was detected to have neck swelling 3 years during annual checkup. Thyroid profile was normal. He was diagnosed to be suffering from goiter, advised to avoid cabbage and radish. Some increase in goiter size took place for next 3 years. 3 years down the line, he was denied promotion on medical grounds of presence of goiter. He filed a petition in court. So this was the clinical picture. A goiter being not treated, and he was denied promotion by the authorities. A 25-year-old lady complained of swelling neck since later half of pregnancy. On evaluation, she had grade 2 diffuse enlargement with a transverse scar mark. She had underwent thyroid surgery before marriage. She did not receive any treatment before surgery, after surgery, and during pregnancy. Thyroid profile at the time of evaluation was within normal limit. Anti-TPO antibody was positive. A 38-year-old woman came for evaluation of neck swelling for about 12 years. She had some discomfort on swallowing. A local healer had advised tattooing 5 years prior. The swelling had apparently remained constant in size initially, but started increasing. There was a grade 3 multinodular goiter with tattoo marks. So we are forcing them to go to faith healers or to unqualified people by telling them not to worry, not to do anything. She had clinical evidence of retrosternal extension, and that was confirmed on imaging study. Now she is a candidate for surgery because of retrosternal extension with compressive symptoms. Then a lady, 28 years old, with grade 3 multinodular goiter, biochemically euthyroid, sonographically multiple nodules with cystic degeneration. FNA showed benign cellular morphology. She was advised, because of size of the tumor, subtotal thyroidectomy. Intraoperative and immediate post-operative periods were uneventful. 3 weeks after surgery, she presented with muscular cramps, tingling and numbness of hands and feet, irritability, disturbed sleep, and lethargy. She was slightly anemic, hypothyroid, hypocalcemic with hyperphosphatemia, and insufficiency of vitamin D, which was coincidental. So she developed hypopara after surgery. So that is a complication. So scar mark, hypopara, change in voice are the common complications. They are not common, but they are not uncommon as well. This was a 9-year-old boy presented with swelling in the upper part of neck, which moved upwards on protrusion of neck. CT scan showed ectopic thyroid gland. He was clinically and biochemically euthyroid, but since ectopia many times is associated in later life with hypothyroidism, and he had a swelling which was not desirable to look at, he was prescribed thyroxine with reduction in the neck swelling size. There is another lady with swelling in almost same location as the previous child, which turned out to be thyroglossal cyst. So here you require surgery if it becomes cosmetically demanded or required by the patient. Otherwise, it can be left as such. So the previous child was a candidate for thyroxine supplementation to prevent further increase in the swelling size. So with these case reports, let us look at the epidemiology. You can have enlarged thyroid gland which can be diffuse or nodular, which can be hypo, hyper, or euthyroid. It can present with compression symptoms. The prevalence is estimated to be more than 2 billion cases worldwide. In India, prevalence is expected to be 40 million, projected to be 40 million. If patient has hypo or hyper, you start treatment appropriate to the biochemical status. If it is euthyroid, do surgical intervention if it is large, causing compression symptoms, if there is malignancy, or when medical management is not practical or ineffective. Radioiodine therapy is suggested to decrease the mass of the thyroid gland and to take care of autonomy if it develops in a multinodular goiter setting. You have guidelines from Endocrine Society, from Indian Thyroid Society, from ATA, discouraging use of thyroxine, labeling it as unscientific, unethical, and unwarranted therapy for euthyroid goiter. The presumption that goiter is innocuous, is harmless, I feel is debatable. A person who sees a swelling in his neck day in and day out would be troubled by thoughts of existence of an abnormality. Looking at it would not be a pleasant experience for him or her. It may be noticed and pointed out by friends, colleagues, workmates, thereby making the person more aware of the abnormality. As I described a case of CISF officer, it is a ground for denying promotion and enrollment in paramilitary and armed forces. It may be cosmetically undesirable and may pose problems in matrimonial issues. Consensus, however, is to leave it as such. Surgical intervention or radioiodine therapy is required. Radioiodine therapy alone or with pre-treatment with recombinant TSH if it becomes large enough to cause cosmetic issues or causes compression, and surgery followed by radioiodine if it becomes malignant. If you look at the patient education leaflet from ATA, it says that many goiters such as multinodular goiter are associated with normal levels of thyroid hormone in blood. These goiters usually do not require any specific treatment after appropriate diagnosis is made. If no specific treatment is suggested, you may be warned. Look at the language. You may be warned that you are at risk of becoming hypo or hyper in future. However, if there are problems associated with the size of the thyroid, such as the goiter getting so large that it constricts the airway, your doctor may suggest treatment by surgical removal. So effectively, we ask the patient to wait till it becomes large enough or it becomes malignant or it causes compressive symptoms to undergo surgery. We have cases of malignancy treated with surgery and radioiodine therapy being given thyroxine suppression trial in the hope that recurrence would not take place locally or distally. If a de-differentiated malignant cell can be expected to respond to TSS suppression by high doses, can't we expect a normal thyroid follicular cell to respond to supplemental doses? I am repeatedly emphasizing not the suppression dose, but supplemental dose. And there is evidence to this in the form of LISA trial, which was conducted in West German city, involving 1,024 subjects over a period of 1 year, and it was placebo-controlled prospective trial. There was an iodide supplementation arm where the patients or the subjects received 150 microgram of iodide per day, a placebo arm, thyroxine supplementation arm, receiving 75 mic of thyroxine per day, and dose adjustment at 3-monthly interval to keep TSH above 0.2, and a combination of thyroxine and iodine supplementation in dose of 75 microgram of thyroxine with 150 microgram of iodide. Dose titration was done at 3-monthly interval. At the end of 1 year, there was 5.2% reduction in nodular size in placebo group, 9% in iodide supplementation group, 12.6% in nodule size in thyroxine supplementation, and the decrease in combo of thyroxine and iodide supplementation group was 21.6% from baseline. The reduction in goiter size was 10% from baseline in combo group as against 1.9% in placebo group. So this is a strategy which is cheap, readily available, free from side effects, as long as TSS suppression is prevented by periodic monitoring. And 21% reduction in nodule size and 10% reduction in goiter volume will be sufficient to render grade 2 goiter non-visible and serve the purpose of most of those suffering from small thyromegaly. However, there are some questions. The long-term course of the thyroid nodule after the end of the treatment, potential indication for switching to long-term iodide monotherapy from a combo, and optimal target range for long-term TSH control need to be established. Advantages are low cost, non-invasive nature, and no need for hospitalization. Disadvantages are unclear mechanism of action, lack of data on long-term success, iatrogenic hyperthyroidism is a possibility, and diminishing compliance over time, and being ineffective in large and nodular goiters, multinodular goiters. After Dr. Mayur asked me to make a presentation, I collected retrospective data from 15 July till 17th of September. 37 patients came for evaluation with euthyroid goiter on thyroxine supplementation. 9 were men, 28 were women, aged 18 to 45 years, under treatment for 3 months to 3 years. Baseline TSH ranged from 0.9 to 3.8, and thyroxine dose was from 25 to 88 mic. Diffuse goiter was present in 32%, solitary thyroid nodule in 27%, and MNG in 40%. In one patient, the size increased. 2 patients reported no improvement. 18 patients reported some improvement. 11 were satisfied with the degree of decrease. Near complete regression was reported by 5, and treatment was discontinued in last 2 months in 2 patients. Thyroxine supplementation is not indicated in this type of goiter, but small goiter are definitely the candidates to be given a trial for 3 to 6 months and subjected to definitive therapy in the form of surgery or radioiodine if required. I understand that many of you would not agree with the proposition, but leaving patients with advice to keep coming back month after month till it becomes large enough to be surgically treated is something which I find rather difficult to accept. Thank you.
Thank you, sir, for your talk. I think all of us have seen patients in our OPD who come with goiter and with cosmetic issues more often than not. And often we do not have any treatment to offer them if we go by the guidelines. So I think it was interesting to see your own data, and you have seen such significant improvement in most of the patients.
40% reported some improvement or satisfactory improvement.
Yes. So I think it is quite a good number, sir. Thank you so much for your talk. The next talk will be by Dr. Subodh Bansal on pitfalls in thyroid function test. It will be a case-based discussion. I would request Dr. Anand Kumar, sir, to introduce our next speaker.
Dr. Ajay,
no.
Are we skipping this?
Yeah, we can skip this and
it's a recorded session. We can play it later on. So because we are already running late, so let's make it on schedule. So I invite Dr. Ajay Shukla for the next session. He'll be Hormone India repertoire. He has done DM Endocrine from SGPGI along with me. He's working as a consultant at Hormone India Lucknow. Over to you to invite our chairperson.
Thank you, Dr. Mayur and Dr. Priyamada, and thank you all the speakers, Dr. Sarita Bajaj ma'am, Dr. VK Bharadwaj sir, for a wonderful session. So now we are going ahead with next session. For that, I will invite my chairpersons, Dr. Suvrit Jain and Dr. Mahavir Singh. Both are my seniors in Sanjay Gandhi PGI. Dr. Suvrit Jain is consultant oncologist at Choturam Hospital, Rohtak. He's done his MD from AIMS, and Dr. Mahavir Singh is MBBS, MD Medicine, DM Endocrinology from Sanjay Gandhi PGI, and is consultant endocrinologist and associate professor of NIMS Jaipur. So I invite both of you. I request Dr. Suvrit Jain, sir, to introduce Dr. Jaideep Khare, sir, for update on T3 replacement.
Thank you, Dr. Ajay and Dr. Mayur, for giving me this opportunity. I'd like to introduce the speaker for this session, Dr. Jaideep Khare. He's an endocrinologist. He has done. He's presently associate professor in Department of Endocrinology in People's College of Medical Sciences, and Director Hormone India and Skin Center in Bhopal. He's the Joint Secretary of Madhya Pradesh Endocrine Society. His total clinical and academic experience is 12 years. He has lots of achievements and honors to his credit. He won the Best Thesis Award in Medicine in 2013 in KGMU. He also received the Best Paper Presentation Award in Epicon 2017 and IdeaCon 2017. He received the USD RSSDI Award for Excellence in Diabetes Care in 2019. He also has several other awards, and he has published various national as well as international publications in reputed journals, and he has delivered several national and international presentations. He's also a member of editorial board in several endocrine and medicine journals. So I invite Dr. Jaideep to deliver his talk.
Dr. Jaideep, are you there? Dr. Jaideep, sir?
Kindly unmute.
Is joined but not able to communicate. Can we go ahead with Dr. Saptarshi Bhattacharya? Dr. Saptarshi, are you there? Dr. Saptarshi.
I am here. I am here. Yeah, thank you. So should I start? Yeah.
No, sir. Dr. Mahavir, kindly introduce our speaker. Yes.
Sir is an endocrinologist, and he did MD in medicine and DM in endocrinology. He completed the specialty certificate from the UK. He's presently senior consultant in endocrine medicine in Trust Apollo Hospital. He's working as a director in e-health and services in diabetes and endocrinology center in Noida. He's the executive committee member in Endocrine Society of India. He's founder secretary of the Delhi Endocrine Society. He's the recipient of the President's Award of Appreciation in 2021 from the Endocrine Society of India. He is ex-president of the Society for the Promotion of Education in Endocrinology and Diabetes, that is SPEED. He's scientific secretary in Endocrine Week 2020, which is organized by the Endocrine Society of India. He has more than 60 publications in national and international journals. So over to you, sir, for your talk in this session.
Thank you, Dr. Mahavir and Dr. Ajay, and thank you, Dr. Jaideep, for the invitation. So I must first congratulate you for the wonderful way you have conducted this whole scientific extravaganza. The topic I will be covering in the next 15 minutes or so is when to poke a thyroid nodule. My screen is visible properly?
Yes, sir, it is visible.
Okay. I think this is a very, very common situation. And before we go ahead, we need to first understand what is a thyroid nodule. So it's a discrete lesion which present in the thyroid gland, and that should be radiologically distinct from the surrounding thyroid parenchyma. So the first thing what we need to understand is, so even if we are clinically getting a nodule, and so somebody might be having a nodular thyroid morphology, but if we are not able to discern a nodule on an ultrasound, so that should not be called a thyroid nodule. So this is unlike most of the situations where we go by the clinical diagnosis. So this is thyroid nodule first of all, we need to understand is a radiological diagnosis. So this is the most important thing what we need to understand. So that implies that whenever we are talking about a thyroid nodule, we should have a radiologic evidence and confirmation of that nodule. So there are different types. We know that there are benign nodules and malignant nodules, and 90% of the nodules are fortunately benign. But the primary target of evaluating a thyroid nodule is to segregate out those 10% which are actually malignant. So if the primary objective when you are going to evaluate a thyroid nodule is, we need to understand that if that nodule is harboring a cancer, we need to detect it and we need to manage it appropriately. So this is the most important aspect of thyroid nodule diagnosis and management. A brief look at the epidemiology. So prevalence is 4 to 7%. It will go up with age. The females have more chance of having nodules. Also, however, in the ratio for malignant nodules, the females. So if a male is having a nodule, there is a slightly higher chance that it might be malignant. So in a male nodule should be evaluated with more caution. So in clinical examination, around 5% in women, 1% in men in iodine sufficient population. We know India is a iodine sufficient country, and ultimately it's a radiological diagnosis, and depending on the age and iodine sufficiency and other factors, it might go up to 19 to 68% on an ultrasound. So the first step is how to ascertain the clinical background. There are some factors like radiation therapy, family history of thyroid cancer. These are important. The age is important. Younger age, higher chance of malignancy. Elderly, higher chance of malignancy. Males, higher chance of malignancy. Location in the isthmus, higher chance of malignancy. And the physical examination, whether the nodule is firm or fixed, how rapidly it became large, where the nodule is located, and whether there are any compressive features or not. So these are all important factors. And having said that, we need to understand that it's not all nodules in the neck are thyroid nodules. You can have congenital conditions, infections like tuberculosis, or there can be neck abscess or cervical lymph nodes which might mimic a thyroid nodule. So an ultrasound diagnosis again is usually able to differentiate between the two. So a very important entity, if there is a family history of papillary thyroid carcinoma, medullary thyroid carcinoma, or thyroid cancer syndromes like Cowden syndrome or MEN2 or Werner, then again you need to be very, very careful. So you need to be very, very sure that before you label that the nodule is benign. So after you have gone through the physical examination and history, check the next step is to check the thyroid function status. So you do a thyroid profile. If the TSH is normal or if the TSH is elevated, then so you go ahead with the evaluation as per protocol. But if the TSH is low, so we will deviate from the standard protocol. So we need to get a thyroid scan done at that particular stage. So in maybe 2 decades back, it was like, okay, you have a thyroid nodule, you get a thyroid scan. So thyroid scan has no role unless the TSH is low. So for a routine evaluation, with a normal TSH or an elevated TSH, please do not get a thyroid scan done. It's not going to anyway add to any additional information. So if in the thyroid scan, it can be a hot nodule, or it can be like that occurs in toxic autonomous nodule, or it can be part of a MNG, or it can be part of a mimic Graves disease where the other lobe is silent. But usually, most of the cases, if we are getting a hot nodule, we more or less have the diagnosis of toxic autonomous nodule. The treatment for that is radioiodine ablation. Your chance of malignancy is practically less. You don't need to get an FNAC. You can go for radioiodine ablation, and prior to that, the person might require anti-thyroid medications for normalizing the thyroid profile. So thyroglobulin, again, as a routine assessment, does not have any role in evaluation of thyroid nodule. Only it's in the follow-up of thyroid malignancy, thyroid papillary thyroid cancer or follicular thyroid cancer. thyroglobulin has a role. It does not have any other role, just for routine diagnosis. So don't get a thyroglobulin level if you have found a nodule on the ultrasound. Calcitonin, we do not have any strong evidence to go for it or not go for it. But obviously, if there is a family history of medullary thyroid carcinoma, or there are ultrasound features which are suggestive of medullary thyroid carcinoma, you might go for calcitonin. Again, routine calcitonin measurement, most probably we do not have any evidence to suggest it. TPO antibody, you might get it done. It's a marker of thyroid autoimmunity. Again, no definitive role as such in assessment of whether there is malignancy or not. So getting a thyroid peroxidase antibody most probably not going to help in the management of a thyroid nodule. So as I already told, if there is suppressed TSH, if there is a toxic autonomous nodule, you need to go for a radioiodine scan. So this is the most important step, is to get an ultrasound. So ultrasound will guide us when to poke a nodule, coming back to our main topic, whether when to follow it up, or we can just leave it. So most of the information related to a thyroid nodule has to be depends on the findings in the ultrasound. This is how a normal thyroid will look. So this is the right lobe, this is the left lobe. You can see the surrounding muscles. The thyroid is slightly more echogenic than the surrounding muscles. So the strap muscles are hypoechoic as compared to the thyroid nodule. So usually a B mode grayscale ultrasound is done. Sometimes to assess vascularity, you can do color Doppler, and there are some studies related to elastography as well. So what are the features we need to look into ultrasound? The most important is echogenicity. I already told that. So if you are getting a hyperechoic nodule, so again, most probably, so that is a safe thing. So the alarming situation is if you are getting a hypoechoic nodule. And the composition is also very important. So if you can see here, if it's a cystic nodule, so that means the chance of this is like a cystic nodule. The chance of malignancy is practically very, very, very less. So these are the different compositions. So this is a cystic nodule. So if you have a partly cystic, partly solid component, it does not, if it rule out malignancy in any way. If it's totally cystic, then only malignancy can be ruled out. If it's predominantly solid, obviously you need to look into the echogenicity of the nodule. And there is another entity called spongiform multiple tiny cystic species. In that case also, the chance of malignancy is very, very less. So if it's a cystic nodule, or if it's a spongiform nodule, you are more or less in a safe zone. But in all other situations, you need to look into other factors also. So echogenicity, so you can see the first nodule, this is hyperechoic. It's more dense than the rest of the thyroid gland. So again, that is something which is reassuring. So if you get a hyperechoic nodule, the chances of malignancy is less. If it's an isoechoic nodule, so same consistency as rest of the thyroid, or hypoechoic nodule, so then you need to be careful, and that increases the chance of malignancy. So first you look into the composition, then you look into the echogenicity of the nodule. Hypoechoic nodule, you need to be careful. Now you need to look into the shape of the nodule. If the nodule is taller than wider in the transverse view, the chance of malignancy is more. So that occurs because of the rapid expansion of the malignant nodule. And if you have irregular margins, it's understood that the chance of malignancy is again going to be more. So these are all alarming signs. So smooth nodule, chance of malignancy less. If it's an irregular nodule, infiltrative nodule, showing extrathyroid invasion. So all these are features suggestive of malignancy, and you need to be careful. So now there are some calcification patterns. So if you have microcalcification like you see here, so and irregular borders, again suggestive of malignancy. Interrupted eggshell calcification, so again suggestive of malignancy. So, but there are some patterns of calcification which do not suggest malignancy. So, and also another important factor is lymph node. So you need to look into the lymph node character. So if you are looking into an echogenic foci dot-like less than 1 millimeter, that is called microcalcification. If it's more than 1 millimeter, that is called macrocalcification. There can be comet-tail artifacts, again suggestive of benign nature of the nodule. Vascularity is another important factor. So if it's if it shows internal vascularity as well as peripheral vascularity, the chances of malignancy is higher. So there are two essential classifications which guide us from the ultrasound findings whether we need to go for FNAC or not. One is the ATA nodule sonographic pattern. So there are patterns like highly suspicious pattern like microcalcifications with hypoechoic nodules, hypoechoic irregular margins, hypoechoic taller than wide. So these are conditions we have already discussed suggestive of highly suspicious of malignancy. So even with a nodule more than 1 centimeter, you need to go for an FNAC. There are some like with intermediate suspicious pattern, hypoechoic nodule with solid nodule with regular margins, hypoechoic solid nodule, hypoechoic solid regular margin nodule. So these are features where you need the suspicion for malignancy is intermittent in the range of 10 to 20%. Whereas if you have hyperechoic nodule, a cystic nodule, the chances of malignancy goes down. If you have a spongiform nodule or a partial or a cystic nodule, the chance of malignancy is very, very less. So this is the ATA, American Thyroid Association recommendation. Highly suspicious pattern, go for an FNAC at more than 1 centimeter. Intermediate suspicion pattern, like hypoechoic nodule with smooth margins without calcification or taller than wide in shape. So you go for an FNAC even at 1 centimeter. Low suspicious pattern like isoechoic or hyperechoic solid nodule or partially cystic nodule with eccentric solid areas, you go for FNAC at more than 1.5 centimeter. Very low suspicion and benign nodules are spongiform or partially cystic nodules without any of the above sonographic features or purely cystic nodules. In those cases, you don't require to do for an FNAC. Very low suspicion pattern, you need to go for an FNAC at more than 2 centimeter. The TRADS is the other way. They have classified the different nodules according to the radiologic criteria. So they have given points according to composition, echogenicity, shape, margin. So these are the and calcification. So these are the patterns where points have been assigned. So and if it's 0 points is TRADS 1, 2 points TRADS 2, 3 points TRADS 3, 4 to 6 TRADS 4, 7 points or more TRADS 5. So ideally a radiologist should be providing a TRADS score for the ultrasound for the nodule which has been detected in the ultrasound, and we can. So there are classifications. So depending on if it's TRADS 5, you need to go for FNAC at more than 1 centimeter. 4 to 6 at 1.5 centimeter. More than 3 TRADS 3, you need to go for FNAC at more than 2.5 centimeter. So these are the TRADS classification. So either you can follow the ATA class guideline or you can follow the ACR TRADS guideline to decide whether FNAC is required. So again, there are some features on the ultrasound of the neck nodes which is suggestive of thyroid possibility of malignancy. So microcalcification, peripheral vascularity, hyperechogenicity, and round shape. So these are features which can predict the malignant nature of a lymph node. So if you have a lymph node which are having these features, you need to get an FNAC simultaneously, both from the thyroid nodule as well as from the lymph node. So if you are getting a suspicious lymph node, so you should get FNAC from both. So finally, so should you get an FNA done? It depends on, first of all, clinical information, then step 3, you ultrasound features, and finally, you look into the size of the nodule, and that will guide you whether you need an FNAC done. So these are the current summary of various guidelines. There are other guidelines also. I'm not going to the details of that. So more or less, ACR, TRADS or ATA is the standard way which helps us decide to go for whether to go for an FNAC or not. And once you get an FNAC, you should ideally, the pathologist should label the thyroid nodule as 1 to 6 of Bethesda, where 5 to 6, the chance of malignancy is very, very high. The treatment will be near total thyroidectomy or along with associated lymph node exploration of the node. And in case of 3 or 4, you can go for molecular testing or lobectomy. And if you detect FNAC on the FNAC suggests there is a malignancy 5 or 6, you need to go for total thyroidectomy. So finally, to recap, first step, if you get a thyroid nodule, ascertain the clinical background, then check thyroid function. TSH low it's a toxic autonomous nodule, you can go for a radioiodine ablation. Next step, get an ultrasound. Then if you get after getting an ultrasound, classify it according to one of the criteria which will help us assess whether to go for FNAC or not. Once you get an FNAC, interpret according to the Bethesda category. So I haven't gone into molecular testing details. So this is this, if available, you can consider for patients who are having Bethesda 3 or 4, having intermediate suspicion of malignancy. So there are some which help us to rule out, or some which might help us to confirm whether malignancy is present. And finally, if you get a nodule which is suggestive of malignancy, you need to go for surgery. Thank you once again for your patient listening. If there are any questions, I will be happy to answer.
Thank you, Dr. Saptarshi. Like in your practice, what do you prefer, like ATA or ECR type?
TRADS. I will prefer TRADS.
Okay.
So that is the most commonly followed one. Even ACA, there is very little difference, maybe 2 centimeter and 2.5 centimeter. And I will look into the patient's clinical profile also. If somebody had a past history of radiation, say for a laryngeal cancer and has a thyroid nodule. So those are also other important aspects, which, or a family history of thyroid, maybe at a slightly lower suspicion, I might go for it.
Okay. So with this, I invite Dr. Jaydeep.
Excuse me, sir. There are a few questions in the chat box also. We'll be very happy if you can answer in the chat box itself.
Okay,
Dr.
thank you. Thank you so much.
Yeah.
Okay.
Thank you, sir.
Thank you.
So now I ask Dr. Subrit Jain sir to introduce Dr. Jaydeep Khare.
Already his introduction has been done. We'll be running late, so we can switch. And just to add, I'll congratulate Dr. Jaydeep for bringing 2 DM endocrine seat at Bhopal.
Thank you, Mayur. Aajao. So thank you. And sorry, I was in another call at that time. I was thinking that Dr. Banjal's lecture will be going on after that one.
No,
So
you can take over, sir.
yeah, thank you. So my today's topic has been slightly covered by Sarita Bajaj ma'am itself, that what is the update on T3. So the most important thing is that whenever we are planning to replace T3, it should be under supervision. Still, the T4 is the treatment of choice for any hypothyroidism, but 10 to 15% cases which doesn't get resolved of their symptoms. So I will be covering about those guidelines. So in a brief introduction, we know that hypothyroidism is one of the most common endocrine disorder seen in approximately 6 to 17% population ranging from various regions, and it is more prevalent in women. And the complications and the clinical manifestations depends and varies from nothing to several features. And it also depends on the duration of the thyroid that the patient is not taking the treatment. So since 1970, levothyroxine replacement therapy is the standard of care in hypothyroid patients, which has replaced the desiccated thyroid extract, which was used for several years in prior years. So whenever we are making the diagnosis of hypothyroidism, the treatment target is to achieve biochemical euthyroidism, that is thyroid profile, which we get in our lab report is normal. Clinical euthyroidism, that is the patient is resolved of his all symptoms. So in a brief introduction, again, that the first report of use of the desiccated thyroid is given in the literature long back in 1891 by Dr. James, and initially it was derived from the sheep and it was injectable forms like insulin. But now it has it was turned into the tablet forms for next 50 to 60 years till 1970, which was made from the beef and the pork thyroid extract. After 1970, it is by the molecular genetic engineering, and we are getting the tablets of levothyroxine. So there is difference between animal and the human thyroid physiology, and the so the pharmaceutical industries had noticed that thing. In humans, the ratio of T4 to T3 is 14:1 in the peripheral blood. But in pig, cow, sheep, it is approximately 5:1 or 4:1. So they've thought that if we replace T4 itself, then there are deiodinases enzyme in our body and it will get converted to T3, and that became the treatment of choice. And the benefits are there, that it is easily, it can be consumed easily, the half life is long, so it is more convenient. And but once something comes, there is always dissatisfaction. So there was dissatisfaction in 10 to 15% cases, and they found out that even if we are giving monotherapy, they are not achieving the clinical euthyroidism. Maybe at the molecular level some defect is there, or whatever, they are not able to achieve it. So the studies, and then the scientists again started finding out that when we are just giving low LT4, there is low free T3 values, and that may lead to some disturbances. And several times we see that the thyroid function test is normal, but the patient is complaining, साहब मेरा बदन दर्द अभी भी नहीं गया, मेरे को सुस्ती लगी रहती है, वजन बढ़ता ही जा रहा है, and the physicians start over treating. The dose of LT4 increases. They just think that it might be lab values may be defective or something. So the patients go into iatrogenic hyperthyroidism, and that is also harmful. So there is renewed interest in late 90s and early 2000s that T3 should be brought back to the standard therapy to mimic more physiological thyroidal secretions. So why? We know that from the thyroid gland, both T3 and T4 are secreted. 20% of the peripheral T3 is secreted from the thyroid gland, and 80% is converted from T4. And T3 is much more active, and receptor affinity is approximately 10 to 20% time. But T4 is having longer half-life, and T3 is having just half-life of around 4 to 6 hours. So how does, if we are giving just long LT4, the circulating T3 will be derived from the T4 by dehydrogenation. If the patient is having defective enzymes, then this will not happen. And if we are giving just T3, then T3 is having short half-life, so there will be much fluctuation, but T4 is having longer half-life, so it brings better compliance and lesser fluctuation. And there are studies that if T3 is used, then the value levels of T3 increases abruptly, immediately, and that can lead to complications like arrhythmias if it is given in inappropriate doses. So important thing is, if we are thinking to give T3, it should be under the supervision of the specialist, that is an endocrinologist. So thus both the ATA and ETA guidelines suggest that in selected cases, trial of LT3 can be considered under careful supervision by an expert in that field. So there were several trials in which they have included the participants, and they have, the criteria for inclusion was that the patients, those who are not getting relief with the LT4 therapy only, were recruited, or those who were having dissatisfaction with the quality of life on questionnaire based assessment, and they were included in the trials. All the patients, those who were taking minimum 1.2 microgram per kg of LT4, and still their thyroid profile was not getting controlled, and their thyroid functions were abnormal, and their clinically they are not achieving euthyroidism. Instead of increasing the doses, they have added the T3 levels. And then the patient, those who were having seriously low T3, total T3 levels, or free T3 levels, those who were already on LT4 monotherapy, were included. So what they found out, that LT4 monotherapy administered once daily produces low normal T3 levels, with low levels being seen in some thyrotomies animal patients also. So it is good if we give some T3, because it will improve the T3, which is 20 times more potent, and it is actually going to act on few receptors, like in central nervous system. The T3 is the only, the central nervous system has just T3 receptors. So it may improve the cognition, it may elevate the signs and symptoms of depression, but it has to be given cautiously. Then LT4 monotherapy administered once daily increase the T4 to T3 ratio, and compared to the native euthyroidism levels. And in pharmacological equivalence, the LT3 to LT4 is approximately 1:3 ratio. So they have improved from 1:14 to 1:3. And in LT3, LT4 combination therapy with the LT3 given once daily produces up to 40% increase in T3 levels, and which may be useful also, may be having side effects also, because T3 may lead to arrhythmias if it is given in excess, and may lead to anxieties also. And the combinations which are expected to produce 7, 44, 88% fluctuations when they are given in the doses, like if the T3 is given in 3.25 microgram per day, then it can produce the fluctuation of 17%, 5, then 44%. And if it is given 10 micrograms, like cytomel tablets, which we have used several times, it produces the fluctuation of 88%. But when T3 is given, the variation is very high, and interpretation of TSH becomes difficult. And again, whether once we have given T3, the TSH drops very rapidly. The mechanism is not very clearly known, but yes. So the physiological dosing of LT3 is difficult. And to achieve conventional T3 preparation with the conventional T3 preparations which are at present, so we need the T3 preparations which are more physiological, and those are slow release, so that it may the fluctuation becomes lower. So to summarize all those studies, there is need for newly adequately powered studies, because till now there are just 14-15 studies, and those have been of shorter duration of 3 months to 6 months only. So these trials has to be of longer duration to be conducted, so that more clear data are there, and the advantages and disadvantages of the parallel versus crossover trial design should be maintained. That in these patients, they have just recruited the patient, those who were fitting into those trials. They haven't crossed over, or they haven't changed the treatment pattern and asked the patient that whether they were feeling better with the monotherapy itself, or they were feeling with the combination therapies. And the etiology of hypothyroidism and the presence of comorbidities conditions should be considered, as I am saying again and again, that if T3 is given, then it is very active, powerful molecule, and it can lead to arrhythmias. And subgroup analysis should be considered in which the combinations was better. So these are the various formulations which are available, and cytomel is the one which we have commonly used in our practice when I was doing my DNB, and other combinations are like this. So to conclude, the recent guidelines suggest that there is insufficient or no strong evidence or superiority of combination of LT4 LT3 monotherapy over LT4 monotherapy. But it also acknowledges that the patients, those who have persistent symptoms or have suboptimal health despite LT4 monotherapy, the patients can be given the trial of the combination therapy if it is supervised by an expert. Thank you. Thanks a lot, because this is coming up, because earlier when the desiccated thyroid was given, it was almost giving the it was like so these studies are coming up that desiccated thyroid contains both T4 and T3. So I have made this slide old is gold. Then again, what we are learning, which may return back. Thank you. Thanks for patience hearing.
Thank you, Dr. Jaideep Khresa. So in your practice, like you said, you used it sometime.
Yes.
So what is the exact condition when you use that, and how was the, like, when you monitor TSH exactly? Like
no, we haven't monitored the TSH at that time. That when I was doing my DNB and when I was SR at Hyderabad, that time whenever the patient used to come for the emergency surgeries, and the patient is in mixed or the TSH is more than 60, then my boss used to say that give some amount of T3, the TSH will drop rapidly, and we can give the fitness to surgeries, because the surgeons like cardiothoracic surgeons or any neurosurgeon, they want that the TSH should be normal before surgery, and if it is an emergency surgery, we can give it.
Is it not unsafe in that emergency situations? Like if we...
Yes, it is definitely. So that's why we should monitor the pulse rate or the heart rate if it is increasing or not. That's why we are again and again saying that it has to be given under supervision only. And the another thing, like we don't have the injectable T4 available in our country. So whenever the patient with myxedema, severe cold, and is seriously sick patient, the cytomel tablet is available in market. We can give it 50 milligram once or twice daily. It will rapidly change the parameters.
Yeah, I think that is the more clear use, I think we can think.
Yes. Thank you.
Thank you, Dr. Jaideep. So I request Dr. Mahavir Singh sir to invite Dr. Gagan Priya ma'am for next session.
Yeah, Dr. Ajay. So I am going to introduce Dr. Gagan Priya. She is a senior consultant endocrinologist at Fortis Mohali. She received many awards, scope certified by the World Obesity Federation, IGM awards for the Best Reviewer 2021, IGM award for the Best Review Article for 2018, Professor MMS Ahuja Award from the AIMS in 2007, and she has co-edited 3 books, and she was in section edited in many books. She has over 65 publications and 25 book chapters in her portfolio. She's a founder of FLAME, that is Forum of Ladies in Medicine. She's a co-editor of the Diabetes India, and she is Indian ambassador in the Diabetes. So over to you, ma'am, for the presentation.
Thank you so much, and congratulations to the team of Hormone India. It's lovely to see such young, dynamic endocrinologists taking the lead in academics ahead. So the topic in the next 20 minutes or so I'll talk of is the etiological diagnosis of thyrotoxicosis. I think upfront, it's very, very important for us to realize that first and foremost, we have to remember not all thyrotoxicosis is hyperthyroidism. Hyperthyroidism is only when the thyrotoxicosis has been caused by an inappropriately high synthesis and secretion from the thyroid gland per se of thyroid hormones. Of course, there can be extra-thyroidal origin of thyroid hormones. We'll talk of in a few cases. But thyrotoxicosis as an entity is a clinical condition that results from excess thyroid hormone effect in various tissues. So that excess thyroid hormone can be iatrogenic, can be hyperthyroidism, can be thyrotoxicosis due to thyroiditis as well. Now, these are some of the common causes we will encounter in clinical practice. Thyrotoxicosis with hyperthyroidism most commonly is seen from Graves' disease or nodular goiter, which can be toxic, multinodular or solitary toxic adenoma. But then we have the rare cases of TSHomas from the pituitary. We could have congenital hyperthyroidism and certain pregnancy-related conditions. I'll stay away from that for this talk. Then even high iodine exposure resulting from contrast agents or iodine-containing drugs like amiodarone can result in hyperthyroidism. The extrathyroidal sources of thyroid hormone could be certain ovarian tumors like struma ovari or metastatic follicular cancer. The other entity we must differentiate from hyper is when there is no hyperthyroidism, but there is a feature of thyroiditis, wherein since the thyroid gland stores in a lot of thyroid hormone in the follicles. So if there is any insult on the thyroid, such as an inflammation, infection, or drug-induced thyroiditis, it can cause an outflow of that stored thyroid hormone and lead to a transient phase of thyrotoxicosis. So all forms of thyroiditis would basically come in this category. And then, of course, can be exogenous sources of thyroid hormones, such as patients taking it for therapy. We know that we suppress TSH in patients who have thyroid, differentiated thyroid malignancies, and there can be other reasons, accidental overingestion or fictitious thyrotoxicosis because of intentional intake. Now, the clinical picture could vary from, most patients you would pick on when they come with frank features of thyrotoxicosis, but quite often you would get referrals because of abnormal lab values wherein you are suspecting thyrotoxicosis. Then there could be goiter, nodule, presentation with neck pain, and certain other things like ophthalmopathy or the history of ingestion of medications. Now, it is very important to make the etiological diagnosis because that will determine the course of management. The management for thyroiditis versus hyperthyroidism is going to be entirely different. And between hyperthyroidism categories also, the management of Graves' disease is going to differ from multinodular goiter or from toxic adenoma. So the very first question is, confirm your thyrotoxicosis. Of course, when you get a clear picture of elevated thyroid hormones with suppressed TSH, prima facie, we can assume we are getting confirmed thyrotoxicosis, but you could have these two entities with normal free T3, free T4, and suppressed TSH, which could be either subclinical thyrotoxicosis, but this picture can also occur in non-thyroidal illness, or could be caused by certain drugs like steroids, or if a patient has undergone recent treatment for hyperthyroidism, partially treated, again, you could have this clinical picture. The second entity that we might encounter is elevated free hormones, T3 and T4, and the TSH may be normal or elevated. Again, you could have a multitude of reasons for such a kind of presentation. Most commonly, this could result from assay interference. If total T4 and total T3 are high, but free hormones are normal, think of elevated TBG levels, elevated binding proteins. But again, you could get such picture from a patient who is on thyroxine and not very compliant. So just a couple of days before your test, usually these patients will tend to take adequate thyroid hormone, and you might get this kind of a picture. But having excluded all of these, then you have to think of resistance to thyroid hormone or TSH adenomas from the pituitary. Let's look at a case scenario about what I'm exactly meaning here. So 25-year lady comes with a package report and says she has a thyroid problem. You can see a T4 elevated, TSH is low. There are no clinical signs or symptoms. When you take a careful history, she has been on supplements taking for the last 1 month. So what happens is she stops those supplements, comes back after 2 to 3 days with another report, and this time the thyroid hormones are actually normal. This is not an uncommon condition to encounter. And what is happening here is she was taking a hair supplement containing high doses of biotin, and she was taking 2 tablets a day. So it has to be remembered that certain substances can interfere with thyroid hormone assays, and biotin in particular, because these assays use biotin-related compounds. You could have false low values in sandwich assays for TSH, and for T3, T4, even the antibody titers could be false high because of interference with biotin. So these lab abnormalities we should be able to exclude. The next important thing is it hyperthyroidism or not? And mind you, thyrotoxic symptoms may not differentiate thyroiditis from hyperthyroidism. There could be certain clues in clinical picture like stigmata of Graves' disease, ophthalmopathy, or presence of nodules or goiter, a past history of thyroid disease, or a family history of autoimmune diseases, or personal history of autoimmune diseases, which could point to etiology. Look for any recent respiratory infections, neck pain, tenderness, pregnancy and postpartum state, and a detailed medication history of a lot of medications can interfere with thyroid or physiology, including thyroxine, iodine, amiodarone, lithium. But now we also know certain cancer drugs like tyrosine kinase inhibitors, immune checkpoint inhibitors, they can cause all sorts of thyroid dysfunctions. So the next question, when you look at biochemistry, you can look at T3, T4 ratio. And in patients who have tissue hyperthyroidism, T3 is usually secreted in higher concentration compared to thyroiditis, where T4 levels are higher, because that's the more, larger amount of stored hormone. So several experts have suggested looking at T3, T4 ratios. Total T3, total T4 ratio of more than 20 could indicate hyperthyroidism. For free T4, the ratio is 4.4. So let's look at two same patient with two kind of blood pictures, 32-year male coming with thyrotoxic symptoms. In the first picture, you can look at total T3 is high, total T4 is not that high, you're getting a ratio of 29. In the second picture, you're getting a ratio of 15. There possibly the second case is thyroiditis, in the first case is hyper. So let's look at a couple of clinical scenarios as we go along investigating. So we have a 35-year lady coming with thyrotoxic symptoms lasting 3 months. She has diffuse goiter, no nodules, no tenderness. And on the examination, you can clearly see exophthalmos and periorbital edema, conjunctival erythema. You look at her profile, it is suggestive of frank thyrotoxicosis. So do we do any further investigations, or can we make a confident diagnosis at this stage? So if the clinical picture is suggestive, and you get these telltale signs of Graves' disease, you can make a confident diagnosis of Graves' disease and put on therapy without the need for investigations further, other than, of course, for planning of therapy. So you can see clearly exophthalmos, lid retraction, periorbital, anterior neck pain radiating to the right ear. 3 weeks back, there is a history of URTI that has improved. And on examination, you get a grade 1 firm palpable diffuse goiter. Again, you're getting T3, T4, TSH, all showing thyrotoxicosis. T3, T4 ratio is 12.8. What should be the next step? Do we go ahead with avoiding the need for unnecessary investigations? And this picture suggested subacute thyrotoxicosis. So we could have managed it as subacute thyroiditis clinically also. But 2 more cases, 35-year lady, weight loss, tremors and palpitations, 3 months, there is diffuse goiter, no nodules. You see a hyperthyroid kind of a blood picture on the thyroid profile. What should be the next step in this case? Can we assume Graves' disease or nodular goiter, etc.? No. The other case is a 43-year lady, again coming with symptoms since 1 month, diffuse goiter with a left side nodule. There is no bruit, and you're getting a picture of hyperthyroidism also. So let's look at how we approach these 2 cases. So what are the differentiating tests we can perform in such a scenario? We can do a thyroid scintigraphy and uptake that we've been doing, I think, ever since I did my DM. That was the first approach. Or we could measure a TSH receptor antibody and ultrasound with color flow Doppler. So why thyroid scintigraphy? Because it helps differentiate various causes of thyrotoxicosis. So if the uptake is normal or increased, think of Graves' disease, nodular goiter, or adenoma. If the uptake is absent, it indicates either tissue thyroiditis or the source of thyroid hormones is elsewhere, like struma ovari or fictitious. The other thing we look at scintigraphy is the tracer distribution, and it's very discriminating again in a way that Graves' disease, you would have a clear picture of diffuse increased uptake in both the glands. That's Graves' disease. Then you could have a functional adenoma wherein you get the uptake only in that part of the gland nodule and the uptake elsewhere is suppressed. Or you could have a classical picture of toxic multinodular goiter, and thyroiditis would have no uptake in thyroid gland, but uptake would be okay, normal in the salivary glands. So in a way, thyroid scintigraphy could be a very useful investigation to differentiate all the various factors. But of course, availability is limited. Cost is a consideration. And if there has been a recent iodine exposure, such as the patient has undergone a recent CT scan with iodinated contrast, it might be unreliable on the thyroid scintigraphy. And even in areas of iodine insufficiency, the uptake might not be very good. However, for times since long, I think thyroid scintigraphy has still been considered the next best investigation in line. But more recently, the role of measuring TSH receptor antibodies has been increasingly understood. And while these assays were difficult to access in the past, I think in the last 1 decade or so, they are more readily available. And what we are measuring by commonly in clinical labs is the competitive binding assays, where we measure thyroid binding immunoglobulins. The bioassays are reserved for research purposes, but even these competitive binding assays have very high sensitivity and specificity for Graves' disease. And if negative or inconclusive, you could think of scintigraphy. In fact, in a recent meta-analysis by the European Thyroid Society, they summarized that using TSH receptor antibody as the next step instead of technetium scintigraphy has shortened the time to diagnosis by 46% and cost by 47%. And in fact, a lot of other countries like Japan and Korea are also recommending TSH receptor antibodies as the next step. But this has to be paired with ultrasound with a color Doppler. In fact, ultrasound also can have very good discriminatory value when done by a trained radiologist or endocrinologist. And what you would see in Graves' disease is a diffuse enlarged hypoechoic gland with a picture that's very typical called thyroid inferno, increased blood flow throughout the gland. On the other hand, thyroiditis would have a gland which is heterogeneous and there would be decreased blood flow. And of course, nodular gland can easily be picked up. In fact, ultrasound might always be needed in a patient with a nodular goiter for correct characterization of those nodules. So let's go back to the two patients we had. So 35-year lady with no other features, just a diffuse goiter. What was done was TSH receptor antibody, it was positive. Ultrasound showed a diffuse goiter with increased vascularity. The diagnosis could be made Graves' disease. The second lady had 43-year lady had thyrotoxicosis, but along with diffuse goiter, she also had a left side thyroid nodule. So for her, the next approach was a technetium scintigraphy and uptake. And while it showed a Graves' disease, it also showed a cold nodule. And I think we already heard from Dr. Saptarshi earlier about how to manage cold, approach these suspicious nodules. This should be further characterized by ultrasound and FNAC for further treatment. So this is to summarize where we stand with the next set of investigations. So you could consider radioactive iodine uptake, which will help differentiate between toxic goiter versus Graves' disease versus thyroiditis or other causes, or depending on availability or lack of availability of radioactive iodine, you could consider a thyroid ultrasound with TRAP. And if you have a TRAP positive diffuse goiter, it's Graves' disease. If you have TRAP negative nodular goiter, then characterization has to be done with both ultrasound and radioactive iodine. So just to summarize, we'll go through a couple of other cases. So this is a 61-year lady with you can see a clear multinodular goiter and you're seeing thyrotoxicosis. In this case, I think we need both ultrasound as well as technetium scintigraphy. Scintigraphy will give us the diagnosis as far as the cause of hyperthyroidism, but an ultrasound will also help to plan the next steps, which most likely in this patient would be surgical. Another lady comes with 67-year lady anxiety palpitations. When you see the blood picture, she has subclinical thyrotoxicosis. She also has hypertension, is 67. She has a nodule 3 centimeters. So then possibility clinically also is AFTN. And when you do the next test, technetium scintigraphy, it confirms the toxic adenoma and it can be easily managed with radioiodine ablation. This was another atypical case from my clinic. She kind of moved us around a bit before we came to the diagnosis. A 36-year lady came with frank thyrotoxic symptoms. She had a history of hypothyroidism diagnosed 4 years back, was on levothyroxine. 2 months back, her referring physician had stopped her thyroxine because she had the blood reports had started showing thyrotoxicosis. And after 1 month, he had put her on methimazole because the thyrotoxicosis somehow persisted. She insisted she was taking methimazole regularly. She was taking nothing else. And when you saw her blood picture, free T4 and free T3 are markedly high, TSH is suppressed. We did a technetium scan, there was no uptake. We did an ultrasound, which was a very small gland, no nodule, no increased vascularity. We also actually did an ultrasound of abdomen pelvis for any ovarian tumors, there was nothing there. So this is a very atypical presentation. And the patient was withholding a lot of information. So the next step in this patient was to measure her serum thyroglobulin levels, which confirmed the small gland of thyroid ultrasound, and her thyroglobulin actually was very low. On direct questioning, she then came forth with a history that while she was taking methimazole, she was also taking levothyroxine 4 tablets a day because she thought it helped with weight reduction. So this was a classic case of factitious thyrotoxicosis. Another patient, 45-year male, palpitations, anxiety, and hyperdefecation. No medications of past history. There was a mild diffuse thyromegaly. In this patient, you see an elevated T3, T4, and TSH, which is also elevated. Now, in the presence of symptoms, this does indicate that we are dealing with a kind of either central hyperthyroidism or resistance to thyroid hormones. Technetium uptake showed diffuse increased uptake, and these were the 3 possibilities. Assay interference was ruled out. There was no family history, and the alpha subunit was normal. So the next step for him was a TSH, MRI of the pituitary area, which showed a clear TSH of us. Last case, a 66-year male came with paroxysmal AF. He had been on amiodarone already for past 6 months, and there was no past or family history of thyroid dysfunction. In the last 4 weeks, he had lost some 3 kilos of weight and had some thyrotoxic symptoms and had come with AF despite being on amiodarone. And what was done further was the blood report confirmed thyrotoxicosis, CRP, ESR were normal. Ultrasound showed a slightly hypoechoic gland with absent hypervascularity, and technician scan was showing absent thyroid uptake. Now, in this case, the diagnosis between type 1 and type 2 thyroiditis was kind of more straightforward. This patient had type 2 destructive thyroiditis, which was induced by amiodarone. But mind you, sometimes differentiating between type 1 and type 2 amiodarone-induced thyrotoxicosis can be difficult. So to quickly wrap up what we've discussed over the last 18-20 minutes, spurious lab results must be excluded before you start investigating further. And of course, they have to be correlated with the clinical picture. It's very important to differentiate between thyrotoxicosis with or without hyperthyroidism. Etiological diagnosis is extremely important because that will determine the course of management. And for most of the patients, once you've ruled out thyroiditis, the differentiation can be made by using either technician scintigraphy or a TSH receptor antibody and ultrasound with color flow Doppler, but this should be a personalized choice. There is no one single route. It has to be depending on the availability of investigations and the clinical picture of the patient. So I'll conclude here. Thank you.
Thank you, Dr. Priya, for such a nice presentation. So, ma'am, like once patient is euthyroid, especially in case of Graves, so role of TRAB antibodies, like how to monitor them in future?
True. So I think long-term monitoring with TRAB is recommended in certain conditions now. One is pregnancy. So a woman who is planning pregnancy or in the first trimester itself, we should be in a patient with confirmed Graves' disease, or if thyrotoxicosis presents for the first time during pregnancy, we should monitor TSH receptor antibodies to determine, one, what is the likely course of thyrotoxicosis during pregnancy, and also to be able to determine fetal risk. The other scenario now is that we are using TSH receptor antibodies to determine whether the likelihood of remission in Graves' disease. So patients where TSH receptor antibody titers become very low or negative, they are more likely to go into remission. If you find, let's say, a patient has been on antithyroidal drugs for even 12 months, 18 months, and your TSH receptor antibody titers are still very high, you might like to continue low-dose antithyroidal for a longer period of time. So I think there's a lot of work going on in that direction. And TSH receptor antibody could be a good marker. Other, of course, parameters we look at is the size of the gland, what is the dose of antithyroidals the patient is on, what was the initial level of T4 elevation that we saw. That is to predict remission.
Okay, thank you, ma'am. I think you have covered very all the aspects of thyrotoxicosis in very short time. So we can quickly go ahead with the next session. Dr. Subrit, I invite you to introduce Dr. Sanjay Yadav.
Unmute yourself.
I welcome Dr. Sanjay Yadav to the Hormone India conference. He is a fellow colleague. He has done MCH endocrine surgery from SGPGI Lucknow. Presently, he has also done a short-term fellowship in endocrine surgery from Johns Hopkins University in USA. And he is presently working as assistant professor of surgery in Jabalpur. He had achieved a Young Investigator Award in a conference from China. He is a recipient of various grants as well as awards from various international conferences. He has publications, 85 publications to his credit in various national and international indexed journals. And he has original research presentations across various countries, Switzerland, Malaysia, various world conferences, and he is a reviewer of various journals. So I welcome Dr. Sanjay to give his talk.
Thank you, Dr. Shubrat and Dr. Ajay, Dr. Mayur, for inviting me for this Hormone India conference. And I have been listening to various presentations. Excellent topics have been selected and excellent presentations. So I will start. So is my screen visible now?
Yes.
Yeah.
Perfect.
Okay. So I will be talking about follow-up of differentiated thyroid cancer. So as everyone says that thyroid cancer is one of the best cancers with highest cure rate, and hence it is one of the best cancers to have. But I think the patients and their care givers might differ with that because of long follow-ups and associated with these cancers. So the incidence of thyroid cancer continues to rise worldwide, and it is basically because of increase in the diagnostic modalities. And overall treatment outcome is excellent. 10-year overall survival is above 90%. However, what we have to remember is that recurrence rate is also very high, 23 to 30%. So what should be the goal of our follow-up? So goal of our follow-up is accurately do the surveillance of the patients who may have possible recurrence, who are thought to have they are that disease free, and to determine the need for additional treatment, in particular radioiodine therapy. As we know, if we can detect the recurrence early, then we can prevent the death of the patient. So disease-specific death rates decrease with early detection of locoregional recurrence. So this is because the most of the recurrences are amenable to treatment. So the aim of follow-up is early discovery and treatment of persistent or recurrent locoregional disease or distant disease. And follow-up surveillance must involve minimal risk to the patient, minimal morbidity to the patient, and minimal discomfort to the patient, and it must be cost effective, especially for our scenario in India. So for this, we have risk stratification of patients with thyroid cancer. So the most widely followed stratification system is ATA. So it divides the patient into low risk, intermediate risk, and high risk. This is after the first surgery. So the low risk patients are papillary thyroid cancers, which do not have any local or distant disease, and all microscopic tumor has been resected. There is no tumor invasion to locoregional or distant tissue structure. There is no vascular invasion. And apart from papillary thyroid cancer, any intrathyroidal encapsulated follicular variant of papillary thyroid cancer, intrathyroidal well-differentiated follicular thyroid cancer with capsular invasion, and minimal vascular invasion, less than 4 foci. So intermediate risk involves microscopic invasion of tumor into perithyroidal soft tissue, papillary thyroid cancer with a vascular invasion, or clinically N1 or more than 5 pathological lymph nodes involved. And high risk involves macroscopic invasion of tumor into perithyroidal soft tissue, meaning gross extrathyroidal extension, post-operative thyroglobulin suggestive of distant metastasis, pathological N1 with any metastatic lymph node more than 3 centimeter in largest dimension. So this initial risk stratification is very important to guide further treatment and to guide the surveillance of the patients. So this, but apart from this, we have what is called as DRS, dynamic risk stratification. Because these patients have excellent prognosis, their stratification should evolve over time with follow-up. So this is a different DRS, a dynamic risk stratification. So initial staging system is to guide the initial therapeutic and diagnostic follow-up strategy decisions, but it is less accurate in predicting long-term outcome. Initial risk estimates are refined based on new data accumulated during each follow-up of the patient. So patients are re-stratified based on response to therapy. So this is dynamic risk stratification. So the excellent response group consists of patients who have suppressed thyroglobulin less than 0.2 nanogram per ml or stimulated thyroglobulin less than 1 nanogram per ml. And thyroglobulin antibodies are absent, and neck examination on imaging is negative. No evidence of any locoregional recurrence. So these patients have very less chances of recurrence. Intermediate or good response category has suppressed thyroglobulin level detectable but less than 1 nanogram to less than 10 nanogram per ml, or stimulated thyroglobulin level is in declining trend. Thyroglobulin antibodies are absent or declining. And on neck examination on imaging, there might be some evidence of disease, but it is clinically insignificant. Then incomplete response group has suppressed thyroglobulin more than 1 nanogram per ml or stimulated thyroglobulin more than 10 nanogram per ml, and thyroglobulin antibodies in the rising trend, or these patients may have imaging wise some locoregional recurrence. So post-operative surveillance modalities are most important one are thyroglobulin. It is a biochemical marker and it can be done in blood. It is done in blood. So that is why it is a non-invasive kind of test. And other imaging modalities are ultrasonography, CT, MRI, then functional imaging modalities, which is used individually on each patient's case basis. So radioactive iodine scan, PET scan, and other scans are there. So thyroglobulin roughly correlates with the amount of thyroid tissue, and this measurement provides important information about the presence or absence of residual, recurrent, or metastatic disease. So undetectable is obviously considered excellent response. Then there could be minimally detectable levels in incomplete response group. And then there is thyroglobulin trends over the time, because as we are progressing from total thyroidectomy to hemithyroidectomy for tumors less than 4 centimeter, where this thyroglobulin trend over time becomes more important. Then stimulated thyroglobulin has very high sensitivity and specificity for recurrent disease. And so this stimulated TG can be after stopping the thyroxine supplement for 30 days, or it can be after injecting a recombinant TSH. Then apart from estimating thyroglobulin, estimation of anti-thyroglobulin autoantibodies is also very important, because auto-TG antibodies are maybe elevated in 25% of thyroid cancer, and but 10% of general population as well. So they may result in falsely lower serum thyroglobulin levels in the assays. So it is also important to monitor these. Then ultrasonography is very sensitive investigation for the neck, but it depends on the it is operator dependent. So it is important that a person recurrences occur in neck only or thyroid bed. So it can detect lesions as small as 2 to 3 millimeter. And then neck ultrasonography along with rising serum thyroglobulin level is a telltale sign that there is some recurrence. Then there could be a recurrence in thyroid bed. So on ultrasonography, these are the signs for detecting the locoregional recurrence. And thyroid bed is especially very critical area, because any recurrence, if it happens there, it is difficult to treat surgically. So suspicious lesions are typically characterized by ovoid shape and are hypoechogenic, may be associated with microcalcifications and cystic components. Then cervical lymph nodes, which are suspicious for malignancy, have loss of fatty hilum, may be round and hypoechoic with microcalcification and cystic appearance. So as I said, the advantages is that it can detect lesions as small as 2 to 3 mm, unaffected by radioiodine avidity, and no radiation exposure, non-invasive, guided FNAC is possible. It's cost effective and it is widely available. Disadvantage is operator dependent. So coming to radioactive iodine scan, so radioactive iodine imaging therapy exploits the capacity of thyroid tumor cells to take up iodine, which is mediated by sodium iodine symporter. So generally preserved in thyroid cancer cells. So that is the work that we exploit in radioactive iodine scanning. So sensitivity is approximately 27 to 55%, but it has high specificity. And it is one of the most sensitive tools for detection of thyroid remnant. So usually pre-treatment whole body scan is performed before doing a radioactive iodine ablation. And radioactive iodine scan may include iodine 131 or 123 with or without SPECT CT. Then post-treatment scanning is done after the radioactive of post-treatment scans affect the prognosis. So preparation for the scan, pregnancy and breastfeeding are absolute contraindication, and radioactive iodine uptake is dependent on adequate stimulation by TSH, which can be obtained by stopping the thyroxine supplement for 1 month or by recombinant TSH. And usually a low iodine diet is prescribed for 7 to 10 days. Then coming to entity, what is called as TENIS, thyroglobulin elevation with normal iodine scan. So in 10 to 15% of the patients, the sodium iodide symporters are absent, so are lacking. So these patients will have a negative radioactive iodine scan, but their thyroglobulin will be elevated. So it is important to detect these patients. Coming to definition of cure. So definition of cure for thyroid cancer is defined as if there is no clinical evidence of tumor, no imaging evidence of tumor by radioactive iodine imaging, or no evidence of tumor on neck ultrasonography, low serum thyroglobulin levels during TSH suppression less than 0.2, or stimulated TG less than 1 ng per ml in the absence of interfering antibodies. So coming to other imaging modalities like CT, it is prescribed based on individual patient, and if there are thyroglobulin level is very high and ultrasonography is suggesting a locoregional recurrence, or there is suspicion of distant metastasis. Similarly, MRI is also prescribed on each case basis. So it is imaging modality of choice for thyroid cancer metastasizing to bone, brain and liver. Then there is some role of 18 FDG PET CT as well, because it is both anatomical and functional. So it is recommended in high risk DTC patient with thyroglobulin more than 10 to evaluate the post-treatment response, and it is a prognostic tool in metastatic disease. So just briefly, what are the protocol for follow-up TSH suppression? So TSH suppression, it is important to decide which patients need suppressive therapy and what is optimum level of TSH suppression. So initial suppression is based on the initial risk stratification. Low risk thyroid cancer patients can be kept in low normal range of TSH 0.5 to 1. Intermediate risk group patients definitely need TSH suppression from 0.1 to 0.5, and high risk patients should be kept, their TSH should be kept below 0.1. Then during follow-up, this has to be modified as per the response per the DRS. So the American thyroid system, because there are harms associated with TSH suppression in detail. So this was the basic modality, basic protocol for follow-up of differentiated thyroid cancer. So thank you. Now I will be happy to take any questions if there are any.
Dr. Sanjay Yadav. I invite chairpersons to ask any questions if they have. Dr. Subrit, Dr. Mahavir. We can quickly ask one or two. Yeah. Any queries from Dr. Subrit or Dr. Mahavir, sir, or anybody else?
The talk was excellent. So I don't have any queries regarding the cancer or the T43 replacement.
Okay. So I think we can move ahead with the next session. For that, I invite Dr. Others to take over Pituitary session, Master of all Masters. So can we have slide on Dr. Others? So Dr. Others KS is consultant in Manipal Hospital, Bangalore. He's alumni of Sanjay Gandhi PGI. And over to Dr. Others.
Hi, good afternoon, everyone. I welcome everyone all to the next session, which is on the master gland, that's the pituitary. So we have three speakers in this session and two chairpersons. I would be, I'm very glad to invite Dr. Anish Ghosh, who will be chairing the session. He is a consultant endocrinologist at Obesity, Diabetes, and Endocrine Center in Trivandrum. So I would request Dr. Anish Ghosh to take over the session, followed by introducing the speakers.
Yeah, thank you so much. Am I audible?
Yes, sir, you're audible, sir. You're audible.
I think let me offer my regards to all the office bearers for having come up with such a wonderful meeting, probably a meeting of involving the entire country. And also, let me just come to the session. We have a very interesting session, I would say, because anything which is related to prolactin, probably the most frequent hormone abnormality that we come across in our clinical practice. Speakers. So let me come to the first speaker, Dr. J.J. Mukherjee. I think Dr. J.J. Mukherjee from Kolkata doesn't need much of an introduction because he is a popular figure in the field of diabetes and endocrinology. I think he is going to discuss in the next 20 minutes, he would discuss pituitary incidentalomas, because every now and then we bump on unexpected findings in the pituitary when an image is taken for a completely different reason. So let us listen to Dr. J.J. Mukherjee. Over to you, sir.
Tech team, kindly play the recorded session as sir is not available live.
Just
It's really pertinent for today's era, because now for every headache, almost everybody gets by himself an MRI.
True.
Even without consulting a doctor.
For inviting me for this prestigious and very nice meeting. You've been listening to a lot of lectures over the past 2 days. So My brief is to discuss approach to pituitary incidentalomas with you. Now, what is the definition of a pituitary incidentaloma? Pituitary incidentalomas are clinically inapparent pituitary masses, which are more clinical features, that are discovered on CT or MR evaluation, generally on MR. On CT, unless until they're very big, you can't see, of the brain for an unrelated condition in a patient without overt signs or symptoms of pituitary disease. So this is very clear. If you're doing MRI or CT, thinking there could be Cushing's, thinking there could be acromegaly, thinking there could be panhypopituitarism, then that's not a pituitary incidentaloma. So let's walk through a lady, 36-year-old, seen in the neurology clinic for non-specific giddiness, hyperlipidemia on statin, pulse is okay, blood pressure is all right, systemic examination is normal, fundus is normal, and as would happen if you go to non-specific giddiness to a neurology clinic, you end up getting a CT scan. This was maybe an upmarket place where the patient went for an MRI. Now, before I show you the MRI of the patient, this is what the MRI of a normal pituitary looks like. This is taken from the Williams textbook. You can see the reference down below. This is the optic chiasm. Then there's a pituitary gland, there is a stalk, there's the sphenoid sinus, that is the intracranial carotid artery, and what to know, a lot of nerves which pass through the cavernous sinus. And that is a schematic representation, and that is an actual MR, again showing the optic chiasm, stalk, pituitary. The stalk should generally be less than 4 millimeters in size. You can see the intracarotid arteries, that's the sphenoid sinus, which is aerated. So if you see this young lady's MRI, this is pre-contrast, this is sagittal, this is coronal, these are T1 weighted images, where the CSF is black in color. And you can already see that that's the stalk, that's the optic chiasm tip there, and you can see that the convex margin to the pituitary. But you don't really see an adenoma here or an incidentaloma here. But when you come to the coronal films, there's a clear-cut, unequivocal hypodense lesion here measuring about 8 millimeters in size. And then when contrast is given, something seems to be there, but then that is much better identified on the T1 post-gadolinium enhanced MR images, where you can see the pituitary incidentaloma. The reason this is incidentaloma is because this lady had no overt symptoms of endocrine disease. She had only come from non-specific giddiness, which probably could have been due to any of many things. And incidentally, this tumor was discovered, adenoma was discovered, and now you're in trouble what to do with this. That's the whole purpose of this lecture over the next 15 to 20 minutes. How often to expect them? This is very variable. This is a meta-analysis. It can be as little as 1.5%. This is all autopsy series, if you can see on the top. Autopsy series, as much as 27%. Now, this is an overkill. I think only 100 autopsies were studied, where they found 27 adenomas. Maybe the ballpark figure, if you see down below, is about 1 in 10. Now, 1 in 10 also to me sounds a little bit in excess, because we do so many MRIs, we don't see incidentalomas. So these are autopsy studies, you see, where they go and chop the pituitary into small details, and they end up finding 2 millimeter, 3 millimeter pituitary adenomas. But if you see, most of them are microadenomas, and then there have been CT and MR studies, where also if you see macroadenomas, more than 1 centimeter or 10 millimeter in size, are far less as compared to microadenomas. So incidentally, you discover microadenomas. Rarely, you may end up discovering a macroadenoma. So this lady with the small microadenoma there, that is the history. What do you do next? So the first thing is, please do not refer to a neurosurgeon, inverted commas, brain tumor. No, pituitary tumor, refer to the neurosurgeon. Please don't. Refer to an endocrinologist first, because most incidentalomas do not require immediate or sometimes late surgical intervention. My last slide will give you the indications for surgical intervention in an incidentally detected pituitary lesion. The second thing we should do is what we've already done. We've critically reviewed the MRI of this young lady. Why? Because there can be so many things which can be discovered. An incidentaloma does not always mean an adenoma. Is it pituitary hypertrophy, hyperplasia? Is it a non-adenometacellular mass? Is it a paracellular mass? Or is it an adenometacellular mass? If you see, 9 out of 10 times there are adenomas, like you saw in this young lady. But sometimes you may end up discovering comes with non-specific giddiness. You may end up finding a meningioma, you can end up finding a germinoma, you can end up finding a rhabdysclepsis. So you need to first see the MRI yourself or discuss with your neuroradiologist and confirm that it is, what is it? So if you think about hyperplasia, this was a young lady I followed up long time ago, almost 20 years ago. Pituitary looks big, convex margin, there's a convex margin. It is not compressing the optic chiasm. Optic chiasm is quite clear from this pituitary, but the height is 12 millimeters. She had presented again with headache and giddiness to the neurologist, was found to have anemia. But then this MRI showed this lesion. So height of normal pituitary ranges from 3 to 9 millimeters in healthy women between the ages of 15 to 30. Data from 3 large neurological series, 600, if you see 0.5%, that's almost 30 out of 600, will have a pituitary size which is more than 9 millimeter. Getting a size of 11, 12 millimeters, not so common, but you should keep that in mind. And these images are generally seen in adolescent girls between the age of 10 to 19. We had the opportunity, this is a patient can do repeat MRIs because of availability. And this patient, I'm not showing the serial MRIs. This lady was followed up over about about 7.5, 8 years. And you see there's been no change in the size. You don't see any adenoma. You don't see any macroadenoma. So this was a hyperplasia. She was subsequently followed up by my colleagues when I left that unit. And over 20 years follow-up, subsequently, I don't have those MRIs because I had left that unit, the lesion had shrunk. Is this a non-adenomatous, not an adenoma, cellular mass? There's so many things which can be there. It can be a germ cell tumor, a craniopharyngioma, meningioma, chordoma, pituitary carcinoma, metastases. These are very rare. Metastases, in my career, I've seen 3 or 4. Pituitary carcinoma, very rare. Chordoma, very rare. Meningioma is quite common, actually. Cranio, again, generally they present in children, but you can have adult onset craniopharyngioma. Sometimes you detect them as an incidentaloma. Majority of the times you go looking for a cranio because there are symptoms. So generally they are not an incidentaloma. Germ cell tumors are also generally not an incidentaloma. Take this young lady, was followed up for 4 years in the gynae unit because she had presented with amenorrhea, galactorrhea, and prolactin was 5 times elevated. They had this MRI and they thought this is a pituitary adenoma. Prolactinoma was treated for about 4 years on initially bromocriptine, later cabergoline. Of course, the periods returned. Of course, the galactorrhea disappeared. But unfortunately, this lesion kept increasing, and it's an obvious no-brainer. But it's not a pituitary lesion. This is, you can see the stalk. I told you the stalk should not be more than 4 millimeters. Look at the huge, thick stalk going up into the hypothalamic region. So this was a dysgerminoma. You need to do beta-HCG either in the blood or in CSF. And the treatment is very simple. You have to give radiotherapy. And you see what happens after radiotherapy. The lesion shrinks. The stalk becomes okay. But the downside is the patient becomes pan-hypopituitary. What about a craniopharyngioma? As I told you, generally you don't get them as an incidentaloma, but you may be surprised. They are generally cellular, supracellular lesions. If they are supracellular, then they are more of a cranio than a rhabdysclepsis. And they have a cystic lesion with some fatty components, so that becomes a craniopharyngioma. You can have a meningioma. Now, meningioma is not that uncommon. And if you're not initiated, you may misinterpret a meningioma for an adenoma. Look at this nice big thing. You may end up thinking this is a large pituitary macroadenoma, but then it is a meningioma. Why? Because there's something called the dural tail sign. The meningioma makes the dural tail hyper enhance. And I am wiser because this was operated and we got the histopathologist meningioma. But to be fair, our neurosurgeon, one look at the MRI had said this is a meningioma. When I first saw this MRI, I was under the impression I'm dealing with a pituitary macroadenoma. Then he taught me this. I'm teaching you this because this is a long time ago. So I learned this dural tail sign, which point towards a meningioma. It can be sarcoidosis, lymphocytic granulomatous hypophysitis, histiocytosis, but these are generally not pituitary lesions. These are generally pituitary stalk and hypothalamic lesions. You can incidentally find a rhabdysclepsis. This is one of the seminal papers which we wrote way back, I think in 1997. And if you Google this is quoted everywhere. Why? It's a very simple paper. We just had 12 patients with Rathke's cleft cyst, because prior to this paper in 1997, everybody thought Rathke's cleft cysts do not recur. They're just benign things, just leave them or marsupialize them, and they don't recur, they don't cause panhypopit, just leave them alone. But we had 12 patients, we found that they presented symptoms, they get some of them get panhypopit, and we found that they can recur. So this paper is quoted every time a Rathke's cleft cyst is described. And if you see, this is how a Rathke's cleft cyst looks like. It's quite different from a craniopharyngioma. Very nice thin wall filled with fluid. And why is fluid? Because on T2 we get MR coronal section, and T2 the CSF is white. You can see this is full of fluids. So now, is it pituitary hypertrophy in our patient? No, because it's a very nice, well-defined lesion. Is it a non-intramedullary mass? No, it is in the pituitary gland. Is it a paracellular mass? No, it is in the pituitary gland. The stalk is nice and thin. There is no dual tail sign. So we are dealing with a common garden 90% pituitary incidentaloma, adenomatous incidentaloma. So this is all this that I have described is finished in 1 minute actually. When you put the MRI up on this thing and you know, this is an adenoma, chalo aage. Aage, what do we do? Is the adenoma hormonally active? Is the adenoma causing mass effect? So you need to ask for history. Hypophysitis, they can cause diabetes insipidus, and ask for mass effect, which is visual symptoms. So you look for any stigmata of Cushing syndrome, acromegaly, is there galactoria, any features of hyperparathyroidism, pale skin and loss of hair, and assess the visual field by confrontation method. If you find something, then of course you go for a proper visual field assessment. So proper history for this lady would now be seen in neurology clinic for non-specific giddiness, no history of hormone excess or deficiency, menstrual history normal, no history of TI, no history of visual symptoms, no postural drop in BP. This is hinting towards adrenal insufficiency. No features to suggest hypoparathyroidism, Cushing's or acromegaly on examination. Again, no galactoria. Visual field is normal. So this would be a proper detailed history and examination of somebody who comes with a incidentally detected pituitary lesion, which you have excluded and confirmed it's a pituitary adenoma. So now when you've done that, you have to exclude, is the adenoma hormonally active? Because Dr. Mukherjee asked all the questions. It's not Cushing's, there's not acromegaly, there's no suggestion of prolactinoma. Why do you want to do hormonally active? Because there are what you call subclinical presentations. Sometimes prolactin can be 2-3 times elevated. There will be no amenorrhea, no galactoria. Galactoria is not present in everybody with hyperprolactinemia. So it could still be a prolactinoma incidentally detected. So there's no real consensus about the optimal workup strategy. My last slide will give you the reference. There is the Endocrine Society guidelines way back in 2011 that will guide you a little bit. I'll share what I do. Now, serum prolactin should be measured in all patients. Silent somatic of adenomas, yes, possible. You could do an IGF-1. Silent corticotroph adenoma, best test is unclear. You could think of with an overnight DEX suppression test, and if it does not suppress, you can do a low-dose dexamethasone suppression test. Is it causing a mass effect? You have to look for features of hypopituitarism. You have to look for all the hormonal evaluations, visual field defects, and cranial nerve deficits. So coming to our patient, if you see, it's not go from below up. It's not a vascular lesion. It's not a metastasis. It's not pituitary abscess sarcoid. It is not craniorhabdic chordoma colloid cyst. It's not meningioma. It's not germinoma teratoma. It's not pituitary hyperplasia. It's a pituitary adenoma. Is it causing mass effect? Before that, look at the hormones. Prolactin is normal. Thyroid is normal. Cortisol was a little bit low rather than high. So she had a short synactin test. Synactin is not available now. We have Citropac. And she clearly passes. So there is no hypoadrenalism. IGF-1 is normal. Visual fields are normal. Which is expected. It's a microadenoma. And it is not causing any, it's not hormonally active. So how will you manage this patient? Non-functioning, incidentally detected pituitary microadenoma measuring 8 millimeters. Refer for surgery. Unfortunately, many patients get referred for surgery. Please, 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 refer to an endocrinologist. Give cabergoline, wait and watch, refer for radiotherapy, refer for gamma knife RT. What should you do? Evaluation of pituitary function in a microadenoma. First of all, whether it's hyperfunctioning, prolactinoma, never sent for surgery, dopamine agonist. Others, you need surgery. Then, in Our Lady, it's a microadenoma. So if it's a clinically non-functioning microadenoma, don't do anything, just follow up, repeat MRI 1 to 5 years, no change, probably let it go. If there is tumor growth, then you have to think of surgery. So answer is wait and watch. Take this young lady, 20-year-old, headache off and on. It looks like a cystic lesion, but then properly when you do a coronal scan, it's not a cystic lesion. It's almost 10 millimeter in size. It's a macroadenoma. Hormonal workup is again negative. So it's a non-functioning, incidentally detected macroadenoma because it's 10 centimeters, 1 centimeter. What would you do? Again, if it is hormonally inactive, macroadenomas, no mass effect, not abetting optic chiasm, again, don't send to the US for surgery. Please follow these patients up. And the frequency of MRI depends on you. Different guidelines would say different. I follow this 6 months, yearly for 5 years. And after that, you decide how frequently you want to monitor. If the mass was abutting or compressing optic chiasm, you need to send for surgery. So this lady also, we chose to wait and watch. And again, we have an opportunity to follow her up over 3 years. If you see quite a biggish lesion, and then what happens over 3 years' time, the lesion shrinks. It would have been really unfortunate if she had been sent for surgery and she would have ended up with some kind of hormonal deficit. Look at this interesting lady, long time ago. But I put this up because a 49-year-old lady, she came for annual checkup, non-specific giddiness. MRI was done and this lesion was detected. Large macroadenoma, you can see, still away from the optic chiasm. And if you see her serum prolactin, the unit is different, but it is almost 12 times elevated. And she had galactoria on stimulation for past 8 years, from the age of 41. She thought it was normal. I'm getting menopausal, so I can have some milk discharge from my breast. So what would you do? You would give cabergoline to her. And if you see, over time, this large macroadenoma very nicely shrinks. There's a little bit of the fluid accumulation in the lesion, not it turns cystic. Sometimes it happens when you treat a prolactinoma. So serum prolactin, lesson number 2, 3, 4, whatever you want to say, serum prolactin should be measured in all patients with pituitary incidentaloma before contemplating any surgical intervention. So I think I've got just another 3 minutes left. So I will give you my summary. 10% of the adult population may harbor a pituitary incidentaloma, provided you go looking into the pituitary. Many a times when an MRI brain is done, 10 millimeter cuts, 3, 4, 8 millimeter cuts are taken, and pituitary incidentalomas are not seen. But if you focus, you may find in 1 in 10 people. Microadenomas far outnumber macroadenomas. It's essential to decide whether it's an adenometacellular mass or a non-adenometacellular mass, paracellular mass. Because non-adenometacellular or paracellular masses definitely need involved treatment. There could be so many things, and a proper workup is required. If it's an adenometacellular mass, then 2 questions must be answered: whether it's hormonally active or whether it's causing compressive symptoms. If hormonally inactive, if it's hormonally active, then of course you need to do surgery, except for a prolactinoma. This is take-home point 2. Prolactinoma never sent to a surgeon unless and until indicated. Indications are very few. And not causing any mass effect that generally can be managed by watchful waiting. I gave you the frequency of follow-up MRI. And as I said, prolactin-secreting tumor should be treated with dopamine agonist therapy. So this is, those of you who are waiting with bated breath, when to send them for a surgery. This is from this guideline. You can take a picture. This is probably the only proper Endocrine Society guideline. There's another article in 2016 in European Journal of Endocrinology. You can just Google, you will get it. It's a free download. These 2 are the very nice resources for pituitary incidentaloma. So if there's a visual deficit, other visual abnormalities, optic nerve or chiasm compression, apoplexy with visual disturbance, or hypersecreting tumors other than prolactinomas, that is when you would think of surgery. So in summary, in the last 20 minutes, I've taken you through incidentally detected pituitary lesions. First of all, decide whether it's hypertrophy, whether it's paracellular mass. I think whether it's a meningioma, whether it is, whether it's a craniopharyngioma, first decide that. Majority of the times, 90% of the time, there will be an adenoma. When you find like this one, like our patient, if it's an adenoma, then you decide whether it's functioning surgery. Majority of them are non-functioning. Non-functioning, look for compressive symptoms. If there are none, then you follow them up. I hope you have learned something. With that, I'll stop here. Thank you.
Thank you, sir. Dr. Adas.
Yeah, thank you for wonderful talk, sir. So I would now like to invite our next chairperson, Dr. Vaibhav Singhal. He's a consultant endocrinologist. So he'll be, so I would like to hand over the session to him to take the session forward with the introduction of our next speaker.
Thanks, Dr. Adarsh, for introducing me to the panel. Thank you, Dr. Mayur and Dr. Ajay Shukla and all the other members of Hormone India for organizing such a wonderful session. Now I'm going to introduce my next speaker, Dr. Anil Basari, who is a former professor head in Department of Endocrinology in PGI Chandigarh. He has received multiple awards like the WIDF Outstanding Investigator Award and the BC Rai Award and Professor B.S. Raheja Award. He was a president, Endocrine Society of India in 2012, and he was also completed a FRCP from Glasgow in 2007, and he has also received other multiple awards. And one thing is not mentioned here, that he has also written a wonderful book for us residents, which has helped us a lot for clearing our exams. So thanks a lot for writing that book, which should have been mentioned at the first book.
Thank you for very, very kind introduction. And I think, yes, I also now found that the Clinical Rounds in Endocrinology, the book which has been written by us way back in 2015-16, I think that has really made wonders. That is, I think, globally acknowledged now. And people are happy with that. I think we will come with the new editions in future.
Yes, sir. We're eagerly waiting for that, sir.
Yeah. Thank you. So I will start my talk that is on prolactinomas and pregnancy. And I think we have already listened to JJ, and he has given very thoughtfully the pituitary incidentalomas. And that's, I think, one of the major challenging tasks in clinical practice. Similarly, you have another challenging area where you find patient is having a prolactinoma in pregnancy, and particularly with the macroadenomas, the decisions are very important. And secondly, during breastfeeding and lactations, what you should do. So I think these queries I will try to answer. So this is the context. I think we'll go ahead with this. So we will discuss two cases. One, the case security one, a 33-year-old lady presented with amenorrhea and galactorrhea. She had a prolactin of 337. Her MRI cella was a 13 millimeter pituitary adenoma with supracellular extension. She was treated with cabergoline and she resumed cycles and missed period for 2 weeks. Then UPT was found to be positive. So what you should do? You should switch to cabergoline to bromocriptine. One, you continue cabergoline, you discontinue cabergoline, or you recommend electro termination of pregnancy. So we'll try to answer what is the most suitable answer in this scenario. As I mentioned that she had a macroadenoma, the tumor size was 13 millimeter and with a supracellular extension, but without any visual field defects. The another case vigility where a lady presented with a severe headache at 37th week of pregnancy, and she had already had a 14 mm prolactinoma with supracellular extension and visual field defects. She had a high serum prolactin treated with cabergoline. Tumor decreased to size to 5 millimeter and mainly became intracellular. She is off cabergoline since conception. Her visual fields are consistently normal. So what you should do? Restart cabergoline, plan for TSS, recommend MRI cella or major serum prolactin. So these are the issues which we are going to discuss with you. So let us see that how common is prolactinomas and how commonly the patients with prolactinomas become pregnant. It's a very rare tumor, roughly around 4 in 10,000, but the most common functional pituitary tumor. The majority of women with prolactinomas, regardless of size, whether it is a micro or macro, are diagnosed prior to conception. And rarely 1% of the women may be diagnosed to have prolactinomas during pregnancy for the first time, either manifesting as apoplexy or the mass effects of the tumor. What is the characteristics of the lactotroph cells? Why we are having so much of concern? Because they are laterally placed, they contribute around 30% of the pituitary mass, and they are very precariously supplied because they are laterally placed. That's why they are very prone for any ischemic injury or ischemic damage. And during pregnancy, you have an estradiol-mediated lactotroph cell hyperplasia. That's why the pituitary mass is further increased by 30%. So the overall mass of the lactotroph during pregnancy is almost 50% plus. There is a small amount of a prolactin comes from the placenta. That is a decidual prolactin, which is not regulated by dopamine. So the important point is that there is a estradiol mediated lactotroph cell hyperplasia during pregnancy. So the pituitary volume is almost 50% is contributed by your lactotrophs. If you look for a serum prolactin in pregnancy, people ask many times how much prolactin can rise during the pregnancy. So you will see that the hair is as the duration of pregnancy increases, there is a consistent rise in a serum prolactin, and the two line indicates it's a range of values. So even at 30 weeks to between 40 weeks, the prolactin can reach up to 500 to 600 nanogram per ml. So it may remain something around 50 to 500 nanogram per ml. So finding a prolactin of 500 or even a 600 at the end of pregnancy is not surprising. If you go further, what happens to anatomical changes in pituitary? There is a progressive rise in pituitary volume, and this is a data done in a 23-year-old woman, normal woman, and there is a progressive increase in pituitary volume during pregnancy. What happens to, say, MRI in pregnancy? There is asymmetrical enlargement and deviation of the stalk. It's different from the physiological enlargement of the pituitary gland, because pituitary gland the stalk is usually not deviated. The pituitary height is usually around 10 millimeter. Normally, it is around 8 to 9 millimeter. Now, the next question comes, if someone is harboring a tumor, does the tumor grow during pregnancy? Yes, they do grow. It's both macro as well as micro, both do grow. And the reason for the growth of a tumor during pregnancy is the tumor tissue also expresses E2 receptors. So again, it is an estradiol mediated tumor hyperplasia or tumor growth. And secondly, many times you withdraw the D2 agonist soon after conception. That can be another contributory factor for the increase in size of the tumor during pregnancy. If you see this data, the person with in microadenomas, patients with symptomatic enlargement is only 2.6. Macroadenomas around 31%, they do experience symptomatic enlargement, while macroadenomas, if they have been received prior surgery or radiation, it's only 5%. Similarly, those who have received even a cabergoline prior, only 4 to 5%, they do have a symptomatic enlargement during pregnancy. So very important point is that even someone has got a macroadenoma, if they receive treatment prior to conception, then the probability of an increase in the size of the tumor is very low. So this is you can see that this is the MRI pictures, the pre-pregnancy and the post-pregnancy at 7 months gestation. The tumor size increases in pregnancy. However, still it is not abating the optic chiasm. If you talk about the tumor enlargement in pregnancy, this is the data by the Molish et al. So those macro and micro, those are macroadenomas without treatment and with treatment. And you can see that again, the last line, only 22% those who did not have enlargement, those who did not have any treatment, while those who had treatment, only 4% or 5% had enlargement of the tumor. So prior treatment is one of the major determinant of the increase in size during pregnancy. So how prolactinomas influence the pregnancy? Yes, in pregnancy, the prolactinomas are basically vulnerable for apoplexy and eventually hypopituitarism. And you are also concerned about the side effects of D2 agonist on fetus if they are continued throughout the pregnancy. So it's a very important, that's why some people have used, even Molish have used this word, the treatment of prolactinoma is pregnancy. Because of as I mentioned, they are laterally placed, they are precocely supplied, and if there is a further enlargement, then the tumor may undergo necrosis. So that's why we say that the prolactinomas are very, very vulnerable for apoplexy. Then what are the chances of apoplexy? This is our own data of pregnancy and tumor outcomes in infertile women with macroprolactinomas on cabergoline therapy. So 2 of our patients, we had 48 pregnancies in 33 women, and the 2 of our patients had apoplexy in second trimester, and both were on cabergoline. So this was how the apoplexy looks like. So this patient presented with a severe headache, and you can see that patient had apoplexy. However, the patient was receiving even prior cabergoline therapy. So if you talk about the effect of D2 agonists on fetus, if you see with malformations with bromocriptine 1.8, with cabergoline 3.8, with a normal 3. So statistically, there is no significant difference between the two, whether the patient has received D2 agonist or not. Certainly the chances are less with bromo as opposed to cabergoline. That's why the guideline also incorporates that if you find out a pregnancy and the patient is having a macroadenoma and it is abutting the optic chiasm, the best is you switch from cabergoline to bromocriptine in first trimester. The clinical dilemma, what should be done if pregnant woman comes in a late first or early second trimester and found to be on bromocriptine and cabergoline? So even if someone is having a macroadenoma, have received cabergoline earlier, it does not justify any for therapeutic abortions. So this is another data from us, macroadenoma and pregnancy outcomes. So this shows that the 48 pregnancies, the 4 had missed abortions, 3 had congenital malformations, and 42 progressed till term, and the 2 had a stillbirth. Is cabergoline teratogenic? We didn't find in our data. And amongst the 42 live births, the low birth weight was in 3, and 7 years follow-up these children is reassuring. So if someone continues cabergoline even during pregnancy and even continues during later, there's no ill effects neither on mother nor on children. Then prior to pregnancy, I think I just wanted to mention that you can take even decisions soon after the UPT is found to be positive. So patients on D2 agonist therapy, sometimes even before resuming the cycles, they do conceive. So they use the barrier contraception till normalization of serum prolactin. Significant reduction in tumor volume already has happened, intracellular or 5 millimeter away from the chiasm. You are not much worried, and reduce the chance of clinically important enlargement during pregnancy. As far as micropalatinoma in pregnancy is concerned, as soon as the UPT is positive, stop dopamine agonist. The low risk of clinically relevant tumor expansion, as I mentioned, and follow monthly for new onset headache and visual disturbances, visual field examinations. No need for periodical imaging and no need for measuring serum prolactin. Many patients are unnecessarily getting a serum prolactin and MRI done with micropalatinoma. It is not required. You are pretty sure about the probability of increasing or expanding the micropalatinoma into the macro or an enlargement in size is only 2.8%. So don't require, in fact. As far as a macro is concerned, I think again you should be very confident that you can stop the drug even if even the larger tumor has become intracellular or if it is 5 millimeter away from the optic chiasm. If even the tumor might be having a supracellular extension, but it is not abutting the chiasm or away from the 5 millimeter away from the chiasm, you can confidently, and particularly when the patient has already been treated prior with cabergoline. So that's a very important that even in macroadenoma, now with a greater understanding, availability of imaging, we are pretty sure about that even you can discontinue even in macropalatinoma. So what about the monitoring? If symptomatic tumor enlargement occurs during pregnancy, you monitor visual fields. You can have a non-contrast cellular MRI, and monitoring of prolactin is again not useful. So only clinical parameters like headache, new onset visual field defects, or these are the clues rather than prolactin. Then you can reinstitute. It is less harmful to the mother and child than surgery. And important point here is that even in pregnancy, if someone has got a new onset headache or visual field defects, don't even ask for a surgical intervention because the effect of cabergoline occurs within hours. So there's a tremendous improvement even in a visual field defects in around 4 to 8 hours, even you institute once the dopamine agonist. So surgical intervention is only to be resorted if there's either apoplexy or there's a new onset neurological deficits. Then you should go for the surgery. What about breastfeeding? Breastfeeding should also be encouraged. Stop dopamine agonists, particularly cabergoline, 2 weeks prior to delivery to facilitate breastfeeding. No evidence regarding increased tumor size during lactation. Remember that the rise in a prolactin, even with each suckling, is very transient. So there's no risk in increase in the tumor size during lactation. An exception is a lady with already someone is having a visual field impairment and tumor is there, then it may be otherwise. Breastfeeding, it should be encouraged. In a postpartum period, prolactin levels are MRI not indicated while lactating. Serum prolactin and pituitary imaging should be done after 2 months of discontinuation of lactation. So hyperprolactinemia after pregnancy, yes, in patients with the tumor, you can see that. So there is the recurrence of hyperprolactinemia, like in our study, was observed in 56% of women. So the prolactin recurs high in those with both macro as well as the micropalatinoma. So it is a treatment in half of the patients, in fact. And this is our data that how the tumor outcome, the tumor size decrease in 63% of the patients, it remains same or increase or disappear. Even the tumor disappeared in 24% of patients. So that's why the pregnancy is the treatment of prolactinoma, because you are taking the advantage of the vulnerability of the ischemic injury to the electrotrophs during pregnancy. So to conclude, the tumor enlargement is rare in microadenomas and unusual in treated macroadenomas. So it's a 3% and 5%. So we are pretty sure about that. And you can barely stop the cabergoline even during pregnancy, even in macroadenomas. The dopamine agonists are not necessary to be continued in majority of cases of macroadenomas. The careful monitoring of a new onset headache and visual field defects is required. Yes, unless the patient is difficult to follow up or difficult to reach to you, then I think issues are there. Otherwise, if there's a headache and new onset headache and visual field defects are there, then certainly you require a non-contrast MRI and you require a reinstitution of a drug. And even the surgical intervention can be avoided because the drug is effective within hours. And there are no significant teratogenic effects of dopamine agonist. And as I showed, the data is almost comparable, 3% with cabergoline and 3.5% with cabergoline and 3% in a normal population. So I think with these, I conclude my talk, and I would like to say that it's a challenge, but I think most of the things are now crystal clear, and in a real world setting, how we should really manage the patients. I think these guidelines now are making it very clear day by day. Thank you.
Thank you, sir, for such a wonderful talk, sir. And sir, you have completed within, sir, earlier than the expected times.
So we can have one question, some questions.
Yes, yes. So my question was, sir, one of the difficulties I have is managing postpartum patients, sir. Those who have, so when do we plan for measuring prolactin, or we don't?
Okay, usually we should not do, because even a lactation can also lead to rise in a prolactin. So what we should do in that scenario is that we can just leave and clinically monitor. If there's a headache or some visual field defects appear, then it is fine. Otherwise, microprolactinoma, no need to worry. And macroprolactinoma, just watch for these new onset symptoms. Yes, if there is if they have been on a cabergoline earlier, then only thing is that you have to discontinue for a period of at least 8 to 12 weeks, and then you should monitor the serum.
Okay. So most of them, usually what happens is that these patients get a prolactin done from outside, and then they come. Then it is difficult to explain them that you need to not continue or discontinue drug without getting those investigations.
It is usually elevated. As I told you, the recurrence is almost in 56% of the women.
Yes.
But I think that is not worrisome. The reason for that, even rather it facilitates, I think, use this opportunity as a facilitating the lactation for a longer time.
Yes.
So I think that will be the better idea rather than having this. And clinically, yes, carefully watch for a visual field defects and new onset headache.
Thank you, sir.
Thank you, sir. Sir, in pregnancy, as pituitary gland is physiologically enlarged, so we have something different criteria for micro and macro in pregnancy, because the strict 10 mm definition is because pituitary itself is enlarging.
Yeah. So pituitary itself is enlarging. I think that it is then your question will be relevant only for those who are identified for the first time during pregnancy.
Yeah.
And those, because the majority of the women are identified prior to conception. So I think the diagnostic criteria should be taken into consideration, particularly for a prolactinoma, only if they are diagnosed for the first time during pregnancy. And I will tell you again, there's one more difficulty is that measuring a serum prolactin during pregnancy will not be rewarding, because you are also at a decidual prolactin. So, so the question is, yes, it gives a thought that we should have a different criteria. But the question becomes irrelevant because only less than 1% come during pregnancy or present during pregnancy, one. And secondly, the serum prolactin does not leave you anywhere.
Sir, just I will add one thing, that in that pregnancy, there is a physiological enlargement of the pituitary. But when talking about the adenoma, that will be a characteristic different, like a mass will be there. So I don't think there should be any different criteria, because micro, that is less than 10 millimeter, macro we say more than 10 millimeter.
I think I raised this question because it's just a merging. Suppose you have a merging of the tumor is very characteristically seen either as a hypointense area during post-contrast. But yes, If it is a tumor is merging with the lactotroph hyperplasia, then you should have. Otherwise, if the tumor is well visualized and tumor is characteristic, I don't think we should have, really.
Yes, sir.
Okay, over to Dr. Adas.
Thank you very much, sir, for that wonderful session on prolactinoma and pregnancy. Now, again, I would request Dr. Vaibhav Singhal to introduce our next speaker and take forward the session ahead.
Thank you, Dr. Adarsh. So my next speaker is going to be B. Padmanabhan Verma. He has done his MBBS, DNB General Medicine and DM Endocrinology. He is currently working as a senior resident in the Department of Endocrinology in NIMS, Hyderabad. He has multiple research publications in various esteemed journals. So over to Dr. Padmanabhan Verma. Hi, Dr. Padmanabhan. Are you?
Yeah.
Okay.
Is my screen visible?
Yes, you are visible.
Yes, you are visible.
Sorry, screen.
Yeah.
It's visible. Go ahead.
Yeah. I hope audio is clear. Very good afternoon. Thanks Hormone India team for having me here. It's my privilege to be here. And today I'll be talking on resistant prolactinoma because we see many cases of prolactinoma. Those normally, usually they'll respond well to the dopamine agonist. If you come to the prolactinoma, they're usually constitute around 50% of the all pituitary adenomas. They're most common causes of the pituitary adenomas, secretory adenomas. And if you see the majority of the patients, up to around 80% of the patients usually responds to the dopamine agonist. And few cases so resistant to these conventional dopamine agonists. Some patients actually respond poorly to one dopamine agonist, but when we change this dopamine agonist from one drug to other, they may respond well. And some patients may initially respond well, but later they may not show that response, and later they may be drug resistant. And also this is called a term called selective resistance. That means this will be discordance in prolactin lowering and decrease in the tumor size. That means in terms of normal prolactin levels, they may achieve the normal prolactin levels, but the tumor size may not reduce or vice versa. And coming to the term drug resistant, usually normally defined as when you use the adequate drug at appropriate dose, and if the patient is very good tolerance, patient is tolerant to the drug and he maintains good compliance. But in spite of all that, if we are not able to achieve the therapeutic targets, then we can call it as a drug resistant. So it usually is a spectrum from full sensitivity to the full resistance. In between, there will be partial responders also. Coming to the definition of resistant prolactinoma, actually there is no universal agreement on the definition because previously they have used the several criteria coming from the, starting from the normalization of prolactin levels. Few studies have they used the 50% reduction in the prolactin levels, and few studies actually take the criteria like to reduce the prolactin level to sufficiently cause ovulation. But it's in the practical setup, it's very difficult to confirm the onset of, confirm the ovulation. So by and large, we are now using the failure to normalize the prolactin levels as the proper criteria when it comes to the microprolactinoma. But when it comes to the macroprolactinoma, because it can cause compression and enlargement and compression of the optic chiasma, where we have to use both normalization of prolactin and significant reduction in the tumor size. So what is a significant reduction in the tumor size? Because when we start patient on dopamine agonist in a patient of prolactinoma, usually there are multiple studies have shown, starting from 30 to 80% of the shrinkage in the tumor. Some patient may respond completely, the disappearance of tumor may be possible. Because the risk of compression mainly depends upon the tumor extension to the optic chiasma. The appropriate criteria will be decrease in the tumor height. That is around, some studies have taken, some guidelines mention 30%, some guidelines mention 50%, but enlarged by, we will take 50% reduction in the tumor height as a significant reduction in the tumor size. So Overall, the resistance to dopamine agonist is defined as failure to achieve normoprolactinemia under maximally tolerated doses when they are used for at least 3 to 6 months, together with lack of decrease in the tumor height when it comes to the microprolactinoma. Into the prevalence, the resistance is more frequent in case of macroprolactinoma compared to the micros. Overall, for cabergoline, the resistance is less, 10 to 20%, 10% in case of microprolactinomas, 20% in case of macroprolactinomas. But when it comes to the bromocriptine, it is little higher. It is 20% in case of micro and 30% in case of macroprolactinoma. And there is no strict rule to which to say that beyond this dose we can call it as a resistant, because there are many studies starting from 0.5 mg per week to, like, there are studies they use maximum 21 mg also. But usually accepted guidelines, I mean accepted dose equivalents between the several dopamine agonists beyond which we can call it as a resistant is more than 15 mg of bromocriptine per day. That is because bromocriptine has very short half-life compared to the cabergoline. Cabergoline has a half-life of around 64 hours. So that's why we give once in a week or twice a week. But bromocriptine ideally we have to give daily. So more than 15 mg of bromocriptine per day or more than 2 mg of cabergoline per week, usually we take it as a standard. In one study by Delgrange et al., out of 122 patients with macroprolactinoma, almost 80% of the patients achieved normal prolactin levels with cabergoline of less than 1.5 mg per week. In 15%, they respond also. The 15% of the patients required 2 to 7 mg per week, but only 6% of the patients could not achieve the medical control despite increasing the doses to at least on an average 3.5 mg per week. So when it comes to the mechanism of dopamine resistance, dopamine agonist resistant, before going to that, we all know that dopamine receptors are like two family of receptors. D1-like receptors, D1 and D5, and D2 family receptors. In that, D2 receptor, D3, D4 receptors will be there. And D1-like receptors actually acts by stimulating the GS alpha and thereby increasing the cyclic AMP production and protein kinase A activation. So these D1-like receptors actually stimulates the prolactin secretion. But D2-like receptors, they act through the G-alpha I and inhibit the production of the cyclic AMP and protein kinase A, thereby inhibit the prolactin secretion. And so all these dopamine agonists act through these D2 receptors, thereby decreasing the prolactin secretion. When it comes to the D2 receptors, again, there are two isoforms. These isoforms formed by alternative splicing, like short isoform and long isoform. We call it a D2S and D2L. The dopamine effects on lactotropes are mediated through the D2S, D2 small isoform receptor. So that's why in patients who have a decreased expression of this D2S receptor or imbalance between the D2S and D2L, that means lesser production of D2S with increased production of D2L, which plays an important role in development of resistant prolactinoma. As I said, and also the other mechanisms by how they develop a resistance are decrease in the dopamine receptor expression and downstream signaling pathways, and reduction in MRA levels of inhibitory G protein alpha subunit, and other mechanisms, disruption of the growth hormone, growth factor signaling. That means increased growth factor signaling, usually mediated by the epithelial growth factor receptors or nerve growth factor receptors. Ultimately, they act through the tyrosine kinase receptors and increase the proliferation. And one more thing is the TGF beta system. Actually, these have a role in the induction of dopamine agonist resistance. There is a significant reduction of the TGF beta 1 and also downstream intracellular effectors like SMAD proteins reported in human dopamine agonist resistant prolactinoma. So this dopamine usually upregulate this TGF beta system, and estrogens downregulate TGF beta system. So if you see here, one is the dopamine D2 receptor, like D2 receptors, they mediate action through the G-alpha inhibitory. One side it will inhibit the cyclic AMP production. So one side it inhibits the PI3 AKT mTOR pathway, so there will be a decrease in the proliferation and promotes the apoptosis. And one more is the TGF beta system. TGF beta also actually through SMAD proteins, it negatively regulates the prolactin secretion. So when there is a decreased down regulation of this TGF beta system, then the patient may develop dopamine agonist resistance. And third one is, as I said, epithelial growth factor receptors act through the tyrosine kinase pathway. They'll also, the increased expression or increased activity of these receptors leads to the dopamine agonist resistance, because these receptor tyrosine kinase receptors also modulate the D2 receptor action. So what are the risk factors for resistant prolactinoma? I mean, these patients, male patients are increased risk of developing resistant prolactinoma, and very young patients, cystic tumors are at increased risk. Large tumors, invasive prolactinoma associated with men's syndromes, they are all increased risk for resistant prolactinoma. And coming to the management, there are options. Are first if patient is first step is shift to cabergoline. Suppose if the patient is on bromocriptine, then we have to shift to the cabergoline. But if patient is already in cabergoline, then there is no point in changing to bromocriptine, because the cabergoline is more efficacious compared to the bromocriptine. And 80% of the, usually 60 to 80% of the bromocriptine resistant patients achieve normal prolactin levels using cabergoline. But in these patients, those who are resistant to bromocriptine, then compared to the normal patients, these patients may require higher dose of cabergoline. Then second aspect is cabergoline dose escalation. So, and we see partial resistance to dopamine agonist normally often overcome by the increasing the dose of the cabergoline. In one study by Ono et al., this study of 150 previously untreated patients, in that 1/3 are macroadenomas. They reported normalization of prolactin levels with less than 2 mg per week in almost all patients except 11 patients. In that also, more than 2 mg per week was required in 11 patients. That means 4 patients required 3 mg, 2 patients required 6 mg, 4 required 9 mg, and 1 patient required 12 mg. But 1 patient did not respond even with 15 mg of cabergoline, 15 mg per week of cabergoline. So as long as the adverse effect do not develop, the dose escalation remains a good therapeutic option. But patient must be informed about the potential long-term side effects of the cabergoline at such high doses, in particular of the risk of cardiac, valvular, and pleural fibrosis. But more than this, actually, what we need to focus more is the risk of impulsive control disorders, that we always will think like screen. When a patient is, we are giving a high doses of cabergoline, then we always focus on the heart, risk of fibrosis, risk of pleural fibrosis. But more common than that is the risk of impulse control disorders. Always, that's why though these patients may develop hypersexuality, these patients may develop increased gambling behavior. So financially, the patients may deteriorate, or their marital relationships may get disturbed. So always, especially when you are giving more than 2 mg per week of cabergoline, always discuss these possible side effects with the patient and also the spouse. Otherwise, if you don't inform the side effects to the patient or other spouse, then when patient develops these kind of hypersexuality or gambling behavior, they may not know that it's because of the drug. So that may disturb their family and financial relations. So that's why I always inform about these impulse control disorders. In fact, in patients, patients taking dopamine agonists daily, in the case of Parkinson's disease, these impulse control disorders are reported to be around 60%. But because prolactinoma, we usually tend to use lesser doses, around the 5 to 10% is the risk of development of these impulse control disorders. But when you are using higher doses, then the risk will be more. So that's why always you need to discuss these side effects. And some studies have shown little benefit beyond 3.5 mg per week. So maintaining this maximal dose and waiting for the time, a watchful waiting may lead to hormonal control after several months. And next option is the surgery. Patients who are resistant to medical treatment or who require higher than the standard doses of cabergoline, not tolerating, and especially with optic chiasmal compression, because this is the thing that is more important than just hyperprolactinemia and all. So then these patients may get benefited from the neurosurgery, even though tumor resection is incomplete. So because just we can do a debulking surgery, then followed by continuing the cabergoline dose. Then they may respond well, then without surgery. Then the transpenoidal or microscopic or endoscopic approach do well for the microprolactinoma, majority of the macroprolactinoma. But those patients who have giant tumors or with intracranial extension, then the craniotomy could be the option. Next is the radiotherapy. Those patients who are resistant to medical therapy but failed surgical therapy, but still exhibit an aggressive behavior, threatening, compressing the optic chiasma, then maybe radiotherapy can effectively control the tumor growth. But the problem with radiotherapy, we all know that it requires many years. And following the non-curative or debulking surgery, both conventional fractionated radiotherapy or stereotactic radiosurgery. Stereotactic radiosurgery, we need to be a bit careful when, especially the tumor is close to the optic chiasma. Then in those cases, we usually go for the conventional fractionated RT. And this therapy allows normalization of prolactin levels at similar rates of around 20 to 40%. But the delay is the problem. This may take up to 3 to 10 years. But along with this, after radiotherapy, if you continue the medical therapy, then prolactin normalization may be finally obtained in 80 to 90% of the patients. And next is the chemotherapy. Like temozolomide is the widely available drug now, and it's orally alkylating agent, highly effective in aggressive neuroendocrine tumors or carcinomas or prolactinomas. The dose usually advised are 150 mg per bed per OD for 5 days in a month. Like that, 6 cycles we have to give. But before every cycle, we have to check for the cytopenias because neutropenia and thrombocytopenia are very common. So this is the algorithm. First, drug-resistant macroprolactinoma, then switch to the drug, then increase the dosage of the drug. Here, the recommendations are there are suggesting to go up to 3.5 mg per week, but beyond that, maybe the side effects will be more, but the response may not be that good. Then if still resistant, then especially if symptoms, complications, large tumor, compressing the optic chiasma or planning pregnancy, very engaged, then better to go for the debulking surgery. After debulking surgery, then again, you have to initiate this patient on cabergoline, then watch for the control. If there is still no control, then to go for the radiotherapy. If after radiotherapy, then temozolomide is also a good option. So in this perspective, I want to discuss, just one case we have seen in our institute NIMS, Hyderabad, recently. It's a 36-year-old male presented with headache, diminished vision in the right eye, and MRI showed 7 centimeters LR mass with optic chiasmal compression. I think I'll go to the correct slide. Yeah. In 2004, he was the initial presentation. He was not following with, at the time, he was not with us. He was consulted outside doctor. Prolactin levels, he presented with headache, blurring of vision. Then directly they have done an MRI scan, showed 7 into 7 into 6 centimeters LR mass. And prolactin levels are more than 10,000. Doctor, because it's compressing the chiasma and also visual field defects were there, they done surgery followed by radiotherapy. Then after that, he lost follow-up for 4 years. Then again came to us in 2018 February. Then prolactin levels were high, but MRI actually showed good response. 1 into 1.9 into 0.7 centimeters. So because we are not sure about his compliance, then we started 0.5 mg per week, then gradually escalated to 2 mg per week. Then within 1 year, he showed good response with prolactin normalization. But again, after 6 months, again, prolactin levels started increasing. We confirmed a good compliance. Then when we repeated the MRI showed increase in the tumor size from 1 to 3.7 centimeter. Then here, because it was, again, this time he developed left-sided decreased vision. Then MRI showed compressing the optic chiasma. So we proceeded with the repeat surgery. And after 6 months, again, with 3 mg per week, he showed very good response with prolactin levels of 50. Then after 12 months post follow-up, again, the tumor started increasing, prolactin levels were increased. And with 3 mg per week also, we are not able to achieve the normal prolactin. Then at this point, we consider, because it's again, tumor is growing, then again, the chance of compression of the optic chiasma is there. So we started temozolomide at this point. We gave 5 days in a month for 6 months. Then after 6 months, he showed very good response with the prolactin of 20. And tumor decreased by almost 50%. With 2 mg per week, we could achieve these targets. And at this point, temozolomide was stopped. Even after 6 months after stopping temozolomide with 2 mg per week, he showed very good response. Tumor size Actually, I did not mention here, it was 1.5 centimeter and with normal prolactin levels. So other available options are close follow-up in older males, postmenopausal women with no symptoms and no threat of compression. If fertility is major concern, then induction of ovulation using clomiphene citrate is a good option. But the pregnancy, the SAR has already extensively discussed, because estrogen promotes the growth of these tumors, though tamoxifen, fulvestrant, anastrozole are the drugs actually tried, but just not usually recommended. What are the future potential therapeutic options? As I discussed in the mechanism, the tyrosine kinase inhibitors has a role, definitely going to have a role in this controlling the tumor. Lapatinib, gefitinib already tried. And combining cabergoline with octreotide, because these receptors are very well expressed in some resistant prolactinoma. And peptide receptor radionuclide therapy also with indium VTPA octreotide is being reported in the patient with giant prolactinoma. And as I said, TGF-beta system is involved in the dopaminergic inhibition of lactotropes. The thrombospondin is actually studied in animal models. So to conclude, most prolactinomas respond very well, but showed some resistance or more resistance with the bromocriptine than cabergoline. The predictive factors were invasiveness of the tumor and male gender. So in that case, need to change the drug, escalate the drug, wait for the long-term effects, surgical debulking, radiotherapy, followed by temozolomide. Despite all these options, few patients will remain hyperprolactinemic, but if they, as long as there is no compression, then we can manage this patient conservatively. And maybe it's the time we need to focus more on the future treatment options. Maybe we need to see how they're going to act. Yeah, thank you. And acknowledge the Department of Endocrinology and Department of Neurosurgery in Hyderabad. Thanks for giving me the opportunity.
Dr. Verma, one question. I'm Dr. Sushil Padhyaya from Lucknow.
Yes.
So how long we can safely use the cabergoline therapy? And second is how to monitor the consequences, that is side effect by the cabergoline.
Sir, how long? Sir, how long means
we can use the therapy?
Sir, how long? Sir, after normalization, it usually recommended after normalization and after reaching our targets, at least we have to continue for at least 2 years. But actually, after normalization, if you try to stop, but at least you have to give 2 years. Then then if tumor is almost disappearing and normal prolactin levels are reached, then we try discontinuing, but which carefully monitoring the prolactin levels. If prolactin levels start rising, then again we have to start using the drug again. But at least you have to continue 2 years after the reaching targets.
How frequent monitoring for the side effects like valvular and
yes, sir. When we are using at higher doses, then definitely at least 6 months or once in a year we have to do the cardiac monitoring. But more common than that, what we are, maybe just because we are not documenting properly that impulsive control disorders, so the frequency, the reported frequency is less, but they are more common, especially in the Western literature. Actually, they're shown that after stopping the drug immediately within a few days or within few weeks, they showed a decrease in the impulsive control disorders. So maybe that impulsive control disorders, whenever the patient comes, then at least we have to ask about these symptoms. Both they have to take this history from the patient and also from the spouse.
Thank you.
So, Dr. Adas.
Thank you very much for the wonderful session on resistant prolactinoma.
Yeah.
It was a very good, concise and comprehensive, which included practical aspects. I think that is all about in this session. So we'll continue with the next session. I would like to hand over the session back to Dr. Ajay Shukla to proceed to next session.
Thank you, Dr. Adas. And we thank our speakers, Dr. J.J. Mukherjee sir, Anil Bhansali sir, and B. Padmanabhan Verma sir for a wonderful session. With this, I invite Dr. Pankaj Gupta to take over the next session. Dr. Pankaj Gupta is trained in adult and pediatric oncology research. He's DMD oncology and part of Hormone India. So Dr. Pankaj Gupta, please go ahead.
Good afternoon all. So, well, we are running on time and keeping the momentum of the presentations. So we will quickly move to our next session. So I will request Dr. Ajay Shukla kindly introduce Dr. Belinda George and initiate the session.
Thank you, Dr. Pankaj. Can we have a slide of Dr. Belinda? So Dr. Belinda George is well known in endocrinology circle. She is MBBS, MD, DM from St. John College, certificate of honor in pathology. She is associate professor in Department of Oncology, St. John National Academy of Health Science, Bangalore. And she has various awards, including Torrent Young Scholar Award and various travel grants and more than 30 publications. So with this, I invite Dr. Belinda George to take over and present her views on copeptin in the diagnosis of diabetes insipidus.
Thank you, Dr. Ajay. Let me just share my screen. So at the outset, let me thank, is it visible? My screen is visible?
Yes.
Okay. Thank you. At the outset, let me thank Hormone India, Team Hormone India, a group of young enthusiastic endocrinologists for inviting me, and all the very best to you for your endeavors in the future as well. So my topic for today is copeptin and the diagnosis of DI. And I have a small disclaimer to start off with, which is basically that I do not have much experience with copeptin. I have not done this assay ever. So this is going to be essentially more than a pragmatic discussion. It's going to be a concept-based discussion. So let's look at in the next 20 minutes, what are the ways in which copeptin can help us diagnose in the diagnosis of diabetes insipidus. Oh. Yes. So you can see that this is just a brief overview of what happens in the hypothalamo-posterior pituitary axis. So you can see that the hypothalamic neurons are here, which synthesize and secrete AVP, and then it is transported down to posterior pituitary, stored here, and released when the appropriate stimulus is applied, which usually responds to both osmotic and volume reduction in volume and reduction in pressure. So these are the stimuli which induce a synthesis of AVP secretion. And you can also see that AVP has a small role to play in the anterior pituitary as well, where it regulates the increase in ACTH in response to stress along with the CRH. So this is a very brief overview of what AVP does. So what happens once the AVP is released from the pituitary? Where does it act? The predominant action that we are concerned with regards to today's discussion is basically in the renal collecting duct, where it acts on the V2 receptor here. And by virtue of its action, it increases expression of a channel called the aquaporin channel. These are water channels. So this leads to reabsorption of water back into the system. And hence it prevents loss of water and causes diuresis, prevents diuresis. So what are the pathologies in which this particular hormone has an imbalance? One is, of course, there is a deficiency in the hormone, which is called central diabetes insipidus, where ADH is not being secreted from the posterior pituitary or from the hypothalamus. The second one is if there is a problem with the action of the ADH. So if there is resistance to ADH action, the kidneys don't respond to ADH in an appropriate manner, and that will also lead to same clinical features which the patient will present with polyuria and polydipsia. We also have a third differential diagnosis to patients who present with polyuria and polydipsia, and that is what is called as primary polydipsia, which can either mean a dipsogenic diabetes insipidus or a psychogenic diabetes insipidus. So this is also very important for us to differentiate from central DI, because what happens is in central DI, all you have to do is replace the hormone and everything will be okay. In nephrogenic DI, if you replace the hormone, it's not going to work. And in primary polydipsia, you should not be replacing the hormone. You should be cutting down on the fluid intake, because that is where the issue is. So it's important for us to start clearly differentiate between these etiologies before we decide on a therapeutic plan. So if we have to differentiate, common sense tells us that all we have to do is look at the vasopressin levels and then look at, give some vasopressin and see the response. So if you have this combination, it should be pretty easy for us to differentiate. So in central DI, you expect the vasopressin to be low, but you expect the patient to respond very well to exogenously given medication. And however, in nephrogenic DI, the vasopressin basal level itself will be high. And if you give any exogenous desmopressin or vasopressin, it's not going to have any response. On the other hand, in dipsogenic DI, you will see that the vasopressin levels are low, and the patient also does not respond to exogenous vasopressin adequately. So this should be pretty easy for us to differentiate between the three forms of DI. However, clinically or practically, we do not do this simply because we do not have vasopressin assays. Reliable vasopressin assays are not there. And why do we not have reliable vasopressin assays? Because this molecule is a fairly unique molecule. One is it has a very short half-life, which is roughly around 24 minutes. So if your sampling is delayed by 30 minutes, you can have varying values. The second, of course, like many other hormones, it is secreted in a pulsatile manner in response to stimuli. So you may not always be catching it at the right time. Another feature is that it's a small peptide. It has only 9 amino acids. So this makes it difficult for us to develop epitopes to create good, robust antibody-based assays. And lastly, it also undergoes very rapid in vitro degradation. So after the sample is collected ex vivo, in vivo also actually, this is degraded very fast, which is why it has a very short half-life. But even ex vivo, the protein undergoes significant degradation. So this makes it a very unstable compound, and then it becomes difficult to store or collect the sample appropriately. So commercial assays that are available today are not very reliable. Only in research settings, you have reliable assays for AVP, which can detect the accurate AVP value. So we do have a challenge with checking the vasopressin. So what have we been doing all these years? We have been using the water deprivation test in order to differentiate between various forms of DI. So here you can see very clearly that if you look at the red line, you can see this is how a normal person will respond to water deprivation or withholding any form of fluid. So your urine osmolality will rise, it will reach a peak, and after that, even if you give desmopressin, which is a synthetic vasopressin, you will see that the urine osmolality cannot further rise because the patient has reached his maximum concentrating ability. If you look at the last little green line here, that actually refers to complete nephrogenic DI. So you can see that even when you deprive the patient of water, the urine osmolality is not rising. Even when you give desmopressin, it's not rising. So this is very clear. Desmopressin is there, but it's not acting. So this is nephrogenic DI. There's another one here, which is a light blue arrow, which is the patient does not respond to water deprivation at all. The urine osmolality continues to remain low. The minute you administer desmopressin, you can see that there is a nice response. So these two extremes, which is complete central DI and complete nephrogenic DI, are very easy for us to differentiate. However, we know that in clinical practice, very often patients fall into the partial or the milder variants. So you can have a partial nephrogenic DI or you can have a mild form of central DI. And this, along with the primary polydipsia, you can see that all of them kind of overlap heavily. So this makes diagnosis very, very difficult for us. And if we do not diagnose it correctly, our therapy is not going to be appropriate. So these are the three variants that we need to fine-tune or improve our diagnostic accuracy, which is partial central DI, partial nephrogenic DI, primary polydipsia. So that is how this is just quickly about how to interpret it. So if there is more than 50% increase, it's clearly central DI. Less than 10%, it's clearly NDI. However, often we will see values between 10 to 50%, which is equivocal. So in order to bridge the gap, that is how this molecule has come. In fact, vasopressin was the first molecule that was attempted, but after many, many years of failed attempts to build a robust vasopressin assay, people started looking at copeptin. So what exactly is copeptin? So as you can see here, copeptin is basically a part of the precursor molecule of vasopressin. So this is a pre-pro vasopressin, and copeptin is part of it. This is what is there in the hypothalamus. And as it is transported down via the axons and reaches the posterior pituitary, it is broken down into vasopressin, neurophysin, and copeptin, and all three of them are stored in the secretory granules there. And when there is a stimulus and there is a response to stimulus during exocytosis, these both vasopressin and copeptin are secreted in equimolar concentrations into the circulation. So then people started thinking, okay, vasopressin and copeptin are coming out from the same place in response to the same stimuli. So can we use this as a surrogate marker of vasopressin? So we'll just look at how it compares with vasopressin. So when you look at the half-life, it has a longer half-life clearly because it is a glycosylated peptide and that increases its half-life. It is co-secreted in equimolar concentrations like I mentioned earlier. It has 39 amino acids. giving us more epitopes in order to create a more robust antibody-based assay. And it is best of all, it is stable ex vivo or in vitro and does not undergo rapid degradation like vasopressin. So even though vasopressin, we could not create successful commercial assays, copeptin, on the other hand, is coming up as an ideal surrogate marker for AV. So briefly, we will look at whatever we have data we have on copeptin. These are early studies which looked at stability of copeptin, and you can see that even at room temperature, this molecule is stable for 7 days. There's hardly any decrease in the levels even at the end of 7 days. At the end of 14 days, of course, you see that there is a subtle reduction in room temperature. But if you're storing it at 4 degrees centigrade, even at 2 weeks, there is hardly any reduction. So this is a very stable compound which can be stored and assayed at a later date. So some basic data, men tend to have slightly higher value than women. But otherwise, they both respond to in the same fashion to hyperosmolar stimuli. And of course, common sense tells you that if there is a water or a liquid meal, there will be a reduction in the AVP. But otherwise, nutrient-based, there is no change in AVP secretion. Copeptin secretion. So whether you can take it irrespective, there's no circadian rhythm either. So you can collect it at any time of the day and irrespective whether you've had a meal or not. However, it's important to remember water or any liquid diet can cause an acute fall in the levels of copeptin. This is exercise. So you can, as logically, we would expect copeptin levels and AVP levels to go up after exercise. So that is what you're seeing here. Another condition where AVP and copeptin is significantly elevated is patients with sepsis. So we again know that AVP secretion of AVP stimulates CRH. So AVP and copeptin are also surrogate markers of stress. They can also be called stress hormones. In fact, correlation with stress-related conditions is better for copeptin when compared to cortisol. And cortisol is the common stress hormone that all of us are familiar with. So any stressful condition also tends to increase your copeptin secretion. This graph shows you the correlation value between AVP and copeptin, and you can see whether it's in normal controls or in patients with sepsis, the correlation is pretty good. In fact, the R value is 0.78. Again, here it depends on what assay you have used. So remember we said commercially available AVP assays are not very robust and they're not very good. So when they tested AVP against copeptin with using commercially available assays, the correlation coefficient was only about 0.3. However, when they checked it with research-based robust assays for AVP, the correlation coefficient was 0.8. So there is a real problem with AVP assay, and copeptin seems to have help us overcome that issue. So we will look at a very simplified algorithm. This is how to use copeptin in our patients who present to us with polyuria, polydipsia. So the first thing you can do is a baseline copeptin. Because initially you have to be sure that the patient does have polyuria, polydipsia. You should also rule out hypercalcemia, hypokalemia, hyperglycemia, etc. So once you have done that, you can go ahead and do a random copeptin level, even without any fluid deprivation. And if it is elevated, we don't really have to concentrate on the numbers if required now, because if you're doing the test, you can always refer to it. So if it is clearly elevated, which is about 21.4, then there is no doubt this patient has nephrogenic PI. However, if it is suppressed and if you have not done any fluid deprivation, we don't have a value for low copeptin. But if the patient has undergone some fluid deprivation, let's say for about 5 hours or 8 hours, and your basal copeptin is less than 2.6, you can also say with some amount of certainty that this is central DI. Now, often when the values fall less than 21 or between these two, what is the next step that we should do? So there we have to do something called stimulated copeptin. How do you stimulate copeptin? What is the greatest stimulus to release AVP from the posterior pituitary? You have to increase the serum osmolality. And what we do to measure serum osmolality is a reliable marker is a plasma sodium level. So you can infuse hypertonic saline, reach a plasma sodium of 147 at least, and then check your copeptin level. This is what is called the stimulated copeptin level. So again, we have cutoffs of 4.9. So if it is more than 4.9, then you're dealing with primary polydipsia. Whereas if it's less than 4.9, you're dealing with central DI. So this is a very useful algorithm if we have access to copeptin assays. So again, this is utility of copeptin in various clinical scenarios. So in polyuria polydipsia, we can start off, like I mentioned earlier, with random copeptin measurement. Your interpretation can be stopped if, or your testing can be stopped if your copeptin levels are very high and you're sure that this is nephrogenic DI. The diagnostic accuracy is excellent. You don't have to do any further testing. Anything less than 21.4, you have to put the patient across to a stimulated copeptin. There are two ways of doing stimulated copeptin. One is the hypertonic saline infusion test that I mentioned. And more recently, there's an arginine infusion test that also has been introduced for stimulation of copeptin. Again, arginine is something that's not available in India, so it's not practically very useful for us. However, the hypertonic saline infusion test, so you give 3% saline, 250 ml bolus over 15 minutes, and then continue it with steady 3% saline at the 3% saline at the rate of 0.15 ml per kg. And then you have to monitor sodium every 30 minutes. And once it crosses 147, you can draw a sample for copeptin. Again, we have discussed the cutoffs. The 4.9 is your cutoff. Anything higher than that is likely to be primary polydipsia. Of course, the arginine infusion test that I just mentioned, it's much more convenient than using hypertonic saline infusion test because side effects are lesser, patients tolerate it better, we can use it in children. So many advantages over the arginine when compared to hypertonic saline. However, the diagnostic accuracy is slightly lesser, but it's good enough, particularly if you want to use it first. And then if you need a confirmation, you can go for the hypertonic saline. Again, the cutoffs here are slightly different. Another place where you can utilize this copeptin is patients who are undergoing transsphenoidal surgery and you want to look at their risk of developing DI. So the first test actually looked at insulin-induced hypoglycemia and stimulated copeptin along with that, and that had a 100% prediction to tell which patient will develop permanent DI following the transsphenoidal surgery. Of course, putting every patient post-TSS to insulin-induced hypoglycemia is probably not a very practical thing to do. So the other test that people did were to use the surgery itself as a stress and see in the first post-operative day, look at the copeptin values and see whether we can predict it. So again here, if the first post-operative day, if your value is very high, the cutoff here they got was 30, it gives you a good negative predictive value that this patient is less likely to develop permanent DI. However, if the value is very less, positive predictive value of this patient developing permanent DI is significantly high. Another place where we can utilize it is in patients, in hospitalized patients with hypernatremia. Often we are not sure what is causing it. Is it simple dehydration? Have we iatrogenically introduced it? Or does this patient also have DI? So if you look at data says that, if the patient has DI, we have to also give desmopressin. Free water alone may be inadequate. So it's sometimes there is a significant delay in starting desmopressin simply because we are not sure about the etiology. So this is one place where copeptin will definitely help to decide whether there is, along with the whatever other reason that's going on in the hospitalized patients in the acute setting, is there coexistent DI as well. Even in hyponatremia, it's useful, but I'm not going to cover that. Just like we spoke about assay in AVP, even with copeptin, there are various assays. And so we should be slightly familiar with what assay we are using and is that really validated or not. So there are different immunoassays which are present and available today. The original one was an immunoliminometric assay, which is called LIA. And then there's another one, which is slightly better version, which is an automated immunofluorescence successor of the same assay, which is on the Cryptor platform. There are many ELISA-based immunoassays that have been developed to measure copeptin. However, these are not truly validated in most of the studies that have been done to date. So it's important for us to dig in and find out if we are ordering a commercial copeptin assay. It's important for us to figure out what the methodology is. So here is a study which looked at these three assays and tried to see how they performed. This is a patient group that we are interested in, which is polyuria polydipsia. And you can see that both Cryptor and ELIA are showing you much lower values of copeptin compared to the ELISA, which is giving you a much, much higher value. So there is a huge incongruence between the values obtained between these two platforms. So this is something that all of us should be alerted to. So the same patients were divided into central DI and primary polydipsia based on the stimulated and basal copeptin value. And you can see that based on the basal copeptin value, you can see, it is 1.6 and 0.8, and here it is 18.2. And the stimulated copeptin value for central DI, when it remained 1.7, 1.4, here it was 17.2. So you're going to miss a lot of your central DI patients, and you're going to misclassify them as primary polydipsia if you're not sure about which assay you're using. So it's important for us to look into it. The primary polydipsia also had elevated. So what seems to be happening here is that there is some false elevation of ABP in these ELISA assays. So if you look at the diagnostic accuracy, you can see that the ELISA had only 55% diagnostic accuracy compared to 98% diagnostic accuracy for the Cryptor-based platform. So it's very, very important for us to be aware of this and to be cognizant of what test we are using in our clinical practice. So that will be the end of my talk. So in conclusion, copeptin is emerging as a diagnostic test of choice in DI. And recent reports have suggested that it can be utilized in many, many other clinical scenarios. Like I showed you sepsis, there are many other clinical scenarios also. It is likely to replace the cumbersome water deprivation test even in our country, because eventually we will get good, reliable copeptin assays here. It's much more easier to do. It has better diagnostic accuracy. So it's a matter of time before we all migrate into it. But the caution that we need to keep in mind is that, always try to look into the details, because commercial assays may be using ELISA platforms, and the diagnostic cutoffs that you and I read in the books will not be applicable for those. So thank you very much.
Thank you, ma'am. Thank you for the wonderful talk. Very interesting talk. And rightly told, madam, copeptin measurement has overcome the many major issues associated with AVP measurement. And various hypotonic polyuric states. So thank you again, madam. And if we don't have any query, can we move ahead?
Yes, I think.
Okay. Dr. Mayur Agrawal, please introduce our next speaker and proceed for the session.
Good afternoon, sir. I welcome you for this session. So, sir is MBBS, MD, DM Endocrinology from AIMS. He was associate professor at GMC Bhopal, and he is teacher of many graduates and postgraduates, including me. He has achieved many awards. His special interest is in Cushing's bone and reproductive endocrinology. Over to you, sir, for your session.
Thank you.
So speaking on a very interesting talk, role of HDDST, because there is always this dicey, because with this IPSS, whether we need this HDDST or not. So that is what sir would be speaking. Over to you, sir.
Yeah. Thank you, Mayur, for the kind introduction. And I've been given the task to talk about a very rare topic, I will say, after passing DM. This was the first time I've been given this kind of topic. So let's see what kind of justice I can do. Let me see. There is some problem with the sharing of my slides. Just one minute.
Yes, we can see the screen.
Yeah, it will come. Is it visible now?
Yes, yes. Kindly make it full. Yeah. Okay.
Very good afternoon to all of you. First of all, at the outset, I would like to thank Dr. Mayur Agrawal, Dr. Ajay Shukla, a young endocrinologist, and Dr. Pankaj Gupta for giving me this opportunity. And my best wishes are with Hormone India, a new initiative on your behalf, because the academics should grow. So this is something which I firmly believe in, and we should bring good endocrinologists, and definitely they should come forward in a more aggressive way. This is what I believe in. So the role of a high-dose dexamethasone suppression test in today's era is something which is like, it's dicey. There are people who say we should completely refute it. But these are from those centers which are well equipped. They have got 3 Tesla MRI, they have got facilities for BIPS, that is bilateral inferior petrosal sinus sampling. But still in India, though fortunately in the last 10 years, the scenario has changed a lot. Even at Bhopal, we have got 3 Tesla MRI. But when I was in the institute, it was really difficult to catheterize both the petrosal vein. So that sampling is a little bit difficult. And so that's why these conventional investigations like high-dose dexamethasone suppression test is still relevant for those areas where we have less facilities. So it has actually for the differential diagnosis of ACTH-dependent Cushing syndrome is definitely is a challenge. And in our series from AIMS also, I'll be showing you that data. We had a lot of places we were stuck up. So the confirmation of the diagnosis in a case of pituitary macroadenoma is usually clear-cut. And in cases of microadenoma or normal findings of MRI, usually with tumors less than 6 millimeter, some of them studies they say less than 5 millimeter, confirmation of diagnosis is challenging, whether we are dealing with an ACTH source from pituitary or it is from ectopic source. That is a question, that's $1 million question which is there. So since if the audience is primarily endocrinologists, this doesn't stand a lot, but I suppose there are some physicians who are also in the crowd. So for the diagnosis of Cushing syndrome, dexamethasone suppression test is used in the evaluation of endogenous Cushing syndrome and assessing for the lack of suppression of the HPXs by exogenous corticosteroids. So it's a potent corticosteroids, almost 30 to 40 times more potent than the physiological cortisol. So what we do when we suspect hypercortisolemia, we subject our patients for 4 screening tests. Basically, one is the dexamethasone suppression test. Other one is the overnight dexamethasone suppression test, the low-dose dexamethasone suppression test. And we go for assessment of 24 hours urinary cortisol. And some of the better institutes and good institutes, they also have facility for salivary cortisol. And there are fixed valid cutoffs for it. And out of this 4 screening tests, if 2 of them or more of them are positive, we usually say it is hypercortisolemia. Then the question arises, from where this cortisol is coming? Is it because of the influence of ACTH which is coming from the pituitary, or there is some other source of ACTH, or it is an autonomously cortisol generating tumor from the adrenal glands? That is something, that's why we go for ACTH assessment. But dear friends, after doing ACTH and the ACTH is high, that is an ACTH dependent Cushing syndrome. But there are 2 possibilities. Either this ACTH is coming from the pituitary, or this ACTH has got some ectopic source. It's not from pituitary. There's a carcinoid in the lung sitting over the lung, or some other tumor nearby which is secreting more of ACTH. So we are in a state of dilemma. That's why we go for imaging, that is MRI. MRI, usually we go for any of the MRIs above 1.5 Tesla, the dynamic pituitary cell scanning is done. And if it shows a tumor which is around a macroadenoma, so we are very sure okay, this ACTH is from that tumor, and we straight away go for the rest of the investigations and the interventions as required. But we are in a state of fix. When this tumor, when the MRI turns out to be normal, or there is a doubtful lesion, we are not very clear, there is a speck of lesion where we are in a doubt, it may be a microadenoma. That is the point of time where we need some extra tests. So when the facilities were not available, people used to go for high-dose dexamethasone suppression test. And the physiology was that, the basic physiology, giving dexamethasone at a very high dose. This 8 milligram amounts to almost 10 times of endogenous cortisol secretion in 24 hours. And the philosophy was, it will lead to suppression of ACTH from the adenomas, the microadenoma. And if the suppression is more than 50%, so it will establish the diagnosis. This was the basic logic behind and the basic knowledge behind the high-dose dexamethasone suppression test and the other investigations. The high dose, it distinguishes pituitary, that is the Cushing's disease, from an ectopic source of ACTH overproduction. And there are 2-3 ways of doing it. The overnight 8 milligram test where we at one go we give 8 milligram in the night, and the morning hours we see for how much cortisol has suppressed from the baseline level. And the 2-day, the conventional, the 2-day 8 milligram dexamethasone suppression test. On the day 1, a baseline morning serum cortisol or 24 hours urinary free cortisol is taken. Then oral dexamethasone 2 milligram every 6 hours is given for 2 days. That is 9-3, 9-3. Some follow 6-12, 6-12. It's up to your convenience. And total dose of that is 16 milligram between day 1 and day 2 with simultaneous collection of urinary sample for UFC. So the serum cortisol levels are checked 6 hours after the last dose, that is 9 a.m. And the principle basically is if the baseline cortisol, there has to be a suppression more than 50%. That usually assures us we are dealing with an ACTH-dependent Cushing's syndrome. It is basically a Cushing's disease, and the source of ACTH is from the pituitary. That is why this high-dose dexamethasone suppression test is required. So interpretation, reduction in urinary free cortisol, a serum cortisol greater than 50% in the overnight or 2-day high-dose dexamethasone Cushing's disease, this establishes the Cushing's disease. At a cutoff of 50% suppression, sensitivity and specificity is around 60 to 100%. So increasing the cutoff, what we used to do when I was working with my professor who was a legend in Cushing's, so she used to say if it is more than 80%, there is a high likelihood of we dealing with a So this is almost the sensitivity 100%, but the sensitivity is less. Specificity is around 100%. And this is what we have observed in our institute. This was a study of high positive predictive value when they combine it with MRI syndrome who underwent pituitary MRI, IGDST and BIPS. They compared it. So the post-predictive value of pituitary, that is the MRI, IGDST and bilateral inferior petrosal sinus sampling, that is BIPS, and the combined tests were calculated and tumor lateralization accuracy was further analyzed. The positive predictive value of combined pituitary MRI and IGDST was 98.6%. Very impressive. It was found to be higher than BIPS. 96.8% of the patient had either negative findings in pituitary MRI or IGDST, showing centralizing BIPS results. For tumor lateralization, the accuracy by pituitary MRI was 88.6%, where the BIPS was 57.5%. So there are trials to say BIPS is better, it is scoring. There are trials where they've combined it with MRI and IGDST and where they've shown these results. This is something which we also used to face during our institute era. So Cushing's syndrome patients with both positive findings in pituitary MRI and IGDST need no further invasive evaluation. BIPS will improve the diagnostic accuracy when negative findings were found in either pituitary MRI or IGDST. If both of them are positive, then definitely you need not go for BIPS. That is something, the conventional wisdom is still prevailing. This is another paper of high-dose dexamethasone suppression test is inferior to pituitary dynamic enhanced MRI in the differential diagnosis of ACTH-dependent Cushing's syndrome. So around 190 patients, a Chinese study, and the pituitary MRI was found to be superior to IGDST in differential diagnosis of ACTH-dependent Cushing's syndrome. Another paper validating the same thought process. If you have a positive finding, then definitely MRI will score over IGDST, because if a tumor is sitting over in pituitary and it is well visible and well differentiated, there is no point. It's most likely it is a Cushing's disease which is causing hypercalcemia. So there's another paper which is talking about the effectiveness versus efficacy, the limited value in clinical practice of high-dose dexamethasone suppression testing in differential diagnosis of adrenocorticotropin-dependent Cushing's syndrome. So this is again of a paper of 112 consecutive patients with ACTH-dependent Cushing's syndrome who were then classified based upon the results of inferior petrosal sinus sampling for ACTH levels. 15.2% had the ectopic ACTH syndrome and the remainder had Cushing's disease. Logistic regression models were used to predict the probability of Cushing's disease, given the results of HGDST before and after adjustment for the contribution of series of potential covariates. So the logistic regression models indicate that the results of HGDST and add little to the differential diagnosis of ACTH-dependent Cushing syndrome, especially after taking other clinical information into account. So now this is again a little bit more divergent data as compared to the previous one. So now they also have this low diagnostic utility of overnight high-dose dexamethasone suppression test. Because I've got told you there are 3 methods of doing it. Either you give it in one go, either you give it through IV, that is IV dexamethasone suppression test, or the 2-day dexamethasone suppression, which we were talking of. So this is in one go, you are giving overnight 8 milligram dexamethasone suppression test. And to conclude, they actually had 88 patients, ACTH suppression Cushing syndrome and Cushing's disease and ectopic ACTH syndrome were diagnosed in 68 and 20 patients respectively. And they concluded that overnight high-dose dexamethasone suppression test had a poor diagnostic value in differentiating Cushing's disease and ectopic ACTH syndrome. So further down, the effects of pituitary dynamic enhanced MRI and high-dose dexamethasone suppression test in the diagnosis of Cushing's disease, bypassing bilateral inferior pituitary sinus sampling. This was again a paper which was published in 2020. The objective was to compare the positive predictive value of the combined pituitary dynamic enhanced MRI and HGDST with BIPS in the diagnosis of Cushing's disease to see whether BIPS can be bypassed. So this was again a good initiative because the facility of BIPS is less available in good number of places. So the method was a retrospective analysis of 118 patients. And so the result was 72 patients had positive findings in both pituitary MRI and high-dose dexamethasone suppression test, of whom 71 patients were confirmed with Cushing's disease. And the positive predictive value of combination of pituitary MRI and HGDST was 98.6%, very impressive, which is higher than BIPS, that is somewhere around about 97%. So 46 patients who had negative findings in pituitary MRI or HGDST, 31 patients were Cushing's disease, among whom 30 patients had centralizing BIPS results. So if you don't have finding, definitely BIPS scores over the rest. But if you have a finding, then definitely you can do well when you can combine, rationally you can combine an MRI with HGDST and you can go ahead with the further intervention. So the positive predictive value of combined pituitary MRI was greater than BIPS, but ACTH-dependent Cushing syndrome patients with both positive findings in pituitary MRI and HGDST need no further invasive evaluation. But in addition, BIPS will improve the diagnosis accuracy when you have negative findings. This is what every paper is telling you. The usefulness of combined high-dose dexamethasone suppression test and desmopressin, because we need to have either CRH or desmopressin, because this is something which will add value to your investigations. So this is a paper. It concluded that dual non-invasive endocrine tests may substantially reduce the need for BIPS in the etiological investigations of ACTH-dependent Cushing syndrome. What they did was 24 hours urine cortisol level during the HGDST, and plasma ACTH levels were done after the desmopressin stimulation test in subjects with confirmed Cushing's disease and ectopic ACTH, and evaluated the positive predictive value and the 2 combined tests in the etiological diagnosis. So the combination of both tests yielded sensitivity of 95.5% and positive predictive value of 98.4 for Cushing's disease, and significantly improved the efficiency of the differential diagnosis between Cushing's disease and ectopic ACTH syndrome. Dear friends, I'll be showing you my data on corticotropic releasing hormone and this similar kind of work which I did when I was in All India Institute. So the limited invasive protocol, that is optimizing diagnostic modalities in corticotropin mediated Cushing's syndrome. This is another study done by some other institute. So evaluated 2 limited invasive protocols, that is LIP1 and LIP2, in limiting the role of BIPS while maintaining a diagnostic accuracy. They are just trying to say that without BIPS we can do, and it is almost as comparable. let's see what they found. So LIP were based on performing HDDST that is greater than 50% cutoff in first LIP1 and greater than 80% in second LIP2, and MRI of the sella in all individuals, and selective use of CT chest and abdomen before BIPS. So using LIP1 and LIP2 and CIS, BIPS could have been avoided in 62.3% of the patients. It was not required because these tests were, when they were combined and HDGST more than 80%, the result was very promising. So they concluded LIPs represent an equally accurate, less invasive, and more cost-effective alternative to the conventional invasive strategy for distinguishing between the Cushing's disease and ectopic Cushing syndrome. So high-dose dexamethasone suppression test has limited precision. Our paper, which has been recently published in 2012, is talking something which is a little bit divergent, because now they have not combined it with MRI or something, other modalities. They have not stimulated ACTH by some kind of DES processing or CRH. So 52% underwent the overnight 8 milligram test, and 64% underwent the 2-day HDDST. And with the 2-day HDDST, only 41 of the 64 patients had greater than 90% suppression for urinary cortisol. So there are some disparities when you do it as an individual test. This is again a very nice case report, which will actually help us in understanding why we are discussing the importance of HDDST and the variations with respect to its combinability and its comparison with an invasive test like BIPS. The patient was admitted to the university, it was in Turkey hospital. On day 3 after admission, the overnight dexamethasone suppression test resulted with cortisol level of 18.5 mcg before the test and 21.9 after the HDDST. Was almost refuting this. The patient was pre-diagnosed as ectopic ACTH Cushing syndrome because HDDST is not suppressed. On 5th day after admission, a thorax CT, abdomen MRI, and DOTA-Tate PET was performed, and the thorax CT showed a nodular lesion. They were excited whether they are dealing with some kind of carcinoid. It was suggestive of neuroendocrine neoplasia, that is carcinoid tumor. On day 11 after admission, the lower lobe of the right lung was resected. It was found on that day there was a necrotizing granulomatous lesion more consistent with tuberculosis rather than a bronchial carcinoid. Again, they are left with the same situation was there like the day 3 where the HDDST was negative. On 13th day after admission, a 1 milligram dexamethasone test was again performed as a screening test, and it was not suppressible. So hypercalcemia was there. ACTH levels were high, that is 65 picogram, but they did not know what is the source of ACTH. On the 17th day after admission, FDG PET CT was performed. No ectopic ACTH dependent focus was detected. It was non-conclusive. On day 24th after admission, it was done an intervention to collect samples from inferior petrosal sinus. They went for the inferior petrosal sinus sampling, a left side ACTH secreting focus, that is ACTH gradient of 139 picogram per ml in right petrosal sinus and greater than 22,000 picogram per ml in the left petrosal sinus after CRH. So after stimulating and doing inferior petrosal sinus sampling, they could lateralize the tumor. And the previous hypophyseal MRI images were reviewed. When we look back after these kind of findings, most of the times we also do find something, yeah, this appears to be a microadenoma. This is happening, and I don't think it has changed in the last 10 years. And the presence of suspicious focus was considered, and left hemihypophysectomy was planned. See, on 24th day after admission, the patient underwent a gamma knife therapy. After that, he started treatment with ketoconazole and the rest of the thing. On day 33rd after admission, he was discharged. So dear friends, to conclude, approximately 50% of microadenomas are visible on pituitary MRI. Pituitary image was relatively unhelpful with a low predictive value of position of the adenoma is identified at surgery. Therefore, pituitary image using MRI should be interpreted together with bilateral inferior petrosal sinus sampling for ACTH. In children, BIPS contributes to the localization of microadenoma by demonstrating lateral or midline ACTH secretion. So this is how the story goes. So ACTH sampling gives a better prediction for the site of the microadenoma than pituitary imaging. So this is talking about BIPS, and this is again, BIPS is superior to HGDST. This is an Indian study done by one of the institutes, SMS Medical College, Jaipur. And what they have shown us is again the efficacy of BIPS in corticotropin-dependent Cushing's syndrome, and they have found BIPS is superior to HGDST. An indication of dynamic and invasive testing for Cushing's disease according to different radiological findings. This is again, they concluded CRH desmopressin test and HGTST have high accuracy in differential diagnosis of ACTH-dependent Cushing's syndrome. This is what we have validated till now. And in patients with microadenoma less than 6 mm or non-visible lesion, a concordant positive response to non-invasive test sufficient to diagnose CD, Cushing's disease, irrespective of MRI finding. This is what I also found when I was doing IJV sampling in my thesis work.
Dr. Sachin, I think we have just 1 minute left.
Yeah, this is the paper which we did. This is a job which we did at All India Institute, and we used to after giving CRH, we used to take samples from both IJVs simultaneously at 3 minutes and 5 minutes. And we used to do the classical CRS stimulation test, and we used to have peripheral samples, that is the typical 120 minutes test. So these are the results for the 3 of the things. In our study, when the MRI had a greater than 5 millimeter lesion, so the high sensitivity was 79% and specificity was 100%. HGDST, when the suppression was greater than 80%, the sensitivity and sensitivity was 41 and specificity was 100. So HGDST suppression greater than 50%, it was around 50. So our study actually said if the HGDST suppresses the cortisol levels for greater than 80%, then definitely it establishes the microadenoma pituitary. And we did CRS IJV and the cutoff value was greater than 1.6, the ratio of central and peripheral ratio, the IJV value of ACTH and the peripheral ACTH ratio. And here also the sensitivity was 83% and specificity was 100%. When we opted for ratio greater than 3, the sensitivity dropped down to 58 and specificity was 100%. And the classical CRS stimulation test, which usually you don't get the data nowadays. And this is what we got. When the ACTH greater than 35%, we took it as a cutoff. So the sensitivity was 100% and specificity was 50. When we made it to greater than 50, it was almost touching 100. So there were discrepancies with respect to the outcome in the classical CRS simulation test. But majority of the times, it was also predicting between the Cushing's disease and ectopic ACTH syndrome. This is what we concluded in our study. So dear friends, dexamethasone suppression test should be performed and interpreted in light of pretest probability based on a thorough history and physical examination. This is a test where we have less facilities, where we have facilities for MRI, but we don't have facilities for entry cases for BIPS, then definitely this is the test which is relevant. But in seeing to this, but it has to be in conjunction with a corticotropin releasing hormone, and to be or desmopressin, because that is something which will again add on to the diagnosis. So I think if you are in a breast center, you should go for CRS stimulated BIPS and other modalities. If you're in a center which is less equipped, you can go for IJV sampling. What we found in our data after giving CRH, it was also to some extent what we could not compare it with BIPS. That is true, but to some extent it was conclusive. So the word of the era of HGDST is there for some of the centers which are not well equipped. For the better and the well equipped centers, definitely they should go for the CRS stimulated BIPS for the diagnosis of Cushing's disease in a state of dilemma. Thank you.
Thank you, sir, for the nice deliberation. I hope the message is loud and clear and very well said. One of the delegate has asked a question in one of your study by Dr. Ramawalia. LIP1, LIP2, what are the protocols?
The LIP1 and LIP2, let me go back. So they are basically, the LIPs were based on performing the SGDST. They had this to greater than 50% cutoff in first LIP1. If from the baseline cortisol levels, if the cortisol levels dropped down to 50%, that was taken in LIP1, and greater than 80% in the second, that is LIP2. And MRA, SELA, and the rest of the things were common in both the LIPs. So using LIPs actually, and there was again one arm where they did BIP, and they compared it with, and the conclusion was based on this only. So this was basically the LIP 1 and 2 had the protocol of 50% suppression of cortisol and 80% cortisol. That was the difference between the two LIPs.
Another question is a very simple question. You can just answer on the chat. Pseudo Cushing's versus Cushing's. We are running late, so we'll just move on to next session. Please, I'll just forward the same thing to the delegate link.
Yeah. Thank you. Thanks a lot.
Thank you. Thank you, sir.
Thank you, sir.
Thank you, sir, for the nice presentation. Now we will move to next presentation. I will request Dr. Ajay kindly introduce our next speaker, Dr. Abhyuday Verma, and start the talk.
Thank you, Dr. Pankaj. Dr. Abhyuday Verma, sir, is from Indore and is MD, DNB in endocrinology and is professor of endocrinology. And he has vast experience in the field of endocrinology, more than 35 publications. He's prolific speaker, ADA certified speakers, and various awards with him. And with that, I invite him. He's also API Indore Chapter 122 Honorable Secretary. So I invite Dr. Abhyuday Verma for the next session on medical management of Cushing disease.
Thank you, Dr. Ajay. And at the outset, I like to thank the whole team of Hormone India for giving me this opportunity. And without wasting much of time, I'll start my presentation. And most of the things, I think Dr. Sachin has already pointed out about the Cushing's disease. I had prepared some of the basic slides regarding the Cushing's disease, the diagnosis. So I will skip about the history of Cushing's syndrome per se. Yes, we should all know that this Cushing's syndrome is basically ACTH dependent in more than 50% of the cases. Ectopic ACTH production, 25%, CRH dependent, and ACTH independent in about 20% of the patients. And we all know, as such, Dr. Sachin has pointed out very well, that it becomes sometimes really confusing and difficult to diagnose cases of the ACTH dependent pituitary adenoma or ectopic ACTH dependent Cushing's disease. However, many ectopic sources are occult, and identification of the source secretion may require meticulous and repeated investigation. Brief overview, I will not go in detail. This we have already discussed about. Yes, plasma ACTH less than 5, usually ACTH independent, and we need a adrenal imaging. And if there are no adrenal lesions, then it may be a exogenous or PPNAD. But if the plasma ACTH levels are more than 50 picograms per ml, it is basically ACTH dependent. We should get a pituitary MRI. And as very well pointed out by Dr. Chittawar, that now we have got better MRIs. A 3T MRI or even higher than that can very well show us a smallest of microadenomas. And positive CRH suppression on dexamethasone, he has already pointed out, gives us a diagnosis of Cushing's disease. And yes, BIPs can also be done. And if there is no ACTH gradient, then we should go for a CT MRI thorax abdomen. This is imaging. You can see here that how comparing between 1.5T MRI and a 3T MRI gives us a very clear picture. Here you may not be able to appreciate, this is a quite busy and small slide, but you can see here the arrows. With 1.5 Tesla MRI, the microadenoma is not visible, but with 3T MRI In both the cases, it is quite visible. And again, BIPS is recommended in patients with inconclusive results. We have seen 70 MRI may preempt IPSS and help in diagnosing against the standard 1.5 and 3T MRI negative Cushing's disease cases in future. So we would be having 70 MRIs which can help us. Ectopic ACTH can be diagnosed with the help of 18F FDG PET, gallium dotate PET, and CTN octreotide. IPSS gold standard, I will not go in detail. We have different confusions, different types of hypercortisolemia like cyclical Cushing's, pseudo Cushing's, and depression and pregnancy also. Here come directly to the algorithm of the management of Cushing's disease. Then I would be starting on the medical management. So when the Cushing's disease is confirmed, first line therapy is advised surgery, the removal of the micro or macro adenoma. If there is no remission or there is a recurrence, we can go for a repeat MRI. Again, 3T or above if it is available. If there is a tumor available on MRI and it is non-resectable, we can go for radiation with interior medications also. And if it is persistent, we all know we have to knock off both the adrenals. And if on recurrence the tumor is resectable, we can repeat the surgery. On the other side, we see hypercortisolemia and no tumor on MRI. We can start patient on medication. Or if it is persistent, even on medication, we can go for the radiation therapy. And last, if we don't get any relief with medication, radiation, a redo surgery, again, the last option left is bilateral adrenal. So this is, in short, the algorithm for the management of Cushing's disease. Treatment, obviously, surgery is the first choice if we see a micro or macro adenoma. Endocrine Society has produced various evidence-based practical guidelines for the treatment of Cushing's syndrome. And it should be a team approach. I won't go for surgeries. Yes. Medical therapies for Cushing's disease. What are the indications of medical therapy? So when we should start thinking of medical therapy in a Cushing's disease? Mind it, the best therapy is surgery, surgical resection of the pituitary adenoma. But then we have some indications for medical therapy, like management of the high cortisol levels when surgery is contraindicated. We may get a lot of our patients, because of various comorbidities, happen due to hypercortisolism. Pre-operative preparation of the patient also, who need to rapidly correct severe complications of the disease like infections, severe hypertension, and acute psychosis due to hypercortisolism, and control of cortisol excess during the period between irradiation and complete response to pituitary radiotherapy. This also we know because it takes time. After radiation, we may immediately not get the benefit. It may take weeks or months for response to the radiotherapy. So these are some of the indications for medical therapy. And this is, in short, you can see for pituitary disease, we have neuromodulators of ACTH release, which are only for Cushing's disease, the pasireotide and cabergoline, directly acting at the pituitary level. But then we have adrenal steroidogenase inhibitors also, like ketoconazole, mitoten, and etomidate, which can take care of all the causes of hypercortisolemia, whether it is ACTH dependent or independent. So we'll talk about adrenal steroidogenesis inhibitors, the meteropon, which basically inhibits cortisol secretion by blocking the final step in cortisol synthesis, namely the conversion from 11-deoxycortisol by the cytochrome P450 enzyme, the 11-hydroxylase. And here the serum cortisol levels fall within 2 hours of starting the therapy, but the effect is short-lived and meteropon requires to be taken 3 times daily. The usual dose ranges from 250 mg twice daily to up to 1.5 grams every 6 hours, with lower doses for adrenal adenoma and higher doses required for ectopic ACTH. And it is effective in about 50% of the cases. The commonest side effect is nausea, and it should be differentiated from the nausea due to adrenal insufficiency. Ketoconazole, imidazole, used as an antifungal, but it blocks variety of steroidogenic cytochrome P450 dependent enzymes. So lowers the plasma cortisol level. Treatment is usually initiated with 200 mg thrice daily and adjusted depending upon the serum cortisol levels. We can adjust the dose between 400 to 1200 mg per day. And an acidic stomach is needed for absorption. So we should tell our patients to avoid PPIs. And in clinical practice, again, this drug is effective in around 50% of the patients. And an additional desirable characteristics of ketoconazole is that it lowers the serum cholesterol levels also, which is commonly seen in patients with Cushing's syndrome. So it has got other metabolic benefits also. It has got a slower onset of action than meteropon, and dose adjustment should be made every 2 to 3 weeks because it takes time to see the benefit. Although the patients with adrenal adenomas, they respond rapidly, and hypoadrenalism can occur within 24 hours also. So maybe go slow, watch every 15-20 days, 2 to 3 weeks, and consistently it induces a reversible rise in liver transaminase and GGT levels. So liver functions should be done regularly, and it is teratogenic for male fetus, and it is contraindicated in pregnancy. Then coming to etomidate, again, this is imidazole, and its principal use as anesthetic agent. It is at a subhypnotic dose, IV. It is a potent inhibitor of cortisol secretion. And the use of IV at subhypnotic doses is an option when oral adrenalytic therapy is not possible, but it requires ICU monitoring. Though in some palliative situation, cases of immediate treatment via subcutaneous pump has also been reported. The doses are 1.2 to 2.5 mg per hour, which lowers the cortisol level to even sometimes a undetectable level. And the patient needs to maintain on a block and replace regime with concomitant use of IV hydrocortisone. So here also, like in thyroid views, we can have block and replace regime for a balanced and better control. The mitoten, it has been used widely for the treatment of cortisol excess due to inoperable adrenocortical carcinomas. But when given at a lower dose, it can effectively control the cortisol secretion in benign cases of Cushing's syndrome. It has got a direct adrenolytic action. It destroys adrenocortical cells, but also blocks the cortisol synthesis. It has got a slow onset of action. The first effects are usually observed within 2 weeks, but changes in dose usually require 6 weeks or more to be fully effective. Then we have this latest drug, the osilodrostat, which is a newer inhibitor of 11-beta hydroxylase with greater potency and longer duration of action compared to metirapone, that shows promise for the treatment of Cushing's disease. We have glucocorticoid receptor blockade also, like mifepristone, which is a potent antagonist that blocks cortisol action and reverses the consequences of hypercortisolemia. But then efficacy of action is determined by clinical assessment, because already the cortisol levels are high. So we cannot just measure cortisol level in this case. And this may result in hypocalcemia because of the action of cortisol binding to the mineralocorticoid receptor. Then we have those direct centrally acting somatostatin analogs like octreotide and lenriotide that binds predominantly to SSTR subtype 2, which are generally ineffective in Cushing's disease. But multi-receptor somatostatin analog like pasireotide demonstrates a high affinity to SSTR subtypes 1, 2, 3, and 5, which normalizes the urinary free cortisol in about 17 to 40% of patients of Cushing's disease, depending on their severity. And the problem is hyperglycemia being the commonest side effect. Then we have a very commonly used drug, cabergoline, which has been also assessed in the treatment of Cushing's disease. It lowers cortisol level and hence the ACTH also. And in recent large series has shown 20 to 25% of patients have achieved good UFC using modest doses. Just 1 mg per week, 0.5 mg twice a week can be given to get desired results. Sorry for this busy slide, but these are some of the latest medications which have been used in Cushing's disease. I won't go in detail. Most of the drugs I have talked about, and few are the latest medications. And then patients who are hypocortisolemic in the immediate post-operative period, they require glucocorticoid therapy, which may take up to 16 to 18 months post-operatively. So this should be taken care. This is post-op patient. We have to see few people they give only for few weeks or months the glucocorticoid therapy, but studies have shown that patients may take 6 to 18 months for HP axis to recover. And suppression of normal serum cortisol on dexamethasone testing in the post-operative period is a poor indicator for long-term remission. Complications of surgery, I won't go in much detail. Other modalities, adrenal surgery, I have talked about, pituitary radiotherapy, and stereotactic radiosurgery also. Role of radiotherapy, I won't talk much. This is the management of persistent or recurrent Cushing's disease. A pituitary surgery, again, transphenodal adenomyomectomy, remission, just follow up every 6 to 12 weeks. Persistence or relapse is there, go for pituitary radiotherapy. Remission, just follow up. Repeat the pituitary surgery. If there is a failure, go for medical therapy. And if these they don't work, go for adrenal surgery. So to conclude, the treatment of Cushing's disease is one of the most challenging tasks in endocrinology, and differentiation of Cushing's disease from other underlying causes of Cushing's syndrome is difficult. Surgery remains the first line treatment for almost all CD patients, and most tumors are microtumors, and TSS is therefore an appropriate approach. Persistent or recurrent Cushing's disease after unsuccessful surgery needs further treatment, including a repeat surgery, medical therapy, radiotherapy, or in few cases, bilateral adenectomy also. Repeat surgery should be considered in patient in whom distinct and accessible tumor is visible on MRI, but it is usually associated with relatively high rates of failure and recurrences. Medical therapies They include adrenal steroidogenesis inhibitors, tumor-directed drugs, and glucocorticoid receptor antagonists. And combinations of these therapies have been tried and have shown to be quite effective with less side effects rather than using a single therapy. Thank you.
Thank you, sir, for the wonderful talk and nicely explained considering all aspects of pushing disease management evaluation. And I would like to highlight one important point from your slides only, that sometimes, rarely, we find patient in cortisol crisis. So, and we don't have a frequent cortisol monitoring. So we can go for a block replace regime with atomidates. This is a very important thing, sir, especially in resource constant setting where we cannot do frequent cortisol. Thank you, sir.
Correct. Very true. Thank you. Thank you, Dr. Mayur.
Thank you very much, sir.
Okay.
Thank you, Dr. Vijay, and for Dr. Pankaj for highlighting that. So I think we can finish with this session and we can move ahead with the next session, Pankaj. Yeah.
Yes.
Over to you, Mayur.
Thank you. For the next session, I welcome our Hormone India repertoire, Dr. Harsha Gunna. He is DM Endo from SGPGI along with me, and he is working at Hormone India, Visakhapatnam. Over to you, Harsha.
Yes, very good evening, everyone, and a very good session, Dr. Mayur. So now we have the adrenal session. So the concept is stress is not just in the head, it's also in the adrenals. For that, we have three distinguished speakers, Dr. Sunil M. Jain, Dr. Ashraf Ghani, and Dr. Manish Kuch. And we have two people to chair the sessions, Dr. Ghanshyam Agarwal and Dr. Kishan Dharampadi. Dr. Ghanshyam Agarwal is a prominent endocrinologist in Lucknow, and he is formerly worked as an associate professor in Sri Venkateswara Institute of Medical Sciences, Tirupati, and he is currently practicing as an endocrinologist in Lucknow. Dr. Kishan Dharampadi is also a product of SGPGI Lucknow, and he is practicing as a specialist endocrinologist in Prime Medical Center, UAE. So now I would hand over the session to the chairperson to take it from here.
Thank you very much, Dr. Harsha, for the kind introduction. So in the previous session, we learned mainly about the hormone excess with respect to the adrenal gland. In this session, we go through about the three interesting topics. One is iatrogenic Cushing's, then followed by management of primary adrenal insufficiency. And last, we have a special situation, that is managing in critically ill state. So to deliberate the first talk, we have with us Dr. Sunil M. Jain. Sir is endocrinologist by training from PGI Chandigarh. He works as a consultant endocrinologist in Indore at Total Diabetes and Health Care Institute. He's a key faculty for various institutes. He has conducted various trials. He is a well-known author with multiple publications, and he has contributed chapters in various textbooks related to diabetes and endocrinology. Over to you, sir, for the next talk. Over to Dr. Sunil Jain.
Yes, sir cannot come live, so it would be a recorded session. Tech team, kindly play.
Hello. I am thankful to Hormone India and Dr. Mayur for this opportunity. And I have been given a topic which is quite relevant in practice in our country, that is iatrogenic Cushing's. So I'm going to talk in next 20 minutes and what we keep seeing in day-to-day practice and how to manage the patients who are having iatrogenic Cushing's. So this will be my agenda for next 15 minutes, 20 minutes rather, when to suspect, what are the clinical manifestations for iatrogenic Cushing's. And obviously iatrogenic means etiology has to be some drug induced. So let us talk of We all know about steroids, but what other than steroids which can cause iatrogenic Cushing's? How it differs from Cushing syndrome, how to diagnose iatrogenic Cushing's, and then how to do a management, and what are the usual steps of management we should follow when we are managing a patient with iatrogenic Cushing's. Now the first point, when to suspect. Obviously, it's too simple that somebody who is on a steroid therapy since long and who is looking like Cushingoid, it is a straightforward diagnosis. But it is not always true. Many times in our country, many patients are receiving indigenous medication and we are not aware that they are taking steroids in the form of indigenous medication. And in fact, in my clinical experience, I believe that that is the most common cause of iatrogenic Cushing's. So look for clinical symptoms and signs for cortisol excess in the patient. If they are present, then we have to inquire about the history of steroid intake. Now, many times patients are suffering from illnesses where steroids are often used to treat, like vitiligo, rheumatoid arthritis, myopathy, etc. If there is an obvious case, we know that this patient is receiving steroid therapy and patient is Cushingoid, then there is no issue in diagnosis. But when we are not aware, then we have to go into depth, inquire about the history of indigenous medication, and doesn't matter, for many reasons patients are receiving steroids, which we are seeing very common in our practice. Now, these are the standard features for Cushing syndrome, which we are going to discuss. But important thing here in iatrogenic Cushing is this syndrome is developing because of external or exogenous steroid intake. And that's why there is an absence of androgenic and mineralocorticoid effects, which we very often see in patients with Cushing syndrome. And we all know that in Cushing syndrome, the cortisol will be high. Here it will be opposite. Here the cortisol will be suppressed. So somebody who looks like Cushing, but the cortisol levels are low, that means we are dealing with an iatrogenic Cushing. And these are the well-known clinical features of Cushing syndrome, we all know. And when a patient will come to us for Cushing, obviously we will have to manage their obesity, we will have to manage their osteoporosis, and the syndrome and the features because of cortisol excess. Since it is iatrogenic Cushing, as I told earlier, the symptoms which are absent will be androgenic and mineralocorticoid effects, and hence these patients won't have hypertension, hirsutism, acne, etc. These are the features which are very often present in patients with Cushing syndrome. Then the issue of hypocalcemia is also less frequent in patients with iatrogenic Cushing, which is quite common in Cushing syndrome endogenous because of the mineralocorticoid effect, which comes from endogenous production of cortisol, while the cortisol or the steroids which we are using for therapeutic purposes like dexamethasone, betnisolone, prednisolone, they have very less mineralocorticoid effects. And same thing for virilizing effects. Rather, few other things like benign intracranial hypertension, glaucoma, subcapsular cataract, avascular necrosis, these are more commonly seen features with exogenous Cushing's. And in COVID era, many doctors have seen the patients who had avascular necrosis of bone, including the facial bones, maxillary bones, and etc., etc. Many such cases had seen during COVID era because of the effect of steroids exogenous on the bone. So any route of steroid administration has been reported to cause Cushing's, oral and injectable being most common. Then there are drugs which can inhibit the cytochrome 450 pathway, like antifungals, voriconazole, itraconazole, ritonavir. And if the patients are receiving these drugs and simultaneously steroid, so the steroid potency will increase by many times, and that's how they can cause exogenous Cushing. Megestrol effect and high dose of medroxyprogesterone acetate also works like a glucocorticoid and can cause exogenous Cushing. And obviously, steroids being given in form of herbal and alternative therapies. And I feel in my clinical experience, this is one of the most common cause. Now, somebody who is receiving a steroid as a pharmacotherapy for treatment of some disease, then we have to look for the three major factors. What is the dose? Any patient who is receiving more than 25 milligram or equivalent of prednisolone is at a risk for Cushing. Higher is the frequency. Somebody receiving just morning dose versus somebody receiving twice daily, thrice daily. Higher is the frequency, more chances of iatrogenic Cushing's and its consequences. And longer is the duration. Generally, we say that a steroid duration of more than 20 days predisposes a patient for iatrogenic Cushing, but somebody receiving a very high dose with a high frequency, even after more than 5 days of therapy, there can be iatrogenic Cushing features appear, but generally it is more than 20 days of therapy. What happens when patients receive exogenous steroids? We all know the negative feedback loop. And because of that, the whole adrenal axis is suppressed. So the CRH, which is coming from hypothalamus, goes to pituitary and leads to secretion of ACTH from corticotroph. And then this ACTH goes to adrenal, where it works on zona fasciculata and reticularis. And from there, it is causing secretion of cortisol and a small amount of adrenal androgen, that is DHEA. That's what is going on. And somebody who is receiving exogenous steroid in whatever form for a longer duration, there is a full suppression of axis from CRH to ACTH to cortisol. And if the duration of therapy is longer, this suppression can remain for 1 year. And we have to remember that the adrenal gland is last to recover. First, pituitary hypothalamus recovers and adrenal gland recovers in the last. So the important feature here is iatrogenic Cushing is a duality. It is a dual disease because patient is having Cushing as well as endogenous secondary adrenal insufficiency because of these exogenous steroids. And hence, the steps for management are very important. We have to ask this question first. Can we withdraw steroids? If yes, good. We have to follow a protocol for steroid withdrawal. But before that, we have to document the adrenal function. So we have to slowly withdraw the steroid. Once we reach to a lower dose of steroid, we can make it alternate day. And now we have to document that patient has an adequate adrenal reserve. And for that, we have to omit steroid for 24 hours and then do the test. If the adrenal reserve is sufficient, we can withdraw glucocorticoids. And we have to remember that for next 1 year, we have to give them a short course of glucocorticoid during the periods of stress. But if the glucocorticoid cannot be withdrawn, then we have no choice. We have to manage all the consequences of cortisol excess. And there the most important is obesity and osteoporosis. If patient has developed diabetes, hyperglycemia, so now there is no specific issue here. We have to manage whatever disorders they are having with the cortisol excess. And that's what we had seen many such patients during COVID era, including the complications and consequences because of steroid excess. So here it will be medical issue dependent management for iatrogenic Cushing. And there the top three are obesity, diabetes, and osteoporosis. For example, let me show you one case which I saw a few days ago. 38-year female, obesity, normal BP, comes to me with small joint pain, etc. But her major objective for consultation was swelling on the body and obesity. So she thought that she is having some thyroid problem. That's why she consulted. On history, she denies any history of any indigenous medication, and that's quite common. She gives a complaint of 8 kg weight gain and looks like Cushingoid. Rest of the tests are normal as shown here. Now, in my experience, many times when patients deny history of intake of indigenous medication, is still you should do a cortisol test and prove that you are not dealing with iatrogenic Cushing. And that's what we did in this case. And her cortisol was undetectable. And then we discussed and explored further and then came to know, and now she disclosed what she is receiving in form of some Ayurvedic powder, etc. This is quite common in our country. So, as far as the approach is concerned, we should first inquire, does the patient has iatrogenic Cushing? One is history is very important here. And then if you measure cortisol and if it is less than 3 microgram in the morning, patient is most likely having exogenous Cushing. I already discussed a specific management of the clinical abnormality whichever are present, which you have to do. As I told earlier, it is a duality. So we have to look for is there any feature of steroid withdrawal syndrome, because many times this patient will stop these medication and come to us with these symptoms: anorexia, nausea, vomiting, myalgia, a lot of symptoms. And a shot of steroid will make them full recover. These are the adrenal withdrawal syndrome. And secondly, we have to look for adrenal reserve. Is the reserve adequate in these patients? And for that, we will have to gradually, those who are having adrenal withdrawal syndrome and those who have secondary adrenal insufficiency, first to do a cortisol replacement. Make them asymptomatic. Once they are fine, now gradually reduce the substitution dose. And once we have come to a dose of, say, hydrocortisone 10 to 15 milligram per day, now omit the hydrocortisone for 24 hours and then do a test for adrenal reserve. Suppose in the test, the cortisol is more than 18 microgram. We can do just a morning cortisol initially. If the cortisol is good, fine, nothing to be done, you can stop substitution. But if the cortisol remains too low, less than 3, continue it. And if the cortisol is between 3 to 18, now we need to do a dynamic test. And in dynamic test, if the response is more than 80, we can stop substitution and explain the patient for next 1 year. If you develop any big infection, fever, medical emergency, you should be covered with the steroid during emergency. If the cortisol is suboptimal, then we have to continue substitution and repeat the test subsequently. What are the tests for adrenal reserve? There are so many tests. One is, I'll just give you a glimpse. One is a insulin hypoglycemia test, which is considered the best test because it does not only test adrenal reserve, it is testing the whole hypothalamo-pituitary axis, where we give insulin dose and create hypoglycemia under our supervision. And if the cortisol goes more than 18, few books or guidelines talk more than 20, then you should consider that the patient has an adequate adrenal reserve. Another test is metirapone test. This is the protocol. CRH test, IV CRH is given here. This is the protocol. All these two things are not available in our country, so I'm not going to discuss them. And this is what we have very commonly available. Now it is available. That is the short ACTH test, where 250 microgram of ACTH should be given as a single shot IV and collect the cortisol sample at 30 to 60 minutes. If the cortisol is more than 18 in any of the two sample, patient is having adrenal reserve. I generally prefer a single test is 30 minutes because it makes it more cost effective for my patients. And then another test which is unfortunately not available, but it is more specific than the high dose short ACTH or synectin test, where rather than 250 microgram, 1 microgram is given because 250 is really a supraphysiologic dose. So this gives us a real test of adrenal reserve, but it is unfortunately not available. So How to manage iatrogenic Cushing's? Let me come to the most important takeaway points. One, we must suspect and diagnose, and should remember that many patients are using steroids without their knowledge. So if somebody is already on steroid therapy, say for rheumatoid arthritis, since 1 year and now coming to us for iatrogenic Cushing's, the story is different. But somebody not aware that they are receiving steroid and now they are sitting in front of us, we will have to suspect. Somebody already on steroids, then they should be tapered in the right way. Gradually reduce the dose. Once we come to a dose, say around 5 to 10 milligram equivalent of prednisolone, make it alternate day fast. Then gradually reduce it further. And once patient is on 2.5 milligram alternate day and comfortable, then we can withdraw it. As I told earlier, it's a common entity in India. I don't have the prevalence number because it's not possible to have these kind of data when patients are receiving in form of indigenous medicine, and hence high index of suspicion is needed. And it's a dual disease, so we have to simultaneously manage the metabolic and bone problems happening due to Cushing as well as adrenal insufficiency. And the short synectin test is the most preferred test, which is easily available now. Again, earlier there was a shortage of this product, but now we have the short synectin or synectin molecule available for the test. Insulin hypoglycemia test is the gold standard, but it is a risky test. So it is better to go with a short synectin test, and that's what we prefer. We must give a steroid substitution till the adrenal recovery is complete. And for that, we have to do a periodic cortisol measurement and as and when required, a synectin test. And when patient's adrenal gland recovers fully, we can stop the cortisol or the steroid doses, and we should inform this patient about steroid coverage during stress. These are the few important things to remember when we are dealing a patient with iatrogenic Cushing's. Many times what I see that these patients, steroids are suddenly withdrawn and we are not taking care of their adrenal insufficiency, and then that creates a medical emergency, and these patients are admitted in shock and many other medical complications. So we have to understand that iatrogenic Cushing is always a dual disease, and accordingly we should manage. Thank you very much.
Thank you, Dr. Sunil Jain, for this fantastic deliberation. You have highlighted one of the most common causes of Cushing syndrome, that is iatrogenic Cushing syndrome. As you have highlighted, chronic exposure to any synthetic steroids results in a dual disease. One is iatrogenic Cushing syndrome. Second is development of secondary adrenal insufficiency or steroid withdrawal syndrome. So patient care provider or any doctor should have a high index of suspicions while when they are treating their patients with the chronic usage of steroids. So patient education is also an important factor which plays a major role here while managing these conditions. If there are any questions, you can unmute yourself and ask. However, I don't see any questions in the chat box. With this, we will move to the second topic in this theme. The second topic is about primary adrenal insufficiency. PAI is one of the most critical as well as potentially life-threatening disorders. However, with the establishment of the newer therapies and the replacement with glucocorticoid and mineralocorticoids, we can achieve good outcomes. To give this talk, we have with us Dr.
We have now Dr. Ghanshyam Agrawal sir also. Sir, kindly introduce our next speaker.
Okay, good evening everyone. So next topic is on permanent adrenal insufficiency. So with us Dr. Ashraf Ghani is the speaker. He is MBBS MD DM and is Professor Endocrinology from Sher-e-Kashmir Institute of Medical Sciences, and he is HOD and SCIPS. So he's having 20 years of clinical experience and fellow of National Academy of Medical Sciences. And he got Best Research Paper Award for Prevalence and Pattern of Dysfunction among the pediatric population of Kashmir. And he's also achiever of so many gold medals. So I will not take much time, and now I invite Dr. Ashraf Ghani for the to deliver his talk on Addison's disease.
Hi, good afternoon, everybody. First of all, let me thank the young Hormone India team, which is the future of India, for giving me opportunity to deliberate on a very important topic. And I am really feeling elated that our youngsters, our students have taken such a big initiative and made a very rapid progress in geometrical progression rather. And they are doing very well in academics, and I wish them best of luck. So I have been asked to deliberate on patterns of steroid replacement on adrenal insufficiency. So before I start sharing my slides, I should thank the chairpersons for the giving me the brief introduction. So the topic is very important. I know it must have been very consciously chosen by the investigators. Are my slide visible?
No, sir, yet not.
Just a minute. I'll just try.
Tech team, if you have the slides, kindly share.
1 minute.
No, sir, we have not. So can you just click on the green color icon?
I should start. So pattern of replacement in primary adrenal insufficiency, as the topic is, I'll start with what adrenal insufficiency is. I'm sure that it must have been already deliberated. We know there is an endocrine disorder where adrenal glands primarily fail, whether it is disease in adrenal glands or it is outside in the hypothalamus pituitary adrenal axis. The disease, although is relatively rare, occurs in 5 per million per year with a prevalence of 35 to 60 cases per million. The disease is life-threatening with a 2-year mortality of more than 80%. And although the disease is autoimmune origin in the West, now in Indian setting, there may be some differences. So if we see that it was Thomas Edison who's credited with description of adrenal insufficiency in 1855, there have been many scientists who have actually contributed, but the name comes from Thomas Edison's description. There have been Dr. Kendall, Rickenstein, Hanch, and so many people who have got Nobel Prize in physiology and medicine for describing various aspects of adrenal physiology and hormones. So if we see adrenal insufficiency, it can be a primary disease in adrenal glands. And of course, when the feedback is lost, you will have elevated ACTH and CRH. The cortisol secretion will be low, but when the disease is in adrenal glands, understandably, we will have low mineralocorticoid and androgens also. But if the disease is in the pituitary, where the ACTH will be deficient, then probably the mineralocorticoid and adrenal component is preserved, and in that case, the local hydrogen, potassium pump and the aldosterone loop remains intact, and they will not have mineralocorticoid deficiency severely. And similarly, in tertiary or what we can say hypothalamic diseases, we will have cortisol low, but you will have mineralocorticoid preserved. So accordingly, we can have several causes which can cause adrenal insufficiency. They could be acquired or they could be genetic, they could be iatrogenic. As Dr. Sunil was saying, iatrogenic in India is common because there is rampant unregulated glucocorticoid use in this country. But the commonest cause of primary adrenal insufficiency, even though in the West, is autoimmune adrenalitis. But we in lower and middle income countries, including India, will have still significant number of cases occurring because of granulomatous diseases like fungal infection, tuberculosis, sarcoidosis, or even metastasis from various cancers, or you can have adrenal hemorrhage or damage of adrenal glands, both glands, because of various infections like AIDS, HIV, amyloidosis is very common. So those diseases should not be overlooked in our practical scenario. So even though exogenous glucocorticoid is high in use in India, and you will have ACTH deficiency and secondary adrenal insufficiency, but a variety of disorders can impact hypothalamus and pituitary, like they could be again tuberculosis, infection, syphilis, fungal, infiltrative disorders like hemochromatosis, or you can have Sheehan is one of the common conditions in India. You can have pituitary disorders, even trauma. In our setting, we get a lot of road traffic accidents, as even we have gunshot injuries. Those traumatic injuries of brain can also impinge pituitary, and you can have secondary adrenal insufficiency. So there are several drugs which are incriminated in causing primary adrenal insufficiency, or they are commonly used in our, everybody must be knowing this list. So we have to be aware of this. These causes of adrenal efficiency. So when adrenal gland or the pituitary or hypothalamus gets affected, you will have generally common symptoms of glucocorticoid deficiency. However, when adrenal gland alone is affected, then you may have superadded symptoms of both mineralocorticoid deficiency and some symptoms because of the androgen deficiency. So accordingly, you will have gut symptoms like nausea, vomiting, constipation, diarrhea, abdominal pain, anorexia, weakness, headache, hypoglycemia, weight loss, hypertension, and you may have hyperpigmentation in primary adrenal. You will have some electrolyte disturbances. So this is very common. Everybody knows it. But if you have superadded mineralocorticoid deficiency, then in that case, you will have additional risks of dehydration, hypotension, and you may have androgen deficiency in women, for example, loss of pubic axillary hair, and you may have decreased libido in women. So whatever the causes and whatever the presentation, the diagnosis remains a challenge. As Dr. Sunil was saying, several battery of tests in endocrinology has been in vogue in practice. Dynamic testing like insulin hypoglycemia, which is considered to be the gold standard, and giving 0.1 to 1.1 unit of insulin per kg and inducing hypoglycemia, glucose of less than 40 milligrams, and then checking cortisol remains gold standard. But the critic is that it may be too stiff a test, which is not normally required for a real life situation in an individual. So accordingly, beta-irapone test, glucagon stimulation, and other tests have been done. So the practicable, most practicable and easily available and with low risk, unlike that of insulin-induced hypoglycemia, is standard ACTH stimulation test. Now we know ACTH stimulation test is a high dose, conventional dose of 250 or 1 microgram, low dose, which has come into practice. Now we have a short cyclin test, which is in vogue, and accordingly, there is a sort of this, you can see this algorithm which has been proposed to evaluate a patient of adrenal insufficiency. Of course, at baseline, we take glucocorticoid level. I will not go in detail of that. Like if you're unequally less than 3.6 microgram of cortisol at baseline, you do not need any test. It is clear-cut adrenal insufficiency. And if you have a baseline more than 18, it is clearly normal. Then in between levels, you need to have a various dynamic tests to take a decision whether it is adrenal insufficiency or not. So Endocrine Society of US says standard dose short cyclin test, that means 250 microgram in children more than 2 years or 50 microgram per kg in infants, would with a IV test with a 30 to 60 milligram cortisol test is good enough. If your cortisol level peaks beyond 20, so you are normal. If it falls short of that magic mark, then you may have adrenal insufficiency. So with 1 microgram, there has been an adequate response. However, there has been a critique that it may fail in certain situations. As I said, that IT being gold standard, people have tried to compare these short cyclin with the ITT only. So a test tetracoxide acetate, which is short cyclin, is actually a synthetic ACTH versus the porcine ACTH, which we were using earlier. Porcine ACTH had some issues like antibody response and other issues. Now it is available in India. So we do tetracoxide test, and it is done with the, which is have been shown globally, as well as there are some Indian studies which I will share with you. It is showing promise in diagnosis, and Endocrine Society US 2016 guidelines also recommend this. So there are some papers that 30-minute cortisol after this injection may be good enough to make a decision of adrenal insufficiency. There are 3, 4, in fact 6 studies which are supporting this. So there is some data even in India that 250 microgram of the concentropin is in Indian patients could match with the Western data. So there are 2 studies which have been published recently, and they have shown that this is good enough. So in addition to concentropin, people use ACTH. If you have more than 2-fold rise in ACTH, 2-fold rise of ACTH than normal, upper limit of normal, then we can think that it is a primary gland involvement. So we covered the areas that what is the cause of adrenal insufficiency, how do we diagnose, how does it present. Although the main crux of my talk would be replacement of adrenal insufficiency and what are the patterns, what are the current scenarios of replacement. That is the main thing. Glucocorticoid replacement and mineralocorticoid replacement. Primary adrenal insufficiency needs both these components. As I said, if you have secondary or tertiary adrenal hypofunction, in that case you may need only glucocorticoid component because mineralocorticoid excess will remain intact. Now, if we need in adrenal glucocorticoid replacement, the conventional treatment recommended is 15 to 25 milligram of hydrocortisone, which comes at cortisone estate. If we give cortisone estate, which is a prodrug, then it is as 20 to 35 milligrams in adults, and you have to give it in 2 to 3 doses. So usually what is done, if you give 10 to 15 milligrams, you give 5 or 7.5 milligram in morning, then in the afternoon you give 2.5, and in late evening you give 2.5, because that is the half-life of the hydrocortisone. But if you have congenital adrenal hyperplasia, in that case you generally give little higher dose, 15 to 25, and you try to give the little higher dose during the night in order to suppress the ACTH. The mineralocorticoid component is fludrocortisone. It is given between 0.05 to 0.2 milligram a day. It is, if you give hydrocortisone in higher doses, then that has a mineralocorticoid potency. Suppose in case of acute insufficiencies, when you give hydrocortisone, otherwise you need mineralocorticoid to be added. Sometimes you give long-acting prednisolone and dexamethasone for glucocorticoid deficiency, but that time mineralocorticoid is to be given separately. Now, current glucocorticoid replacement therapy, actually in lower and middle income countries, as I said, when you take a decision of replacement, you may have the cause of adrenal insufficiency, for example, tuberculosis, sarcoid, or any other fungal infection. In that situation, you might have to address the primary disease which is causing adrenal insufficiency. So in the process of replacement, we should not forget the addressing the primary disease as well. So replacement has to be done with the glucocorticoid, but sometimes for compliance reasons and also for longer suppression or better suppression of adrenal axis, like in congenital adrenal hyperplasia, we may choose long-acting glucocorticoids. So I will dedicate 2-3 slides to what are the issues with long-term glucocorticoid replacements, as we also in practice give prednisolone rather than hydrocortisone, because hydrocortisone has to be given 3 times a day. Compliance is usually an issue. The cost is also an issue. So if we give prednisolone or we give dexamethasone, in that situation, we have to be very sure of that we don't cause any long-term adverse events of glucocorticoids. For example, you have problems in blood pressure, problems in anthropometry, you may have issues on glucose, lipid metabolism, you have bone health issues, you have to do bone density or even bone markers, especially in children. You may have to think of bone morphology. Then you may have in growing and adolescents and growing children, then you have hypothalamic axis should not be suppressed permanently. You should not cause long-term cardiovascular risk, diabetes risk, and eye issues. So in that case, you have to balance out here between the long-term glucocorticoid effects and the compliance. So we have some data on the bone issues, the fracture risk increased by the glucocorticoids here. So the long-term glucocorticoids have been actually, the compliance issue has been replaced by converting the hydrocortisone into slow release forms. For example, Takeda, Japan, has given this plenadiene, and plenadiene was actually recommended, approved in AI in 2011, FDA also. The main pharmacological principle was that it gives a first immediate release preparation and long-term preparation. So you can see how in volunteers it showed that it gives a slow rise. For example, if you compare this curve, the curve B, where we have given 3 doses of hydrocortisone, and the upper one is the normal curve. So we are trying to mimic that curve. So if you see the Plenidrin curve, it shows the chronocort or Plenidrin has shown almost similar to the normal curve. So that means we are trying to mimic the physiological replacement of the glucocorticoid. There is the attempt. So one is daily Plenidrin. So overcoming the issue of compliance and versus twice daily or thrice daily hydrocortisone has shown little better response. So another preparation which is marketed in UK by Adrenal company is Chronocort. It again has a hydrocortisone layer. It has an inert core inside, then a hydrocortisone layer, then a sustained release layer, and then it has an entry coating. So similarly, if you give that, it releases. It has that what is called toothbrush type of regimen. 1/3 of it is released at say 7 a.m. and then 2/3 is released by 11 p.m. so that it gives a cover, and it has been shown to have a significant effect in non-classical CAH patients. As you can see, it is almost this chronocort, which is the blue line, is almost going with the normal circadian cortisol rhythm, which is the orange line. So that blue line and orange line are almost superimposing each other, means that it has shown a significant advance in the drug delivery system in case of non-classical CAH, even classical CAH as a primary adrenal insufficiency. So the Plenidrin and multi-particulate chronocort preparations, they have, both of them have one or the other benefits. One has to be given once and another is to be given twice. So that way both have shown the cortisol curve like normal physiology. So there is a actually clinical trial going on in congenital adrenal hyperplasia about the chronocort. We expect the results of this trial by January 2025, and this will tell us whether the chronocort actually shows superior benefit to the conventional hydrocortisone in the non-classical CAH. So monitoring of long-term glucocorticoid component is a challenge because most of us in clinics see various parameters like how is their appetite, how is their fatigue level, and we also sometimes check ACTH, but in clinics, ACTH has not proven beneficial. Checking cortisol levels are not again beneficial. So what we do in them is a clinical assessment of well-being. Now, regarding the mineralocorticoid replacement therapy, the only preparation available is the fludrocortisone, because it is a synthetic MC9 alpha form of hydrocortisone, fludrocortisone, and it is a fluorinated molecule. The problem with fludrocortisone is short of life, but it is dosing has an issue. If we give underdosing, it will cause persistent state of hypovolemia, orthostatic hypertension, and persistent tachycardia. That may lead to elevation of urea and potassium levels. So people have tried to see how to monitor the mineralocorticoid replacement. Electrolytes and renin have been conventionally used. For example, this study showed that renin and electrolytes can indicate mineralocorticoid activity in the replacement of the patients on long-term basis in this 6-year study. But serum electrolytes have been shown to normalize with lower doses of fludrocortisone. So the problem is when we start small dose, initially electrolytes normalize. Then whether we are underdosing or overdosing, electrolytes cannot tell you. In conventional practice, we ask our residents, we ourselves try to do patient comes adrenaline, we say do electrolytes. But here the most important thing which we forget in clinical practice is that sodium and potassium normalizes even with small dose, and it cannot tell us whether we are giving adequate replacement. Now, what is the most important? Between 0 to 200 milligrams of fludrocortisone, the electrolytes will not tell us anything. So once we give initial dose, they will normalize, then they will not. And then second thing is plasma renin activity. So plasma renin activity, there is data that it might actually help us in gauging the mineralocorticoid. If you can see in this picture, this study showed that sodium normalizes initially, potassium drops initially, and then renin activity correlates well with the level. But the issue with renin levels is that minimum time required is usually 2 weeks. The plasma renin, actually mineralocorticoid does not have any direct effect on plasma renin activity. It is indirect by changing the vascular volume and blood pressure. So if we have the facility available of plasma renin activity, it is a good marker. But there is a problem with this good marker as well. What is the problem? That when we try to titrate the fludrocortisone dose with renin, the upper level, when we go the upper limit of the normal, plasma renin activity is highly dependent on sodium intake, and therefore it may have a problem that if somebody is taking high salt intake, then it is not a good predictor. Second issue with plasma renin activity is that it is significantly varies between the different doses of fludrocortisone. And data also suggests that mineralocorticoid dosing, underdosing, has a little value if we are checking if we are checking the adequate replacement. So if we are giving excess dose, it has a little value to differentiate between adequate and excess dose. Here I want to repeat, if I said correctly, that mineralocorticoid may actually, if we are giving underdosing of mineralocorticoid, plasma renin activity may demonstrate that. So if we are giving overdose, plasma renin activity will not actually make a difference between adequate and overdosing. So the challenge is that if you are giving overdosing of mineralocorticoid, plasma renin even cannot help. So what is the answer is atrial natriuretic peptide. There is this one wonderful study. It has shown that they have actually compared various doses of mineralocorticoid ranging from 0.1 milligram to 0.2. They have tried to give in different doses, and they have seen that if we give ANP, levels will be actually in higher dose, in overdose, they will be altered. So in the lower doses, you have mineralocorticoid activity. If you are giving underdosing, at that time renin will be a good marker, and if you are overdosing, atrial natriuretic peptide will be a good marker. In other words, these two are complementary to each other. So if you are starting mineralocorticoid replacement and mineralocorticoid replacement, sodium and potassium initially will be a good marker that you have initiated.
Sorry to interrupt you, sir. You are already 3-4 minutes over. So can you finish?
Yeah, I am just concluding. So if you are overdosing, in that case you have plasma renin activity, and if you are underdosing, in that case you have atrial natriuretic peptide, a good marker. So I conclude here that primary adrenal insufficiency, although relatively less common, is a very lethal disorder. In India, we should be mindful of the non-autoimmune reasons And before starting replacement, we should also look for the treatment of that condition which causes adrenal insufficiency. For gauging the adequacy of replacement, it is a tricky situation, and glucocorticoid excess can be consequential. As you know, there are a lot of adverse events. So we should have a very good clinical judgment for checking glucocorticoid excess. For mineralocorticoid excess, we have to initially do sodium potassium, but that is not the most important situation. You should actually, if possible, you should gauge renin and atrial natriuretic peptide, complement each other between underdosing and overdosing of mineralocorticoid. Second and last thing is that we have several preparations and several formulations in pipeline which are likely to benefit the patients in future and also give ease of replacement to the clinicians, because the compliance may be better with these preparations. Thank you very much.
Thank you, sir. And Dr. Ghanshyam, sir, you are on mute.
Yeah, thank you for the excellent deliberation. I just want to ask one question. Do you have any experience for DHEA replacement in females of Addison's disease?
Yes, sir. I did not actually say that. You have in women, because of androgen deficiency, you have significant quality of life issues. They have sexual issues, and there is also some problem with the bone health. So DHA replacement is given outside. In fact, in West, DHA replacement is given, but it depends upon the level of care you are achieving. So the primary thing, it is something like wearing a pant is giving glucocorticoid replacement, wearing a shirt is a mineralocorticoid, and wearing a necktie is giving DHEAs. So if you have the continuum care so excellent, so you can do a graded care.
Thank you, sir. Thank you. So can I go for the next?
Dr. Ghanshyam, sir, I think there is modification.
Yes, sir. Thank you very much, sir. Thank you very much, beloved speakers, for your fantastic sessions. Now we have a small intervention, like we would postpone the session from Dr. Vaibhav Pathak, who is in place of Dr. Manish Kuch, and we quickly move on to Dr. Chaitra Selvan session in the next talk in the next session, and we'll come back to Dr. Vaibhav Pathak's lecture in some time.
Thank you.
Yes. Thank you, sir.
Thank you very much.
Yes, sir.
So we like to invite Dr. Upadhyay and Dr. Ambika as a chairperson for this. Dr. Tony? Dr. Tony, sir, are you there?
Yes, yes. So, very good afternoon, very good evening, everyone. So we'll go on to next session. So I'll first be introducing the chairpersons. So we have Dr. Sushil Upadhyay, sir, who is a DM endocrinologist. He has his own clinic in Nirmala Nagar, Lucknow. He's Chief Endocrinologist, Sahara Hospital, Lucknow, and Vivekananda Polyclinic and Medical Sciences. And we also have Dr. Ambika. She's my woman in STBGI. She, Sir Sushil Upadhyay, sir, can you please introduce Chitra Selvan, madam?
Yeah, thank you, Dr. Tony Joseph. First of all, congratulations to this Hormone India team, especially Dr. Ajay and Dr. Mayur, organizing this nice and very well selected topics. And secondly, thanks to organizers for inviting me for the chairing this session. We have three interesting topics. First one is by Dr. Chitra Selvan, that is a multidisciplinary approach of the polycystic ovarian disease. Dr. Chitra Selvan is well-known endocrinologist from the city of Bengaluru. She is Associate Professor of Endocrinology from Ramaiah Medical College, Bengaluru. So the multiple achievements from to his credits. So doctor will not take much time for the introducing, their CV is on your display. So Dr. Chitra Selvan, over to you.
Thank you so much, sir. Thank you, Dr. Sushil, for that kind introduction. And thank you to the young brigade at Hormone India for this kind introduction and for this very successfully attended program today. I'm going to be spending the next 15 minutes. Can I ask the host to set a timer? to take you through the multidisciplinary management of PCOS, or what might be multidisciplinary in our minds and what might be some of the lacunae that probably we haven't been able to address completely, which possibly makes the management of PCOS a little easier, maybe 2 or 3 decades from now. So we all know that this is an extremely common condition. It's the most common endocrine disorder in women of reproductive conditions, and it's only set to increase with all the effects of our current lifestyle. We can have multiple debates about whether this is genetic or whether this is environmental, but we will all agree that the prevalence is only going to increase. We've also probably made peace with the fact that this is no longer just a reproductive condition, it is a metabolic disease. In fact, one of the major challenges in pulling out guidelines for this condition has been that there have been numerous arguments about the name itself. There are many people who want to change it to many other things, but we do know now that this is predominantly an endocrine/metabolic condition, which probably presents with some reproductive symptoms, which makes it a condition which is probably likely to be presented to a pediatrician or a gynecologist first. And in this context of management of all of these heterogeneous presentations which could be possible with PCOS, we are now very comfortable with bringing on a dermatologist on board, bringing in a gynecologist on board, maybe even bringing in a nutritionist or a dietitian on board. Definitely endocrinologists believe that we are at the heart of the fulcrum of PCOS management, whether it is true or not in clinical practice, but we do know that we form a very important part of coordinating this care. But probably the attribute about PCOS which hasn't received all the attention that is due is the fact that this is a condition which is heavy with many psychosocial issues, be it related to body image, self-esteem, depression, and anxiety. And now as a young endocrinologist, you might be thinking, what's in it for me? Why should I bother or care to pause about this? I'm already screening for numerous metabolic complications. But at the end of the day, we are all trying to improve outcomes for our patients and also improve the journey of reaching that outcome for our patients. So with that in mind, I'm going to make an argument saying that, yes, while we are all comfortable with bringing in all of these people to address these various manifestations, I think the missing piece in this jigsaw puzzle is to bring on a psychologist, and I'm going to make my case for the same. So much of my argument is based on 2 large studies that we've done in the last year or 2. And this is a study called as the Blue Morpho, which we had the good fortune to collaborate with University of Birmingham. And my co-collaborator from India is Dr. Tejal from Mumbai. We're extremely passionate about this work, and this is work which we did in the middle of the crazy COVID pandemic. So it kind of adapted to the demands of that time. And this was an international survey done to assess the emotional and the psychosocial well-being amongst women in PCOS. And the focus was to look at emotional well-being, screening for anxiety and depression, psychosocial well-being in the form of body dysmorphism and weight stigma, and sexual well-being as well. There is nothing subversive about looking at sexual function at all. There is enough evidence to suggest that sexual dysfunction strongly correlates with well-being in women's health. So this is what we set out to do. So this happened in 2 phases. The UK arm went on in September and October, and India joined them in May and June. And what we did then was to have a scale out a questionnaire which patients answered from their phones, and we collated all this information. And the questionnaires which were used were 4 validated questionnaires. One is the hospital anxiety and depression questionnaire. This is very commonly used. It's a very important screening tool for both of these conditions. We also looked at the body image questionnaire. So higher the score, greater the body dysmorphism. We also looked at the beliefs about obese people score, which is to assess the patient's perception about weight stigma during their clinic visits. And also we looked at the female sexual function index. Again, here higher score indicates sexual dysfunction. We had the unique opportunity to look at the differences of the prevalence of these conditions based on the ethnicity and also the country of origin. We recruited close to 1,000 patients with self-reported PCOS. Of course, this was done online during the pandemic, so there was no way. So if the patient had ever been told that they had PCOS, they were able to participate. We had close to 75% of people who were white in British ethnicity. India contributed about 453 patients to the entire survey. Up to 44% of them were between 26 to 35 years. And what we found was the prevalence of anxiety overall in the total cohort was about 60%. That's roughly 2/3 of all women had anxiety. About 1/4 of them had depression, and about 8% had both anxiety and depression. A good 38% of women, irrespective of which country they came from, had body dysmorphism, and sexual well-being was very poor overall, with a total score of around 20. Overall, the score was 36. So higher the score, greater the dysfunction. So we were quite surprised with these findings. And when we're trying to look at, I'm sure this is just a UK-based phenomenon. I'm sure our patients are not as afflicted by these conditions. And this was the breakup of the subgroup to take a look at the ethnicity. While body dysmorphism was definitely more prevalent in the white ethnicity, depression was more prevalent in the Indian ethnicity individuals, whereas anxiety was maybe equally divided between the two groups. So the take-home message from this screening prevalence study was that there is a very high prevalence. But we were always wondering about the methodology, because this was a link which was sent out, and this was always a self-reported study. So we went ahead and did another aspect of the study where we screened for this ourselves in our clinic. And again, here we had two spots in which we did the study, one in India. Here the collaborators were Dr. Tejal Lathia and me. And again, the other group to compare with was the University of Birmingham PCOS clinic. So when they came into the clinic, before they even spoke to the doctor, they did their hospital anxiety and depression score, administered about 5 minutes prior, just after their registration. And post-clinic, the review included their patient experience of the entire consult, and then what all recommendations they got. And what we found here was similar to the findings that we found there, that body image issues or body dysmorphism affected close to 40%. Anxiety was reported in about 25%, and depression to the tune of around 25%. So again, here in the patients who are meeting your clinic as well. So even while you might think that self-reported mental health issues might be greater, even in our clinics, we found this to be higher. Of course, we've not studied rural India. We've not studied subgroups of the urban ethnicity. Both Tejal and I are in metro cities. So we've probably catered to the urban. Probably women alone might not be representative, but these are still numbers which are very high. And this is similar to the numbers which are reported in literature. If you review PCOS and mental health conditions, the number of papers which have come out in the last decade are amazing. And there is also a strong predisposition for eating disorders in women with PCOS. Now, if you're wondering why we have to talk about this as an endocrinologist, my job is to prevent diabetes, prevent GDM, prevent maybe infertility, all of those. That is probably because behavioral change itself is a science by itself. All of us know that the first 3 roles of management is lifestyle changes in PCOS, but you and I never received any training in how to effect behavioral change, especially in chronic conditions, especially in a vulnerable population who might have a very high prevalence of mental health conditions, which we probably do not have much experience in handling. Some of us might be more aware than the others, so we might have now understood that there are stages to change. We know this in the context of insulin when it comes to type 2 diabetes, right? That you might need to give your patient time to contemplate, to prepare for it, and then to take action. We might, in the same way, draw meaning from this and apply it into our clinical practice when we effect behavioral changes. But this is the most superficial layer of behavioral change. I'm going to just delve into one such program, which is trying to design lifestyle changes or behavioral change around lifestyle as a model for diabetes. And this is the scheme by which they plan to work. So if you take a look at it, they have a very systematic way in identifying the barriers, finding out the function which is likely to address the barrier, and then having therapies which are particularly designed for the barrier that you've identified to then implement it. Like, for example, they have issues like goal setting. While goal setting seems like a very, very simple thing, the art of goal setting itself is something which they study for a few hours or months. So this is again something which we've been learning because our patients are coming back and telling us that while they are working with psychologists who are, yes, screening for mental health issues, but also behaving as behavioral therapists who are finding them doable actions to bring closer their lifestyle changes, implement it and sustain those changes. This is another very easily implemented behavioral change wheel, which they follow, similar to how you identify the stages of change that your patient is ready for. And these are some of the other techniques that they use, which we are slowly beginning to learn. Apparently, nudging is a technique which works in particular individuals who have a certain predisposition. Boosting is another way, but at the end of the day, they're all working towards behavioral change. So just to pause and think with this information that I've just told you, the guidelines now say that asking about emotional well-being and managing of the same is appropriate is a recommendation now. The new guideline by NICE is being written right now as we speak and will be out in a year or so, which will be properly including all of the data which is which was presented now. But nobody's even taught us how to screen for emotional well-being. So if you need just one single indicator, one or two questions to ask about these particular things, I think is the message I'd want the audience to leave with. Over the last 2 weeks, how often have you felt bothered by these problems, feeling down, depressed, or hopeless, or not finding any interest or pleasure for doing things? Over the last 2 weeks, how often have you felt nervous, anxious, or on the edge, not being able to stop or control worrying? If any of these responses are positive, so that's one question for depression and one question for anxiety, you probably need to send them in for screening. And I would only wish that you go back and try this, and you will be amazed at the number of women who will be grateful that you suggested screening. If they're unwilling to meet a person, send them the link to one of the screening questionnaires and let them take a question. So from the work that we've done and from the findings which is published already, mental health concerns are very, very prevalent. Screening for them is imperative. All behavioral changes depends on your mental well-being. A person who's struggling with anxiety and depression is probably not very able to implement the lifestyle changes, but then we go on and we blame them for not making those lifestyle changes which would cure them of their PCOS. So providing the adequate support for them to sort all of this out probably is the best step out. And we have a good bunch of people who are trained in this exactly, and probably we should seek help from all the psychologists. So my parting away message would be that the audience would think about this the next time they're meeting a woman with PCOS. That's my email ID and my Twitter handle. If you have any questions, I'm ready to take it. Thank you so much, Hormone India.
Yeah. Thanks. Big congratulations, Dr. Chitra, for this nice study, well-planned study. So my one question is that you have sent this patient to psychiatrist or psychologist? Yeah?
Psychologist.
Psychologist, yeah. Any treatment was given to these patients and they are helped by these three treatments? What type of drugs, anti-anxiety, anti-depression, what drugs they have been given?
That's a great question, sir. So the most patients are overall more happier going to a psychologist than a psychiatrist because everybody's wary of psychiatric medications. To give you a rough indication of all the people who met a psychologist when their score on these screening tools were higher, less than 10% of them required psychiatric medications. The others just needed support in the form of cognitive behavioral therapy, which the psychologist is able to provide the same. About 10% of women who needed to be on medications are continuing to seek cognitive behavioral therapy and showing improvements as well.
Second question, have you got any metabolic parameter improvement by these counselings and all these things? You have received anything here?
That's a very good question, sir. So we haven't been able to observe pre-intervention and post-intervention yet, but there is a lot of data about cognitive behavioral therapy as an important tool when it comes to making lifestyle changes and metabolic improvement, especially in obesity, pediatric obesity, and also in pediatric diabetes. Lots of data in the last, let's say, 4 or 5 years.
Thank you. Any question by other the panelists? Yeah.
I see Dr. Vrind Kumar's hand is up, sir.
Is there a cause and effect relationship between anxiety, depression, and metabolism?
I think with anxiety, depression, and metabolic conditions, it's a two-way street. They kind of feed each other. We do know that mortality rates amongst individuals with diabetes with depression is higher than just individuals with diabetes and no depression. We do know that. And we do know that stress can exacerbate metabolic dysregulation. I feel like the relationship could be bidirectional.
So any pharmacological intervention would be desirable?
So I think so far, I haven't been the one who is treating the anxiety or the depression. I just leave it to the experts. But screening for them is my role, and I'm actively involved in that. The psychologists are actually very, very considerate in terms of not pushing too many people on medications, because they do understand that they are already struggling with metabolic complications, and adding many anti-anxiety or depression medications could potentially lead to further weight gain or further worsening of metabolic parameters.
Okay, thank you.
Thank you, sir. Thank you for the question.
Thank you, Chitra ma'am, for that lucid talk, for shedding light on the emotional aspects, the psychological aspects, etc. So thank you, ma'am, once again, and thank you, Sushil sir, for chairing that session. So next we have Dr. Vaibhav Patak. So to introduce him, we have Dr. Ambika. Dr. Ambika, please introduce Dr. Vaibhav.
Hi, good evening, everyone. And I would like to congratulate the entire team of Hormone India for organizing such an excellent event. And the next speaker is Dr. Vaibhav Patak, and he's a consultant at the Department of Endocrinology and Diabetes at Medanta, Lucknow. And he has had 8 publications and written chapters in the RSSDI, and he also has secured some awards in the Endo Update. And he's also a co-investigator in multiple clinical trials. So I invite Dr. Vaibhav Patak for his talk, please.
Yeah. Thank you. Good evening, everybody. My slides.
Yes, it's visible. Kindly make in full screen mode, presentation mode.
Yeah. Is it visible?
Yeah, perfect.
Yeah. Is it visible now? Yeah. So at the outset, let me thank the Hormone India team for organizing this wonderful academic session. And before I proceed, and let me put 2 disclaimers before I start. That I mean, the topic was allotted to Dr. Manish Guj, but due to unforeseen circumstances, I had to chip in. And that too in a topic which has generated a lot of controversies, and it's a very debatable topic, and there is again no clear-cut consensus to diagnose this topic and how to treat this topic. So I'll try to make it very simple and concise, so that we can take some few important messages at the end of my talk. So this would be my outline of the talk. That is, I will be discussing just about a little bit of physiology, then the clinical features, diagnosis, and treatment. So what happens when any sort of threat happens to body, be it a non-infectious or an infectious threat, that leads to a systemic inflammation. And we all know for that threat, be it infectious or a non-infectious. And it's a appropriately regulated event for the body to mount an adequate response. And as with anything, I mean, excess or the persistent inflammation would lead to destruction. And as is that even a less systematic inflammation also not mount the adequate response. So if you look at the three major domains that how the body responds to any sort of stress, that is the stress system mediated by HPA axis, that is the hypopituitary, hypothalamus, pituitary, adrenal axis, which would be primary focus of our talk going ahead. And secondly, the that is the acute phase reaction, and then subsequently the how the target body target organ responds to its defense against the threat which has occurred to the body. So this is what happens in the physiology, that is at the rest. This is hypothalamus and the humoral and neuronal regulation of the secretion of ACTH occurs by CRH and ABP, which we all know. And then ACTH comes, this leads to secretion of various adrenal hormones from the various layers of the adrenals. This is what happens in the stress. In stress, what happens is that apart from the conventional players in form of CRH and ABP, other players becomes very important. That is the DAMP and the PAMP, that is the disease-associated molecular pattern and the pathogen-associated molecular patterns. They start playing an important role, and the subsequent slides I'll be discussing that how do they play, what are the proposed mechanisms that why does this thing occur. So these we can say that it is not only the direct effect of these molecules, but as well as there are it does lead to the activation of autonomic nervous system, as is because, for example, this is an inflamed tissue, and these are the nerve terminals of the systemic nervous system, and these get activated, and these leads to the increased secretion of CRH, and subsequently this pathway through which it leads to secretion of increased cortisol. Apart from that, there are other toll-like receptors which has been proven again that they are there at the level of the adrenals as well, that is in the layer of zona fasciculata, and that leads to the increased secretion, or for that matter, increased response of the adrenals towards the threat which has occurred to the body. And as I said in the beginning, anything which a body is mounting a response, it has to have a balance between systemic inflammation as well as the signal which is getting that is the activated and dysregulated HPA axis. So what happens when there is sepsis, or for that matter any septic shock, that is there is overwhelming systemic inflammation, and which is primarily driven by the hyperactivated inflammatory pathways, which is classically by the NF-kB path signal system, and because of the less activated and dysregulated HPA axis response. So when this imbalance occurs, that is what leads to the overwhelming systemic inflammation, and that is when our patients can go into septic shocks and various other complications of the primary disease. And that is what has led to this term, that is the critical illness-related corticoid insufficiency. And this term was a few decades back, this term used to be known as relative adrenal insufficiency. But in 2008, this term was given, and this is to say that this is a dysregulated systemic inflammation resulting from inadequate intracellular glucocorticoid mediated anti-inflammatory activity for the severity of patient's critical illness. And while we are using this term, that is the critical illness related corticosteroid insufficiency, we have to be very careful while using this term, that this term should not be used in patients who already have any sort of adrenal, be it primary or secondary adrenal insufficiency. And why do we need to study about this, and why do we need to understand this, is that because it has been shown in multiple studies that patients who does have critical illness related corticosteroid insufficiency, they have increased length of ICU stay, increased mortality, and they do have higher levels of biomarkers of inflammation as well as the various other complications. Now, if you look at the prevalence of what is this corticosteroid insufficiency in critical illnesses, that depends upon the population studied as well as the diagnostic criteria, because the diagnostic criteria, as I said in the beginning, that the disclaimer which I put, that it's a very debatable topic, and still there are a lot of areas in this topic which does lack a consensus among clinicians as well as the intensivists. So if you look at the prevalence, it is around 10 to 20% in the critically ill patients. And if you look at the septic shock patients, that is around more than 50%. Now, we all know from our basic physiology as well as that adrenals are very important for our physiology. And even when body is mounting a response towards any sort of threat, that is be it an infectious or a non-infectious threat, they do have a very important role to play, because if they are not functioning properly, or if the body is not able to mount an adequate response, then these sort of things would start happening. That is, it will lead to the decreased gluconeogenesis, that patients may land up into hypoglycemia. There will be increased capillary permeability, vasodilatation, that what leads to the onset of septic shock or shock, and that it can have effect on the brain function as well, and patients can have delirium, fatigue, and as well as the various other things. And one most important thing is that is the effect of steroids, for that matter corticosteroids, on the immune cell, that leads to the, when they are not mounting adequate response, that leads to the increased inflammatory cytokines, increased risk of severe inflammatory shock syndrome, and as well as the various other end organ damage. So that is why it is important for body to mount adequate response during any sort of stress. And if you look at the mechanisms, that why and how does it this concept evolved and why it happens. So initially, as I said, the term used to be relative adrenal insufficiency, and over the time it has evolved that initially it was thought that probably adrenals are not able to mount an adequate response. Then it was thought that the ACTH is probably not getting secreted properly because of the various mechanisms which has been proposed. But over the time it has emerged, and it has been proven in any problem with the adrenals, or for that matter any sort of problem with the pituitary, but rather the majority of the problems lie in the alteration of the corticosteroid metabolisms. And what happens is that whenever patient is having sepsis or any sort of illness, there is reduced production of corticosteroid binding globulins, there is decreased cortisol transport, and that is what leads to the increased levels of the free cortisol. So it has been proven in studies that if you look at the total cortisol levels in patients who are having cortisol, for that matter, general population, the total cortisol level does not differ. But if you measure the free cortisol levels differ. So that is what has the metabolism, which is getting altered in the patients who are having inflammation at matter critical illness. The target tissue resistance, that is the inadequate glucocorticoid receptor alpha activity, the decreased level of activity of the corticosteroids which body is producing, or which body is mounting against the threat which has occurred. And that is what has, I'll be discussing this further ahead, but that is what has led to some people who propose that as there is tissue resistance to the corticosteroids, so we should be using a higher dose of corticosteroids while we are treating any sort of septic shock, or for that matter, when patients are getting diagnosed with corticosteroid related critical illness. If you talk about symptoms and sign, I would say they are very non-specific, and to see it in that they are just the extension of what the primary problem has occurred to the patient. And these all we know from the previous talks, which that other speakers have highlighted, that which can occur in patients with a primary as well as secondary adrenal insufficiency. But a few of the important things which we do need to have always keep in our mind, that when do we have to suspect this thing, that is the corticosteroid related insufficiency in critical illness. So when patients are not responding to adequate doses of vasopressor, when patients are not responding to adequate resuscitation, when patients has new onset of any hyponatremia, hypercalcemia, we know that this can occur in primary adrenal insufficiency as well. So then we do have to keep a watch that this patient might be having this corticosteroid insufficiency. But again, I would just say that the symptoms are non-specific, and we have to be careful while diagnosing and while interpreting these symptoms. Now comes the very controversial area, the few slides which I have tried to put in. As again, as I said in the beginning, there is no consensus regarding this topic. So if you look at the diagnosis, there was a guidelines published in 2017 by the Society of Critical Medicine, and in which they have said that there is no consensus regarding whether to use a delta cortisol, that is of the change in the baseline cortisol at 60 minutes of less than 9 micrograms per deciliter after post-entropin stimulation, or a random plasma cortisol of less than 10 microgram per deciliter for the diagnosis of this corticosteroid insufficiency. And one more approach which has been again suggested, but again it has been not proven in studies, is whether the hemodynamic response to hydrocortisone can be used. So again, the call is to you, but again, if you look at the data, majority of the studies which have done the studies in terms of what they're trying to look into is that the hydrocortisone dose, or for that matter, whether beneficial for them, these patients in terms of mortality or not. Majority of them have not used random cortisol, but rather they have used the delta cortisol value. So if available, delta cortisol can be used to again get an idea that yes, whether this patient will be having any benefit in terms of giving corticosteroids for his septic shock, or for that matter, any critical illness. Now, few alternatives to diagnosis. Again, this is with any cortisol thing which we start discussing with Cushing, or for that matter, other things. These things do come. So in this patients also, free cortisol as well as the salivary free cortisol levels have been tried, but again, recommendations till 2018 are that yes, these are not yet proven because we do lack normative data, and again the difficulty in terms of the availability of these resources for the quick diagnosis. Now comes again the most important and how we manage these patients. We can use two methods to diagnose the patient with random cortisol, but again, like said, there is uncertainty in the data, and the data which has been there and which has been done, they do prove a few things. If you look at in terms of hemodynamic status response for that, and the organ dysfunction response, hemodynamic dysfunction response, saying that the patients who have who do response quickly give a response in terms of their resolution of the shock. So there is benefit in terms of that, but survival benefit, if there is a doubt regarding the survival benefit. So I'll be quickly taking through few important studies and few probably landmark studies which has been done in regard to this. So this was the study. Let's go back to this was a study way back 20. That was the 2002. It was a placebo-controlled blind study, and it was 300 patients, and all the patients were done a short simulation test. It was 6 hourly plus cortisone 50 microgram once daily, and they tried to look at the 20 survival benefit non-responders. As I said in the beginning, this is a very good diagnostic test which can be done to see whether it will be beneficial for his survival or not. This delta cortisol thing, and in this study, it was benefit at the end of 28 days when patients are giving hydrocortisone plus fludrocortisone. Now, after this, a new study came, that is the Corticus study in 2006, and it gave a completely different result. And even in this study, short synaptic stimulation test was done, but again, the difference here is that here the patients were given only hydrocortisone, not the fludrocortisone, and that was compared with the placebo. And we can see that all-cause mortality benefit was cortisone when it was compared with the placebo, but the probability of resolution of septic shock was better with hydrocortisone when compared with the placebo. So mortality benefit is again two studies I have shown. That is this one, it is showing a good mortality benefit, but this is showing not the mortality benefit. Now, again, as I said, in the sepsis with shock and sepsis without shock, so there is a clear consensus, at least on this thing, that sepsis without shock, there is probably no role of hydrocortisone. And this is what again was proven by a study, that is the or placebo, and they were looked into the time to onset of shock, and it was no difference between hydrocortisone versus placebo. So severe sepsis without shock, there is no role of hydrocortisone. So these are the what recommendations are. And as we have, this was published in 2017, and after a few meta-analyses are also there, but again there is no notice. But after looking into a lot of papers, and this Society for Critical Care Medicine came with, again, this was a weak recommendation that we suggest using the corticosteroids in patients with septic shock that is not responsive to fluid. We have to be very careful here. That is not responsive to failed fluid, or that is not responsive to moderate to high dose of norepinephrine or equivalent vasopressin. Now, again, as I said, with sepsis, without shock, there is no role of hydrocortisone. This is very clear. Now, after this 2017 paper came, there were few studies which came in 2018 and 2019, which again gave a conflicting result, which I'll be taking you through next. But once we have started with the hydrocortisone, now we have to be seeing that what is the dose and duration. And as seen with the, everybody had a different dosing of regards to hydrocortisone. What was done in the recovery trial, which was done by the NHS, it did give us something different, dexamethasone, but in our country, everybody had a different protocol regarding the regarding the hydrocortisone dose. So similarly, that is the case here as well, that there is no clear consensus that yes, what should be the dose and how much time it should be given and what should be the duration. So this guideline, they have said that the dose should be less than 400 milligrams per day for three days at full dose. And they are saying that we have to give a low dose, keeping into account that then it may have some adverse effect in terms of what hydrocortisone, that any steroids can cause, like hypernatremia, hyperglycemia, and all those things. So they are saying that we can go with a low dose and long course in these patients with a septic shock. Now, after, as I said, after 2017, two more papers came, and they were published in NECM, and they were done on large number of the population and large number of the patients. And this was what the study which was done, and in which they gave hydrocortisone plus fludrocortisone for adults with septic shock. And there were around 1,200 patient study. Short synectin stimulation test was done. And again, important thing to note here is that the thing which was used here was hydrocortisone combined with the fludrocortisone, and 90-day survival benefit was seen. And as we can see here, that there was significant benefit in terms of survival when patients were given hydrocortisone plus fludrocortisone compared with the placebo. Now, after this, another paper came, which was the Adrenal study, which was done in Australia. And this was study which was done in patients who are having septic shock, where and there were large number of the patients, that is 3,600 patients. But one thing was short synectin stimulation for the recruitment or before the randomization of the patient. So that is, they did not use fludrocortisone, but rather they use only hydrocortisone. And they looked into the 90-day survival benefit. And as we can see, there was no benefit in terms of placebo in this trial. So not to confuse anybody, just I'll summarize what I have discussed, and that yes, this is a very important concept, that is the corticosteroid insufficiency in critical illness. And we have seen in multiple studies, there is no doubt, they have shown that it does increases the mortality and morbidity in our patients. And corticosteroids, if at all is to be used, it can be used in patients who are not responsive to vasopressors, or they are not responsive to adequate amount of fluid. Benefit of treatment is there only in septic shock, and patients who are not having shock, there is probably a doubtful benefit or probably not benefit. If available, if synectin, as has been already said by previous speaker, that synectin is now easily available with us. So if not, availability is not an issue, short synectin stimulation test is a very important step which can be done, which would predict that yes, this patient would be benefiting from our hydrocortisone and fludrocortisone therapy or not. And the studies which I have discussed, they have shown one very clear thing, that yes, mortality benefit may be doubtful thing, but again, the resolution of shock, that is the time to resolution of the shock, less days on mechanization, these all studies have shown that these are the clear-cut benefit in those patients who are having sepsis with the shock. And one last thing which I would like to say is that whether adding fludrocortisone has shown benefit, as we can see in the two studies which have shown benefit in terms of mortality. In those, as we saw that fludrocortisone was given along with the hydrocortisone. But again, the people or those who doubt or those who oppose this thing, that yes, we all know that once we are starting or once we are using hydrocortisone at higher doses, the fludrocortisone activity or the mineralocorticoid activity also is taken care of. So again, this is again a debatable and controversial thing. But as far as studies goes, we can see that the patients who were or the studies who were using hydrocortisone plus fludrocortisone, they did show mortality benefit rather the studies which used only hydrocortisone. So with this, I would like to thank you, and thank you for your kind attention.
Thank you, Dr. Vaibhav, for that extensive talk on adrenal insufficiency in critical care setting. Thank you for covering Sarki in such detail about the pathogenesis, the diagnostic criteria, about the controversies and management. Thank you, Dr. Vaibhav. I don't see any questions in the chat box. So we can go to the next topic by Dr. Sharat Kumar sir. So it is on hormone replacement therapy in menopause, concepts, controversies, and approach to treatment. So I would request Dr. Sushil Ubade sir once more to introduce our next speaker. Over to you, sir. Sir, please unmute.
Yeah, thank you. Dr. Sarat sir is our senior colleague in this Lucknow city. He is an excellent orator, MD, DM, and DNB endocrinology from BHU. And he is a professor, ERA Medical College, Lucknow, Vice President of Indian Menopause Society. He is having multiple publications, book chapters in his credit. Now, Sarat sir, over to you, sir.
So, first of all, I would like to thank the organizers of this wonderful conference. I see an extensive list of participants. All the senior faculty have been roped in, and I am really delighted to be a part of this. And next, I would like to thank my friend, Dr. Sushil, who has very kindly helped me out in all those years. So, with this, I think I would come to the topic straight. So hormone replacement is something which is very close to my heart. Now, have you given me right to share?
Sir, there will be icon share to screen.
No, that's I'm
share to screen.
सर आपको आपकी स्क्रीन पे ग्रीन कलर का आइकन दिखाई देगा शेयर स्क्रीन करके
supra-adult levels. And these elevated concentrations actually persist for longer than the postnatal rises in FSH, LH, and testosterone, which fall by 6 to 9 months of age to very low concentrations that then persist throughout childhood. This neonatal increase in inhibin B concentrations and actually may reflect the increase in the number of Sertoli cells which occur at this point of time. Now, after this quiescent period of childhood that you see over here, you would realize that puberty is associated again with an increase in the blood levels of inhibin B. Initially, mind you, this increase is associated positively with FSH levels in the blood. But at a later stage, which is not actually very clearly defined, there's a switch to, there's an inverse relationship between the blood levels of FSH and inhibin B, which is actually characteristic what is seen in the adult human male. And that's why inhibin B potentially is a very useful indicator of spermatogenesis and Sertoli cell function in adults when AMH may no longer be measurable. Now, when you look at AMH, on the other hand, what do you see? AMH, mind you, as we know, is the anti-Mullerian hormone. It is secreted by the immature Sertoli cells, and its concentration before puberty is extremely high. But as puberty progresses, these immature Sertoli cells differentiate to mature Sertoli cells, and as you can see in the green line over here, the AMH levels then drop significantly. Now, because AMH is actually a functional marker of immature Sertoli cells, it is possible that higher AMH levels in early life will lead to increased support by mature Sertoli cells of germ cells in adulthood. This is the pattern which is actually seen in males as far as inhibin B and AMH is concerned. Now, what about, and as I said, what actually happens is that inhibin B has an inhibitory effect. It almost has a negative feedback effect on the hypothalamus and the LH and FSH secretion by the pituitary. So when you look at the pituitary hormone effects, you know LH FSH stimulates spermatogenesis and testosterone secretion by the testes. The Sertoli cells facilitate this spermatogenesis, but once some spermatogenesis crosses a certain threshold, your inhibin B levels are actually going to have a negative inhibitory influence on the FSH and very, very tightly control the entire process of spermatogenesis. Now, when you look at your female patients, what do you see? What is it that you will see as far as the reproductive cycle goes? What you realize is that inhibin B is produced by the granulosa cells of small as well as large antral follicles over here. If you see over here, you would realize the small and large antral follicles are what are producing inhibin B. Now, both estradiol as well as inhibin B again will going to inhibit pituitary FSH secretion. So again, it has a negative feedback mechanism. Now, as the size of the follicle pool declines, inhibin B levels, mind you, fall. And what we need to realize is the FSH levels rise. So that basically reflects a loss of this inhibin restraint. What is important and what has implications for us in clinical practice is that inhibin levels, mind you, change within the menstrual cycle. So you will have inhibin levels actually peaking in the early to mid follicular phase. And there is going to be a secondary peak at the time of ovulation. And this is important for us because this has implications when we are evaluating the inhibin B levels in our patients. Now, what about AMH? AMH, we all know, is secreted by the small preantral, the large preantral follicles, and actually it is first secreted by the fetal germ cells at 36 gestational weeks. And at birth, mind you, the levels of AMH are approximately 1.6 nanogram per ml. This then subsequently continuously rises to about 10 years of age. It peaks in adolescence. And then, as we all know, there's a decline after the age of 18 years until menopause. What is very important for us to also realize and understand is, again, AMH is having a feedback inhibition of FSH at two levels. Firstly, most importantly, it inhibits recruitment of these primordial follicles into the growing pool. And secondly, it reduces the sensitivity of antral follicles to FSH, which is a feedback mechanism of AMH and FSH after menarche. And what that translates for you and me means that AMH is actually going to control the recruitment mechanism of these primordial follicles to primary follicles, and that is how it regulates the reproductive lifespan. And a high level of AMH actually during adolescence may be a predictor for natural fertility and reproductive lifespan. And why are we talking about all this? We are talking about all this because we all know at the end of the day, when you are talking about the effect of hormones, when you are talking about the effect of all these different parameters during a patient planning pregnancy, either a male or female, it has a number of implications for the patient. Now, when you look, how do you actually define? If I just talk in terms of, defining fertility, what do you say? You talk in terms of fertility as, if I define it very simply, as the natural capacity of a couple to establish a clinical pregnancy. And in this entire process, there are going to be a number of factors which are going to influence the quantity and quality of oocytes or spermatozoa, as well as factors which are going to affect the process of fertilization, embryo implantation. And in females, the most important factor which actually influences fertility is ovarian aging. And what we know very well, that there is an age-related decline in ovarian function, which is related to the gradual loss of primordial follicles when follicular atresia takes place. And importantly, follicular atresia is a gene-independent process that starts before birth. And actually the function of AMH, mind you, is to slow the recruitment of these primordial follicles, so that the high levels of AMH that we see at puberty actually may be responsible for the decreased rate of follicular atresia that you are seeing, so that both AMH and primordial follicles decrease with age after sexual maturation, which indicates that AMH is actually a marker of ovarian aging. Now, when I am talking about ovarian aging, and I am talking about in which situations we need to be testing ovarian reserve, the indications have really widened. The indications are widened because we as a society have changed increasingly. We now have our patients opting for pregnancies much later than what was done maybe a decade or 2 decades earlier. So there are going to be different situations now than what we saw initially. Now, when you're talking about indications for ovarian reserve testing, it could be women undergoing infertility evaluation or treatment, which is the most common area where ovarian reserve testing is done. It could be individualization for assisted reproductive technology, ovarian stimulation protocol and dosing, which again is very, very important. History of premature ovarian failure or early menopause. It could be in PCOS. It could be in perimenopause, because as I said, as our patients opt for pregnancies much later in life, we are going to have situations where our patients also want to know as to when they are going to attain menopause. Women with BRCA1 or FMR1 pre-mutations are another group of patients where we do opt for ovarian reserve testing. A number of patients now are talking in terms of elective freezing of eggs, where they are not prepared for a pregnancy at a particular point of time and may want to opt for it at a later point of time. Oocyte donors, we are going to check ovarian reserve. Fertility preservation before and after gonadotoxic treatment. As we know, a number of our cancer survivor patients do plan pregnancies and do want to know their reproductive potential before and after therapy. And of course, pre-operative prior to ovarian surgery in the reproductive age group, as well as diagnosis and recurrent surveillance for granulosa cell tumors. So you have the indications have widened. And when the indications widen, our skills, our ways of being able to actually assess ovarian reserve also need to improve. When we talk about conventional tests, we have always spoken about FSH. You and me have been very comfortable with using a day 3 FSH and always accept that a FSH more than 10 indicates a reduced reserve. We also talk in terms of using a combination of tests. It could be FSH with estradiol or inhibin B levels. Ovarian volume measurement has all been used, and ovarian antral follicle measurement, as we all know, the AFC count has been used very, very commonly when we are talking in terms of assessing ovarian reserve estimation. So where does AMH come in this entire story? The advantage of AMH, mind you friends, is that it is a robust measurement, not significantly influenced by a number of variables which normally influence the menstrual cycle or the reproductive cycles. And most importantly, when you look at the AMH levels in menstrual cycles, there's no real cyclic variation in the AMH levels. You would realize when you look at this graph over here, it is relatively quite a stable level throughout throughout the menstrual cycle, and that gives you a big advantage when you are evaluating AMH levels in the menstrual cycle. As I've already spoken about in great detail, because I thought it was very relevant when we're talking about AMH expression and ovarian reserve, this is how AMH is expressed, and AMH is actually a very, very close reflection of the ovarian reserve, which gradually reduces as you grow older. Now, when we look at AMH in ovarian failure, what do you see? When you look at it as a marker of premature ovarian insufficiency, yes, it is a good marker because it has a low susceptibility to the effect by HRT. It can predict the transient or permanent state. And though there is some evidence in literature which says that some of the HRTs can influence AMH markers, you can potentially stop the HRT and then evaluate the AMH to have a more accurate reflection of what is the ovarian reserve. When you are looking at iatrogenic ovarian failure, be it post-chemotherapy or radiotherapy, we are looking at AMH levels before and after chemo or radiotherapy, because a high AMH level before chemo radiotherapy would be a better reflection of whether your patient is going to have what kind of reproductive capacity post chemo radiotherapy, or whether this patient is going to continue with their menstrual cycles or they are going to be potentially amenorrheic post therapy. And it also helps us understand better as to which drugs, it helps the oncologists understand which drugs could potentially be used more intelligently. For example, we know that certain drugs like cyclophosphamide and melphalan have a high ovarian toxicity, vis-a-vis vincristine, bleomycin, and methotrexate, which have a low ovarian toxicity. And it really helps your oncologists make a much better decision as to which drug potentially they could use in a patient, especially if a patient is very keen on having ovarian functions post chemotherapy or radiotherapy, where it is very important for the patient. There are also situations like this where if the AMH levels are not commensurate for a patient to possibly undergo chemo or radio and plan a pregnancy, where you freeze the eggs prior to the procedure so that the patient can then at some point of time plan a pregnancy subsequently. PCOS. PCOS, you realize that, the theory about AMH and PCOS has raised a lot of, I would say, excitement, a lot of ripples, because it is believed that the AMH receptor, which is expressed in the hypothalamic GN-releasing hormone-producing neurons, is actually regulating the HPG axis and is actually responsible for the excessive androgens. We all know the AMH levels are higher in PCOS patients, and this actually is going to inhibit the recruitment of primary follicles from the primordial pool and has fewer growing follicles. The follicles don't really grow, but you have more 2 to 6 millimeter non-growing follicles. And we also know that because of these elevated serum AMH levels, there's going to be a later age at menopause compared to women without PCOS. A lot of new data as far as AMH and PCOS goes, regarding whether this patient when you are stimulating the patient, especially when you're doing ART, and whether you're stimulating the patient, whether this patient is going to have a hyperstimulation syndrome, whether this patient is going to respond well to therapy. The AMH along with inhibin B and FSH is used in conjunction to understand which patient of your PCOS is going to respond better to induction therapy, for example, with clomiphene citrate or any one of the other ovulation induction regimens. Now, when you look at AMH in fertility, which is the area where AMH is used the most, what do you see? When you look at fertility, as I said, there are two things which matter: your quality, and as we all know, the oocyte quality is determined to a significant extent by age, and quantity, which is a surrogate marker of the reflection of the quantity, is AMH. So AMH is actually going to predict the probability of conception, the oocyte yield. It can serve as a fertility test before marriage. I increasingly see a number of young patients coming to me and asking me, "Madam, can we please check whether I am fertile, whether I will have any problems after marriage?" I mean, we now have patients coming to us pre-conception and asking for these tests and asking to be evaluated whether they are going to have any problems post-marriage. I have questions like, "Ma'am, how late can I delay my pregnancy? Ma'am, is it okay if I just freeze my eggs and plan a pregnancy later?" So you are having increasingly a patient population which has different demands, a patient population which has different ideas about how they want to lead their lives. And as a clinician, we need to help them do it to the best of our ability. As I said, it also predicts OHSS and also excessive response to FSH, for example, an AMH more than 3, which we often see in our PCO patients. Poor responders to FSH are also based on AMH levels, for example, an AMH level less than 1. And you may also select the initial FHS dose based on the AMH. But I would also like to put a caveat over here that please do not base your entire decision on the AMH level. You often see in clinical practice that there may actually sometimes be a complete disjunct between what the AMH levels say, and the patients do come back to you with pregnancy, with very, very successful pregnancies. So I always say that yes, AMH levels are a good reflection of your ovarian reserve, but at the same time, we do know in clinical practice there can be situations where your patients with a low AMH level would still come to you back with pregnancies. So when you advise your patients, depending on age and AMH, what would you advise them? For example, if the AH is more than 3, but the age is less than 38, you would suggest IVF, but there's an increased risk of OHSS. If the age is more than 38 years with an AMH of more than 3, less frequent in occurrence, but better outcomes are expected. If the AMH is between 1 to 2.9 and age is less than 38, you're expecting a healthy yield and a very, very optimal outcome. But with the same AMH, if your age is more than 38, you're expecting low pregnancy potential and IVF may be tried. Less than 1, as we've been saying, modest or low yield or may require more cycles. And of course, if the patient is more than 38, you would discuss alternate options with the patient as far as fertility goes. As I said, when you're talking about fertility, patients are also asking you, "Ma'am, when will I go into menopause?" And this is important because low levels actually come on almost 5 years prior to actual menopause, and you can really predict the age in 20 to 49 years old. And I think in certain situations, it does prepare your patients better for menopause. Coming to male fertility, you would think I've completely forgotten about male fertility. If you look at AMH levels in disorders of male fertility, I'm not going to go into the DSD disorders because time does not permit me to cover that entire framework. So what I am going to be talking about AMH levels, briefly run through it as to what implications it has as far as male fertility goes. You would realize that when you're looking at pubertal delay, there will be a normal prepubertal level in puberty, and it would actually, there's a lot of data which show that AMH levels do help you differentiate between hypo and your congenital, your CDGP. So you are increasingly using it to differentiate these disorders. When you look at severe congenital hypo, you would realize that there's a decrease in puberty. Klinefelter syndrome, it will be within the reference range until puberty. A puberty-related decline, there's a delay in that, and thereafter declines to subnormal concentrations in adults. Non-obstructive azoospermia is an area where it is increasingly used and you find decreased AMH levels. Varicoceles, it is elevated in early onset varicoceles in prepubertal and pubertal boys, but decrease in adults with severe varicocele. And it is increased in boys with McCune-Albright syndrome, but in male senescence, you are expecting an age-related decrease in AMH levels. When you talk about NOA, which is a severe form of male infertility, where you talk in terms of using TSC or micro TSC, because that is the way you would actually offer fertility to your patient. There is no reliable biochemical marker really, but because AMH has a parakine control of Leydig cell function, this ratio, the elevated AMH and AMH-TT ratio, does tell you there's a depleted germ cell reservoir. And if the AMH is more than 4.6, you may need to rethink about your decision about any kind of surgical intervention. You may need to rethink about your decision about doing a micro TSC, because in these patients, you would not have good outcomes. Now, when I talk about inhibin B, we all know inhibin B correlates with sperm concentration in men with normal and impaired spermatogenesis, correlates positively with sperm count and testicular volume, and serum inhibin B and FSH are inversely correlated. In females, on the other hand, it is again a good surrogate measure of follicle health and viability. If your day 3 inhibin B is reduced, it means that there is a declining ovarian reserve and this patient is not going to do very well with ovulation stimulation. High levels of follicular fluid inhibin A and B levels do correlate with better pregnancy rates and better ovarian response in patients undergoing hormonal stimulation for oocyte retrieval. Now, when we look at very high AMH levels, what do they tell us? A, it could be just a reflection of ovarian hyperthecosis. B, they may precede tumors like granulosa cell tumors of the ovary. It can also have a direct correlation with the tumor size. Mind you, it also predicts recurrence of tumor. And of course, it also tells you the success of ovarian transplantation in fertility preservation. Some of the downsides when you're using parameters like AMH is there's a significant individual variability, which can sometimes be more than 100-fold. As I said, you can predict fertilization, you can predict blastulation, you can predict even maybe miscarriages, but not live birth rate. There's lack of standardization in the assay, and there's also an ethnic variability, and all this holds true even for your inhibin B levels. And to add to it, you also need to be careful when you are checking your inhibin B levels of your patient, because you need to check it, as I said, in the earlier phase of your menstrual cycle. So if I summarize, in clinical practice, definite marker of ovarian reserve. Very, very important roles now being seen in PCOS, DSD, and menopause. So very important area of expertise is going to come up in these areas. Possibly in pubertal disorders, tumors, definite role I would still say in ART protocols. And of course, the future is AMH analogs, which at this point of time, I have overshot time a little. I will not get into the details. Thank you very, very much for your patient listening. Really appreciate it from the bottom of my heart. Thank you. And once again, thanks to the organizers.
Thank you, ma'am, for such a nice deliberation. And this was a recorded session, so we cannot have any question and answer session. And also, we are running late. So I welcome our next Hormone India repertoire, Dr. Shiven Verma. So we'll be discussing obesity. Already we have discussed few things, and we even had yesterday an obesity workshop. So it is a level higher, beyond basic. So over to you, Dr. Shiven. Please introduce our chairpersons.
Thank you, Dr. Mayur. Since we are getting late, so I will not be taking much time. For this session, we have two talks, one by Dr. Nitin Kapoor from CMC Vellore, who will be speaking on sarcopenic obesity in India and what the clinician need to know. And another one by Dr. Harsha Pamnani from Bhopal. She will be speaking on monogenic obesity. We have our chairpersons here for this interesting session, Dr. Pankaj Pirwani, consultant endocrinologist, and Dr. Mayur Agrawal himself needs no introduction now. Can you just play the introductory slide for Dr. Pankaj?
Dr. Pankaj is a DMD endocrine.
Dr. Pankaj, are you here?
Yes, yes.
Yeah,
Yes, so just we'll go further. We'll start the session. We'll play Dr. Nitin Kapoor's slides later on. Dr. Harsha has requested to ask her to deliver her talk first. So
I think Dr. Nitin is live.
Dr. Harsha?
Shiven, Dr. Nitin is live, I think so.
He's live?
Yes.
Okay. Okay, so we'll go ahead with
I'm live, but then I would still go by
just
the recorded version.
Yes, sir. We'll play the recorded session, but will not keep you waiting. So just Dr. Pankaj, please introduce Dr. Nitin, and we'll go with Dr. Nitin Kapoor's lecture first.
Okay. So I would like to congratulate, first of all, Dr. Mayur Agrawal and team for organizing such a wonderful academic event and giving me this opportunity to chair the session. So Dr. Nitin Kapoor sir needs no introduction. Basically, he is very well known. He is currently faculty at CMC Vellore, Professor of Endocrinology, and he have many achievements in the field of endocrinology. Lot of work he have done, and currently is focusing on obesity and related disorders. And he is having multiple these publications to his credit in relation to obesity. So with that, I would like to welcome Dr. Nitin Kapoor sir for delivering his talk.
Tech team, kindly play the recorded session. Sir will be live for question and answer session.
I'd like to thank and congratulate Dr. Mayur Agrawal and the entire team at Hormone India for having me here and also for doing spectacular work across the country as a team called Hormone India. Friends, in the next couple of minutes, I shall take you through this topic of sarcopenic obesity, what a clinician needs to know. And I'm going to address this topic by answering 3 questions. I will talk about the what, the why, and the how. I'll talk about what is sarcopenia and sarcopenic obesity, what is the concept, how do we define it, what's the problem statement, especially with respect to the Indian setting. I'll talk about why this is important for all of us as clinicians here to know about it. How is it relevant to our clinical practice? How do we understand its pathogenesis leading on to its complications? And the last and the most important bit, how do we manage it? What are the 3 pillars of management of sarcopenia and sarcopenic obesity in terms of diet, exercise, and medicines? So let's get started directly with the first thing. And I think all of us are well aware of what is coming in the future, what we call it as the Grey Dawn or the Grey Wave. And what I mean by this terminology is that, yes, with an increasing life expectancy across the globe and even in countries like India, we are definitely going to have more and more elderly people in the society. When you look at the life expectancy in some of the states in India, it is at par with many Western countries. And so in this regard, we as healthcare professionals need to gear up, need to know how to address the problems of the elderly, and sarcopenia and sarcopenic obesity is definitely one of them. When you talk of the normal process of aging, what we know is that as we age, the fat content in the body tends to increase, whereas the muscle content tends to decrease. And if I plot this in a very simple 2x2 table, we see that anybody with a low muscle mass or having a low muscle mass in combination with a high fat mass would be called to have sarcopenic obesity. The problem definitely gets more compounded in the Indian population where we know that we are already prone to have much higher body fat than other populations despite having a lower BMI. This was a study that we did a couple of years ago looking at the prevalence of lean diabetes, people who are thin, not having type 1 diabetes, but type 2 diabetes or a diabetes of a low BMI, and how this is common in the Indian setting. Another study that we did, we talked about the prevalence of normal weight obesity, people who have a normal BMI and high body fat. To our surprise, we found that about 2/3 of the people who have a normal BMI in this particular cohort actually had high body fat percentage. And the prevalence of diabetes, hypertension, and dyslipidemia in these people was significantly higher than who are non-obese. So when you're talking of a phenotype wherein the BMI is low, but the fat content is high, obviously if I have to increase the fat content, I need to reduce the other compartments of the body if I want to keep the BMI still low. And that is what contributes to sarcopenic obesity. Looking at the definition of what is sarcopenia first, sarcopenia consists of three broad aspects that we talk about. We talk about physical function, which can be easily measured with the help of gait speed. We talk about muscle strength that can be measured with the help of a hand grip dynamometer, or we talk of muscle mass, which can be measured with the help of some kind of a body composition analyzer. And if there is presence of at least 2 out of 3, and there are several different consensus as well as definitions for how to define sarcopenia, but ultimately all of them look at these 3 parameters, and at least 2 of them should be present to define sarcopenia. More recently, the European Consensus Group came up with this proposition that if there is only presence of low muscle strength, it should be probable sarcopenia. If there is low muscle strength with low muscle mass, as assessed by a body composition analyzer, it would qualify for the definition of sarcopenia. But if there is all 3 of them, if I add low physical performance to sarcopenia, it would be severe sarcopenia. And there are several Asian definitions, the studies from India as well. But very recently, there's a group of people from different South Asian countries came up with something more simple, given the hard reality today that we do not have DEXA scans available at every nook and corner or every PHC, or nor do we have body composition analyzers so widespread in our country. We need to talk about more simple definitions, more practical definitions that we can use in our day-to-day practice, and still keeping the 3 pillars of muscle strength, muscle function, and muscle mass, probably looking at more clinical and easy to measure parameters. We can measure muscle mass through an high-end MRI or DEXA scan, but we can get a fairly good idea of that with the help of calf circumference as well. Talking about muscle function, not very difficult to ask our patients to have a particular distance to cover and talk about the walking speed. Also, looking at muscle strength is not very difficult, but even if we want to make it more simple, what we can use is a very simple screening questionnaire called the SAR-F questionnaire, having to use only 5 questions, each of which is graded between 0, 1, and 2. And if our patient has a SAR-F questionnaire score of more than equal to 4, yes, we can suspect sarcopenia and do the formal assessment for these patients. So there is indeed a simple way of assessing sarcopenia first, or at least screen patients for sarcopenia, and then help in our clinical practice to diagnose them. So we talked about sarcopenia. What about sarcopenic obesity? Again, a lot of definitions that have been proposed. It is essentially presence of sarcopenia in the presence of high body fat percentage. Several definitions have been proposed, and based on which the prevalence globally varies from as low as 3% to 12%. We know that body fat percentage in the Asian phenotype is definitely much higher than the West. The cutoffs that have been proposed in the West is as simple as 25 to 35%, but our metabolic thresholds are much lower, so probably a much lower body fat percentage is proposed in the Indian setting. Talking about the problem statement, and again, very recently, we looked at this longitudinal aging study in India, data from over 72,000 elderly people from India through the national survey, and we look at that approximately 1 in 10 people, elderly people in India, have sarcopenic obesity. So it is definitely not something that can be just brushed under the carpet. It is something that needs to be recognized, is common, is something that is very specific also to our ethnicity, and is going to be increasing in the coming years. So with this, I move on to the second part of my topic as to why is it important in clinical practice to identify people with sarcopenic obesity along with sarcopenia. Let's talk about pathogenesis. And what we realize is this indeed is a vicious cycle. Well, if somebody has got sarcopenia or poor muscle strength and mass, definitely that person cannot do adequate amount of exercise or physical activity that is required. And therefore, that patient is ultimately going to burn less calories and accumulate more fat and get into an obese phenotype. Well, if somebody has obesity, there is increased amount of fat often in ectopic sites, and one of the sites ectopically is also the muscle. And if there is increased intramuscular fat, definitely it contributes to poor muscle function and strength. Not to forget that when there is obesity, there is also a much higher increment of inflammatory cytokines, which also deeply and negatively impact the muscle, and therefore again ensuing sarcopenia, and this cycle keeps going on. Further on, when we start aging, this entire process is catalyzed by all the hormonal changes that happen with aging, thereby further compounding the problem of sarcopenic obesity. And then this particular slide, you see that there are so many problems that can be affected by sarcopenic obesity. But talking about hardcore evidence, of what evidence do we have? And maybe I'll start with just talking about mortality to begin with. And we see in this excellent study of over 4,500 people aged between 60 to 80 years, we see that they're looking at mortality, and they're talking about follow-up of as good as 11 years. And when we look at the mortality, the white bar that you see here are people who are normal weight. But then when we see obesity, that is the dark black spots that you see. So we see that definitely people with obesity have a higher mortality than normal weight people. But if the person has only sarcopenia, that provides a higher mortality odds than just people with obesity. But if you combine sarcopenia and sarcopenic obesity, and these are the biggest bars that you see. And so, yes, sarcopenic obesity is a very strong indicator of mortality. We're talking about frailty, disability, and admissions. Again, in this project where they've studied men, and we look at the odds ratio of frailty as high as 2 times higher risk of developing frailty if you have sarcopenic obesity. Not only this, we talk of the muscle, then we also talk of the bone, and we also talk of the joint together. This is knee arthritis. The odds ratio is 3.5. So people with sarcopenic obesity have a 3.5 higher chance of developing knee osteoarthritis. And when talking about osteoporosis, again, it's not only osteoporosis, but even vertebral fractures, which are more commonly associated with sarcopenic obesity. Talking about metabolic syndrome, you talk about diabetes, hypertension, and dyslipidemia, and you look at the odds, which are as high as 8 times. A patient with sarcopenic obesity will have 8 times higher risk of developing metabolic syndrome, as against only 2 times for people who just have sarcopenia. Not only affecting all these metabolic parameters, but also affecting the psyche. And sarcopenic obesity has also been associated with depression. So cutting a long story short, what I'm talking today about is sarcopenic obesity and how this can influence all these different organ systems and, most importantly, increase mortality. And this is why we as clinicians need to be aware of this entity. So, well, we've so far talked about our increasing aging population. We've talked about the different definitions of sarcopenic obesity and how our South Asian ethnicity tends to be more prone to develop this particular phenotype. We talked about its different pathogenic factors and how this is a vicious cycle. But more importantly, also, we've looked at hardcore evidence with respect to the multitude effects that it can cause. Most important of it is the highest risk provided for mortality. And now the last bit of my talk, where we talk about how do we manage it. And there are three broad pillars of management of sarcopenic obesity. It is the exercise, it is the diet, and it is the medications. Predominantly exercise and diet. Let's start with the exercise. And there are several studies that talk about how different types of exercise can increase the muscle strength, which is no big news. We all know that both resistance and aerobic training can definitely improve not only the muscle mass, but also muscle strength. Very simple exercises, given that we're talking of a disease that is more common in the elderly. So very simple exercises like chair exercises, using a band exercise, simple aerobic training is very helpful. And it's not only just the exercise which is done as a short-term plan, but a long-term plan is something that goes in a long way. But having known that, we always remember that when we advise exercise to any person, and specifically more in elderly, we go in a very graded fashion. We don't talk about resistance exercises on day one. We first talk about flexibility enhancement, then teach them balance. We really don't want to have a fall and a fracture in somebody who's more prone to develop a fracture. Then we talk of aerobic exercises, and lastly, we talk of resistance exercises. And this is a graded prescription that we want to provide. Talking about diet, and though there is a kind of a paradox where we're talking of low-calorie diet, and that is to address the obesity part, but the important point is that we need to make up for the protein as well. So there is calorie restriction without restriction of protein. So even in clinical practice, when we talk of elderly people and we are trying to get their weight loss, it is very, very important to also talk about good protein intake for them, because otherwise they would develop sarcopenia. Obviously, good to also ensure good calcium and vitamin D supplementation. But still, the most important aspect, especially again in the South Asian region, is talking about good, adequate protein intake, 1 to 1.2 grams per kg body weight. We are not talking of high protein diets. We're just recommending to take an amount of protein that should be taken by a normal, healthy individual. Very surprisingly, recently, when we looked at our own data, and this is data from a pediatric clinic where most of our people are having morbid obesity, we see that despite consuming much more calories that one patient should for their given weight, they still don't meet up the amount of protein that they should be consuming. So definitely increase protein intake with calorie restriction is the mantra for managing sarcopenic obesity. Moving on to the last bit, which is talking about medications. And at this point, we talk of calcium and vitamin D, but there are no specific approved medications for sarcopenic obesity, but a lot in the pipeline that we need to be on the lookout for. There are drugs which are being developed as myostatin inhibitors. There are drugs like oral ghrelin analogs, and several anti-obesity medications are being tested. Hormones do play a very important role. Both a premature menopause needs to be addressed, and similarly in men, late onset hypogonadism is indeed something that needs to be addressed to prevent sarcopenia. So with this, I think the treatment aspect of sarcopenic obesity in today's world is good exercise, resistance as well as aerobic, not starting with that, but gradually reaching to it. Good nutrition in terms of good protein intake, but a limited calorie intake. And that's how we address the problem of sarcopenic obesity. To conclude, I think we did speak of how and what is sarcopenic obesity, just a confluence of high amount of fat with low protein or low muscle mass. We talked about simple methods of assessing sarcopenic obesity using simple questionnaires like the SARC-F questionnaire, and also looking at the impact of sarcopenic obesity on different metabolic parameters, talking about mortality, talking about depression, as well as on the metabolic syndrome. And last, we also talked about how we address this problem in terms of treatment. Thank you, and I'd be happy to take any questions.
Yeah, thank you so much, sir, for very nice and so many publication of yours we have seen. So such a comprehensive work on sarcopenic obesity. Just a quick question from your side. So what kind of population you suggest to target to detect for sarcopenic obesity? I mean, in general, we cannot ask all patients to screen for this. So what kind of population should be targeted?
Right. Thank you, Shivendra, for that question. So basically, there are two types of sarcopenia, the primary and the secondary. In my talk, I just focused on secondary sarcopenia. So the elderly population, somebody above 60 in the LASI study where we showed that 10% of elderly population have sarcopenic obesity, that's 60 plus. So everybody 60 plus to at least go through that SARCF questionnaire. If that is positive, take it further. So that would be the short answer to that.
And any further simple things which we can use to detect, because we don't have DEXA scans, and the standard DEXA scans are also not available everywhere.
That's true, and therefore, in the recent consensus, we proposed instead of muscle mass by DEXA to just use the calf circumference. Very easy to measure. The highest circumference in the calf, cutoffs of 33 for women, 36 centimeters for men have been proposed, and that can be used. So without DEXA scan, using muscle mass by calf circumference is an option.
And they are standardized for the Indian population also.
Not as yet. At this point, we've just completed a study which shows good results with those. It should be published soon.
Okay, thanks a lot, sir. Thanks a lot for sharing this information also. So I don't see any other question from in the chat box. So it was very wonderful to listen you again, sir. We'll keep calling you again and again for more discussions on other topics as well.
Thank you, sir.
Thank you, and congratulations for the great work again.
Thank you, sir.
Bye-bye.
Yeah, we move on to our next presentation, which will be by Dr. Harsha Pamnani. And Dr. Mayur, you can very well introduce Dr. Harsha.
Yeah. So, cannot see the slides. Okay. She is MD Medicine Gold Medalist, DNB Endocrinology, presently working as a consultant endocrinologist at Bhopal Siddhanta Red Cross Hospital. And she has more than 10 years of experience, and she is a speaker at various national conferences. And she has also received awards for publications. Over to you, Dr. Harsha.
Thank you, Dr. Mayur, for the kind introduction. Thank you, Shivendra Verma, sir, and Team Hormone India for this opportunity. So, just a minute, I will.
She'll be also talking on beyond basic topic, that is monogenic obesity. That's a really relevant talk today.
I am not able to share the screen.
Kindly go in presentation mode.
Ma'am, you can just click the below on your screen, right side below icon. Yeah. Yes, perfectly work. Thank you.
So the talk of today is monogenic obesity. So just a few basic, like in more than 2 years of age, when we called overweight, we call it by if the BMI is more than 85 percentile and less than 95 percentile for age and sex as per the CDC growth charts. Obese if it is more than 95 percentile for age and sex, and extremely obese if it is above 35 kg per meter square or BMI is more than 120% of the 95th percentile. If the patient is less than 2 years of age, obese is if the sex-specific weight for recumbent length is more than 97.7 percentile as per the WHO growth chart. So we know that childhood obesity have multiple reasons, and today I will be discussing about the genetic predisposition. It is one of the cause, and there are multiple reasons. So if we come to etiology, obesity, it has causes like physiological, like in this there is normal growth, puberty and development, and it is pathological. In this we have genetic, that is monogenic syndrome, in which the patient mainly have hyperphagia, vision and puberty problems. Second is the secondary hypothalamic cause. In this also there is hyperphagia. And third is the endocrine cause, in which hypothyroidism, GHD, Turner syndrome is there. And in this growth and puberty delay is present. So we'll discuss today regarding the genetic monogenic obesity. So it's wise to divide it in two forms: obesity that is associated with the developmental delay and obesity without developmental delay. So in the developmental delay, the causes are dominant and recessive. In dominant, the conditions are Prader-Willi syndrome, Fragile X syndrome, Albright hereditary osteodystrophy, BDNF and TRK beta deficiency, and SIM1 deficiency. In recessive syndromes, there are Bardet-Biedl syndrome, TUB deficiency, Alstrom syndrome, and Cohen syndrome. And second one is obesity without developmental delay. So in this also there are dominant and recessive. In dominant, there is MC4R deficiency, SH2B1 deficiency, KSR2 deficiency, and in recessive there is congenital leptin deficiency, leptin receptor deficiency, and POMC, PCSK1 deficiency. So we'll discuss one by one. The topic is tough, but we'll keep it simple. So first we'll come to dominant disorders with developmental delay. So just see the happy faces of the child and see the small hands of the child. The child is having Prader-Willi. So first we'll discuss about that. It is the most common syndromal cause of obesity. It is due to imprinting error. Mainly there is paternally expressed genes are imprinted. There is deletion of the paternal segment in maximum number of cases. Even also some cases have loss of entire paternal chromosome with maternal disomy. And there is methylation disorder. There is minimal balance translocation is also seen. So how does patient presents? Mainly the patient presents with the feeding difficulty, and patient has feeding difficulty. It improves after 6 months. And then from 1 year onwards, patient develops hyperphagia. And so they gain weight. Diminished fetal activity is also there. Hypotonia, mental retardation, short stature, and small hands and feet are there. Hypogonadotrophic hypogonadism, obesity, sleep disturbance. Patients has OSA also, and obsessive compulsive disorders are also seen in these patients. So mainly the diagnosis of Prader-Willi syndrome is clinical. Mainly 8.5 points are needed for diagnosis, and in this disorder, ghrelin levels are increased, and GH response is diminished in this disorder. And the treatment of this disorder is mainly a low-calorie diet, and mainly exercise and low-calorie diet. Basically, psychological and behavioral therapy is needed. Growth hormone therapy is given in this treatment, and mainly we have to be cautious. If the patient has obstructive sleep apnea, then growth hormone is not given at that time till the sleep apnea is decreased, and then we can give growth hormone. It reverses many of the features of the Prader-Willi. And clomiphene citrate is tried in this condition, but it's controversial. So there are many criteria for it. There is major criteria and minor criteria. In major criteria, mainly there is hypotonia, poor sucking reflex that improves with age. Patient has feeding problem, mainly weight gain is poor, and then they gain weight after 1 year, and the weight gain is rapid after 1 year. They have characteristic facial features like there is narrow bifrontal diameter, there is almond shaped eyes, and there is fish turned mouth. Hypogonadotrophic hypogonadism is seen, and the patient has also some minor criteria. Mainly minor criteria, there is reduced fetal movement and infantile lethargy that improves with age. Characteristic behavioral problems is also there. Temper tantrum and OCDs are there. Sleep disturbances or apnea. Short stature is seen. Patient has hypopigmentation also, and mainly the characteristic, there is also small hands and feet and narrow hands with straight ulnar border. There is eye abnormalities are also seen. Speech articulation defect is seen. There are many additional features. These additional features are not needed for diagnosis. If they are present, they just increase the possibility of diagnosis. And then for the criteria, that is for interpretation of the diagnosis, within 3 years of age, then 8 points are needed, of which 5 must be measured. And supportive criteria only increase or decrease the level of diagnosis. For the physiology of the disorder, mainly ghrelin levels are increased in the predar villi, and it is thought that it is the causative feature for the hyperphagia. Next is the Fragile X syndrome. In those category of developmental disorder, it is the most common cause of inherited mental retardation, and there is unstable expression of CGG repeat. CGG repeat, it is present on the FMR1 gene, and it encodes for FMRP proteins, and it negatively regulates protein synthesis. So if it is not present, then transcripts are over translated, and this decreased synaptic strength. So there is mental retardation. And the patient has mainly moderate to severe mental retardation, macroorchidism, large ears, macrocephaly, prognathism, high-pitched jocular speech is present, and there is the delay in the language acquisition and behavioral problem. And in some cases, obesity is present with the rounded faces. And the treatment is clonidine and carbamazepine and valproate. They are tried, and they have behavioral modifying effects also, and they have anti-seizure effects and behavioral modification effects also. Third one is SIM1 deficiency. SIM1, it is the transcription factor that is needed for the development and the function of the paraventricular nucleus of the hypothalamus. There are multiple mutations like translocation, deletion are there. And in this, there is severe hyperphagia, obesity, autonomic dysfunction like low systolic blood pressure is there, and there is speech and language delay. There is neurobehavioral abnormalities seen in SIM1 deficiency. Then there is Albright's hereditary dystrophy, osteodystrophy. In this, there is germline mutation in the gene AS1, which leads to reduced expression of the GS alpha, and it can be maternally transmitted or paternally transmitted. If it is maternally transmitted, then in addition to AHO, there is also resistance to different hormones like PTH and TRH and others. And if it is paternally transmitted, there is only AHO phenotype. And this is pseudo hypoparathyroidism. In this, patient can have short stature, obesity is present in 50%, there is mild developmental delay, round faces, brachydactyly, ectopic soft tissue ossification, that is osteoma cutis can be seen, and there is impaired olfaction. And there can be BDNF and TRK beta deficiency also. So in chromosomal 11 deletion or point mutation that disrupt brain-derived neurotropic factor and its receptor that is TRK beta. And these mutations are de novo mainly. Mainly in this type of mutation, both parents can have normal weight and IQ, and child has severe hyperphagia, obesity, moderate to severe learning disability, hyperactivity, short-term memory impairment, and impaired pain sensation. Now we'll come to recessive disorders with developmental delay. So in this, you can see the polydactyly. The patient has 6 digits. So it is Bardet Biedl, and it can have triallelic inheritance. There can be 2 mutations in one gene and 1 mutation in second gene, and it mainly involves the basal body, and modified centriole is involved in this. And the patient can have central obesity, mental retardation, dysmorphic extremities, in which it can be polydactyly, syndactyly, or brachydactyly. There could be retinal dystrophy, and hypogonadism is mainly male, is limited to male only, and there are also structural and renal disease. The treatment is that accessory digits, they are non-functional and they should be excised by orthopedician or by plastic surgeon. And there is no beneficial role of growth hormone or testosterone in this disorder. In retinal, in this Bardet Biedl, retinal dystrophy, mainly retinitis pigmentosa is seen in all, and primary optic atrophy is associated with retinitis pigmentosa in this disorder. There is visual deterioration, and visual loss is seen by the 3rd decade. Hypogonadism, it is mainly limited to males, and there is a high prevalence of the congenital heart disease also. There are many neurological findings like nystagmus, ataxia, and hypotonia, and the patient has high risk for hypertension, prothrombotic state, and renal abnormalities. But the Bardet Biedl differs from the Lawrence-Moon Biedl in that Lawrence-Moon Biedl, they do not have polydactyly. In Lawrence-Moon Biedl, there is retinal pigmentary degeneration. Patient has mental retardation, hypogonadism, and spastic paraparesis with distal limb weakness, but without polydactyly. And one is
Dr. Harsha, sorry to interrupt. Can you just rush through the time? It's already running very fast.
Okay.
You can rush through your slides.
Cohen syndrome, it is also very rare. In this, there is mental retardation, microcephaly, there are hypotonia, there is progressive retinochoroidal dystrophy is seen. Means patient has high-grade myopia and retinochoroidal dystrophy. It is the essential feature of the Cohen syndrome, and the vision mainly deteriorate early, but by 40 years, patient is usually handicapped. And Alstrom, there is also a mutation in the ALMS1 gene. And in this, there is also obesity, retinal dystrophy. In this, there is early loss of central vision, in contrast to other pigmentary retinopathies in which there is peripheral vision loss. There is also deafness, and insulin resistance is severe in this patient. So they develop diabetes also, and hypertriglyceridemia is also seen in this. There is mental retardation is not present, and polydactyly and hypogonadism is also absent in this. And in some subset, there could be diabetic cardiomyopathy or hepatic renal dysfunction, hypothyroidism, male hypogonadism, short stature, and mild to moderate developmental problems can be seen. And TUB deficiency is also rare, in which deafness, retinal dystrophy, and late onset obesity is seen. Now we come to second class, in which there is no developmental delay, in which there we comes to dominant disorders. One is the most common, that is MC4R deficiency. It is the most common cause of genetic obesity syndrome, and MC4R sequencing, it is a part of routine assessment in the severely obese child. The patient has hyperphagia. It develops from the first few years, and the peculiarity is that the patient has fat mass and lean mass. Both is increased in this disorder, and the BMD is also increased. Patient has increase in the linear growth, and the important thing is that there is reduced sympathetic activity. Patient can have low blood pressure, and insulin levels are high in this condition. And the treatment of the condition is that some patients respond to bariatric surgery, Roux-en-Y gastric bypass, and MC4R agonist has also been tried in this condition, that is setmelanotide. SH2B1, it is also rare, and SH2B1, as we know, it is involved in leptin and insulin signaling, and in its absence, there is hyperphagia, highly penetrant familial severe early onset obesity, insulin resistance, behavioral problem, aggression is there, and there is speech and language delay. KSR2 deficiency is also rare, in which obesity, and the important is that some patients respond to metformin that cause marked weight loss in some subgroup of these patients, and patients have reduced basal fatty acid oxidation. And recessive disorders without developmental delay, in this there is congenital leptin deficiency, and there are many mutations in that. And leptin deficiency, patient complains of hyperphagia, normal birth weight patient, more fat mass is there, and there is reduced sympathetic activity. Patient can have type 2 diabetes in third, fourth decade, and hypothalamic hypothyroidism and hypogonadism is seen. And important is that there is impaired T cell function, more childhood infection is seen in this disorder, and patient has undetectable leptin levels, and then by genotyping, it is found that patient has leptin deficiency, and subcutaneous metrileptin can be tried in this condition. Leptin receptor deficiency, it mainly has inability to phosphorylate STAT3, and presentation wise, they both are similar. Clinically presentation, they both are similar, and serum leptin levels may not elevate disproportionately in this condition. If there is means truncated extracellular domain of leptin receptor, then it elevates leptin levels. Then there is POMC deficiency. And in POMC deficiency, patient can present with adrenal crisis, and patient can have lifelong glucocorticoid, and patient can have pale skin and red hair if there is MSH deficiency, hyperphagia, early onset obesity, and cholestatic jaundice. And then MC4R agonist can be has been recommended in this condition also. Then PCSK1 mutation. In this, there are many features like there is early onset obesity, there is low cortisol, there is postprandial hypoglycemia because of impaired processing of proinsulin to insulin. There could be central DI, there could be hypo, and mainly there is small intestine absorptive dysfunction. It is characteristic. Then, we'll deal about the monogenic obesity just to approach just a few slides. Like the guidelines recommend that you just plot on the CDC normative BMI percentiles, and then you review the BMI percentile at least annually. Routine endocrine tests are not required in every condition. It is required when growth velocity is decreased. Genetic testing, they should be done if there is extreme early onset obesity in less than 5 years. If there is extreme hyperphagia, means if there is food seeking behavior, patient continuously search for food, continuously grazing for food, stealing food, and waking at night to find the food. If there is means if patient is voraciously eating, and there are other features suggestive of syndromic form, or there is family history of extreme obesity, or if it is in less than 5 years, then you should go for genetic testing. And then you just see if the child is obese by history and physical examination. If everything is normal, then you see the comorbidities, you do lifestyle, diet, exercise, and then you decide for pharmacotherapy and bariatric surgery. If there is antipsychotic drug, you reevaluate that. And if there is any history of physical findings is abnormal, then you see if there is attenuated growth velocity, then endocrine cause is there. If there is CNS injury, then there is hypothalamic obesity. And if there is neurodevelopmental abnormalities or severe hyperphagia, then it is genetic evaluation should be done. And if there is developmental delay or there is no developmental delay, if developmental delay is present, then clinical features, if suggestive of Prader-Willi, go for DNA methylation studies. If it is not, then you do the karyotyping or genetic analysis. If there is eye involvement, retinal dystrophy, photophobia, or nystagmus, then it is Bardet-Biedl, Alstom, or TUB deficiency. If there is no eye involvement, then you can see from the genetic NGS panel. And if there is no developmental delay, you can do leptin or insulin, proinsulin, and then you can decide regarding leptin deficiency, PCSK1, what features are suggested for that. And then there is NGS, there is obesity gene panel of 36 genes by which you can see other genes. Yes, it has been associated with multiple complications of obesity, And then we have to do weight, height, BMI, BP, acanthosis nigricans, skin tags, acne, hirsutism, edema, goiter, fundus, and we have to see the physical findings of syndromic obesity. Yes, we have to plot. And if the BMI is more than 85 percentile, the patient should be assessed for comorbidities. In non-pharmacological therapy, diet, by seeing the BMI, you can give
Sorry
the
to interrupt, last 30 seconds.
yeah, calorie deficit diet, and then exercise and academic screen time should be reduced, and psychosocial and social activities watched for. In pharmacological therapy, if the patient is less than 16 years, no pharmacological therapy is recommended if the patient is overweight, and you can consider medicine if the patient is more than 16 years or the patient has BMI more than 30 or more than 27 if more one related comorbidity. Only Orlistat is FDA approved for obesity treatment in 12 to 16 years. And setmelanotide, yes, it has been approved for mainly these conditions. It can be tried in these conditions. And bariatric surgery in infants, if needed, there are criteria for it. And mainly to conclude, yes, pediatric obesity, it is mainly ongoing serious health concern. It has basis in genetic susceptibilities, and there are several monogenic causes and syndromes in association. Genetic screening is indicated only if there is a specific history and physical examination, if the child is less than 5 years, or there is syndromic features or extreme hyperphagia. And endocrine etiologies are rare. And if there is growth attenuation, then you should look for. Pediatric comorbidities are common and they should be screened. Screening for mental issues is important, and lifestyle modification behavioral therapy is the cornerstone. Anti-obesity drugs, mainly in pediatric population, they are used in research settings. And the diagnosis of genetic obesity syndrome, it is important because it appropriately manage the child's health. It lessens the social stigma that a child has eaten or family has given. Means we have to counsel the patient regarding the genetic counseling. Genes are responsible, and possibility of bariatric surgery could be there. We have to look for consanguineous relationships, and there is the family history of obesity or other things we have to look for. So thank you for your patience listening. And if there is any question, I can take it.
Yeah, thank you, Dr. Harsha. Very nice, very nice. And you have presented in detail the individual monogenic diabetes plus the newer individual monogenic diabetes causes also being included in detail. So there are no questions in chat box as yet. So we thank you so much for this wonderful presentation. Now it is over to Dr. Mayur, who will be the rapporteur for the next session.
Thank you. Thank you.
Thank you all the speakers and chairperson. For the next session, for dyselectrolemia, obviously the hypercalcemia is often referred, but not the other thing. So all those things are also included in endocrinology, and we should actually sensitize the peer group, other doctors, that these all should be evaluated for endocrine causes. So hypercalcemia, hypocalcemia, hypokalemia, hyponatremia, and we've not included all those phosphate and magnesium metabolism, but at least these are really important. So I welcome our chairperson, Dr. Tony Joseph and Dr. Ajay Shukla. Obviously need no introduction. We can just switch to the CV slide of Dr. Arpandev Bhattacharya sir. Dr. Tony, please introduce.
So Dr. Arpandev Bhattacharya sir is an endocrinologist. He's a consultant in the Department of Diabetes and Endocrinology, MHB. He's a professor of endocrinology, JJMMC, Davangere, Karnataka, and co-chair Shivajyoti, Indranagar, Bangalore. So over to you, sir, for the next talk.
Thanks, Dr. Tony, and thanks Mayur and all of the Hormone India. Wonderful initiative. I wish you all the good success, and nice to see that our endocrinology is going. I remember when we have done the DM back in 1992, a few people are there, every state. It's very nice to see. Will you allow me to share my screen? Yeah, I think I can now. Okay, very important topic. Hyphatic, simple clinical discussion. That's what I would prefer to do. So around maybe 15-16 minutes, I'll go through hypercalcemia evaluation. This is the topic given to me, but no treatment. I'm not going to get treatment, but if the question comes to the treatment, I'm happy to encounter them. A little bit of introduction needed definitely these days. So I do not have any share in the pharmaceutical industry, and this is not a contracted speaker program. So views expressed essentially of mine, but important disclaimer is that I have recently heard a talk, in a physical meeting talk on hypercalcemia from Deepak Khandelwal, and I really liked and took some slides from him with his permission. So that's my plan. Calcium homeostasis, measurement, hypercalcemia, and the main part I'll tell you a case and how to solve hypercalcemia, how to evaluate. That is my portion, and I'll end with the take-home points. So calcium homeostasis. So as mineral, most of the calcium is there, and the crystals. A very small portion are there in the plasma. Whatever there in the plasma, 45% are ionized form, which is physiologically active form. And I'll be campaigning a little bit against ionized form, but remember, this is a physiologically active form. 45% bound to protein, mainly albumin, and that's why we do albumin-corrected calcium. And 10% complex with anions like a citrate, phosphate, sulfur, etc. So there are mainly three organs: the bone, the intestine, the kidney. From the bone, calcium comes in the extracellular fluid, goes back in the same way. From the intestine, mainly absorption. Some amount is going out in the stool. And the kidney one is a very important organ for maintaining calcium homeostasis, which will be coming and going there. So that maintaining a normal calcium level for our body. A quick vitamin D, all these we know very, very clearly. Sunlight. In the skin, we have a D, which can be D2 or D3 or D2 and D3. That's what D means. In the liver, it will become 25 hydroxy D. In the kidney, with the influence of PTH, the activation of the 1,5-hydroxylase enzyme will become 125 dihydroxy vitamin D, and this will make an active vitamin D binding protein where the calcium will be absorbed. And top bit, the calcitonin hormone from the thyroid gland. It stimulates the calcium deposit in the bone, reduce the calcium uptake, reduce the calcium. All three organs I was mentioning. That means high calcitonin will give low calcium, whereas high parathyroid hormone will give a bit higher calcium. So basically, a balance of three organs: bone, intestine, and kidney. Three hormone: vitamin D, PTH, and calcitonin. And here, end of the day, we have the calcium in the blood, which need to be maintained in a correct level, below which there is a problem, above which also there is a problem. How do we measure? Fasting sample is not required, but it is required for the phosphate. And sometimes we can see a falsely high level of serum calcium, and that's the term used as sustained hypercalcemia. At least 2 samples will document. There can be lab error, there can be sample taken error, there can be sample taken with the drip in the same hand, sample taken with the tourniquets. This is one particular sample. Phlebotomy. It is important that it should be taken without not a lot of squeezing, clinching fist or the tourniquet. To be taken ADTA-free vial washed with dilute hydrochloride. This should be prepared. Things comes now. Tourniquet causes a venostasis, thereby total calcium can go up, and the fist clinching can go up. Free calcium, that is ionized calcium, can go up. Should be in the resting state, that's no doubt, and we should use a wide bore needle to avoid the hemolysis. So when you're talking about ionized and total calcium, so ionized calcium, that's the average level, influences the many cellular and function, tight control, PTH control, measured directly from that calcium specific electrode. Now this is important to remember. This is costly and only some institute will have. Most of the time, if we see an ionized calcium defect, is actually electrode defect. But albumin corrected total calcium, what we do, the basis of the calculation is that initially I mentioned the 50% of the calcium is bound to albumin. And this is a simple formula. You can put a lot of point or something. I just made some simple formula because this is what we use in the world. 4 minus serum albumin into 0.8 plus serum calcium. So albumin is high means your calcium is calculated should be normal, but measured all a bit low. Albumin low is measured will be low. That is the other way around. What I necessarily wanted to tell you that in clinical practice, ionized calcium is not helpful unless proved otherwise. I have a serious problem in this because of the electrode. A lot of places a wrong electrode or expired electrode gives a falsely abnormal report of ionized calcium. No clinical situation is there that we cannot manage or diagnose with an albumin-corrected total calcium. Barring a few, for example, some people are on ICU and there are a lot of other medications. They have a severe acid-base disturbance. One or two other than situation, all our clinical practice should be equally done with albumin-corrected total calcium, which is certainly a lot cheaper than ionized calcium. Sustained hypercalcemia, to avoid the interpretation of the lab error, we need at least 2 samples to document a hypercalcemia. That's worth doing it rather than investigating different causes and then you come back and realize your initial value was a lab error. So that's very nice. Roughly, we make the level of 12 and 14, less than 12, no need to panic. Just cool down and see what is happening, what correction can be done. If it is more than 14, important. There can be a cardiac problem, cardiac rhythm disturbance. We need an immediate action. So that's a severe hypercalcemia. In between 12 and 14, we will tell it's a moderate hypercalcemia. Okay, let's come to the presentation. Now, causes, if you see before there's a presentation, there are different ways to classify. I have classified one particular one as a common and uncommon. The commonest, obviously, PTH related. Second common is a malignancy related. So PTH related, it can be adenoma, hyperplasia, or some other condition like lithium or familial issue. Malignancy associated hypercalcemia is pretty also common. But there are some uncommon causes like a milk alkali syndrome, vitamin A, D toxicity. Nowadays, vitamin D, because of overzealous supplement, we are seeing some cases of vitamin D toxicity with a high calcium level. So I can't tell this is very uncommon now. Sarcoidosis, thyrotoxicity, Addison's disease, thiazide, and all this a little bit uncommon. Symptoms and the signs are pretty non-specific. Gastrointestinal symptom, anorexia, nausea, vomiting, constipation, neuromuscular weakness, lethargy, confusion, coma, depending on degree of calcium, genitourinary, polyuria, nocturia, renal colic, cardiovascular syncope, mainly rhythm disturbance. Signs also very non-specific. Dehydration is almost a consistent feature of the hypercalcemia, and there will be signs related to the organ system. But don't forget this one. Very old aging, more than 100 years. Bone, stones, groans, psychic modes. They can explain everything related to the bone-related problem, kidney stone-related problem, abdominal colic-related problem, and depression and psychic mood. Bones, stones, groans, and psychic moods. It was there in our MBBS textbook. So otherwise, it can be an acute presentation when they usually present with a neuropsychiatric and a cardiovascular symptom. Acute presentation can be mostly because of malignancy. Very important. But parathyroid crisis can give rise to acute presentation. But one important thing we need to remember, hyperparathyroidism is more of a chronic presentation because over the time, your hyperplasia and adenoma increasing the TSH level, increasing the PTH level. But one thing is very sure, if your calcium level is very, very high, it is likely diagnosis is primary hyperparathyroidism because of malignancy associated hypercalcemia, when your calcium will go to 16-7, primary malignancy will kill you. So if you see somebody at 16-17 calcium, is more or less, it is a primary hyperparathyroidism that you'll be thinking of. Now with this little quick background, let us solve this puzzle. After 3 days of tiring experience and whole of the day of today working, if you are saying, please go with me. Let's take this case. This is the lady of 71, name is Mangalamma, admitted to our hospital in Manipal Hospital, Bangalore. Referred as biochemical screening showed serum calcium of 15.6 milligram per deciliter on 40 days after admission. Now, why was it done? It's not very clear. They just thrown a biochemistry orthopedic team, and that's it. It was like that. So basically, patient was admitted with orthopedician with a non-united fracture with infection. The initial fracture happened around 30 days back. So admission 30 days back, fracture happened, and 40 days after, that is 70 days after the fracture, we are seeing, because first time on calcium was done, which showed 15.6%. Patient was operated in a different city and a nursing home. Because the patient was not improving and non-union, they are referred to Bangalore. Background problem with type 2 diabetes, on insulin, fair control, and high blood pressure, not on thyroid. So assessment, as I told you, with signs of symptom. She was conscious oriented, BP was normal, sinus rhythm, normal heart rate, systemic examination normal. There is a big open infected wound which was pool and discharge, which was repeatedly being drained and taken care of. Biochemically, albumin 2.1, normal renal function, hemoglobin is low, urine at 1+ ketone. Chest X-ray, ultrasound, abdomen were normal. Now, treatment-wise, orthopedic team, intravenous antibiotic and regular dressing, secondary suturing, all have been done in the hospital. For the medical condition, there is a supplement, some protein infusion, and diabetes is managed by the modified basal bolus insulin. She was recovering well, but some reason or other, blood calcium was done. And that's how we have been referred. So we rechecked. I told you, sustained hypercalcemia, we need to get a recheck done. We have rechecked, it's 15.2. Phosphate was a bit lower side. Alkaline phosphate is 463, pretty okay. Some reason or other, ionized calcium was done. I was camping actually against ionized calcium. ECG showed some hypercalcemic change. Shortened QT interval. This is the strip of the ECG for this lady. So, assessment-wise, when you started seeing, clinically well hydrated, average intake output was like this, 1.1.4 liter. Renal function normal, albumin 3.2. That was an admission albumin. Now albumin 3.2, serum calcium corrected becomes 16.1. Patient was given an IV fluid as our standard practice of managing hypercalcemia, furosemide and pomidronate. It is a bit few years old. Pomidronate was easily available, and that is our preferred treatment. 30 milligram per day we have given for 5 days. So what next? What is the cause of patients? We are treating hypercalcemia, we are treating, but we need to find the cause of hypercalcemia. Very high calcium, as I told, suggestive of hyperparathyroidism. It can be of this condition and increased bone resorption, radiology of subperiosteal resorption. By now, you understand the commonest cause will be PTH-induced hypercalcemia or hyperparathyroidism. These are some pictures. It looks like about the X-ray skeletal survey you do, periosteal resorption, osteoporosis, juxtaarticular, and the tuft resorption. Very nicely seen in this picture. And if you see on bone scan, you can see all those active hot areas. So this is a different patient of primary hyperparathyroidism. Just for the sake of the picture I'm showing, that's the next picture, and very nicely juxtaarticular osteoporosis is seen, and a tuft lysis of the terminal phalanges is very nicely seen. Also the skull X-ray. In our time, we used to do all skeletal X-ray whenever you used to get a primary hyperparathyroidism, and the X-ray of the loss of lamina dura is called, and the X-ray of the bone, of the mandible. You can do a pelvis X-ray. You can see a bit of very thin bone is seen, and some osteitis fibrosa cystica. It can be seen. This is like this osteitis fibrosa cystica, but this is a different patient. Don't forget it. And you can do a scan. So this is technician and tetraphosphate scan, which showed a definite big parathyroid adenoma, confirming diagnosis to this person. And this is one of the Deepak's picture, which nicely picked up a mediastinal parathyroid adenoma. Very nice. This patient presented acute pancreatitis is reported. There are case reports on ectopic parathyroid. Now, what will you do with our person now? This lady, very high calcium. We have started treating. We know PTH, very high calcium. I told primary hyperparathyroidism is likely diagnosis 16 calcium. We need to do a PTH to diagnose whether there is a PTH dependent or PTH independent hypercalcemia. The PTH came at 6.7. So clearly disproportionately low or a high calcium level suppress the PTH, parathyroid gland. Normal homeostasis. So this is, we are dealing with the PTH independent hypercalcemia. And by definition, 16 means severe hypercalcemia. What next? I told patient has bone disorder and we need to think of malignancy associated hypercalcemia. We have done a myeloma screen. Skeletal survey was normal, bench-juice protein was negative, serum electrophoresis was actually normal. This is a serum electrophoresis on the right side from a patient with an M band, myeloma band, and the left side is our patients who showed a normal protein electrophoresis. And a classic person's, another patient, remember, a multiple myeloma X-ray should show this. Our person X-ray was completely normal. So other malignancies, hematological malignancies, solid tumors, PTH-related peptide, osteolysis, whatever reason it can be. Prognosis is actually quite a bit bad because by the time calcium goes, but we have done investigation, multiple myeloma ruled out, chest X-ray ESR was normal, CBC was normal, ultrasound abdomen was normal, actually a bone marrow was done, and that was normal. CA125 was normal, pap smear was negative, even if it's say 71 years, we thought that let us do a good cancer screening. So more or less in our clinical practice, no malignancy associated hypercalcemia. So top two common causes ruled out, primary hyperparathyroidism and malignancy associated hypercalcemia. Now comes rare cause, we need to pick up. Thyrotoxicosis and Addison's disease are normal. Thyroid function and cortisol is normal. ACE level, angiotensin converting enzyme, was normal. Vitamin D, actually vitamin D was not the A, vitamin D was normal, and milk alkali syndrome is unlikely because serum bicarbonate was only 24. Now where are we now with our patient? So this is day one we started seeing. Calcium was very high, phosphate was around 2.2, so we have given diuresis, Lasix for around 3-4 days, then pomidronate for 5 days, and we can see that slowly every day the calcium is coming down. So something happened after 6-7 days, the calcium level is maintained nicely without doing anything till I knew the patient around 6 months after discharge. So what happened? What is the puzzle? Pomidronate did work. Maintained the calcium level in the normal range, but given only one course, 5 days. So this was the diagnosis. Hypercalcemia related to immobility is known, but it is error of the cause. And purposefully in our rare classification table of the rare causes, I didn't mention that. Mainly happens in young people, and is good to know a lot of people with a spinal injury because they are prolonged immobilization. Spinal fracture. This is what happened. This our patient also had a fracture, and then person was bed rest for a long time, 30 days in a different city, 40 days in Manipal hospital. So basically patient was immobile for more than 2 months. And maximum chance happened actually after 4 months in the literature. But obviously it has to be a retrospective diagnosis. We have ruled out all other causes, and we found that after mobilization started, things improved. Mechanism, increased bone resorption. Treatment, biphosphonate, we have given. Calcitonin we didn't have to give, or only biphosphonate. And prognosis is usually good, provided we recognize early and do this. So that's my take-home point, few take-home points. Appropriate collection and assay for sample for PTH and calcium is necessary. We need to document sustained hypercalcemia. I learned this word from Deepak's lecture. At least 2 samples we need to do just to see that we are doing a real hypercalcemia rather than spurious hypercalcemia. We need to find out whether PTH independent and PTH dependent, because that's the commonest cause, easily diagnosed. Treatment of hypercalcemia depends on severity and depends on symptoms also, and obviously the etiology. Do not forget that hypercalcemia can be there without symptom, which we call asymptomatic hypercalcemia. And this is because it's more common because of package servicing going on. Everywhere you go, every lab you go, they prefer package, and people just like it. 99 tests in 2,000 rupees, and who will not like it? And this is being recognized now that we are seeing an asymptomatic hypercalcemia, milder hyperparathyroidism cases, but they are not to be neglected. If you neglect it, they can go to hypercalcemia, clinical hypercalcemia symptom, but particular attention of these cases should be done, whether the kidney function is good, whether there is nephrolithiasis is good, whether there is bone density is not decreased. And in that case, some treatment is needed. Otherwise, up to 12, we keep on waiting. So one lesson, keep walking. I told keep walking. I didn't tell to follow this gentleman. That's up to you. Thank you very much. Thanks, Hormone India team. Thank you.
Thank you, sir. Well in time, one quick question. Whether you correct for increased albumin level as well as you correct for hypoalbuminemia?
Usually that situation is rare, but the answer is yes. Answer is yes, but hyperalbuminemia conditions are very unusual situation. We have gone through the literature about this issue. The answer is yes.
And at what level?
4. You keep the 4 as normal.
Okay, so anything
above 4, yeah, above 4, whatever amount is there, we'll subtract. Below 4, whatever amount there, we'll add. That is the best way, the bedside presentation.
Okay, thank you. Any more question from or any question in the chat box? I don't see any.
Yeah, there are no questions.
Okay, thank you very much for sir that wonderful lecture. So
thanks
now,
very much, very nice.
So now I welcome Dr. Sandeep Julka. Dr. Ajay Shukla, please introduce our next speaker. He'll be speaking on hypocalcemia.
So now we have Dr. Sandeep Julka. He's alumni of DM Sanjay Gandhi PGI, DM Endocrinology, and he's based in Indore, Senior Consultant Department of Endocrinology, Apollo Hospital, Indore. And he's very well known all over India, physically very active, and lot of social activities and lot of scientific records in his credits. And like one of the most important thing about, like, he has very special interest in lifestyle issues. With that, I invite Dr. Sandeep Julka sir to speak on hypocalcemia.
Over to you.
Thank you. Yeah, thank you, Mayur. Thank you, Ajay, Tony. With you around, the future of endocrinology is very bright. I'm really proud of you all. And hopefully someday you will include me in Hormone India. You said you won't take people more than 50 years of age. Please reconsider.
You're not 50. You are even younger than us.
Yeah. So
at least physically, I will.
Physical age is much lesser than us.
I'll start sharing my screen. So idea is to, can you see the slides? Slide.
Not yet.
Can you see the slides?
No, sir.
Not yet, sir.
So I'll try again. Done?
Yes, sir.
Yeah. So what I've done is to make it as clinical as possible. Dr. Arpandev's lecture was excellent. Just to tell that I am as of now managing a patient with parathyroidism, which we will publish. The patient is on cinacalcet and calcitonin spray, and he's doing quite well. Sometimes hypocalcemia presents to the physician, and the idea is to find out the real culprit leading to hypocalcemia. And sometimes it is hypocalcemia is masqueraded, presents, and it's an endocrine problem which presents as hypocalcemia. So I'll start with the story. It's always good to start with the story. Now this family came to me. This is the patient and the sister, and this is the patient's child.
Slides are not moving, sir.
Slides are not moving?
I think you can reshare and
okay,
make it full screen, then reshare.
Sorry for the technical glitch.
Yes, sir. The slides are moving, but please make it full slide.
Yeah.
Yes,
okay.
sir.
So I'll be fast. Now, this lady presented in 2008, actually. This photograph is taken in 16th of September 22, but this lady presented to us in 2008. She actually presented to another hospital with quadriparesis, and she was hypertensive at that time on 2 antihypertensives uncontrolled. So they worked up and they found that she had hypokalemia, CPK was high, but quadriparesis, they did an LP, they did an ANMG, they initially diagnosed her as GBS. They wanted to give her IVIG. And since the cost of IVIG was very high, so she got shifted to our hospital under a neurologist. And then the neurologist called me because she was hypertensive and hypokalemic, and he thought that it could be something related to a hormone. So we did an investigation. We did a morning 8 a.m. aldosterone, which was high. And the first saline loading test we did the saline loading test in the ICU, in which over 4 hours, 2 liters of fluid is given. And after that, a pre and a post aldosterone is done. And to see the suppression of less than 5 nanogram per DL, it was unsuppressed. And then we did a CT scan. It was a right adrenal adenoma. She was stabilized and surgery was done and she recovered. And this was the adenoma. So this lady was initially, obviously, she presented as an unmarried lady, and she was moving around with uncontrolled hypertension for several years, and it turned out to have Conn syndrome, primary hyperaldosteronism. And then later on, she got married and she came with a child, and I was really, really happy, and we clicked this photograph. The second case is also very, very interesting. This 40-year-old male presented, was a known diabetic, presented with quadriparesis to us. You see the potassium in this, it is 2018, he presented with a potassium 1.6. And so we, obviously it is an emergency, we gave him parenteral potassium replacement. But as you notice that he was hypertensive and he was Cushingoid, we did a lower overnight dexamethasone suppression test, which is a screening test for Cushing's. It came unsuppressed. Then we did a low dose, which is a confirmatory test for Cushing's, which was again unsuppressed. And we did an overnight high dose. And when this was also unsuppressed, means either you're dealing with a pituitary macroadenoma or you're dealing with an adrenal cause of Cushing's. And the ACTH was significantly high. When the ACTH was so high, we thought that, and there was severe hypokalemia, we thought we should look for an ectopic source. We got a CT scan done, and then we found a mass in the thymus. The patient had a very high chromogranate. It was a neuroendocrine tumor. The patient underwent surgery, and the patient recovered initially, but then again he started having a lot of weakness, and we unfortunately lost him during COVID. So sometimes you get a patient who is diabetic. It is said that the eyes do not see what the mind does not know. So you have to keep your eyes and ears open. And sometimes you may have a cause of secondary diabetes, especially when diabetes has significant proximal muscle weakness or hypertension or present with severe hypokalemia. This is another case with ectopic ACTH syndrome. Again, this lady presented with a potassium of 1.37. Unfortunately, although we diagnosed the patient, I put her on ketoconazole. She was lost to follow-up. We could not do more for her later on. The next, after the adrenals, the next set of cases are very, very interesting, and I'm sure we will all encounter them, and sometimes even I may have missed it. So this lady presented with hypokalemia and paraparesis. She was 56 years of age. Hypothyroid with progressive weakness over at least 8 years. She was having recurrent admissions with hypokalemia. Any small trigger of infection or loose motions presented, she used to present with hypokalemia. So, and she was advised potassium replacement. And when she presented with hypokalemia and hypothyroidism, we did a ABG. In ABG, we found that she had acidosis. Bicarbonate was around 13. There was pH was 7.3. But you see here that the urine pH was 6.5. So she had what is known as the distal RTA. And over these years, you see that recurrent, she was admitted in various hospitals with hypokalemia. And on one occasion, she was even put on a ventilator for a day. And then, of course, when you treat her, we give Scholl solution, but here we gave Portrait and we gave Sobisus for bicarbonate. And then you see when the ABG recovered, the pH was 7.4 and bicarbonate was normal. This lady also had Schirmer's test, which was positive, which she had dry eyes. And although we didn't work up with a complete antibody panel, but I'm sure she would have turned out to be Sjogren syndrome. This is another case with distal RTA. So whenever you have a lady with or females are more prone for hypokalemia and thyroid and Sjogren's, but otherwise one should keep that in mind as well. This is a second case, again treated with Portrait and Sobisus Fort. So it is known that you could have primary Sjogren syndrome with hypokalemic paralysis. So these are our two cases. Another interesting case is hypokalemic periodic paralysis. This 25-year-old male presented with progressive weakness of lower limbs, gradually progressive, and he could not walk unaided. And also he had a history of weight loss, hyperdefecation, and palpitations. And somebody had suggested that you take Seroportlor whenever you have such episodes. He turned out to have hyperthyroidism, and his potassium was not too low. Probably some of it he was taking, but it is known that even in thyrotoxic periodic paralysis, which is a type of hypokalemic paralysis with thyrotoxicosis, you could have almost near normal potassium and still the patient can be symptomatic. And then of course the patient was treated with the mainstay of treatment is to cure hyperthyroidism. Definitely once you do that, the paralytic episodes then go away. Otherwise what you have to do is to advise the patient to not take significant carbohydrate meal, because that triggers insulin release and shift of potassium into the cells. So this is a case of thyrotoxic periodic paralysis. So these were the various cases I was discussing about hypokalemia. One case, I'm sorry, I have my teacher who is the next speaker, Professor Dr. Subhash Yadav. I'll just take his permission. I saw this case yesterday and I just could not resist sharing this case with everybody. This case was referred to me by a senior physician from Khandwa. 43-year-old lady presented with hypertension, premature menopause, hyponatremia, and reversible cardiomyopathy. She got this is angio done, I think, on the 25th of August. She presented to that hospital with this ECG, which is frank. You would say there are hyperacute changes of in ECG. Tropi was probably positive. Her echo showed ejection fraction of 15%, but the angio done there was absolutely normal. Then they discharged her, but what you see here, if you pay attention, she had a thyroid function which showed low T3, low T4, and low TSH. And then she presented to me yesterday, this is 17th of September, with the sodium of 117. So, and then we took a history in 2006. She had postpartum hemorrhage. She did not lactate. She had premature menopause. She had recurrent episodes of hyponatremia. And she probably has Sheehan syndrome and a very rare, which is known as a Tukotsubo cardiomyopathy, which is a reversible cardiomyopathy. So idea is for the physician to keep in mind that sometimes, like Dr. Arpandev stated, that once you have hypercalcemia, you have to treat it as an emergency, but you have to find out what is lurking behind the scenes, which is causing hypercalcemia. So what we discussed here today is thyrotoxic periodic paralysis. We discussed adrenal steroid excess, which is alkalotic hypokalemia. We discussed primary hyperaldosteronism, Conn's case, which we discussed. And then we also discussed cases of renal tubular acidosis. If you have these in mind, then you cannot miss. And of course, you have to think out of the box, because in clinical medicine, sometimes you may encounter cases like I encountered one yesterday. Thank you so much.
Thank you, Dr. Sandeep.
Thank you, sir, for that excellent talk and very good clinical cases, which actually opened the eyes.
And we all encounter such cases. Like right now, I have admitted one patient with quadriparesis, admitted in neurology, and misdiagnosed as spontaneous melanosis just because they find sodium changes. And incidentally, we found hypokalemia. We corrected that, but just because whenever we have hypokalemia, generally we expect alkalosis. And if you are seeing hypokalemia along with acidosis, especially with anion gap normal, we can always calculate, urine anion gap as well as we can look into the pH of urine, and that will give us clue of distal RTA, and which is very often missed. And many times we believe that alkaline phosphate will be abnormal. That is not the case. Many times it is actually normal. So thank you, sir.
So one more point. Hypokalemia can lead to significant myopathy and rise in CPK. That also misleads the neurologists.
Yeah.
So there are case reports of, so my patient who came to another hospital, the first cons case had CPK in thousands. Everybody got misled. So there is hypokalemic myopathy also. So that really opens our eyes.
And that CG was really scary. Like, like nobody will think that diagnosis in endocrine. So I think that these all disorders are actually the, it's a kind of phenotype which has underlying endocrine disorder, and that is how endocrine is mainly a etiological diagnosis in endocrine. So thank you, sir. I think we should move with the next session. Can we put Dr. Subhash Yadav sir slide? Dr. Tony, can you carry this?
Sure. So Dr. Subhash Yadav sir is our professor at STPJ. So he's still there. He's the professor there. He'll be talking about hyponatremia. So over to you, sir. Tech team, please, can you put up the recording?
Good evening. Today I am going to talk regarding the hyponatremia. Hyponatremia, which is defined as a plasma sodium concentration less than 135 millimole per liter. It is a common disorder occurring in up to 20% of the hospitalized patients, and it is more common in critical care patients. And in addition to potentially life-threatening condition, hyponatremia is an independent predictor of mortality in intensive care unit in the geriatric patient and the patient with those with the heart failure and the cirrhosis. This disorder is almost always the result of an increase in circulating vasopressin and or increased renal sensitivity to vasopressin combined with the intake of free water, but a notable exception in hyponatremia due to low solute intake. So hyponatremia can be diagnostically divided into three groups depending upon the clinical history and the volume status, like hypovolemic, euvolemic, and hypervolemic. We know that hypovolemic hyponatremia because of renal loss, gastrointestinal loss. Normovolemic, the commonest cause is SIDH, and most importantly, sometimes remain quite subtle is adrenal insufficiency, hypothyroidism, and other important cause is primary polydipsia. And for hypervolemic cause, the commonest is heart failure and the cirrhosis. These are the fluid over state. There are other categorization of the hyponatremia also, like acute if it exists less than 48 hours, chronic if it exists at least for 48 hours. And depending upon the sodium concentration, it can be grouped into mild, moderate, and profound. Profound is less than 125 millimole per liter of sodium. Also, depending upon the symptoms, it can be divided into moderate, severe, when there is a nausea without vomiting, confusion and headache is present. In the severe, there is a vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizure, and the coma. So we know that there are various causes for the hyponatremia. Those are like divided into like decreased volume of extracellular fluid, important is the renal sodium loss, and the extracellular sodium loss are the diarrhea, vomiting, excessive sodium. And those with the increased volume of extracellular fluid, as I said previously, congestive heart failure, cirrhosis, nephrotic syndrome. And most importantly, those with a normal volume of the extracellular fluid having the hyponatremia. The important thing we see most commonly in our practice are thiazide diuretics, hypothyroidism, and adrenal efficiency. These two are sometimes very subtle and they present just with the hyponatremia initially. And other important is SIDH, that is a syndrome of inappropriate secretion of antidiuretic hormone, and it is caused by the various disease like malignancy, central nervous disease, some of the drugs, pulmonary condition, and other important and the rare causes for hyponatremia are excessive water intake and decreased intake of the fluid. So let's see what are the clinical manifestation of this hyponatremia. We know that hyponatremia is almost always associated with the hypoosmolality, and it is fall in the plasma osmolality that promote the movement of water into the cell and the possible development of the cerebral edema. The manifestation of hypotonic hyponatremia are largely related to the dysfunction of the central nervous system, and they are more conspicuous when the decrease in the serum sodium concentration is large and rapid. That is a very important. And the symptoms are like headache, nausea, vomiting, muscle cramps, lethargy, restlessness, disorientation, and depressed reflexes can be observed in these patients. Whereas the most patients with the serum sodium concentration exceeding 125 millimole per liter are asymptomatic, and those with the lower values may have a symptom, and more common when this disorder develop very rapidly. So the complication of severe and rapidly evolving hyponatremia includes seizure, coma, permanent brain damage, respiratory arrest, brainstem herniation, and the death. And these complications often occur with excessive water retention in patients who are essentially euvolemic. Hypotonic hyponatremia lead to the entry of water in the brain, and it results in the cerebral edema. And because of the then what adaptation happen actually? Because of the surrounding cranial limits, the expansion of the brain intracranial hypertension develop with the risk of the brain injury. The initial diagnostic approach to the hyponatremia consists of a directed history and physical examination as well as the selected laboratory test. So we have to concentrate on some important history and the physical examination while evaluating the patient of the hyponatremia. What are those? Like history of electrolyte fluid loss and the sign of extracellular volume depletion such as decreased skin turgor, low jugular venous pressure, hypotension. Other thing like we should take the history of low protein intake or very high fluid intake. Some other history also important when the patient come with the hyponatremia, especially the elderly patient, whether they have any malignancies, central nervous system disease, any pulmonary disease, or HIV infection, heart failure. Some of the medication can cause hyponatremia. We have to take account. Most commonly are the thiazide diuretics or thiazide type diuretics, mannitol, intravenous globulin, anti-epileptic, antidepressant, and antipsychotic. Other important history sometimes we get is the recent history of surgery, and we should always look for the peripheral edema or ascites, which can be due to heart failure, cirrhosis, or kidney failure. Symptom and signs suggestive of adrenal insufficiency in hypothyroidism, we should always look for in these patients. And also important is the prior episodes of hyponatremia. So in addition, it is important to evaluate the rapidity of the onset of hyponatremia and severity of the symptom due to hyponatremia, because it helps in guiding the therapy for the hyponatremia. Many times the history and physical examination often provide important clues the cause of hyponatremia, but many times these patients present at a very subtle degree of volume depletion and very difficult to differentiate between euvolemic and hypovolemic. So the laboratory testing is always required to establish the diagnosis. This we have seen in previous slides also. The hyponatremia patient can be divided into hypovolemic, euvolemic, and hypervolemic based on the volume status. And then we should go for the urinary sodium. If hypovolemic patient with having high urinary sodium, more than 30 mg/%, the most common cause is the renal loss. If the urinary sodium is less than 30, then probably it is because of the extra renal losses like vomiting, diarrhea, or third spacing of the fluid. If there is a euvolemia, that is patient is not having any edema, The important causes glucocorticoid deficiency, hypothyroidism, and the SIDH. That is the most important thing we have to remember. And if there is a hypervolemia, there should not be any doubt. It can be because of nephrotic syndrome, cirrhosis, and cardiac failure. If the urinary sodium is low, that is less than 30 mg/%. If the urinary sodium is more than 30 mg/%, we can definitely search for acute or chronic renal failure. So what are the important management guide as far as the hyponatremia is concerned? Patient with the severe and moderately severe hyponatremia have a risk of cerebral edema, and that always outweighs the risk of osmotic demyelination syndrome. So this justifies the treatment irrespective of the biochemical degree or timing. So we have to treat the severe or moderately severe hyponatremia patient with the hypertonic saline. In absence of severe or moderately severe symptom, there is a time for diagnostic assessment and cause-specific treatment. And if hyponatremia is mild and the symptoms are severe or moderately severe, accept the causality money in the exceptional cases. And before going to the proper approachment, we should have some few lines regarding some important concept. Hyponatremia means plasma osmolality, and the plasma osmolality is usually less than 280 milliosmol per kg. What happens normally in hyponatremia? Normally the kidney will conserve the sodium, so the sodium will be less, that is less than 30 mg/%. But if except in SIDH, diabetic, salt losing, or mineralocorticoid deficiency, it can be high, that is more than 30 mg/%. So if the ADH is activated, as in most of the cases, the urine osmolality will be more, that is usually more than 100 milliosmol per kg. So first step in diagnosis is the getting the sodium done. Preferably it should be done with the ion specific electrode using the direct potentiometry to avoid the fallacious sodium level. Next step is the getting done the serum osmolality. Serum osmolality should be measured by the osmometer. It should not be ideally calculated. If osmometer is not available, we can do with the help of serum blood sugar, plasma blood sugar, serum triglyceride, and the protein. But we have to remember a few things. For each 100 mg increase in blood glucose above 100 mg/%, decrease sodium by 1.6 milliequivalent per liter. And when the serum triglyceride are above 100 mg/%, for every 500 mg rise in serum triglyceride, fall in serum sodium will be about 1 milliequivalent per liter. And if the serum protein is above 8 gram per liter, for every 1 gram per liter rise in the serum protein, fall in serum sodium will be about 4 milliequivalent per liter. This thing we have to remember when we are interpreting the value of the serum sodium and the osmolality. Then to assess the ADH activity, the normal response to hyponatremia is marked suppression of the ADH, and that will result in excretion of the maximum dilute urine, and the urine osmolality will be below 100 milliosmol per kg, and specific gravity should be less than 1.003. But if the value is above this level, it indicates an inability to excrete the free water normally, and there will be impaired water excretion, and it is usually labeled when the urine osmolality is more than 150 millimole per osmolality per kg in cases of hyponatremia. Fourth step is to doing the urinary sodium, determination of source of sodium loss, whether it is renal or the extrarenal. Clinical assessment of the volume status is less accurate than the urinary sodium. If the initial urinary sodium is equivocal, it could be difficult to differentiate the true hypovolemia or euvolemia. In hypovolemic patient, there will be ADH will be suppressed and result in urine osmolality less than 100 milliosmol per kg. In euvolemic patient, urine osmolality will remain elevated due to independent ADH release. Other important thing we have to remember, urine sodium will increase in both until the volume status is corrected in hypovolemic patient. Then how to differentiate between the hypovolemic and euvolemic hyponatremia? That is, hypovolemia and euvolemic means you can say between SIDH. In SIDH, there will be low uric acid, that is less than 4 mg%, and the BUN is also low, less than 5 mg% are seen. And it is mainly because of uric acid is mainly reduced because of reduced proximal tubular sodium and uric acid reabsorption, and the low BUN is because of stimulation of V1A receptor contribute to urea wasting. Similarly, in hypovolemia, the uric acid and urea level may be normal or high. Some other clue to different causes. If there is a metabolic alkalosis plus hypoclemia, then probably it is because of diuretic use and vomiting. If there is a metabolic acidosis and hypokalemia, then probably there is a diarrhea and the laxative abuse causing the hyponatremia. Other important clue, metabolic acidosis with hyperkalemia. The cause of hyponatremia may be primary adrenal insufficiency in the patient without renal failure. And normal acid base and the potassium, then most likely is the SIDH. Then how to differentiate between hypovolemic and euvolemic? This is a very old concept. I mean, it is quite dangerous. Administration of 0.9% saline with the monitoring of sodium and follow up 6 to 8 hours. If hypovolemic hyponatremia, it will be improved. But when there is a euvolemic hyponatremia, it will be worsen. So now we'll move to the management. In the management, we have to determine what is the duration of hyponatremia, what is the severity of the hyponatremia, and also to determine the severity of the symptoms. So these are the three important baseline. We have to classify these hyponatremia. Then we have to decide whether patient will need hospitalization, and we should know what is the goal of therapy. Our goal of therapy is usually prevent a further decline in sodium, prevent the brain herniation, relieve the symptom of hyponatremia, and most importantly, avoid the oral correction. So the definition of hyponatremia, depending on the time, as I said in the previously also, can be categorized into acute if exists less than 48 hours, chronic if exists at least for 48 hours. Depending upon the serum sodium, mild 130 to 135 millimole, moderate 125 to 129 millimole, profound and less than 125 millimole. And depending upon the symptoms, it can be categorized into moderately severe and the severe. In severe, you include vomiting, cardiorespiratory distress, abnormal and the deep somnolence, seizure, and the coma. And what are the therapies for hyponatremia? We can, depending upon the type, severity, we can give the hypertonic and isotonic saline, fluid restriction, Vaptan, that is a AVP2 receptor antagonist, salt plus furosemide, and in rare cases, desmopressin. So, hypertonic saline, which is usually come as 100 ml contain 513 milliequivalent. In each 1000 ml, it contains 513 milliequivalent. And it is the most reliable method to raise the serum sodium quickly in acute and the severe hyponatremia. So hypertonic saline should be given only in acute and severe hyponatremia. Various formulae exist for calculating the initial infusion rate. Most simple formula, infusion rate is equal to patient weight in kg into desired correction rate, that is milliequivalent per liter per hour. Alternatively, some of the guidelines say you can give 100 ml of 3% saline bolus, repeat once if there is no clinical improvement in 30 minutes. The rationale for this is the replacement will increase the serum sodium by 2 to 4 millimole per liter and can reduce the brain swelling and intracranial pressure. But the most of the time it is given in the infusion rate. Other way to calculate the how much to give as an infusion is based on the change in the serum sodium we want and what we are going to infuse and what is the current serum sodium. So change in serum sodium is equal to infused sodium, that is what we are going to offer as a hypotonic saline, minus serum sodium divided by total body water plus 1. And other way is not, though it is also commonly used, sodium requirement is equal to total body water into desired sodium concentration minus current sodium concentration. But most commonly advocated method is like is change in serum sodium. So few lines for the therapies. After weighing the available evidence and the all to real risk of overshooting the mark, it is recommended a targeted rate of correction that does not exceed 8 millimole per liter on any day of the treatment. So correction should not exceed 8 millimole. The remaining within this range, the initial rate of correction can still be 1 to 2 millimole per liter per hour for several hours in patients with severe symptoms. A recommended indication for stopping the rapid correction of the symptom hypernatremia, these are if there is a suggestion of life-threatening manifestation, moderation of other symptoms, or achievement of the serum sodium concentration of usually more than 125 millimole per liter, or even lower if the baseline serum sodium concentration is was below 100 millimole per liter. And other option to give the isotonic saline. Isotonic saline of 1 liter contain 154 millimole of the sodium, and it is a treatment of choice for the depletion hyponatremia, that is hyponatremia because of hypovolemia, mainly not for the SIDS. It is the initial therapy portion where the clinical sign of hypovolemia. It is ineffective for the dilution hyponatremia like SIDH. In fact, it can worsen the volume status in patient with the hypervolemic hyponatremia. So this therapy should not be given at least hypervolemic hyponatremia. And other option of treating the hyponatremia is a fluid restriction, and it is a widely accepted treatment for the patient with the chronic hyponatremia. So chronic hyponatremia should be treated with a fluid restriction, and in SIDS the fluid restriction should be around 500 to 1 liter per day, and the serum sodium increases very slowly even with the severe restriction. It is economically favorable not to be used in the hypovolemic patient, not practical for the ICU patient. And there are some predictor for failure of this fluid restriction. What are those? If the urine osmolality is high, that is more than 500 milliosmol per kg, and the sum of urinary sodium and potassium concentration exceed the serum sodium concentration. Other marker is 24-hour urine volume is less than 1500 ml per day, and other marker is increase in the serum sodium concentration less than 2 millimole per day in 24 hours on fluid restriction of less than 1 liter per day. The other therapy we can offer the patient of hyponatremia is arginine vasopressin receptor antagonist. It is a conventional therapy, very high efficacy, and this is approved treatment for euvolemic hyponatremia and hypervolemic hyponatremia. The drugs are like ponimaptan, is approved for the euvolemic and hypervolemic hyponatremia in hospitalized patient. Dose it is given as 20 milligram loading dose over 30 minutes, followed by the continuous infusion of 20 to 40 milligram per day. Therapy is given only for 4 days, and in this, when you are giving this therapy, sodium should be measured every 6 to 8 hours. If the correction exceeds 8 to 12 millimole per liter in 24 hours, infusion should be stopped and patient should be monitored closely. Other is a tablet form of tolvaptan. It is FDA approved for the treatment of euvolemic and hypervolemic hyponatremia. It is started with the dose of 15 milligram per day, and it can be given up to 60 milligram per day. It is a contraindicated in hypovolemic hyponatremia, and tolvaptans are ineffective when the serum creatinine is more than 3 milligram per cent. Other rarely used therapies are urea. It corrects the hypoosmolality by increasing the solute through water excretion and decreasing the urinary sodium excretion. It is given the dose of 15 to 60 gram per day and 15 gram per day weekly increment to achieve the normalization of the sodium. It is not a FDA approved agent is not easily available, and its efficacy is comparable with the Vaptas. Other therapy which is also sometimes practiced are the combination of furosemide and the sodium chloride. Furosemide in the dose of 20 to 40 milligram per day coupled with the high salt intake of 200 milligram per day represent an extension of treatment of acute symptomatic hyponatremia to chronic management of euvolemic hyponatremia. Other just important line regarding calculating the dose of oral salt tablet, use the same principle as intravenous isotonic or hypertonic saline. 9 gram of oral salt provide a similar quantity of sodium as 1 liter of isotonic saline, that is give around 154 milliquarant, but it is without water, and 1 gram of oral salt is equal to the 35 ml of 3% saline. So just to conclude, the important thing, identify the symptoms, severe or moderately severe, decide whether it is acute or chronic, both acute in origin and severe hyponatremia, whether acute or chronic, has the same management to preserve the brain function. Treat moderately severe, acute and chronic hyponatremia differently. Identify rapidly reversible cause of hyponatremia and treat the rapid correction. An important thing, while treating, you should identify the patient at the risk of osmotic demyelination. These patients are mainly serum sodium less than 105, hypokalemia, alcoholic, malnutrition, and advanced liver disease.